Esteemed colleagues and dear friends from Pan India who have joined this program virtually, a very hearty welcome to the second day and the penultimate day of the NUCD 9th edition. Dear friends, to recap yesterday's, I'll take only 1 minute to say that yesterday's program centered around 7 sessions were fabulous. We had discussion regarding the nutritional management of type 2 diabetes mellitus, focusing on the comprehensive weight management. Manisha, we had a full session on the renal diet. By Rudrashish, we had a session on the protein in diabetic diet. The next 2 sessions were new concepts. In diabetes, we discussed 6 new concepts: remission and reversal, re-reversal by Mohan, the posture control matters by myself, and the mind-body medicine and diabetes by Sanjay Kalra. In the second, we discussed 3 more concepts: sarcopenia, the newer clusters in type 2 diabetes in India by Anjana, sarcopenia by Rajesh Rajput, and the NAFLD by Dr. Shibram. We then passed on to a session, a very, very important session on the oral drugs. And before that, we had a session on the concept of monitoring. We can only change what we measure. Jan gave a fabulous presentation on the TIR, CGMS, followed by HB1C versus TIR by no less a person than Professor S.K. Sharma from Jaipur. And also he spoke also on the structured self-monitoring blood glucose. Then we had a session on the interchangeable insulin. Following that, we had a full session on oral hypoglycemic drugs, starting with Vilda, followed by metformin in pre-diabetes. Fantastic talk by Dr. J.J. Mukherjee. We had a talk on the evidences for dapagliflozin. Fantastic session. And also re-emergence of sulfonylurea by Kalyanda from Calcutta. Last, we passed on to a session on the insulin, where we discussed regarding the co-formulation. We discussed regarding the oral semaglutide in detail, and also the hospital-based management of hyperglycemia with Degludec, a game changer, and new evidence presented by it was a great talk by Dr. Soumik Ghosh. Dear friends, while we passed today, I must tell you that we have very important sessions today: observing session, clinical practical sessions. Today, first session we start, as Jan just now pointed out, we have 2 consecutive sessions, the complications. Diabetes sweet disease with sour company, and the morbidities are very important to discuss. So we'll start off the discussion on the CKD. And you know, I have a person for you who is fabulous. She will introduce herself through her talk, Manisha. Absolutely fabulous regarding the CKD in diabetes. Followed by, we have talk on a very new system by a person whom you know, whom all of us adore because of his devotion to his specialty. He gave the oration recently, Vidyut, my dear friend. I'm calling my first name Vidyut, you are so younger to me. And musculoskeletal system in diabetes, a new, fabulously new topic. And followed that by the sexual dysfunction diabetes by no less a person than Deepak Jumani. We pass on after this to a very important session on the technology. And we have brought for you today, dear friends, the automated insulin delivery system, AIDS, which was introduced last year. And Dr. Sambit Das, Professor Sambit Das will speak about it, followed by our very dear friend Jyoti, the head of technical division of the RSSDI. He will be addressing us on the smart insulin pens, followed by CGMS by no less a person that our dear, very, very dear Dr. Bansi Sabo. Dear friends, the next session will be very exciting on the autoimmunity and diabetes. We'll start off with a talk by no less a person than the presiding officer of all that you are seeing, Professor Dr. Alok Kanungo. He had worked extensively on the LADA. His PhD also on the young diabetics and LADA. And I had requested him to speak on his topic. He will be speaking on the LADA, followed by the autoimmunity and type 1 diabetes by CB Sanjeevi from Stockholm, from the Karolinska Stockholm, and it's a great talk by Sanjeevi, and followed by, we have for you a gentleman from Kanpur, whom all of you know, who is called the king of clinical type 1 diabetes. Largest population of type 1 diabetes in the country. Rishi, my dear friend, Professor Dr. Rishi Shikla from Kanpur, is going to speak to us on the clinical aspects of managing type 1 diabetes in our country. Dear friend, following that, we have a very exciting session. The dual GLP and the GIP agonist, the tirzepatide in diabetes mellitus, is absolutely a new talk, a topic which has hitherto not been discussed in detail, and we have from United States our dear friend Dr. Debjit Tripathi to do justice to this, the dual combination and the tirzepatide and its clinical positioning in diabetology. He is an authority on that. Followed by a talk on the PCOD, polycystic ovary disease, by our dear friend Dr. Jargar, and next followed by Dr. Nikhil Tandon, Padam Shri Dr. Nikhil Tandon from AIMS Delhi, on a topic, the long-term outcome of GDM. Following this, we have 4 independent lectures, and the independent lectures center around the CV benefit and CV prevention by DPP4 SGLT2 combination. We have the treatment with G2O basal insulin by dear Arundhati, who will be joining us from the Brugad, followed by the drugs by our own Dr. Abhay Shah, speaking to us regarding the basal insulin therapy, and that's the program for the today. Dear friends, it's my great opportunity, privilege to hand over the session to Professor Dr. Jayant Panda, who is the head of the Department of Medicine and Diabetology at the S7 College, Cuttack. And without taking any more time, I just request all of you to listen to the topic relaxedly. We have got set questions, because this year's NUCD, like other years, but it is more this year, we have to make it interactive. So there are full time for the context setting by the chairperson. There are the 3 great lectures in every session, followed by a moderator and full panel discussion. Over to Jayant to invite the first session speaker and take it forward.
Thank you, sir. Thank you for the wrap-up of yesterday's program. Yesterday, we have received many good feedback regarding the content of scientific discussions and the time keeping and very relevant issues which were put forth. And you have also highlighted today's program in today's sessions, which are interesting, and we have faculties who are best in their field and from the national and the international importance. I welcome all of you to the session 7, the complications in diabetes 1. Following that, we have another session on complication in diabetes 2. In this session, we have Dr. Manoj Chotrai, who will be chairing this session and introducing our guest speakers, and 3 important topics of CKD, musculoskeletal system in diabetes, and heart failure prevention will be covered by Professor Manisha Shahai from Hyderabad, Professor Bidyut Das from Cuttack, and Dr. P.K. Shahu from Bhubaneswar. Following that, in the panel discussion, we will have Dr. Rajiv Chawla along with our faculties, and Dr. Bharat Panigrahi will be moderating the session. So without delay, I invite all the faculties, chairperson and moderator, and hand over to Dr. Manoj Chotrai for the introduction of the first speaker and starting the first session. Sir, unmute karan, sir, unmute. Manoj sir, unmute karan.
Hello, good morning.
Yeah, we are audible now. Yes, Manoj.
So, we'll be dealing this session on complications of diabetes. So, mainly the kidney is mostly affected, And it is seen that 40% of the diabetics, they have kidney disease. The most peculiar problem is those who are undiagnosed, they have also 30 to 40%, they have got all kidney disease. And pre-diabetics, they are more suffer. 17 to 18% of the pre-diabetics, they also suffer from kidney disease. So kidney plays a pivotal role in our system, and diabetes affects it. So we'll be discussing, Dr. Manisha Saha will be discussing on CKD in diabetes. And I have not received the full.
It's coming on the screen. Come on the screen now.
Manisha Saha, she is the head professor and head of the department of Osmania Medical College, Hyderabad, and editor-in-chief in Journal of Transplantation, deputy chair CME Committee of International Society, and president of Hyderabad Nephrology Forum, fellow Academy of Medical Sciences, and KDI Geo Anemia Working Group member, examiner in MRCP, and reviewer in international journals. And she has got 13 gold medals and 165 publications, and many more things to her credit. She is the vice president of Indian Society of Nephrology and council member for International Society of Nephrology, chairs South Asia Regional Board. Now, Dr. Manisha Saha will be speaking on CKD in diabetes. Madam, over to you.
So thank you for the nice introduction, and thank you for inviting me here. So at the outset, I would like to congratulate the faculty for hosting and organizing such a grand conference with such a good audience and good comments so far. So today we'll be dealing with the diabetic kidney disease, which is one of the major complications of diabetes, as was highlighted by the chairperson. So we call it the CKD, chronic kidney disease, is a global killer in plain sight. People are not aware of chronic kidney disease. If you see the figures, roughly 18% of Indians have diabetes, 18 to 20%. Hypertension is seen in 25%. But do you know CKD occurs in 17%? CKD is almost as common as diabetes, but people are not aware of it. People are aware of diabetes, thankfully now, hypertension, heart disease, but they are not aware of chronic kidney disease. This is our own Indian study, which shows that out of all causes of CKD, diabetic CKD is the most common, the forerunner in India, which causes CKD. And unfortunately, though we have so many services available in India, India cannot provide dialysis to all patients of diabetic CKD. You must be aware of PM Yojana, where they are starting dialysis centers in all the districts of India. Huge exercise. But remember, even with all these facilities, we can do dialysis only for 50,000 new patients every year. And how many patients of CKD need dialysis every year? 2 lakh. So out of 2 lakh people, we will be providing dialysis only to 50,000, and 1.5 lakh will just die. We know that we have dialysis and transplant. So apart from the limited facilities, it's very costly. The dialysis is roughly 30,000 rupees per month. So 2,000 rupees per session, every alternate day patient comes for dialysis. So it's a very poor quality of life for the patient, and it's lifelong. Transplant is available, but India does around 12,000 transplants per year. And we need how many transplants? 2 lakh per year. Can we meet the numbers? And then transplant is expensive as well. So if we don't treat diabetic CKD, this is where we end, dialysis or transplant, which is limited, and the cost is huge. In addition, the diabetic CKD, apart from contributing to the cost and poor quality of life, look at the effect on cardiovascular diseases. A person who has diabetes and CKD is shown in the violet bar, and all risks are multiplied. Congestive heart failure, acute myocardial infarction, CVAs, peripheral vascular disease, ASCVD, and death. Everything is multiplied so many times, twice, if a patient has both diabetes as well as CKD. Therefore, DKD management and knowing about it is important, and that's why the importance of this session. Now, remember, diabetic patient can have 2 types of kidney diseases. First, kidney disease, where the kidney disease is because of hyperglycemia. That is the main culprit. And this is typically diabetic kidney disease or diabetic nephropathy, as it was called. And here, generally, you have proteinuria. It progresses gradually, and it's associated with diabetic retinopathy. So this is the main focus of discussion today. And almost 70% of diabetics with kidney disease have this type of kidney disease. We call it DKD. Now, a diabetic person can have kidney disease because of other reasons. Maybe because of lupus nephritis, maybe some glomerular disease can occur in a diabetic. So these diseases are called non-diabetic kidney diseases. They are not associated with retinopathy. They have a rapid progression and they need separate treatment. So this is not we are discussing today. We are discussing diabetic kidney disease, which is because of hyperglycemia. Now, how do we identify diabetic kidney disease? What are the symptoms of kidney disease? Remember, we have 5 stages of CKD. In a diabetic also, we can have these 5 stages of CKD progression. The last stage is where the patient needs dialysis or transplant. And then slowly the patients of diabetes progress from 1, 2, 3, 4, 5 stages. In stage 1 and 2, there is no abnormality. Patient is completely asymptomatic. All diabetics, they may have CKD, many of them, but we don't know, no symptoms. So early DKD can be asymptomatic. The last stage, you have symptoms, and this is where the patient comes to the nephrologist. There's decreased urine output, swelling of pit. So this everybody recognizes, and most of the patients in our OPs come in this stage when they have full-blown edema and swelling. The middle stage, the stage 3 and 4, again, they have symptoms, but many of the times the symptoms may not be related to the kidney. They may be affecting the blood, anemia, hypertension. The patient may have pruritus, may have loss of appetite, vomiting, and the patient may have cardiac symptoms, may have respiratory system, breathlessness symptoms. So the patients keep on going to different specialties. They never end up with the nephrologist because creatinine is often not done because nobody thinks that the cause of this symptom in a diabetic may be kidney because the symptoms are related to other organs. So what I have emphasized is that diabetic kidney disease in the early stages, you may miss it. Therefore, screening is essential. So all diabetics, let us see what type of screening should we do. So what is the toolkit for screening? Only 2 tests, urine albumin and creatinine. With the creatinine, calculate the eGFR. So this message, all diabetics should undergo these 2 tests. This is the message which should go across. Urine albumin, repeated measurements are important, at least 2 out of 3 measurements. And we should not test for urine albumin in the presence of fever, UTI, or if the patient is pregnant or sugars are uncontrolled, CHF. So you should check when the diabetic person is otherwise stable. And we all know that microalbuminuria, then you have moderately increased albuminuria, severely increased albuminuria. So nowadays we don't use the term microalbuminuria, but again, we call it moderate or severe. Remember the numbers. Less than 30 milligram per day is fine. More than 300 milligram per day, it's already in the stage of severe albuminuria. So please do a urine albumin test. You can do it with a dipstick, which gives a semi-quantitative estimation, or you can send it to the lab and you will have this report. The other important thing is the creatinine and GFR. So asymptomatic diabetics also, this should be done and get the creatinine from the lab. The lab can do the GFR if you want. Otherwise, this smart formula can be downloaded on all smartphones. It is free for download. And you use the CKD epi formula nowadays, not the other ones. So you have to just fill the creatinine, the age, gender. And the new CKD epi formula, even race is not. So creatinine, age, and gender, and you have the GFR. So on your prescriptions, on the physician's prescription, always urine albumin report should be there and the GFR should be mentioned. It's mandatory, which many of us do not do. So after checking the albumin and GFR, we can classify the patient as which stage of CKD. The left side, you can see the GFR, G1 to G5. So G5 means the last stage. So if the GFR is between less than 15, you call it G5. And suppose the albumin is more than 300, you call it A3. So if a person comes with albumin more than 300 and a GFR less than 15, you call it G5A3. So this is how it should look on your prescription. Just remember, think honestly, are you writing it? Many of us are not. We should do it. Even the nephrologist sometimes don't write. That is wrong. So that's the first step. You should screen and diagnose DKD early. So should you screen everyone? No. All type 2 diabetics from onset, you have to screen. Whereas type 1 diabetic, you can start screening after 5 years of onset of diabetes. So please remember, most of the patients are type 2 diabetes and all of them annually urine albumin creatinine ratio and a GFR. Who should be doing the screening? Should the nephrologist do the screening? No, because by the time patient comes to nephrologist, they already have stage 5. So it's no use. Nephrologist should do it, but the main people doing it should be the physicians and GPs. You have 10 lakh physicians and GPs in India and only 2,000 nephrologists. So screening of all diabetics cannot be done by nephrologist alone. And they are the correct people, the physicians, because who will be seeing diabetic patients who are asymptomatic regarding the kidney. So all these patients, please screen. And if screening is positive, then we do all the other investigations, LFT, RFT, the iron profile, calcium profile. We also look at the ultrasound, lipid profile. So all these tests are done in case the screen is positive. And this is generally the domain of the nephrologist. Remember one thing, renal biopsy. So should we do renal biopsy for all patients of diabetic nephropathy? No, it's not required. You should do renal biopsy only when there are some suspicious features. For example, hematuria, rapidly progressive renal failure, nephrotic syndrome, systemic features, example, rash, or if the diabetic person does not have retinopathy. So these are the clues that the patient may be having the non-diabetic kidney disease, which I said may be because of other conditions, not because of hyperglycemia. So this is not to be managed by the physician, refer to the nephrologist. So if any of these things are there, routine diabetic nephropathy, these things will not be there. No hematuria, retinopathy is generally there. It is slowly progressive. So those diseases should be managed by the physician, but any such suspicion, refer to nephro for a renal biopsy. Fine, so we have such patient who has come to your clinic, 47 years old, software professional. He's a diabetic hypertensive, he's a smoker. He is on the obese side, blood pressure 140/90, HbA1c is 8.3, creatinine is 2.1, his GFR is already 36. Cholesterol is a bit high, he has bilateral NPDR, and kidney size is normal. He is on metformin and glimepiride, telmisartan, CT. So this is generally the prescription what we get from many of the referring physicians or GPs. So is this enough? So there are 1, 2, 3 drugs on the prescription. Is this enough? What do the guidelines say? Remember, the first point in your prescription should be a diet advice. Healthy plate. So healthy plate for diabetic nephropathy is again like a normal plate. Half of it fruits and vegetables. 1/4 is carbohydrate, that too whole grain, and 1/4 should be lean protein. So this can be advised for all early stages of diabetic nephropathy. Avoid animal protein, go for plant protein. Plant protein is better. So protein should not be restricted in a vegetarian. They should be allowed to take all vegetarian protein diet. If they want to take animal protein, then you can use egg or chicken, fish. Meat should be avoided. And the first point on the prescription should be about diet, which should include salt advice. So say salt, half teaspoon per day if the patient is hypertensive, 1 teaspoon if not hypertensive. But remember to tell, avoid salt substitutes. They will go and purchase salt substitutes. They should not be used. Go for natural spices. You can go for lemon. You can go for garlic and onion powders. They also have the same taste without sodium. Avoid soya salt. These things should be told, soya sauce and all. People have a lot of salads nowadays, then they put salad dressing on that. Salad dressing should also be avoided. It contains sodium. So this is the first point on your prescription. What should be the second point? Lifestyle advice. So for diabetic nephropathy patients, 150 minutes per week. That's 30 minutes per day, 5 days a week. Right? Stop smoking. That should be mentioned on the prescription. It's important. About BP control, what target? This patient is 140/90 BP. Is that okay? No. What do the latest guidelines say? Bring the BP down to 120 unless the patient is not able to tolerate it. Fine. So the second should be about BP advice, target BP, and what drug. The person is on telmisartan 40 mg. Do you agree with that? Remember, it's correct. RAS blockade should be the first line drug, but the dose is wrong. Remember, for diabetic nephropathy, nephroprotection, you should go to 80 mg telmisartan. So the message is all ACE inhibitors or ARBs, whatever you are using, use full dose unless the patient has side effects, and do not combine ACE or ARB. Both should not be combined, any of them. So telmisartan dose was increased to 80 mg. Still, after that, the blood pressure was not controlled. So what should be the second line drug in diabetic nephropathy? Calcium channel blocker can be used. Then still not controlled, you can go for loop diuretics or thiazide diuretics depending on the GFR. Then mineralocorticoid receptor antagonists, then minoxidil and hydralazine. Lastly, clonidine or moxonidine. This is the way it should be used in a patient with diabetic kidney disease. So this patient was therefore initiated on telmisartan, made 80 mg, amlodipine was added, and chlorthalidone was already there. So triple drug combination. So that was about BP control. His BP got controlled. What about blood sugar? Target 6.5 to 8 is the latest guideline in diabetic nephropathy. Why the targets are so much varying? For younger patients who are not having any other comorbidities, who can manage hypoglycemia, you can go for stricter target. So for this patient, software 47 years, go for 6.5. For older individuals who are staying alone, hypoglycemia, unawareness, many comorbidities, go for lighter target. 8 is okay. Remember, HbA1c is not very accurate, but still we use it. It may be falsely low or falsely high in case of diabetic kidney disease. So use it with a pinch of salt. This is the best available as of now. But as you must have heard yesterday, continuous monitoring of blood glucose is also coming in a big way in diabetic nephropathy, where you have a discrepancy between the blood sugars and HbA1c. So this can also be used. So glycemic targets I've told you. Now, how do we attain these glycemic targets for diabetic nephropathy? Remember that it's not only glucose control now. Glucocentric approach is not enough. We should look at protection of other organs, preservation of beta cell function, weight reduction, minimum hypoglycemia. So all these things and a good quality of life. So what drugs is this patient on? He is taking metformin and glimepiride. Is that correct? His GFR is more than 30. It's around 36, which we saw. So this person, metformin continuing is correct. You can continue with the metformin. Depending on the GFR, you can adjust the dose. So more than 60, same dose. 45 to 60 also same dose, but you have to monitor carefully. 30 to 45, half the dose. And less than 30, stop metformin. So metformin still remains the first drug of choice for renoprotection as well. Now, second, what do we do? SGLT2 inhibitors, they have come in a big way, and they should be the second drug of choice. In this patient, they are not there. So you may say SGLT2, they reduce the hyperglycemia by excreting sugar in the urine. How they are renoprotective? They are renoprotective because they counteract the hyperfiltration. The kidney damage occurs by hyperfiltration. We know that as there is more and more nephron loss, the remaining kidney starts hyperfiltering. The more nephrons work, the more disease they become. So overwork spoils the kidney. Hyperfiltration spoils the kidney. And how do SGLT2 inhibitors help here? We all know that SGLT2 block the SGLT2 in the proximal tubule. And as a result, what happens? More sodium and glucose, it reaches the distal tubule. And in the distal tubule, what happens is we have macula densa, which receives this sodium. And then what does it do? It tells the efferent arteriole that already I'm receiving so much of sodium and glucose, so do not filter more blood. As a result, there is constriction of the efferent arteriole and there is decreased pressure inside the glomerulus. And this brings down the hyperfiltration. And this is the main mechanism of renoprotection by SGLT2 inhibitors. They have other mechanisms as well, but this is one of the main ones. And that is why they are very smart drugs. They are helpful in weight reduction, reduce the BP, cardioprotective, they reduce hyperfiltration, they are smart diuretics, they decrease the albuminuria, decrease the renal work, and decrease inflammation. So many mechanisms of action and multi-pronged effect of SGLT2. So this drug should be added in the prescription. Therefore, for this person, dapagliflozin was added 10 milligram, and chlorthalidone was reduced to avoid the risk of dehydration, because dapagliflozin also causes some renoprotection by excreting the extra water. So what happened was creatinine went up to 2.2 and the urine sugar became 3+. So patient was scared that creatinine is going up, but we told that that can occur with dapagliflozin, no need to stop it. Future renoprotection is going to be there. So the albumin had come down, but not totally come down after dapagliflozin. Creatinine started declining. So after DAPA and metformin, what do we do? SGLT2 is not enough. You have residual risk after SGLT2 as well. So what is the next step? Next step is to add GLP-1 receptor agonists. So these are other renoprotective drugs which should be added if the patient is not well controlled on SGLT2, or if the patient does not tolerate SGLT2, these can be added. So these are other important renoprotective drugs. So this was done. The patient was started on liraglutide as well. Now, is the prescription complete? Do we need to do anything? Still some proteinuria is there. Around UPCR is the protein is around 430 milligram, not normal. So the creatinine has come down. So now we have evidence from Fidelio trial and you have Fidelity trial which show that finerenone can be added. It is renoprotective and cardioprotective. So this is another new drug for the management of diabetic nephropathy, which helps in renoprotection. So 10 milligram finerenone was added. So now the prescription looks like this. Is this complete as of now? Let us see. Any other therapy? Yes. Do not forget to add statin for all patients of diabetic nephropathy. Even if the cholesterol is normal, This is for cardiovascular benefit. So above the age of 18 years, all diabetics with nephropathy should be on statin. Bicarbonate should be added to maintain serum bicarbonate 22. Aspirin is added only if the history of cardiovascular disease is there. Uricosuric agents, the uric acid was 7.4 for this patient, not required. Only symptomatic hyperuricemia you should add. Otherwise, many prescriptions we keep on adding allopurinol for Bixostat. Add if the uric acid is above 9 or if the patient is symptomatic. And manage anemia and mineral bone disease by giving iron and erythropoietin. This patient was okay. So diabetic nephropathy does not only mean glucose control. So many other parameters need to be looked at. So now this prescription seems complete. We have added atorvastatin, sodium bicarbonate was added as well. So recent concept is not glucocentric approach, it's a holistic approach. So coming to the end of my talk, the prescription which had 3 drugs written on it was not complete, and now the prescription is complete, where you can see how many measures, 10 measures. So the 10 commandments for diabetic nephropathy. You may think why madam is talking again and again. This we all know, but this is a study published in leading journal. We are also authors of this in leading institutes from India. Only 40%, 48% patients are on ROS blockade, 40% are on statins, metformin only 25%, and iron and ESA therapy for diabetic nephropathy non-existent. So remember, it's important. There are a couple of recent advances. We have non-albuminic DKD, which we will discuss during the question hour, where albuminuria is not there, still the patient has DKD. This is associated with more of macrovascular disease and absence of retinopathy, has a better prognosis. However, the drugs are not very effective. And we have so many other players as well. I'm not talking about that. This looks like a scary slide, but at the same time, an exciting slide because so many pathways are there and new drugs are coming up. So, ladies and gentlemen, concluding, I have great regard for Indian doctors. We are all trying to do our best in our fields, but we are working alone. We need to collaborate. Together, we can make a difference. That's why the purpose of this seminar, the physician talking to the nephro and endos. Prevention is better than cure. You can see testing is only testing and treatment prevention 3,000 per month. Dialysis transplant is 30,000 per month. So I think this should be the main message. If you want to really take hold of diabetic nephropathy, screen them early, and for treatment, use a 10-point agenda. So this will go a long way in preventing diabetic nephropathy. Thank you for a patient hearing.
Thank you, Dr. Saha, for a very nice presentation and informations. Only thing is that many cases we are seeing that diabetes is controlled, but the creatinine is more than 3. Those cases, what should be done?
Yes, absolutely, sir. So what happens is, as the creatinine goes up to 3, you all know that the diabetes automatically gets controlled. Patients become very happy that my sugar was not controlled for 10, 15 years. Now it's becoming controlled. And we get scared because hypoglycemia is an early sign of diabetic nephropathy. So many of the times the patients are tested when they develop low blood sugar or sugar gets controlled. But what do we do now? So still in this condition, will you use SGLT2? You have to use SGLT2. You can reduce the dose of other anti-hyperglycemic agents. You have to add SGLT2 for nephroprotection. We are underusing these drugs. In addition, see that the RAS blockade is complete. So all those 10 points, what I have told, are for those patients who, even if they have a normal blood sugar, you still have to use all those 10 points. So that should be done. The message should go across the 10 points. It's not only for management of diabetes. Diabetes management is 1 point. Other 9 points also have to be done. So I hope that answers your question.
Thank you. Thank you, madam. Now, Dr. Panda, anything you to tell?
We'll go on to the next topic, sir. Professor Bidudas, sir. So you have to invite Professor Bidudas, sir, for the next talk.
We introduce him and let him start the talk. We'll be having discussion at the end, Dr. Chotrai.
Okay. Okay, now it is Professor Bidudas will be telling on musculoskeletal system in diabetes. And Professor Bidudas needs know, he's the father of autoimmune disease. That section he has started in SC Medical College, immunology. Previously, we didn't know that immunology and rheumatology are separate, but he has created the department in that, and he's a faculty in Institute of Sciences, faculty of Public Health Foundation, many awards to his distinction, and he's the Best Odisha Citizen Award. He has get so many awards, and he's loved by a great people. All the patients love him, and his outdoors sometimes last 1 a.m. At 1 a.m. he will be seeing patients without charging anything, and patient will be waiting for him. So he needs no introduction. Dr. Vidyadas is an institution himself. So I invite Dr. Das to start his subject on musculoskeletal.
Actually, the musculoskeletal system is very relevant in a diabetic. That has been realized of late. And Professor Das, being a doyen in immunology and dermatology, and inspired lakhs of followers and students to the specialty, it's a very nice moment to hear him at this juncture regarding the musculoskeletal system in diabetes. So without much delay, we present you Professor Vidyadas for the topic musculoskeletal system in diabetes. Sure.
Well, thank you, John. Esteemed chairperson, Dr. Manoj Babu, Dr. Jayant, my teacher, whom I love, Professor Das, Ashok Das, and of course, Alok Tanungo, who forced me to come and give this talk. And I told him that I don't deal with diabetes. I'm a purely clinical immunologist who deals mostly with immunological problems. But lately, as I can understand that the musculoskeletal manifestations in diabetes are pretty common, and they are mostly seen by orthopedicians. They hardly come to a rheumatologist. When they do come, they are almost in an advanced stage, and there is very little we can do about them. And a lot of people even don't know these musculoskeletal manifestations are part of diabetes. I must congratulate Professor Manisha. I was impressed. Excellent talk, madam. I was pretty impressed with your talk. Now, all of us know, as I've told you, that is a very important manifestation of diabetes mellitus. Now, we see hundreds of patients of different different diseases, including mostly autoimmune diseases. But when these patients come with problems of the bone or the joint or the muscle, they normally say that we are being treated for this disease by other specialties for large many years. And when we realize that actually is a diabetic, and that has been taken as a separate kind of problem, and they have not been linked, and the whole issue comes to light that perhaps that equation has not been worked out. And most of them receive very little attention compared to the more serious macrovascular complications. And I can understand that because they are more serious, life-threatening compared to the musculoskeletal conditions. But these conditions, they are recognized early, they affect the quality of life quite badly. And if they can be recognized early and you manage them early, you can significantly improve the quality of life. Before I proceed, I must talk about a case where I realized why these cases are missed and why people don't understand the link between diabetes and musculoskeletal symptom. This guy came in December, mid-December to us. He was from Pune. He's a Air Force person. He came, he showed a lot of people there his problems, like he had swelling of fingers of both the fingers, both the hands, difficulty in making a fist, and there was tightening of skin around the fingers for 6 months. And for this reason, he has gone around multiple specialists, including orthopedicians, and he did not get any relief. He was a diabetic for 20 years. Very, very important clue there. He had coronary artery disease 2009 and has been put on a stent. He's on medication, mostly oral diabetic agents. I don't know his HbA1c and all that is not available to us. Blood pressure was 130/80. And the musculoskeletal examination showed no tenderness of the joint, but only swelling of the joints around the MCP and PIPs. Other systems were normal. Now he has been subjected, he has gone from Pune to Delhi, and then because he stays in Orissa, he landed up in Orissa and has been investigated extensively at Bhubaneswar. seen by physicians, orthopedicians, and even rheumatologists. And the spectrum of differential diagnosis was from rheumatoid arthritis to connective tissue disease to scleroderma to multiple myeloma to chronic regional pain syndrome. You can see the wide ranging, and all that you see, his fingers were quite puffy and the skin was tight and he was unable to flex his fingers. Now, these were the investigations done from outside. That's what he showed us. His CBC was normal, urine was normal, ESR CRP was within normal limits, and they've done the rheumatoid factor, anti-CCB, HLA-B27 were normal. I couldn't figure out, ANA has been done, which is normal. ANA profile was negative, serum membrane was normal. The kappa lambda beta 2 microglobulin levels were normal. Then they did the X-ray chest, hands, normal. MRI showed only mild septum edema on the palmar aspect. MRI spine, MRI pelvis, CT thorax. You can see the extensive investigation that he has been subjected to, and most of them had normal results. Then he went through another series of investigations. Vitamin B12, 105 picograms. He was given vitamin B12. His prostate-specific antigen was done. Serum cortisol, morning samples were normal. The CT scan of the whole abdomen has been done. DEXA scan has been done. Upper GI endoscopy showed fundal erosions because he has been taking anti-inflammatory drugs for a long time. Echo was normal. And most people came to their wits' end, and one of the rheumatologists advised that you need to have a flexor tendon biopsy and MDP bone scan. That is where he, almost like the last straw on the camel's back, he ran away and came to us. He came to a rheumatology OPD on 22nd December 2022. We examined the way we do for all patients who come with rheumatological problems. A simple test that we did was what's called a prayer sign. It demonstrated a classical prayer sign. There was no tenderness of the joints. And this is one of the classical presentation of what is called a diabetic chiroarthropathy, stiffness of the joint, stiffness of the skin, otherwise called limited joint mobility syndrome. He was counseled, he was extremely relieved and advised to have physiotherapy and perhaps analgesic and nothing more because there was no other drug to control his diabetes as far as practicable and do physiotherapy. Now, this case I presented to show that he has gone around multiple places. From Pune, he went to Delhi, he went to Calcutta, then he came to Odisha, Bhubaneswar, and has been seen by so many people. People have thought of so many things, have been investigated such widely, but the link between diabetes and this condition has escaped because sometimes it is told what the mind doesn't know, the eyes cannot see. There's an example of that. And by simple counseling, he was so relieved that he blessed us a lot and went back. This is just to suggest that we have very important musculoskeletal manifestation of diabetes. If you group them into 4 groups, like soft tissue involvement, joint, bone, muscle involvement, the first group, that's the soft tissue, are the most predominant. We see limited joint mobility syndrome, which I showed, chiroarthropathy or diabetic stiff hand syndrome. And the other one is the last, which we see adhesive capsulitis or frozen shoulder. And carpal tunnel syndrome is pretty common. Stenosing tenosynovitis or trigger finger is equally common. Dupuytren's contraction is not that common. But we do see, but most of them, they are treated by orthopedicians and other specialties, and they rarely come to us. In the joint, the diabetic neuroarthropathy, that's the Charcot's arthropathy, is not very common. Recently, we published a series of 4 or 5 cases of Charcot's arthropathy of the elbows, which is very, very uncommon. And some of them had syringomyelia. Gouty arthritis, it's supposed to be an association with diabetes because of the metabolic syndrome hyperuricemia. And the other 2 conditions, the bone osteoporosis and fracture, very important because in diabetic, having fracture can lead to big problems in management because of multiple complications. And it's been seen that fracture rates, fragility fracture rates are very high in diabetes. A very interesting disease, what is called diffuse idiopathic skeletal hypostosis. I'll show you a picture how they are misdiagnosed as cases of ankylosing spondylitis, but they're very well linked or associated with diabetes mellitus. And lastly, the muscles are involved. Diabetic amyotrophy previously was supposed to be a neuropathy. It is neuropathy. Now we talk about diabetic sarcopenia, extensive loss of muscle in diabetics for reasons not known. And last but not the least, again very rare, diabetic muscle infarction or diabetic myonecrosis. I've seen most of these cases. I've not seen a case of diabetic muscle infarction or diabetic myonecrosis. So this is to suggest that If we have in the mind that diabetes can give rise to this condition, I'm sure we can help a lot of people before they come in a very advanced stage. Very important, because we have to understand the pathophysiology of this condition, then we can target the pathophysiology by which we can prevent progression of this disease. As usual, since most of us understand it's presumed to be multifactorial, you have a genetic predisposition. Some people develop these conditions faster than the others. Some people don't even develop. So obviously there is a genetic we do not know. Even the GWAS studies hasn't shown much. There's a microvascular impairment, and there's most important, the accumulation of advanced glycation end product. This is supposed to be the most important aspect of the pathophysiology of musculoskeletal disorders. I think it's true for most of the complications that we see in diabetes. The oxidative stress, reactive oxygen species, which is generated, causes damage to the cells. And of course, diabetic neuropathy, which contributes to Charcot's arthropathy. The fibroblastic proliferative disorder, the soft tissue, which I was showing as the most common in diabetes mellitus, has been worked up a little more than the other conditions. The abnormal accumulation of AGE, which I showed, is one of the most important factors. And this collagen tissue, especially with which fibroblastic proliferation is associated with, is very susceptible to glycation. And tendon AGE cross-linking reduces sensitivity to collagenase, so there is less turnover, remodeling capacity is reduced, and it increases stiffness. Interestingly, AGE enhances transcription factor NF-kappa B, resulting in high TNF-alpha and IL-6. So this is where the immunologist is perhaps linked with the diabetologist in regard to the musculoskeletal conditions. Otherwise, we know immunology has a big role to play, inflammation has a big role to play in diabetes. So the cooperation between an immunologist and a diabetologist will be something that we'll see in the near future. And last, increased ROS triggers inflammatory response and induces cell damage. So all of them, the soft tissue component that we see in the majority of musculoskeletal disorders associated with diabetes is related to AGE and its downward cascades. Now, the prevalence, as you can see, this is something that we have, people have been done by epidemiological studies. All that I wanted to say, that these disorders are much more in diabetics compared to non-diabetics, whether it's adhesive capsulitis, frozen shoulder, limited joint mobility, 25 to 76%. This diabetic cardiomyopathy is invariably misdiagnosed as rheumatoid arthritis or scleroderma. That's where people make a mistake. Dupuytren's contracture, there are many other conditions, but here the rates are very high. Carpal tunnel syndrome we see in many conditions. Of course, diabetes is one of the more important factors. Flexor tenosynovitis. This slide suggests that we do see large number of musculoskeletal problems with diabetes. This is the first one, that is the adhesive capsulitis, which we see. It has a progressive painful restriction of shoulder joints. Lots of people come to us with this after they have shown the orthopedician and nothing has happened. And we say, are you a diabetic? Yes, sir. Did you tell this history? No, sir. You should have told the history, and it would have been very easy to make a diagnosis. And here, especially the abduction and external rotations are pretty limited. Sometimes you can make a mistake of just the rotator cuff tendinitis. The cause is proliferation of fibroblast, myoblast, collagen. It has 3 phases. Initially, painful phase. This is where you should catch them, find out their sugar levels, see whether they are controlled or not. As Dr. Manisha was telling, the control is so vital, so vital, and that if you don't control it, you have the downward cascade going on. Then you have the adhesive phase. Then it becomes very difficult to treat them because they are so stiff. You have to inject or you have to do surgery. Then the resolution phase. Some of the patients do resolve over time by just physiotherapy and analgesics or NSAIDs. The other one is the chiroarthropathy, which I showed. These are the typical 2 signs that we can do in the clinic to see. One is the prayer sign on the left side. The right side is called a tabletop sign. The fingers cannot be opposed to the table. These are mostly painless progressive stiffness. Fixed flexion. That patient which I showed had this exactly. Fixed flexion contracture, decreased grip strength. And the skin of the hand is waxy, and sometimes it can be stiff. So we make a diagnosis of scleroderma, which is wrong actually. The diagnostic tips are prayer table sign. Very simple signs. You don't need great investigations for this. Treatment, controlled diabetes, physiotherapy, analgesics. In fact, as you see, most of this condition requires simple interventions. Control of diabetes is primary, physiotherapy, analgesics, sometimes analgesics and steroid injections. Very common, we see trigger fingers, and then we realize that he is diabetic. Dramatic response, just inject the tendons, they have dramatic response. But again, they come back if the diabetes is not controlled. It is caused by inflammation attributable to repeated friction between flexor tendon and sheath. Interestingly, one has to remember it affects the thumb, index, and middle, not the other two fingers. If you keep that in mind, you can pick them up. Bilateral, most common in women. Physiotherapy, local steroid injections. And Dupuytren's contracture, they come at this stage pretty late. They are slowly progressive fibroproliferative disorder of the palmar fascia, joint stiffness, loss of full extension, palmar digital thickening, tethering, contraction, third, fourth. There you saw first, second, third year, third, fourth, and it is mostly progressive and very difficult to treat this patient. Very difficult. At this stage, one has to do a fasciotomy or fasciectomy in surgery. Again, they come back. Now, when you come to the joint involvement, Charcot's, as I told you, related the neuropathy. Gouty is more like an association because of her metabolic syndrome. And recently, I saw a couple of papers that showed high incidence of osteoarthritis and rheumatoid arthritis in diabetes. And they are mostly associational rather than cause and effect. You can explain by many ways, but cause and effect relationship has never been shown. And Charcot, this is how they come. These are one of our patients. Progressive painless joint destruction. So there are multiple factors involved in this: the mechanical factor, vascular factor, neuropathic factor, and of course, the inflammatory cytokines add to that. Because of repeated trauma, increased laxity, there is fragmentation of articular cartilage and collapse of the bones. Weight-bearing joints like foot, ankle, knees are very important. We got elbow joints because he had syringomyelia. X-rays, very quickly you can catch MRI of the affected joints. Rarely we need, and you have to do a differential diagnosis of septic arthritis and osteomyelitis. Now, the simple X-ray shows you fragmentation and collapse of the bone in Charcot's. Diagnosis becomes very, very simple. Now, this is gout. Most of us must have seen. Now we are seeing increasing number of gout, perhaps diabetes associated with them. A lot of people with diabetes have gout now, part of the metabolic syndrome, hyperuricemia. More than 9 we treat. Unless it's symptomatic, we don't treat. Asymptomatic, more than 9 we treat. And the concept that diabetes increases risk of gout still remains controversial. However, a 3 years community-based study revealed that 16% of patients with diabetes develop gout compared to 2.7%. So there's definite interlinking between them. But again, cause and effect relationship has not been established. Bone involvement, this is very interesting. Osteoporosis and fragility factors is something we should be aware of in diabetics. And the other one is called DISH, that is the diffuse idiopathic skeletal hyperosteosis, something where the diagnostic skills are tested of many of the physicians. So osteoporosis, most studies have reported increased fragility fractures in diabetes. But the BMD on which we base is low in type 1 diabetes, but very high in type 2 diabetes mellitus. Normally, you see a high BMD, and still they have fractures. So we know fractures have two components. One is a BMD, other one is a microarchitecture. It is believed that in type 2 diabetes, even if the BMD is high, the microarchitecture is defective. Therefore, you get more fragility fractures. And most of the community-based observations have shown that fracture risk was 24 to 63% higher in patients with poor glycemic control. Again, we come back to the same topic of glycemic control. The risk of hip fracture in patients with more than 10 years of diabetes is almost 1.19, and diabetes-related complications increases risk of fracture. Very, very important, because I know most elderly people live for long years. They become old. We have a huge elderly population. A lot of them have diabetes, and they'll get a fracture, and it is horrible treating them. And they're very, very difficult to treat. And since I told you type 2 diabetes have high BMD, what is the method by which you can say these guys have a risk of fracture? Now, how do we test for fracture? How do we test? And now, sorry, I forgot this. Sodium glucose co-transporter, which now the previous speaker was talking about, a very important drug which is being used. This was shown that what the relationship between the SGLT and type 2 diabetes and fractures. A meta-analysis and randomized controlled trials have shown there is about 78 RCTs, 85,000 patients showed that canagliflozin seems to increase the risk of fracture, while other SGLTs do not result in higher incidence of fractures. This is a new drug people are using. This they have to understand and remember. Now, what's the mechanism of fractures in diabetes mellitus? Again, same thing, based on multiple factors, bone intrinsic factors like accumulation of AGE, low bone turnover, changes in bone microstructure, which I believe is type 2 diabetes. And there are extrinsic factors, there are other complications like peripheral neuropathy, hypoglycemia if the patient on an insulin, muscle weakness because of sarcopenia weakness, and visual impairment, the trip and fall. So fall is a very, very important concept in fractures. Assessment of diabetes type 2, most of the other ones you can make very clearly. DEXA and FRAX are very good, but here is the problem. The DEXA is high, FRAX cannot tell you without the normal DEXA. So the assessment is difficult. So the two other things have come in, what is called a trabecular bone score. It's based on a DEXA, but on the lumbar spine, and it's based on some calculations where you can do what is called a trabecular bone score. There's no porosity of the trabecular bones. The other one is called a quantitative CT. This again deals with the peripheral bones, and they can suggest possibility of poor microarchitecture in the bones. Otherwise, these two are rarely done in India. Microindentation, you see what is the resistance of periosteal bone when you put a probe in, that suggests poor microarchitecture. And of course, biomarkers, there are several, but very, very expensive. We rarely use biomarkers in our practice because of its cost. So these are things, but two things, the history of diabetes type 2, and then if you can do a trabecular bone score or a quantitative CT, which is available, you can suggest. And so what we need now is a better stratification criteria for diabetes fracture in type 2 diabetes, and also how to deal with these patients when they do not have a low DEXA, low bone density. This is called DISH. And as you can see, those bones protruding out, they look exactly like ankylosing spondylitis. The patient comes with very, very stiff back, cannot bend forward. But the beauty is it is very thick. These are osteophytes, actually, calcification and ossification of anterolateral ligament spine. Prevalence is very high in diabetes, 5 to 50% higher than general population. Patients have stiff spinal stiffness, low backache. So easily, I've seen hundreds of patients, they come with us X-ray like this and say they have been diagnosed with ankylosing spondylitis. Although there's no feature, doesn't fit into the classification criteria. All they need is, again, control of diabetes, good physiotherapy, rarely NSAIDs, and sometimes surgery if there is compression of the roots or the cord. Finally, the muscle involvement. Diabetic sarcopenia is something that we see nowadays, poorly controlled, and diabetic myonecrosis. Now, sarcopenia has now been related as a chronic complication of type 2 diabetes mellitus, and its reduction in muscle mass. There are quite a few patients who have very quickly, they lose the muscle mass and associated with decrease in muscle strength. It is 3 times more common in diabetes compared to general population. Associated with higher hospitalization, cardiovascular events, and mortality. It could be reversible through musculoskeletal rehabilitation, but I'm not sure it does the kind of rehabilitation that we do here. Yesterday, I think there was a talk on this.
Where talk on sarcopenia.
Type 1 diabetes, spontaneous infarction, acute sub.
Hardik, what is the problem?
Sir, I think internet problem for Bidyu sir side.
Okay, then Bidut, I would suggest Professor Chaudhary, if there's a problem, Bidut, how many slides are left? Bidut, are you listening? Bidut, can you ask on phone, Jayant or Surinder? I don't have Bidut's number.
So can you hear me now?
Yeah, now you're clear. Yes, Bidut, you are clear. I was trying to reach you, Bidut. Yeah, how many slides are left? You can continue, no problem. Continue.
Last slide.
Last slide.
Can you see this slide?
No,
Not yet. Just start sharing.
Yes, just go.
I think it was disconnected. Yeah.
Yeah,
Last slide.
now it has come, Bidut. Now it is very clear. You can go for the previous slide to that, because that was very new thing which I also saw in Calcutta. But put the previous slide also kindly put, Bidut.
Previous slide.
Previous slide. That is a new entity, and I happen to see one in Calcutta. I'll show you.
Sarcopenia.
No, my necrosis.
Necrosis.
Fantastic entity. Yeah. Please start with this, and then we'll finish.
So sorry, there was some problem, and I believe in Murphy's law. If something has to go wrong, it will go wrong. You can't do anything about it. That is Murphy's law.
Absolutely.
Even if I sit in telemedicine hall and with all facilities, gadgets, if something has to go wrong, it will go wrong. So diabetic myonecrosis this is a case I've never seen. I've seen all other cases. This is something I've never seen, and they come acutely, with swelling of the calf and thigh muscles because of infarction, and invariably they are treated as DVT or myositis because of the acute onset. There is increased CPK, ESR, CRP, MRI can help, but it's self-limiting. I have no experience on this, so I'll not be able to go further on this. Next. So what's the take-home message that we have? I have established from the very first case that I showed that we can miss these cases if you do not think about that diabetes and MSK can be closely linked. So there's widespread MSK affection in diabetes. And I just went through the different aspects, the soft tissue, the joint, the bone, and the muscles. Subclinical, if you pick them up at very early stages, associated with long duration of disease and poor glycemic control. That's the bottom line. And some of these people, if you help them, they can get very good quality of life. A majority of problems are soft tissue related and non-inflammatory. The first case had no inflammation. And I don't know why people still stuck to looking at inflammatory diseases and multiple myeloma, etc. A diagnosis is obviously based on good clinical assessment, not on all the investigations. I'm really amazed. I was amazed to see the kind of investigation that has been done on that patient. You just need good clinical assessment and a correlation that diabetes can present like this. These are the diseases that can occur. And good glycemic control, early diagnosis, that's all you need. And when they come to us, analgesics, partially they get relieved, the NSAIDs, sometimes their inflammation, because diabetes and inflammations are almost linked now. Physiotherapy is mandatory, which nobody does. No matter how much you induce them, they'll do it for 5 days, 7 days, and then they lose interest. They want dramatic results with medications. Local steroid injection in some of the conditions like trigofingerol, dramatic, they get response, very good response. And of course, it becomes so late, sometimes surgery is what they require. Thank you very much.
Thank you, Dr. Das, for enlightening us about the new things, and diabetic myonecrosis. Diabetic myonecrosis, is it resolved after diabetes is controlled?
In fact, basically you have an infarction. So following an infarction, it gets resolved. The way we have strokes and they get resolved in good time. But with diabetes control, they do not recur. It's a very rare entity. You don't see too many. Don't see too many of them.
Yeah, I think Vidit, you are correct. It is very, very rare. And Calcutta has reported 2 cases. Once I happened to see when I went for examination, and it is to control diabetes. That's the only thing you can do. Nothing much. You're absolutely very, very rare.
Very excellent information, sir, and good presentation and guidelines for the people dealing with diabetes. They have to keep an eye and should not unnecessarily medicate people because the majority of the problems related to soft tissue, not inflammatory, or and then the timely they have to detect physiotherapy and the local intralesional therapy may help.
Actually, I wanted to tell one simple thing. As most of these patients actually come by orthopedicians. By the time they come to us, it's pretty late. So we miss them. The bottom line, second thing is, other than good control, is physiotherapy. I don't know why people are not sticking to physiotherapy. It's a very wonderful thing. A lot of things can be resolved with good physiotherapy, but patients don't stick to physiotherapy for a long time. And therefore they come
very
back.
True. Sir, very true, sir. Actually, in India, people think that the only medications will help, not the physiotherapy. They listen to doctors only.
I think Alok has a point. Alok?
Yes, thank you, Vidyut, for excellent talk.
Yes, sir.
One thing is the way you have presented, the job of diabetologist is now increased and physicians. They are the prime referring physicians who should do the basic test and then decide whether it will go to orthopedician or to immunologist. So I think the role for diabetologist and endocrinologist and physicians is much more now. Thank you for the excellent talk.
Thank you.
You are right, sir. And we have very interesting panel discussion. I am sure it will be very informative with faculties like Professor Das and Manisha and PK Shah, sir. We'll go to the next session, and we welcome Dr. Rajiv Chawla. Welcome, sir. After the third talk, we'll go. And I request Professor Das, we have a very interesting session on autoimmune and diabetes, autoimmunity and diabetes.
PK Shah has not arrived. PK Shah has not arrived.
Yeah,
Yes, I'm there. I'm there. I'm there.
Not PK Shah.
Can be there. That will be very informative.
Next is Dr. PK Sahu, no?
PK Shah, sir, has arrived, sir.
Yeah. So we can have his talk, Jan. Then we'll have the.
I request Manoj Shah to introduce Dr. PK Shah, sir, and he'll share his slides.
It's a pleasure to introduce Dr. PK Sahu. Dr. PK Sahu is the head of the department of Apollo Hospital.
Sir, namaskar.
And we have heard him many times, and he's very precise in his subject. He'll be talking on heart failure prevention. And diabetic people, the diabetic patients silently die due to myocardial infarction and heart failure. And many times we miss those things. And he will be enlightening us with the few points. It is seen that 9 to 20% of the diabetic, they suffer from heart failure. So how to prevent it? Dr. Sahu will enlighten us. Dr. Sahu, please.
Mayank, please see is coming from some attendee. Kindly mute him.
Yes.
Dr. Sahu?
Yes. Are the slides visible?
Yes, sir. Visible.
Thank
Full
you.
screen.
Thank you, NUCD, for inviting me to give a talk. In fact, I was a little bit puzzled about when I was supposed to talk on heart failure prevention, because this is a very important aspect that we all should know. And why is heart failure prevention necessary? In 1933, Lewis had said that the very essence of cardiovascular practice is the early recognition of heart failure. I highlight the words early recognition of heart failure. This is what we as physicians, as endocrinologists, as diabetologists, and as cardiologists first somehow have to recognize heart failure. Now, if you try to see the cardiovascular continuum, which you are all aware of, these are the major 4 risk factors, whether this is diabetes, hypertension, atherosclerosis, smoking. These all ultimately lead to atherosclerosis. Just a minute. These all lead to atherosclerosis. And when atherosclerosis sets in, it all leads to coronary artery disease, ischemia, thrombosis, reduced contractility, remodeling, finally heart failure. My job is today to see that where we can stop this continuum so that we can prevent heart failure and our patients do not go to heart failure. To discuss these issues, I'll be bringing some luminaries who will be asking certain questions. This gentleman is always in the news for no reason or some specific reason. If you ask the question, is heart failure an area of concern for diabetics? Yes, it's an area of concern. Because if you'll see, heart failure increases almost 2 to 5-fold when diabetes is there. But the other conditions you see, whether stroke, coronary artery disease, deaths are also equally high, but heart failure is something which goes unrecognized. And if you try to see which is the first manifestation of type 2 diabetes-related CV disease, after peripheral artery disease, it is heart failure. And type 2 diabetes trials have shown that heart failure is prevalent in almost 10 to 30% of the patients. And chronic heart failure trials have shown almost 30% of patients. So each 4 patients you see, at least there will be 30% of your patients, 100 patients, 30% of patients who must have already gone or are due to go to heart failure. Now, what we as physicians do, or as diabetologists or endocrinologists or cardiologists do, we treat it as 2 entities. Either we treat heart failure or we treat diabetes. But we have to realize that diabetes ultimately one or the other day will go into a chronic heart failure. And this is where my topic comes. How can we prevent this? Because all these factors, hyperglycemia, insulin resistance, all these things lead to chronic heart failure in the long run. Now, what is the prevalence? For each 1% increase in HbA1c, the risk of incident heart failure increases by 8% to 36%. So 4 to 8 times higher versus non-diabetic patients. So this highlights a problem that this is really a big issue and we have to recognize this earlier. What happens when these patients go to this thing, heart failure? Usually after they're diagnosed, gradually within first heart failure hospitalization, you'll see the time span goes decreasing and soon within 4 hospitalizations, they ultimately lead to death. So this highlights the importance that heart failure has to be detected early. The next question this person would like to ask, why is it important to detect heart failure in diabetics? Let us see. Now, we have 4 stages of heart failure. These are the 2 stages, that is stage A and B, where we can do prevention. But when the patient goes to stage C and D, nothing can be done because already the patient has had signs and symptoms and has refractory heart failure. So just to highlight that as the patient starts sliding down, the patient's quality of life decreases and the mortality does increase. A great criteria he talked. If you ask you, what do we mean by early detection of diabetes? Early detection of diabetes, as per the ACC-AHA, clearly states that it is stage A, stage B, or stage C1. There is no limitation of physical activity, no symptoms. These are the patients who are at risk of developing heart failure. Of course, when the person comes to stage 2, stage 3, stage 4, these patients are easy to detect and have existing heart failure. Now, these first 2 stages of A and B are very important, and it suggests that for these patients who are at risk of developing heart failure, we can have therapeutic interventions introduced even before the appearance of LV dysfunction or symptoms can reduce the population morbidity and mortality. Now, if you try to see what are the various types of heart failure, it can be reduced ejection fraction or preserved ejection fraction. This is an entity which we have started recognizing more and more. And as we go through this entity, we have the mid-range ejection fraction or the recovery ejection fraction. Now, anything less than 40% ejection fraction on an echo, this is the echo diagnostic criteria, is reduced ejection fraction. Anything more than 50% is preserved. Between 40 to 50%, we have this mid-range or recovering, because the reduced ejection fraction can gradually improve with therapy and can go to preserved ejection fraction. Now, this gap between preserved ejection fraction and reduced ejection fraction is very little, because these patients of preserved ejection fraction have an equal bad mortality and morbidity as compared to reduced ejection fraction. So here comes the issue that we have to recognize this. We don't just recognize this entity, we have to recognize also those with preserved ejection fraction. This young, beautiful lady, actress, daughter of a very senior actor, how do we detect heart failure in early diabetes? Signs and symptoms by doing certain biochemical tests, electrocardiography, echocardiography. Now, what are the signs and symptoms? A diabetic may first come to you telling, I'm short of breath, tired, some swollen ankles, loss of appetite, coughing, dizziness, abdominal bloating, sleep disturbance. These symptoms are usually confused with other diseases and we ignore them. But in any diabetic, we have to be sure that possibly is my patient going into heart failure? And that is where we start doing an ECG. If you see a normal ECG and a patient with congestive heart failure, where the patient starts having widening of the QRS, the various parameters which are source, LA overload, LV hypertrophy, bundle branch blocks, and of course, these all indicate and gives us an idea. Suppose the patient has gone to atrial fibrillation, from ECG, we can pick up a lot of things. And the value of ECG is especially in identifying systolic dysfunction. Then let us come to the biochemical parameters. We have the ANPs, the BNPs, and the CNPs. And among them, the most important is the BNP, because what happens whenever there is a myocardial stretch, there is a cardiac cells, they start releasing the pre-pro-BNP, they become the pro-BNP, and they divide into the anti-pro-BNP and BNP. Our now labs, mostly they do all anti-pro-BNP and BNP, and we have to identify if the patient has complaints whether the anti-pro-BNP or BNP is higher. And based on that, we have to give therapy that is the neprilysin inhibitors, and these biomarkers are very important. And we have targets for these biomarkers. If this biomarker is raised, we can target the drugs. Now, the European Society of Cardiology and the American College of Cardiology have a class 1 recommendation for doing NT-proBNP, and there is more than 300, possibly a patient has gone into heart failure. But one thing of caution is that NT-proBNP may be raised in various situations. For example, in CKD and strokes, one has to be careful, but please don't go by the report that if it is more than 300, it is always this thing that is heart failure. There is the age variation also. For example, less than 50, it should be more than 450, 50 to 75, more than 900, more than 75, more than 1800, then only you think of heart failure. So please analyze the NT-proBNP reports very carefully. Now, it has been shown that if the NT-proBNP is high, then the chances of mortality and the recurrent heart failure hospitalization is also high. So after ECG, the biochemical parameter is very important. There have been various newer biochemical parameters, the ST2, galactine, microRNA, procalcitonin, MMP, but we don't have an access to all this except in the ST2. The soluble supplement tuberculous ST2 has shown to be associated with adverse outcomes in heart failure and predict mortality risk. In fact, the PRIDE study showed that if the ST2 values are more than 0.2, they have an increased risk of death at 1 year. And please remember that inferior to NT-proBNP for diagnosis of heart failure, it only suggests that what is the mortality or the outcome. And this ST2 is now available in many labs and it can be done. Echo in 1972 is just when Echo started, it was just the M mode, and in 2023 you have to spend almost 40 minutes on Echo because you do the M mode, a 2D, a 3D, a diastole, a strain, a contrast, a Doppler, and there are various factors which can be seen and which can detect. I won't go into all these details because these markers, there are echo markers where you can do phenotyping and prognostic assessment, and also we can know the additional marker for the prognosis. Now, echo has advanced a lot and has, in evaluation of heart failure patient, it picks up early heart failure patients. Besides that, the scoring system, the HFpEF system, in which there are various parameters, whether the body mass index, hypertension, atrial fibrillation, pulmonary hypertension, elder, and filling pressure. So you have a score of 9, and if the patient has a score more than 4, the chances of heart failure is very high. So clinically also with echo, you can also know whether the patient has got heart failure or not. These are the various parameters, let them the clinical, the laboratory parameters, the ECG parameters, the chest X-ray, the echo parameters, which all, if compounded, can show very sensitive indices for detecting heart failure early. Now, this was in 2022 when an update came that if the patient is stage A, try to see for the risk factors, go for a proBNP. If the proBNP is normal, again ask the patient to come after 1 year. Stage B, already when dysfunction has started, either the earliest to occur is diastolic dysfunction, then again you go for a proBNP. If it is elevated, go for various imaging, especially echo, and if it is yes, your patient is in heart failure and needs to be treated, because anytime your patient of stage B can go to a stage C or a stage D. Now, why managing heart failure is a challenge in diabetics? Because picking them up is very important, and then also managing them. Now, it is seen that what we as physicians do, we treat both of these as different entities. We have to think about each diabetic possibly having heart failure. And this is one of the most dangerous disease combination in modern medicine, making the treatment more difficult because you have to be very prudent in choosing the drugs. The next important thing, we have very limited drugs which can prevent heart failure. And many hypoglycemic drugs have been found to have a potential CV risk, which are not conducive to heart failure. So we have to be very selective in drugs, and therefore it's necessary to further explore the treatment plan of diabetes mellitus combined with heart failure. Now, how do we prevent heart failure diabetes? If Kamala Hassan would ask, definitely we have to remember whether it's a rich or the poor, all hearts are equal. And the first basic concept that should go that lifestyle modifications are very important. No smoking, a proper diet, could go away with stress, do exercise, do yoga, do meditation, and this will possibly help more than 50% of a patient. And as Professor Das was telling, no one wants physiotherapy, no one wants also lifestyle modification. They just want drug. And as you see the 2022 stratification, first was stated that there's a lifestyle modification diabetes, and then we have to have glycemic control, blood pressure management, lipid management, and agents with cardiovascular kidney benefit are very important. Now, great personality. We all awe at him. Are there drugs that can prevent heart failure? Yes, there are drugs. And when SGLT2 came, it was a big step forward because we started thinking that possibly with this SGLT2 inhibitors can work on this cardiovascular continuum, and it can prevent atherosclerosis. Now, how does it prevent atherosclerosis? This is a narrative review from Nature, which showed that a host of mechanisms and all this help in having prevention of atherosclerosis, and these drugs do modify atherosclerosis. And atherosclerosis is the first stage where the heart failure begins. And if you can start this drug early, these are definitely preventive drugs. Moreover, these are animal models which showed that you can see the intimal thickness when they put on SGLT2 inhibitors versus non-SGLT2 inhibitors. The intimal media thickness decreased when they were put on SGLT2 inhibitors, and this was something very interesting that appeared last year, giving us more confidence that these drugs could prevent atherosclerosis. Intimal media thickness is prevented by DAPA. Now, diabetes-induced myocardial injury markers, the increment was also halted by DAPA. So these were the new evidence that we're getting. And more importantly, recently we've got evidence that DAPA can stabilize diabetes-induced atherosclerotic plaque instability. This is very important. So in the mouse model, which was done, and histopathology studies has shown that if you start DAPA early, you can do a plaque stabilization. So the next question comes, can it prevent myocardial infarction? Yes, it has been shown that it can prevent myocardial infarction. And this was on the rabbit models. You see the control tissues of the heart, what happens in a diabetic, the myocardium. And if you put DAPA, it is almost comparable to the control. So it gives us more evidence. Of course, these are on animal models. These are new studies that are coming up, and also highlights the fact that in the diabetes, if we use SGLT2 inhibitors, definitely it does not become fibrotic. So it is the anti-fibrotic drug which has to be started early. Next, can it prevent heart failure? Of course. The first trial to do was the DECLARE TIMI58, which showed that if you use DAPA, it did prevent renal composite burns, the deaths, the major adverse cardiac events, and cardiovascular death and hospitalization from heart failure. And it all results in a lower rate of cardiovascular death and hospitalization from heart failure, highlighting the fact that DAPA is started early, can prevent heart failure. So the ACC-AHA came with the guidelines that 3 randomized controlled trials have shown that SGLT2 inhibitors can reduce heart failure and can be extended to primary prevention. This was something very important and gave us insight that in 2019, we have taken a big step ahead in having the SGLT2 inhibitors in preventing heart failure. Then came the guidelines from 2018 to 2016. All guidelines started stating and upgrading the use of SGLT2 inhibitors in prevention of heart failure and in treating heart failure. The other trial, which you're all aware, is the DAPA heart failure study, which clearly showed that if the patient has gone into heart failure, if you put these patients on DAPA, they do well. Then came a big leap forward. And this was ARNI, or the sacubitril valsartan combination. And the 2022 Heart Failure Society of USA and the ACC-AHA clearly stated in patients with heart failure class 2 to 3 symptoms, use of ARNI is a class 1 recommendation for morbidity and mortality reduction. And you have to use ACRB where ARNI is not feasible, or patients with intolerance to ACI because of cough and angioedema, but ARNI is a class 1 indication in patients. So use these 2 drugs, which were previously used as the class 1 drugs. They have been replaced by ARNI as the first drug. And it has been shown that when you use ARNI, there is significant decrement in the NT-proBNP levels, almost 25% reduction in NT-proBNP levels in SAC-VAL combination compared to enalapril, diabetes, and heart failure. So if you detect a patient who is having a high proBNP, you have to put them on the SGLT2 inhibitors and have to put them on the SAC-VAL combination. And let us see which scores best. This was a mortality benefit of ARP, AC inhibitors, and you see ARNI. ARNI has the maximum mortality benefit so far as this thing that is heart failure is concerned. So we have to take evidence which is before us and go ahead with the treatment. These 2 gentlemen could never make a ministry. So with the question comes, can we have SGLT2 inhibitors ARNI to prevent heart failure and diabetics? Yes. The EAC 2021 guidelines clearly states that SGLT2 inhibitor has to be added with SAC-VAL for patients who are prone to diabetes or have a heart failure. And also this has been endorsed by the ACC 2022 guidelines. And it was seen that when there was a comprehensive therapy of both these drugs, the cardiovascular death, the hospitalization, and the all-cause mortality was significantly reduced. So comprehensive therapy halt or delay clinical progression or heart failure with reduced ejection fraction patients compared to conventional therapy. The thing again went further that these studies like the DAPA heart failure, the Emperor heart failure clearly stated that this combination is much better than giving single drug. So as practicing physicians, we have to move with science and possibly think of this combination. And the pooled meta-analysis clearly indicates that there is a 32% lower occurrence of CV death or heart failure hospitalization, heart failure with reduced ejection fraction when SGLT2 inhibitors are combined with a SAC-VAL combination. A very famous personality because she married one of our famous actors, Priyanka Chopra, Nick Jones. What is the pharmacotherapy to prevent heart failure and diabetes? These were the fantastic four for which I have been proposed now as the great things. And these three drugs have shown that these are the interventions which has to be given to prevent heart failure and in patients with diabetes. A person who ruled a good economic politician who will ask what are the tips and tricks to prevent heart failure. Definitely, this is what is done. In stage A, the primary care physician, the dietitian, endocrinologist have to see that assess it, and they have to start the patient on SGLT2 inhibitors with ARNI, of course. And in stage B, we have to be very careful in medical management. You have try to avoid DPP4, thiazolidines, and sulfonylureas, and try to stick to SGLT2 inhibitors as the most important thing. And most importantly, do a biochemical test and an echo to diagnose your patients. Now, why was I showing all these personalities? They have something in common, and that was diabetes. All these big personalities, whether politicians, film actors, musicians, all have diabetes in common, and they had to fight and are leading a good life in spite of their diabetes. So if you ask me the question, can heart failure and diabetes be prevented? The answer from my side is a big yes. Detect early, treat early with appropriate drugs, and you'll definitely see heart failure can be prevented. Thank you very much for the patient hearing.
Thank you, Professor Dr. Sahu, for that lucid presentation. Only thing is that diabetics, when they are presented to ICU as a sepsis case, there are many times we see that NT and pro-BNP is much higher. In those, what will be done?
See, NT-proBNP can be high in many cases. Even you see in kidney failure, in a stroke, all these things you have to be very careful in interpreting the NT-proBNP levels. So just don't go by NT-proBNP. Try to take resort to other investigations like your this thing that is echo, your ECG, your chest X-ray, and your clinical acumen, of course. So if you tell me that we should not be guided directly only with investigations, we have to think the patient, see the patient clinically, and also resort to especially echo in diagnosis.
I think Professor Chotrai now will pass on to Dr. Bharat Panigrahi, who is the moderator for the question answer, and you all join him.
We had a very impressive session. All three speakers have done very well in passing on the message in a very limited time. So now the panel discussion will be very interesting, and I request Professor Ashok Das also to be there during the panel, and request Dr. Bharat Panigrahi and invite Dr. Rajiv Chawla. So please,
Rajiv, please join. Rajiv, please join.
Thank you. Thank you,
Dr.
sir.
Bharat Panigrahi is MD Medicine and a fellowship in multiple fields, rheumatology and pediatric rheumatology also. He is a consultant in internal medicine and rheumatology at KR LV Prasad Eye Institute and Amri Hospitals, Bhubaneswar at present. He is the immediate past president of API Odisha, and he will be moderating this interesting session of nephrology, rheumatology, and cardiology together. So let us start with, and before that, I invite Dr. Rajiv Chawla to the panel. And we have Dr. Chawla, who is a known figure in national level. He is the past president of RSSDI, and he has multiple accolades.
Thank you. We can.
So, just a request to Professor Bharat Panigrahi. We are running 40 minutes late. Kindly ask the speakers panelists to be very brief and specific.
Thank you. Thank you. Thank you, Alok.
Bharat, please start.
Yeah. So thank you, Professor Das, and all the three speakers who have done excellent job.
Good
And
job.
yeah. So let me start with Dr. Manisha Sahai.
Manisha, sir. Manisha.
So Dr. Manisha, you have shown in your slides regarding albuminuric and non-albuminuric kidney disease. Fine. And of late, during the last decade or so, we are coming across with a lot of cases of non-albuminuric kidney disease. Okay. So the pathophysiology, the line of treatment, I think everything is different in case of non-albuminuric kidney disease than the albuminuric kidney disease. So will you please highlight how to manage a case of non-albuminuric kidney disease?
Yeah, so thank you for that question. So this is an emerging entity. 20% of all patients with diabetic kidney disease have non-albuminuric diabetic kidney disease. So it's a huge number. And as you said, the pathophysiology is different. It is more related to inflammation and macrovascular disease rather than microvascular disease. Therefore, microalbuminuria is not there, retinopathy is not there. Mostly you have associations with coronary artery disease, strokes, so macrovascular disease. So as of now, it's difficult to diagnose. You have to only look at the GFR. GFR will be low, but albuminuria will not be there. So that's the only way of early diagnosis. It progresses slowly as compared to the albuminuric variety. And most of the drugs we have, for example, RAS blockade, should we use them in albuminuric or non-albuminuric? Albuminuric, definitely we use them. What about non-albuminuric? Evidence is not very clear, but you can use for other pleiotropic effects of RAS blockade. So we still continue to use them. SGLT2, also we use the drug because they again have multiple mechanisms of action, not only control of albuminuria. So as of now, the evidence supporting the use of these drugs, what we use in albuminuric diabetic nephropathy, is not that strong for non-albuminuric diabetic nephropathy. We will get more and more evidence later on. Nowadays, we have finrenone, which acts on the inflammation part of it, aldosterone part of it. So diabetic nephropathy has many pathogenesis. One of them is through the albuminuria route. So we still continue to use all these drugs. And again, the lifestyle measures are important for non-albuminuric disease as well. So the whole important thing is that we check the albumin and do not check the GFR. Then what will happen is we will miss the non-albuminuric nephropathy. So do both and treat them as of now similarly.
But regarding the RAS blockers, RAS has little role in case of non-albuminuric kidney disease. Number one. Number two,
the role. It is not to say that they don't have any role. We cannot say that there is no role of RAS blockade. That statement is wrong. The albuminuria part role is not there, but RAS have other benefits also. They also have anti-inflammatory effects. We all know the pleiotropic effects of RAS blockade, so they can still be used. But as you rightly said, the evidence for their benefit in non-albuminuric is far less than in albuminuric. But you should still use them. It's not that you diagnose that and stop it. That's not the correct thing to do, because RAS also reduces the intraglomerular pressure, the hyperfiltration. All those is also reduced by RAS, which is a component of non-albuminuric diabetic nephropathy as well. So as of now, the evidence is evolving. So much highlight is there on non-albuminuric nephropathy to point out to the physicians and general practitioners that do not think there is no albuminuria, there is no diabetic nephropathy. There still might be diabetic nephropathy. So check for albuminuria as well as GFR both. So that is the importance. And all the treatments we use for albuminuric, use for non-albuminuric. But
we can go to second question, Bharat.
No. Even in case of albuminuric kidney disease, the range from 30 to 299, the role of RAS blockers again is modest. It is
absolutely
only,
that's what I said.
Yeah. So that's why
Yes.
Is there any absolute indication for renal biopsy in this setting?
So if you are sure that there is many of these patients, that's an excellent question. They don't have retinopathy. So as far as the evidence goes now, such patients where we have a low GFR, absence of retinopathy, we tend to do a biopsy. So many of them, though it's not diagnostic, but still at least you can find out if you are missing out on other non-diabetic kidney diseases. Nothing else is there. The biopsy still shows diabetic nephropathy. You are doubly sure. that it is probably non-albuminic diabetic nephropathy.
Okay. So last question to you. You have shown in one of your slide the upcoming drugs, because now everything we are target oriented. Okay. So you have shown regarding the PCSK inhibitors, regarding the age inhibitors, regarding the TFG beta inhibitors. So what is the status? What is the future of these drugs in 2-3 lines? Can you tell me?
So as of now, they are all under trial, and many of them are under randomized control trials. They are not in clinical use. The latest entrant has been the Finrenone, which we already know. So apart from SGLT2 and the GLP-1RA, the other drugs, so many of them are there. You have the PKC inhibitors, you have anti-endothelin drugs as well. As of now, they are not a part of the guideline so far. So probably another 2-3 years down the line, you may have some of these drugs which will be an addition to our armamentarium for management of diabetic nephropathy.
Thank you. Thank you. But you,
Bharat, I have one question, if you kindly allow me. Question, Manisha. I know that we had, I'll ask a very pointed question, Manisha. If it is wrong question, then you change the question to what should be a correct question. We start Finrenone at what level of GFR? Or we can't start with what, 26? Minimum 26? What's your take on that, Manisha?
25.
25, don't say.
More than 25.
Yes. Finrenone is available in 2 doses, 10 mg and 20 mg in India. And GFR is more than 60, you can start with 20 mg. GFR between 30 to 60, generally 10 mg. And between 25 to 30, be mindful of potassium and all that, and still you can start with a dose of 10 mg.
And
so
my second question is SGLT2. What is your GFR level at which you will take, what's your take on GFR versus SGLT2 prescription in DKD?
Question again, sir. So now initially when we started the SGLT2 whole thing, credence trial and all, the cutoff was 30. Then later on, after the DAPA CKD, the GFR came down to 25.
Yeah,
and now after you have the recent trials, now it's 20. So 20 GFR and above, you can start the SGLT2 inhibitor.
Good. Thank you, Manisha.
One thing just to continue that once you've started it, you can continue it even if the GFR falls. So GFR 15, 18, you can still use it till the patient goes on dialysis.
Thank you.
One thing, you have shown a case. So after SGLT2 inhibitor, you added GLP-1 agonist. Then you added Finrenone. You are a treated case of CKD. Why did you add GLP-1 agonist, not Finrenone directly? Because GLP-1 agonist is only indicated if there is poor glycemic control even after SGLT2 inhibitor. So here is a case of only CKD. So why not after SGLT2 inhibitor direct Finrenone without adding GLP-1 agonist?
Excellent question again, sir. So GLP-1 agonists, as you know, are renoprotective, and we have multiple trials to support that. You have Pioneer, Sustain, so many trials are there. So GLP-1 act through the sodium hydrogen exchanger pathway, and they are also renoprotective. So as per the KDIGO consensus guidelines, SGLT2, if not tolerant, GLP-1RA, both for cardio and reno, and then Finrenone. So as of now, Finrenone, it's up to you. You want to add Finrenone directly after the SGLT2, it's fine. But remember, Finrenone benefits more for the proteinuria aspect, not regarding the stabilization of GFR. GLP-1RA do both.
But ADA guidelines say after this ACE inhibitor and ARB, add SGLT2 inhibitor, then go to Finrenone. Then not GLP-1 against in between.
KDIGO guidelines. Yes. So KDIGO guidelines put it a little bit differently. They say GLP-1 and then Finrenone. So probably it's a matter of time. We'll have a consensus among all guidelines as well.
Okay. Thank you. Thank you. So next stage our
Vidyut
Babu. So welcome, Vidyut Babu. So you have really described so nicely that I don't dare to ask you any question now. But I will ask. Definitely, I will ask. I will not leave you. So
you know the answers.
So you see, we are dealing with diabetes here. Diabetes and its complications, musculoskeletal complications. So all these complications are diabetes related. So do you feel that only glycemic control will in these complications will give a good outlook of these diabetes complications, or it doesn't have any role?
I said right from the beginning that there are multifactorial causes. And I also stressed that controlling diabetes is very, very important. Controlling glycemic control is very, very important. Most epidemiological studies have shown that if you have a good control of diabetes, these musculoskeletal disorders may be retarded. They may not be stopped, but they may be retarded. The progress may be retarded. So basically, the first, and when we talk about control of any complication, I think the top order is control of sugar and control of glycemic control. That's very, very important.
So why I am asking this question to you, because most of the, not all, most of these complications are the duration related complications. More the duration, these complications are, as you have already shown, that these are all age related. Because what is the pathogenesis? Pathogenesis is, that is the advanced glycation and products and linking collagen. That in the early part of the disease, if you control the diabetes, then there will be reversible. But in the latter part of the disease, these are not reversible. So even if you control the hyperglycemia, this link is not reversible. That's why many studies show that even if you control the diabetes, it doesn't have any effect on the outcome of the disease. That's why I wanted to give your expert opinion. Because yes, in the early part of the disease, that has some effect, but in the latter part of the disease complication, these are not the glycemic control doesn't give a good outcome.
Bharat, can I come in for a minute?
Yeah, yes.
The thing that he described beautifully, Vidyut, that spontaneous myonecrosis, Vidyut, and I would like to take my friends that I had a chance to see one case. It's a spontaneous myonecrosis that occurs usually in the calf muscle or thigh muscle. It is not related to the acute thromboembolism, nor related to any vehicle, any vessel block. So it occurs spontaneously. It is the death of the muscles, as Vidyut really said, and it presents with acute or subacute pain, with swelling and also tenderness. So it's present like a mass. And the diagnosis we made was by biopsy. And the biopsy classically will show the closing of the capillaries and closing of the arterioles. And this is a very rare entity, as Vidyut rightly pointed out. One has to be aware of this. And I also saw another case in the this rare disease, myonecrosis. Thank you very much. The last question to you is the relationship between the diabetes, musculoskeletal system, and inflammation. Because diabetes, everything is inflammation. And Vidyut, you are otoproto. You are buried in throughout in inflammation. So what is your take on that? Diabetes, musculoskeletal disease, inflammation.
Sir, I did tell you that very shortly we are going to have a very good interaction between immunologists and diabetologists. This is coming very soon. And what I see, the number of immunological factors that have come in, inflammation is going up. So there's a very close relationship. Now we say diabetes is an inflammatory disease, and I would not be wrong if we say
exactly same thing I'm coming to.
So
absolutely.
So much of inflammation, so many immunological inflammatory markers. I'm very sure it has a very big role to play in musculoskeletal.
Exactly. Thank you very much. And Vidyut, be in your gang and also join our gang.
Okay.
Rajiv, any comment? Rajiv?
I think
my last question.
Dr. Vidyut Das' presentation was wonderful. I mean, you very rightly said myonecrosis and certain new things. We already knew that there is an advanced glycation end products and inflammatory disease of the tendons and fascia, leading on to all those different contractures and everything. But certain things were unique in his presentation. We haven't seen honestly. So we have heard about it, read in literature, but certain of his presentations were very, very good. I think it was wonderful.
Okay, my last question to Vidyut Babu. You have very nicely described regarding the adhesive capsulitis or frozen shoulder. So one question in doubt, because NSAIDs are being used rampantly for pain relief in these cases. But there are many studies which say that the role of NSAIDs is not that robust. So what is your comment on that?
I'd shown there are 3 phases. The initial phase is painful phase, and then you have a restrictive phase. Then gradually it goes into a fibrotic phase. The initial stages, there is inflammation. And that is the stage. If you give anti-inflammatory, if you can inject the shoulder also, you get good result. And we know inflammation is there in a lot of these conditions. And shoulder joint especially, people don't come. They come very late. They come only fibro state, and then they say, do something. That at that point of time, NSAIDs and local steroid doesn't have much effect. Their physiotherapy has a vital effect. And again, I must reiterate, I do not know why Indians are so wary about physiotherapy. This concept of physiotherapy has to be drilled into the minds of the patients. Very, very important for all of in our field, especially. We know physiotherapy is so vital, but unfortunately, people don't accept it. So that is the stage.
Okay.
Professor Das, there is a general feelings among diabetologists and physicians that why did that orthopedic surgeon give injection in your joint? It will cause sepsis, this, that. So that prevents many diabetologists and physicians to advise for injections. What is your message?
Which conditions?
Frozen shoulder, adhesive capsulitis. Adhesive capsulitis. Frozen shoulder.
Initial stages, it is nice to give an injection, and that actually works very well. In my experience, people who come, they come very late. But people who have come early and we have injected, they have done fantastically well, and especially associated with physiotherapy. The sugar levels may go up a little bit, I'm sure, but it comes down after a certain period of time.
Absolutely.
But agent patient has a right shoulder affection, he cannot even eat his food, he cannot lift his hand, he becomes a cripple. And then you ask him to, at a later stage, to do a surgery, and that is still worse in a diabetic.
I think subsequent physiotherapy really helps subsequently after an injection.
We had a physiotherapy graduate did a thesis on this, comparing physiotherapy and you know, it is excellent. He had actually 40 cases.
Okay.
Mohan Krishnan. He has published that also.
Yeah.
Okay, Dr. Prasant.
I thought you would have
Excellent talk by PK Sahu. Please ask him questions, Bharat. One or two questions.
Dr. Prasant, you have shown this prevention of, we are talking of prevention, maybe primary prevention, maybe secondary prevention. Okay. So primary prevention of heart failure, they have shown the lifestyle modification, fine. But the landmark trial, look ahead trial, that which was a completely supervised trial, but that didn't show any benefit of any cardiovascular disease benefit or heart failure benefit. So what's your comment on that?
Nice question, sir, because Look Ahead trial was in fact funded by the National Institute of Health. They had 2 arms, the intensive arm and the diabetes support and education arm. But if you try to go deep into the study, you'll definitely see there are some flaws in the study. Most of the patients who were enrolled had a choice whether they would go for diet or physical activity. And these physical activity was not done under supervision. They were allowed to do at home. Next thing is that only if you see the amount of patients who were enrolled were hardly around, I think 15% cardiovascular patients. Others did not have any disease. But as a result of the 9 years follow-up or in between 9 to 10 years follow-up, they clearly showed that there was definitely some improvement in so far as the weight reduction was considered, so far as the glycemic levels or as the lipid levels, all were improved. So let us not go by the fact that the Look Ahead trial shows that even if you put physical activity, etc., you'll not do harm to the patient. So those are a wrong concept because the trial design was wrong. In fact, if you try to analyze and you read the criticisms about this trial, they have clearly stated that these patients, those who are above 65 years, they were more effective because they were more stringent to this thing, that is physical activity diet that was proposed. But the younger population did not do well because they were not caring about the diet, etc. So just please don't be misguided by the fact that the Look Ahead says that no, it is not, it is lifestyle modifications don't work. In fact, lifestyle modifications do work. If you go between the lines of the Look Ahead, it showed that there was definitely good glycemic control, lipid control, and in the long run, the patient did well.
Thank you. So far as SGLT2 inhibitors are concerned, yes, SGLT2 inhibitors is a part of treatment of heart failure. There is no doubt in it. But so far as prevention, okay, once heart failure is there, and if you give SGLT2 inhibitor, it will retard the progression. But what about the primary prevention? Do you feel that all the patients should be given SGLT2 inhibitors? All the diabetes patients should be given SGLT2 inhibitor to prevent heart failure? What is your role as a primary prevention?
If you ask me this question as a cardiologist, I'll tell yes, because it has been shown that we have to know what is the mechanism by which SGLT2 inhibitors work. Basically, it is not the diabetes control that I am interested about. It is the fact that it prevents atherosclerosis, it works as a diuresis, it decreases LV mass volume, and of course improves the endothelial dysfunction. And this is what a cardiologist wants. Ultimately, diabetic patients will land up in atherosclerosis. So you must have been seen that nowadays it is said that SGLT2 inhibitors were the first line drugs along with metformin. So as cardiologists, I will definitely agree that it has to be put in the primary prevention drug. And you'll see the guidelines are changing, and our AHA, ACC heart failure guidelines have already put it much higher up and has thought that SGLT2 inhibitors have to be used once a patient is detected as a diabetic, and moreover, it's a very cheap drug now with less of side effects. So why not put them early?
But the guidelines differ. Anyway, it is now all the panelists have to comment on that.
I think Bharat will close. We are 40 minutes late because
with your comment only, with yours.
I think
Rajiv. Let Rajiv comment.
Dr. Prashant has beautifully shown the management of heart failure, the pathogenesis, how it goes about. And he very rightly said today guidelines, whether you talk about ACC or our own RSSG 22 guidelines, we have a much higher hierarchy for SGLT2 after metformin. Almost in every patient who has atherosclerotic cardiovascular disease or multiple risk factor or reduced ejection fraction. Other than that, of course, beta blocker, ARNI, and even now MRA, and with the availability of finerenone, I think we have multiple tools to handle not only the prevention of heart failure, but subsequent progression of heart failure in setting of type 2 diabetes.
I think Rajiv, you said all. I asked a question to John Bush last week in a virtual meeting. I think you were there. I asked him why, Prashant, full marks to you. I said why ESC, European Society of Cardiology, said SGLT2 number 1 in diabetics and non-diabetics. Why ADA took so much time? EAG is so tough. He said because we are very conservative. Thank you very much. But I think the message
in 2019, European Society of Cardiology 2019.
Anybody above 55 years having 2 risk factors should be given SGLT2. So I think that includes almost 80 to 90%.
Exactly.
Very true.
Thank you very much. I think to interest of time, Bharat, thank you very much for conducting so well. Thanks to Rajiv. Rajiv, thank you very much for joining. I understand. I mean, I'm extremely happy you could join. And the 3 excellence, we give a big round of applause for all the 3 talks to Manisha.
Wonderful presentation by all 3 speakers.
Great.
Dr. Manisha, Dr. Das, and Dr.
We didn't have time to talk detail, discuss about your topic, but it was great, Prashant, and you made a real difference. Dear friends, now I'll be in favor of saving time. I'll invite right away the chairperson of the next session, Shishir Babu, and Debulna Jena and Dr. D. Jena to kindly join, and Devachan Jena. And over to you. Please be conscious about the time, sir. Shishir Babu, let us start. Yes, 3 wonderful.
Thank you, Professor Ashok Kumar Das. Now this is session 8. It is definitely a continuation of session 7. And also the topic continues to be complications in diabetes. But at the outset, I express my respect and also I congratulate Professor Ashok Kumar Das and Dr. Jayant Kumar Panda in association with Chairman NUCD for conducting this NUCD from year to year gracefully. Sir, I feel and everybody feels because of your high profile stature and high profile stature others, that invites the entire national faculty as well as the delegates of the entire country and the state. Thank you very much, and please continue to maintain it. And just because this contest setting you given for 5 minutes, I will not take more time. Within that time, my contest setting will complete. So diabetes complications is well known to everybody. Now we have this diabetes related complications almost affects all the organ systems, and it is responsible for majority of morbidity and mortality associated with the disease. We have acute complications, we have chronic complications. Acute is very vulnerable to everyone. That is decay and hyperosmolar, hyperglycemic state. Now, hypoglycemia as a part of it, it is a side effect or a reaction to insulin and sulfonylureas. Chronic complications, well known, microvascular, macrovascular. But what is more important is non-vascular. Non-vascular complications of diabetes. That is infection, skin diseases, and very less, Professor Das, we are discussing on hearing loss. And the diseases associated with the increased risk of dementia and Alzheimer's. And the most important is the diabetic hepatopathy and this oral cavity in diabetes. So these are the various complications that that includes acute, chronic, then vascular, non-vascular. In vascular, again, micro and macrovascular complications. With this, we will come to the topic. In the section 8, we have 3 speakers. One speaker, Professor J.B. Kanwar, he will be speaking on hypoglycemia. The other one, Dr. Ghansam Goel, he will be speaking on diabetic neuropathy and diabetic foot syndrome. And the third one is a national famous Dr. Deepak Jumani. So it's my pleasure to introduce Professor Jay Bhanu Kanwar. I tell you, Professor Das, there is no diabetes meeting or symposium, seminar, or conference without Professor J.B. Kanwar. He is a perfect academician, a very magnetic and attractive speaker. And in the recent Odisha Endocrine Society conference, he was the chairman scientific committee with his humble, untiring effort. It attracted all the categories of delegates. So he is now the professor, Department of Endocrinology, IMS Sam Hospital. He's done his DM from Sanjay Gandhi Postgraduate Institute, Lucknow. He's working the professor of IMS and Sam Hospital. He has published many articles, reviewer of many journals, past secretary of Odisha Endocrine Society, and organized many national and state conferences. With this, I take immense pleasure to invite you, Professor Kanwar, on the topic hypoglycemia. This is a very important thing. We really neglect, we do not understand, particularly hypoglycemia unawareness. So with this, I hand over the mic to you, hypoglycemia, neurocognitive and cardiometabolic and beyond. Over to you, Professor Kanwar.
Thank you, Sisi sir. At the outset, I'm very thankful for this nice introduction. Very good noon to all of you. It's almost 12 o'clock. A good noon to Ashok sir and Professor Jain Panda and all the delegates and of our panelists sitting over here. Today, I will be speaking on hypoglycemia and its consequences. And, you know, there are many consequences of hypoglycemia, most importantly, neurocognitive and cardiometabolic. I will also speak about what are the long-term consequences of hypoglycemia, like what are the effect on dementia, what are the effect on the memory, and what are the effect on the brain volume about that. So I would start with the history of hypoglycemia. We all knew that hypoglycemia could be fatal from the very beginning with the discovery of insulin. And you can see that the small child, she is Elizabeth Hughes. She was fortunate to receive insulin in 1999 when she was one of the among all the patients who received insulin, and she continued to survive for 60 years after receiving insulin. But the interesting aspect is that Thea Cooper and Arthur Eisenberg and published this book called Breakthrough Elizabeth Hughes in the Discovery of Insulin and Making of Medical Miracle. She clearly mentioned there's a sister, there's a nurse called Blanche who used to share a bed in the hope of that Blanche could better detect and respond to a nighttime attack. And Blanche saved Elizabeth's life dozens of times with orange juices or molasses of case. So we all do understand what she was referring to. She was referring to hypoglycemia. So how do you classify hypoglycemia? This is a classification of ADA. There's a severe hypoglycemia where there are typical symptoms of hypoglycemia, which requires some other person to supplement glucose or carbohydrate or inject with glucagon level. At that time, the plasma glucose concentration may not be available, but if you supplement with glucose, then the symptoms of hypoglycemia that recovers, that satisfy the Whipple's criteria, that's called severe hypoglycemia. And documented severe hypoglycemia is where there is typical symptoms of hypoglycemia, and it's documented to have plasma glucose concentration of less than 70 milligram per deciliter. In asymptomatic hypoglycemia, there is no typical symptoms of hypoglycemia, and patient tends to check the blood sugar and the plasma glucose concentration is less than 70. Then you said this is asymptomatic hypoglycememia. And in probable symptomatic hypoglycemia event, where there are typical symptoms of hypoglycemia, however, there was no documented plasma glucose concentration. However, probably this is induced by the blood sugar level of less than 70 milligram per deciliter. And there is another term is pseudo-hypoglycemia. Many of the times, patient presents with typical symptoms of hypoglycemia, and they check their blood sugar, and blood sugar they found it's more than 70 milligram per deciliter. And ADA, why ADA took this cutoff of 70? That's actually the lower normal limit of blood sugar level in a non-diabetic person. If the blood sugar goes below 70, there is secretion of the counter-regulatory hormone. So that's why the cutoff is about 70 milligram per deciliter. However, the International Hypoglycemia Study Group, where the experts from both ADA and Endocrine Society, they had a conference to look into what blood sugar level should be mentioned, should be reported in clinical trials. And they said that about 54 milligram per deciliter, which is a serious and clinically important biochemical hypoglycemia, that should be reported in the clinical studies instead of the 70 milligram per deciliter. And the glycemic threshold, as I mentioned, what time, what blood sugar level there will be symptoms and signs of hypoglycemia would develop. That is the dynamic. If the blood sugar, someone is having recurrent hypoglycemia, then the glycemic threshold for developing the symptoms that becomes lower. And if someone is having high blood sugar level, a poorly controlled blood sugar level, and suddenly blood sugar becomes normal with treatment, then the patient feels hypoglycemic. So the threshold can be dynamic. And if you look at the physiological and behavioral defense against hypoglycemia, when there is blood sugar is reduced or there is hypoglycemia, the pancreatic beta cell that decrease insulin secretion, that is the primary first defense against hypoglycemia. And once the insulin secretion is decreased, that activates the alpha cell, which increase secretion of the glucagon level. And there is also increased sympathoadrenal output, increased epinephrine secretion from the adrenal medulla, and the sympathoneural outflow is also increased with increased norepinephrine and acetylcholine secretion. And you can see the right side picture, which shows the what blood sugar level these counter-regulatory hormone secretion occurs when the blood sugar level goes below the glucagon level, and the level increases and adrenal level increases. And when the blood sugar goes below about 3 millimole per liter, about 54 milligram per deciliter, there would be cognitive dysfunction. If it still goes further below to less than 2.8 millimole per liter, that is about 50 milligram per deciliter, the patient will have neuroglycopenic symptoms. Why are these neurogenic symptoms are important? The patient will have the subjective symptoms of hypoglycemia because of these neurogenic symptoms. So, and what are these neurogenic symptoms? The patient may have sweating, increased hunger, and tingling sensation. These are predominantly cholinergic symptoms, and the predominant adrenal symptoms are patient will have tremor, palpitation, and patient may feel anxious. And if the sugar still goes below, then patient will have neuroglycopenic symptoms. And you can see from the picture, these bars are the symptoms of neurogenic symptoms of hypoglycemia. And there is euglycemia, that is EU, there is no symptoms of hypoglycemia. And in the violet bar, you can see these are the typical neurogenic symptoms of hypoglycemia. But you can see when there is a adrenergic receptor blockade with the medication, then the symptoms they are not that florid as compared to when there is no blockade. And when there is further blockade with both alpha and beta adrenergic and cholinergic receptor, then there is the iodinous symptoms are much reduced. That picture clearly shows the primary iodinous symptoms are by the cholinergic blockade, cholinergic symptoms. These are increased sweating, hunger, and tingling sensation. And now, coming to another important aspect of hypoglycemia is hypoglycemia-associated autonomic failure. This typically occurs in patients with type 1 diabetes and long-standing type 2 diabetes who have frequent hypoglycemia. They do not experience the symptoms of hypoglycemia unless the blood sugar is much lower level. These are because of attenuated sympathoadrenal activity. And this attenuated sympathoadrenal activity is actually functional. Functional means these are not absolute deficiency in the sympathoadrenal activity. If you scrupulously avoid hypoglycemia for maybe 2 to 3 weeks of time, there may be preservation of this sympathoadrenal activity. And why this HAP is important? Because if someone is having HAP, then there is 25-fold higher risk of developing hypoglycemia in the patient who are trying to have intensive glycemic control. This is a schematic diagram of HAP, why this is happening, what is the mechanism of the HAP. As you can see on the left-hand side, is in early type 2 diabetes, there is some preservation of the beta cell. If there is marked absolute therapeutic hyperinsulinemia, means if you give larger dose of insulin, then only there will be for hypoglycemia, isolated episodes of hypoglycemia. But on the contrary, if you see on the right-hand side, when there is advanced type 2 diabetes or type 1 diabetes, where there is absolute beta cell failure, there is no beta cell, there is no endogenous insulin secretion is there. So if you give exogenous insulin, it's maybe in a mild or moderate amount of therapeutic hyperinsulinemia, which normally doesn't cause hypoglycemia. But if there is HAP, so if you give a small amount of insulin, that will lead to hypoglycemia. This is primarily because of the beta cell failure. As beta cell is not working, so even there is hypoglycemia, there is no further decrease in insulin. As we all know, normally if the insulin goes down, that stimulates glucagon level during hypoglycemia. If there is HAP, there is no beta cell, there is no decrease in insulin, that would obviously there is no increase in the glucagon. The initial counter-regulatory hormone systems are lost. Then comes the attenuated sympathoadrenal response to hypoglycemia. And there is decreased adrenal secretion of epinephrine, and there is a decreased adrenergic and cholinergic manifestation leading to impaired awareness and further leading to recurrent hypoglycemia. And this recurrent hypoglycemia further precipitated this this hypoglycemia-associated autonomic failure. And recently, this has also been seen with exercise. If somebody is doing exercise, after a few hours of excessive exercise, in a type 1 or long-standing type 2 diabetes patient, they can have also HAP-like symptoms. And the patient is also asleep. They can also induce the HAP-like, the mechanism is not known, but these are also found to have not only recurrent hypoglycemia, exercise, sleep, that precipitated hypoglycemia-associated autonomic failure. And why there is sympathoadrenal deficiency in HAP? This is primarily we do not know exactly what is the mechanism. However, there is brain fuel hypothesis, brain metabolism hypothesis. So many hypotheses have been proposed, particularly by Cryer, who was a pioneer member of one of the international hypoglycemic study group. And they found that there is increased glutathione activity in the brain vasculature to increase the glucose uptake during hypoglycemia. Also, there is increased GABA levels in ventromedial hypothalamus, and that causes altered ventromedial hypothalamus sensing of glucose. So these are the probable mechanism, this glutathione activity and the altered DMH sensing that reduces the adrenomedular sympathetic output, and that reduces these symptoms of hypoglycemia. So now coming to the potential consequences of hypoglycemia, we already have discussed about the loss of awareness. They can have impaired memory, particularly consolidation of recent memory, particularly in type 1 diabetes patient, and they can have confusion, dizziness, they can end up in coma. So these are the symptoms of hypoglycemia, but the problem is they have lots of psychological impacts. Not many times has been discussed about the psychological impact of hypoglycemia. These hypoglycemia attacks are actually very distressing. They find it's very problematic for the patient developing hypoglycemia. They have the poor quality of life, and many of the times they feel very bad about these things. They can have some social embarrassment. If somebody is like somebody, if I'm I'm presenting, and if I develop hypoglycemia, my thought process would be different. So that may sometimes cause psychological disarrangement in public. And another important aspect is the fear of hypoglycemia. About 50% of type 1 and type 2 diabetes patients, and as well as their relatives also have this fear of hypoglycemia. Patient may develop a hypoglycemia. That fear, many of the times, patients are not able to achieve the good glycemic control, and many of the times we see in clinical practice reducing the insulin dose or oral antidiabetic dose prescribed by the physician. There may be many societal impact, maybe loss of driving privilege, there may be restricted employment, there may be breakdown in the familial relationship. We need to understand all these aspects of hypoglycemia. There may be increased risk of death, and particularly in the type 1 diabetes, the death may not be that acute or may not be that common, but it's very rare. But as been described, with 10% of type 1 diabetes have increased risk of mortality. Now, coming to another important aspect of cardiovascular consequence of hypoglycemia. And we all know what is the mechanism of hypoglycemia leading to cardiovascular damage. That hypoglycemia increases epinephrine secretion per adrenaline, which increases the hemodynamic changes, increases cardiac output, increases cardiac contractility, and increases heart workload. And that also has rheumological factors, like increase in the platelet activation, decreases the fibrinolytic activity. And hypoglycemia also activates renin-angiotensin system that increases the aldosterone level, causing hypokalemia. So hypokalemia can have repolarization defect and leading to arrhythmias in patients with hypoglycemia. So multiple factors with hemodynamic changes, hemorrhagical changes, inflammatory changes all lead to endothelial dysfunction, leading to cardiovascular outcomes. Just to present one case of actually the hypoglycemia causing death. This is a continuous glucose monitoring of a patient who died of hypoglycemia. You can see the blood sugar level the previous day, the previous night, and the morning when the patient died, the blood sugar levels are low, the hypoglycemia, and the patient underwent and the patient died, and autopsy was done, no cause was found. So probably it was attributed to the hypoglycemia induced arrhythmia. So why this is arrhythmia is happening? This is probably because of the increased QT interval. You can see from this ECG that left hand side is the normal QT interval, and on the right hand side, this is actually the experimentally induced hypoglycemia has shown there is prolongation of the QT interval, and you can clearly see the U wave here in the ECG, and this leads to repolarization defect and causes multiple arrhythmias in this patient, causing immediate death with hypoglycemia. Now, what is the effect on the long-term effect of cardiovascular event with a hypoglycemia? So what is the effect of severe hypoglycemia on the cardiovascular event, or what is the effect of the cardiovascular event on the severe hypoglycemia? This is a data from the exenatide outcome study, that is Excel study. This is a post-hoc analysis. And after doing all kind of adjustment with all kind of factors like the duration of diabetes, people taking anti-diabetic agents, HbA1c, these all factors are adjusted, and they clearly found, as you can see in the panel A, there is severe increase in the with the severe hypoglycemia, the all-cause death, cardiovascular death, myocardial infarction, hospitalization for acute coronary syndrome, hospitalization for heart failure, all increase by about 1.8 to 2 times those with hypoglycemia. Similarly, on the B panel, you see with the preceding events, even those who had cardiac manifestation like fatal or non-fatal myocardial infarction, stroke, hospitalization, there is increased risk of severe hypoglycemia. How long it persists actually? And I mentioned one case where there is death with the immediate hypoglycemia. What is happening to the long-term outcome of severe hypoglycemia? That this time-bound, time-dependent HR plot clearly shows this hazard ratio continues to remain higher even after 5 years of severe hypoglycemia. That with the persistent hazard ratio is persistent over the time, both hypoglycemia and the patient who developed myocardial infarction or cardiac event, the risk of hypoglycemia is also persistent over the 5 years duration. This is clearly shown in this graph. Now coming to the long-term outcome of hypoglycemia, what is the effect of hypoglycemia on the cognitive impairment, what is the effect on the dementia and brain volume. So this is a study population taken from the atherosclerotic risk community in the US community study, and they this data in 87 and 1989, and they in each visit they assessed these parameter like cognitive assessment, brain volume, changes in cognitive dementia assessment, and they started doing this assessment since very beginning. And some assessment was done from 96, that is change in cognitive test score, and they continue to follow for 15 years. And in 2013, when they finally looked into the data, out of these 15,000 odd patients who developed diabetes, about 2,000 odd patients had diabetes at final visit in 2013. They had severe hypoglycemia in about 3% of the cases. And those who had severe hypoglycemia, they found that the risk of dementia is much higher versus the normal cognitive status. And the hypoglycemia was associated with smaller total volume of brain volume. And hypoglycemia is strongly associated with incident dementia. So not only those patients who had some dementia problem that further precipitated about by 2.5 times, and there is those who didn't have dementia, they found that those patients have severe hypoglycemia after 15 years. They can have also, they can develop incident dementia. So to come to my end of my presentation, the counter-regulatory response to hypoglycemia are gradually lost as the duration of diabetes increases. And the key feature of hypoglycemia-associated autonomic failure in diabetes is there is attenuated sympathoadrenal response to hypoglycemia, the most often caused by recent hypoglycemia, or also sometimes with the exercise. And there is increased risk of cardiovascular and all-cause mortality, as I saw a few of the studies with severe hypoglycemia. And hypoglycemia, of course, affect neurocognition and memory acutely. And it can have a long-term impact on the brain function and the brain volume at long term. There's not much data available, but few the studies, as I shown the direct study, the follow-up data clearly shown that there is an increase in the dementia risk patient developing hypoglycemia. Thank you. I come to end of my presentation.
Thank you, Professor Kanwar. As usual, it's an excellent talk, and today it is still more excellent plus, because all the mechanisms you have described, which is very, very important, particularly the mechanism of hypoglycemia unawareness, we will be discussing at the later time. So without that, we are not putting any doubts or questions. Thank you so much. Now I hand over the mic to my co-chairperson, Dr. Devarchan Janda, to conduct the rest of the session, inviting two other speakers with the giving a little bit introduction about the subject. Over to you, Dr. Jana. Thank you, Professor Kanwar. Please, we wait. We will be discussing.
So, thank you, sir. Thank you, Jan sir. Thank you, Alok sir. And thank you, Ashok sir, for giving me an opportunity to chair this session. So, as usual, sir has conducted one program in Mumbai 3-4 years ago. On foot ulcer. I was one attendee, and it created a lot of interest in management of diabetes. So nicely, sir has the whole day he has discussed about foot ulcer. So the program was just after my completion of a DM course in ACV. So I always remember that program. So nice program, sir. So diabetic foot ulcer and amputation, they are associated with high mortality rate, and these can be prevented. So to talk on the subject, we have the stalwart on this field, Dr. Ghanashyam Goel. Sir is a consultant, a diabetologist, and a diabetic foot specialist. He is the director and head of diabetologist. He's working in Kolkata, started the first diabetic foot clinic in Eastern India. He is the organizing secretary of IdeaCon. He's honorable secretary of, and he's the past vice president, Diabetic Foot Society, and many more publication and accolades he has to start the deliberation. I
invite Professor Goel, Dr. Ghanashyam Goel. Sir, please.
I think you have to unmute, Ghanshyam. You have to unmute yourself. Unmute. I think you are muted. You have to unmute, Ghanshyam.
Very good morning.
Yeah.
Friends, colleagues. At the outset, thanks to the team NUCD for inviting me. So I'm going to discuss diabetic neuropathy and diabetic foot syndrome. Diabetic foot syndrome is defined by WHO as an ulceration of the feet above the malleoli associated with neuropathy and different grades of ischemia and infection. As you all are aware, cost of diabetic foot ulcer is greater than that of the 5 most costly forms of cancer. Every 20 seconds, someone is amputated. Lifetime risk of people with diabetes to develop a foot ulcer is 34%. More than 50% diabetic foot ulcers become infected. As we all know, median time to healing a DFU without surgery is approximately 12 weeks, and it is associated with a high risk of limb loss through the amputations. 5-year survival following presentation with a new DFU is of the order of only 50 to 60% and worse than that of many common cancers. They one of the very important paper which has been published by Professor Bolton and David Armstrong in 2017 in New England Journal of Medicine. And what they have shown that the incidence of diabetic foot ulcers, lifetime incidence, is around 34%, not 15 or 25%. And simultaneously, if a person's ulcer is healed, the recurrence rate within 1 year is 40%, and it increases by 60% after 3 years. So what they have suggested, instead of telling our patients that your ulcer is healed, that we should use the term, your ulcer is in remission. Who is at the risk of foot ulceration? Patients who are in neuropathy, peripheral vascular disease, posterior foot ulceration, microvascular complications, poor glycemic control, smoking, foot deformity, and amputation. These are the patients who will be at the high risk. Then how to define neuropathy? I think this is the simplest definition. You all have known to this definition. Presence of symptoms and or signs of peripheral nerve dysfunction in people with diabetes after other causes has been excluded. So diabetic neuropathy agonizes when it's painful and damages when it's painless. Among diabetes complication, damage to the peripheral and autonomic nervous system is the most prevalent. And effect of DPN on patient morbidity and quality of life are substantial. It predisposes to falls and superficial injuries, which can lead and amputations. Painless diabetes not aware of minor foot injuries that can become major problems. Cause of alopecia is believed to be related to the blockage of small arteries that supply affected nerves. And patient is not any that is there. Then patient is not feeling a problem with it. There's a motor nerve damage on motor neuropathy. There is a bursting of the small muscles of feet, and there is a clawing of feet you can see. And the autonomic nerve damage, you can see dryness of feet, loss of hairs, and cracks, which are suggestive of autonomic nerve damage. Localized callus, it is a precursor of ulcer. We all know that's there. Then this is the patient which came to us, long-standing diabetes and having a non-healing ulcer since more than 1 year, and you see what is there, that the staplers were inside and patient was not aware of it, and patient was not having on account of loss of productive sensation. Then the movement sites for testing, you see these are the 3 sites, now the 5. Great TOF, first empty head and fifth empty head. Out of these 3, if two or more than two places patient is unable to feel, it means patient is having loss of protective sensation or patient is having sensory neuropathy. So the International Working Group on Diabetic 2019 guidelines. Then this is how you categorize the high risk fit. If patient who is no LOPS, no PAD, no deformity, in the risk category 0, and patient should be examined by a journalist or a specialist every year. If patient has LOPS plus minus deformities every 3 to 6 months, grade 2 PAD, peripheral arterial disease plus minus LOPS, loss of protective sensation, every 2 to 3 months. And if a patient is having history of ulceration or amputation or sharp foot, every 1 to or whenever patient comes to you. So stepwise approach for primary care. All individuals should be assessed for diabetic peripheral neuropathy, starting at diagnosis of type 2 diabetes and 5 years after the diagnosis of type 1. And after that, at least once in a year. This is the how you diagnose the painful diabetic neuropathy. Take a targeted history, assess for diabetic peripheral neuropathy symptoms, test for clinical signs, develop a differential diagnosis, and perform a confirmatory testing if needed. So history, you have to go for if poor glycemic control, long duration of diabetes, older age, tall stature as the neuropathy is length dependent, hypertension, obesity, and metabolic syndrome. These are the patients who are at high risk of diabetic neuropathy. Then about the large fiber or myelinated fiber neuropathy and the small nerve fiber or unmyelinated C fibers neuropathy. Symptoms: numbness, tingling, poor balance. And how you examine? You do a ankle reflex, vibration perception threshold, 10 gram monofilament, or you can go for proprioception. But about the small nerve fibers, you can have a thermal or cold or hot discrimination or pin prick sensation, which is absent or reduced, or patient may have pain, burning, electric shocks, stabbing, hyperalgesia, or anhedonia. Small fiber neuropathy, burning, lancinating, tingling, shooting, electric shock-like sensation occurring in varying combinations and typically worse at night. Pain may be accompanied by dysesthesia, such as exaggerated response to painful stimuli. Then pain may be directly or indirectly interfere with daily activities or lead to loss of balance, disability, psychosocial impairment, sleep disturbances, and reduced health-related quality of life. Thus, there should be a strong suspicion of DPN in individuals presenting with any of these complications. About the large fiber neuropathy, numbness, tingling without pain, loss of protective sensation, in more advanced stages, more balanced weakness and unsteadiness, that means to fall. Some individuals may also present with completely insensate numb feet. Asymptomatic diabetic neuropathy. Half of the people with diabetic peripheral neuropathy may be either asymptomatic or reluctant to report some symptoms. So, to summarize, periodic, flexible assessment for diabetic peripheral neuropathy risk factors and symptoms and their trajectories of time should be part of standard care for all people with diabetes. What are the tests? One is for the small fiber damage, pinprick sensation using sharp objects such as safety pin, temperature threshold sensation, which will mostly performed with a cold metal such as tuning fork, or for the large fiber neuropathy, you can use a 128 Hz tuning fork, or you can touch light touch pressure with a 10 gram monofilament, or you can use a biothiometer or bilateral ankle reflex. So how to manage DPN? Management remains suboptimal. In type 1 diabetes, glucose control slows DPN progression. In type 2 diabetes, glucose control only marginally affects DPN progression, especially when patients have metabolic syndrome. Therefore, managing DPN in people with type 2 diabetes currently revolves around weight loss and exercise to mitigate the metabolic syndrome. About the peripheral neuropathy, that is painful. 30% of all individuals with DPN will experience painful symptoms that will require pharmacological and other treatments. Role of glycemic control, it's an important point. Early studies suggested that stable glycemic control with few excursions into hyperglycemia or hypoglycemia was associated with reduced pain scores as assessed on a VAS. Later, with the advent of continuous glucose monitoring, a small study confirmed people with painful DPN have greater fluctuations in glucose and poorer overall glycemic control than MASH subject with painless neuropathy. Acute painful diabetic neuropathy, as in the past we used to use it as an insulin neuritis, by recent review by Gibson have suggested we should call it the treatment-induced neuropathy of diabetes, as insulin is not the only cause to cause the neuropathic pain or insulin neuritis. Chronic diabetic neuropathy, common among all ages in both type 1 or type 2. And what is therapeutic approach? There are no pathogenetically oriented pharmacological treatment approved by US FDA. So there are 3 FDA approved therapies for painful DPN: pregabalin, duloxetine, and tapentadol. So how will approach? First, identify person with painful neuropathy. Other causes of the neuropathy should be excluded. Non-pharmacological therapies. Then pharmacological therapies, which is anticonvulsant, pregabalin and gabapentin, SNSRIs, duloxetine, tricyclic antidepressant. If not, then it's a combination therapy. Multiple drug combination therapy isn't listed in this figure. Means you can use a combination of pregabalin plus duloxetine, or you can use a nutraceutical just like vitamin B12 and others, and even local treatment. The capsicum 8% patch is also there. So pharmacotherapy should be individualized, depends on comorbidities, cost, potential drug-drug interaction, potential for adverse effects, and all the factors to be taken together. Different drugs for the treatment of painful diabetic neuropathy. There was a meta-analysis which have shown pregabalin and duloxetine shows good therapeutic effect on painful DPN, but adverse effects were also significant, so always remember it. Topical therapy, now 8% long-acting capsicum patch has been developed, is now approved by FDA for painful diabetic neuropathy. Duration of treatment, this is very important. It is recommended that after 6 months of symptom relief, a slow and gradual reduction of drug treatment should be attempted. If symptoms reappear during this gradual reduction, a lower dose may be required for the next few months, when further review and attempted reduction should take place. This is a typical presentation of the diabetic foot syndrome. In clinics, we also neuropathic foot, infected foot, the foot with the maggots. And neuropathic foot, we all know a lot of callus around the ulcer. It is on the plantar surface and the wet infected gangrene, plantar callus, and there is a loss of protective sensation. While neuroischemic foot is called not pink, it's black, pulseless, or it's not painful, it's very painful, marginated ulcers. So what are the modern day management of DFU? We all know it is the debridement and infection control, then the offloading and vascular assessment. And nowadays, in addition to this simple multidisciplinary diabetic foot care, the simple principles, multidisciplinary diabetic foot care is now becoming a mainstay of the therapy. So I'm just going to have a 2-3 cases discussion regarding this particular thing. One is the neuropathic foot, bilateral cratoid and second empty head ulcers, multiple ulcers, history of barefoot walking, and since last 5 months, this monofilament test was severely impaired or not able to feel. ABI was normal, X-ray doesn't show any osteomyelitis, and you see patient debridement was done at the clinic, and offloading was provided by the most modified posterior slab. One is this, and second, then it has been given the offloading by the foam dressing or SK offloading based on principles of Samadhan system. Then outcome after 15 weeks, you see these ulcers which were there, it has been healed after 15 weeks. So only problem in these ulcers, why they were not healing, was the lack of offloading. These are the offloading ways, how you will check it. So gold standard is the total contact cast, then posterior slab, and all these bed rest is not practically possible. The different ways of offloading. There's a felt form dressing, total contact cast, there's a modified footwear, posterior slab, and the air cast. This is the infected diabetic foot, extensive gangrene of lower 1/3 of the foot. Hemoglobin was less than 7, creatinine was high, and patient was in very sepsis, and patient required below knee amputation. Discuss with a family member and life-threatening situation. And you see, to save the life, the major amputation, below knee amputation has been done. So below knee amputation is a life-challenging event. It is a last resort when all options of saving the limb have failed. Sometimes BKs are performed in order to save the life of the patient. Advances in surgical procedure and improved and advanced processes have enabled patient to return to almost near normal life post-amputation. This is an ischemic case presented with severe pain in the right foot, 2 weeks, a smoker, pedal pulses were not palpable, A1C poorly controlled, creatinine 1.54, right lower limb artery shows occlusion of SFA and popliteal artery. Angioplasty has been done, and you see after angioplasty, after 1 week, this amputation of the great toe has been done and it has been healed, and you can see this is the result. So it's a multidisciplinary approach. So that's why nowadays multidisciplinary approach is mandatory. You require diabetologist, endocrinologist, or physician who is the captain of the team, then surgeon, plastic surgeon, vascular surgeons, podiatrist, orthopedic surgeon, all these are required, and the orthotist or podiatrist. So dear friends, to conclude, diabetic peripheral neuropathy is one of the commonest complications of diabetes. Peripheral neuropathy agonizes when painful and damages when painless. Diabetic neuropathy can be nightmare for both, for the patient suffering from it and for the clinicians trying to manage it. Fit have to bear the major brunt of damage done by painless peripheral neuropathy. Protective and preventive measures are the most important aspect of fighting painless neuropathy. So dear friends, pay attention to the basic tenets of wound care. Nothing supplants the role of good basic wound care. Offloading, debridement, infection control, management of ischemia if necessary. Keep Indian scenario in mind, availability and affordability. Thank you very much for giving patience hearing. Thank you.
So thank you, sir, for your nice and informative talk on DFU. So as usual, it is a teamwork, taking the surgeon, the diabetologist, and the radiologist. So, sir, be present for the panel discussion. I will go for the next talk. That is about erectile dysfunction, which is a bothersome and distasteful complication in diabetes patient, affecting quality of life. And with more number of diabetes patients, those who are diagnosed early, and some of them, they go to auto mode, they don't hear the physician, and there is more chance of increase in number of this devastating erectile dysfunction in the near future. So to talk about this topic, I request Dr. Deepak Jumani. He is a senior sexual health and physician, diplomat American Board certified fellow of American College of Sexologists, ASC CT certified sex therapist, and many more. He's the editor of International Journal of Psychology and Counseling, co-chairman of IMS Initiative for Sexual Study. And I request Professor Deepak Jumani to deliver his talk.
Thank you very much, sir, for that very sexy introduction. At the outset, I thank Dr. Alok Kanogo and all my friends in Bhubaneswar, my teacher and mentor, Dr. Professor A.K. Das, for inviting me here and giving me an opportunity to share my thoughts, views, concepts, and passion. With pranams to God and thanks to my teachers, Dr. O.P. Kapoor, Prakash Kothari, and my mentor, teacher, Dr. Shashank Joshi, I beseech them to bless me always. I have no conflict of interest. Prime Minister offered us lockdown and GST. Look at his hands are down. Then he told me, Deepak. Then I said, what I will offer is, I will say unlockdown and I'll offer my GST. And my GST to all of you is great sex therapy. When you are married, wonders happen. But when you get diabetes, you wonder what happened. 80% of men struggle with erectile dysfunction in silence today. When I Googled, I find Viagra had 196 million web pages and aspirin had only 53 million web pages. Diabetes is the sexual health tsunami of our century. Every diabetic male or female today have some bedroom woes. 62% of women admitted that they were not satisfied with their sex lives. And 40%.
Ask you, Deepak, have you started your sharing your slides?
Yeah, I have. You can't hear?
It is not coming at all.
Okay,
That's why, because I have seen the way you were speaking is report, but slides will 45.
Slides, Deepak.
Okay. I'll just share my slide. 1 second.
Yeah, but we're all interested. We're waiting for it. So take your time.
Yeah. I want to see that snake charmer slide.
Okay. Is it visible now?
Yes. Make it full screen.
Yes.
Is it okay now? Yeah.
Bold enough. It is full screen.
Yeah.
And changing also. Please continue.
With pranams to God and thanks to my teachers, I beseech them to bless me always. I have no conflict of interest. Prime Minister Narendra Modi ji gave us lockdown and GST. Look at his hands are down. He was helpless. Then he told me, Deepak. So I told him, sir, I will also give something to my friends and I'll make them unlock down and I'll give them my GST, and my GST is great sex therapy. When you get married, wonders happened. But when you get diabetes, you wonder what happened. 80% of men struggle with erectile dysfunction in silence. They don't talk about it. When I Googled, I found 196 million web pages for Viagra and 53 million web pages for aspirin. Diabetes, friends, is a sexual health tsunami of our century. 40% of men above the age of 40 do have issues in the bedroom, and 62% of women admitted in a survey that they were not satisfied with their sex lives. Impotence has been the main cause of divorces in India. Is sex a secret? Who doesn't know what is sex? Every Tom, Dick, and every child even knows today what is a secret. So, but let us know what we should know, that sex is not a secret, but it is a sacred thing. And how do we physicians learn about the sexual dysfunction is by asking 4 questions to our patients. That do you have desire in having sex, or do you have desire, or no desire, or low desire? And then comes the arousal. Do you get erections? Do you don't get erections? Are you able to penetrate? Are you able to ejaculate? And same with the women. So erectile dysfunction, friends, is a focal point of men's health initiative today. And the basic issue of erectile dysfunction in India is that there is a rising trend. India has the largest population of males in the world, also has the largest number of men in the sexually active and reproductive age group. India has a rising prevalence also of the lifestyle diseases such as diabetes, cardiovascular disease, hypertension, which are the common risk factors for erectile dysfunction. And the sad thing is, erectile dysfunction remains underdiagnosed, with several men never coming to medical attention because of the sensitivity of the issues. There is definitely a rise in erectile dysfunction, especially in the younger age group. Men with metabolic syndrome have impaired endothelial dysfunction. We'll come to a little later what is endothelium and how does the endothelium get dysfunction. But remember, friends, every person who has one or the other issue of metabolic syndrome has got endothelial dysfunction. And the prevalence of metabolic syndrome in men is always with organic erectile dysfunction. And the 4 types of patients, diabetic, obese, dyslipidemic, and hypertensive, are the deadly quadrant for patients having erectile dysfunction. Let me give you a newer perspective of it. What is the current perspective? That diabetes is an established risk factor for sexual dysfunction in men, as 3-fold increased risk of erectile dysfunction was documented in diabetic men compared to non-diabetic men. As among women, evidence regarding this is very less, but yes, there is definitely a higher prevalence of female sexual dysfunctions in diabetic women, and most commonly we see depression in them. When you look at the sexuality and diabetes, so why this happened is they have studied that erectile dysfunction occurs as one of the first problems. And along with that, there is also a decrease in the testosterone level. So diabetes definitely has a detrimental effect on the sexual functions of our patients. So diabetologists who primarily care for their patients should just not look for glycemic control, but also take help from urologists, psychologists, sexologists, and try to improve the quality of life by taking into the holistic aspect of it. Now, for many, it becomes a tragedy in their bedroom. This problem becomes a tragedy. So can we turn the tragedy into bliss? Yes, we can today. And what is the prevalence? Diabetes is more prevalent in India and China. And I call India the diabetes capital of the world. Erectile dysfunction is the commonest complication of diabetes. So India are the erectile dysfunction capital of the world. Our first huge data, 56,000 patients, all men diabetics had ED, premature ejaculation, and hypoactive sexual desire disorders. Women all had low desire, and depression was the most common thing which we saw. So we need to break all barriers. Patients don't come and tell us. We need to talk to our patients. We need to break the ice. We need to come out of clinical inertia and ask our patients that, do you have problems in making love? Friends, if you ask this question to your patients who are 30 years and above and having a family history of metabolic syndrome, you will be surprised that these patients are waiting for you to initiate a dialogue on this. So the tip of a man is nothing but a tip of an iceberg. How and why this happens? Men with erectile dysfunction have been studied in European male aging studies as having higher risk of death. Erectile dysfunction, poor morning erections, and low libido had a higher mortality risk compared to men with no sexual symptoms. This has been studied. So it's a huge problem to the man and to the partner, and there is definitely a dent in the relationship between it. So this needs to it is nothing but emotional dysfunction. So the onus of sexual health of our patients lies with we physicians, and we are all going to live more. How are we going to spend the 60 plus gifted years? Are we going to spend in autonomy, dignity, gracefully age, or be sexually happy? Or do we want to be diseased, depressed, dependent, unhappy, or emotionally crippled? So we need to take care of our own selves and our own patients. So there's definitely a link between diabetes and sexual dysfunctions. Obesity, hypertension, sleep apnea, and depression are common conditions that occur along with diabetes. The time and energy spent on managing diabetes and related conditions can take a toll on emotional health. Changes in testosterone or estrogen because of diabetes, menopause, or co-occurring conditions can impact the libido, lubrication, and ability to become sexually aroused. Diabetes impacts blood flow, which could affect blood reaching the penis or vagina. For a man to achieve and sustain erection, he needs blood to flow in the penis. In women, decreased blood flow can play a role in vaginal dryness. High levels of glucose can also cause damage to the nerves, and the tip of the penis and clitoris are loaded with nerves. So these get affected and there is decreased sexual sensations. So let us understand what exactly happens. This is the vascular endothelium, and this is the corpora cavernosa smooth muscle cell. Normal endothelium produces endothelial nitric oxide synthetase, which diffuses the nitric oxide, which is the main chemical signaling molecule or the currency of the cell, which enters into the corpora cavernosa smooth muscle cell of the penis, converts GTP into cyclic GMP with the help of this enzyme gonadal cyclase. This cyclic GMP, through various mechanisms, relaxes the smooth muscle of the penile corpora cavernosa muscle cell and allows the blood to flow in, and the penis becomes erect. But sadly, this cyclic GMP hydrolyzes into 5-GMP with the help of an enzyme called phosphodiesterase 5. So what do we understand from this? We understand that for an erection, you need a normal endothelium, which produces normal endothelial nitric oxide synthetase and nitric oxide. Okay. So hence, anything which happens to a man like erectile dysfunction is nothing else but an endothelial dysfunction. So hyperglycemia in diabetes, increased advanced glycated end products, which we all know. There is definitely an oxidative stress. These alter the molecular things in the endothelium, like endothelial nitric oxide synthetase and nitric oxide. There are macromolecular damage, protein oxidation modification, endothelial gets apoptotic, and there is vascular endothelial signaling inhibition which happens. All these ultimately lead to cavernosal endothelial dysfunction, and there are functional alteration between the endothelium. So this results in erectile dysfunction. So definitely erectile and endothelial dysfunction in type 2 diabetes, there is definitely a link. It decreases the nitric oxide, it thickens the basement membrane of the capillaries. And when we look at the diabetic corpora cavernosa, because of glucose overload, advanced glycated end products increase ROS, they reduce the nitric oxide, and there is apoptosis. Simultaneously, we've also seen in diabetics reduction of testosterone, and through these mechanisms, there is corpora cavernosa smooth muscle cell dysfunction, and this leads to erectile failure in these patients. There are a lot of mechanisms which we know. Advanced glycated end products, increased levels of oxygen-free radicals, impaired nitric oxide synthesis, increased endothelin B, which is a vasoconstrictor, upregulation of Rho-A, Rho kinase, which produces generalized vasoconstriction in the penile and penile vasculature, neuropathic damage, and impaired cyclic GMP. During COVID, we found the coronavirus present in the corpora cavernosa. Friends, COVID is not a sexually transmitted disease, but definitely they've spotted this, and it had caused erectile dysfunction in the later stages. So SARS-2 receptor ACE enzyme 2 is expressed in the human pancreatic islet beta cells, and this was upregulated during inflammatory stages like COVID. So COVID-19 and diabetes have a complex bidirectional relationship. So what we physicians need to know about erectile dysfunction today, we need to get educated our own selves to treat our patients. John Malal gave a very beautiful algorithm. First, ask your patient, then legitimize the problem of erectile dysfunction. Tell them that these problems are very, very common in every diabetic, every hypertensive. So he doesn't feel that he's alone. And if you cannot go ahead, send them to or refer them to a good sexologist. Otherwise, open up a discussion and evaluate and work together and give a comprehensive treatment plan. Erectile dysfunction has got multiple causes: vascular, neurogenic, penile, trauma, hormonal imbalance, drug-induced, psychogenic. So many causes are there. But what I say is that what actually happens in erectile dysfunction is the nerves stimulate, vessels circulate, muscles facilitate, and hormones regulate. So if your nerves, vessels, muscles, and hormones are normal, your sex life is always rocking. Why should we be worried about erectile dysfunction? Is it something to be panicked about? Yes, because erectile dysfunction is nothing else but subclinical cardiovascular disease. And we know cardiovascular diseases are the global mortality, global cause of increased mortality across the world. And erectile dysfunction, friends, is the earliest marker of myocardial infarction because the penile arteries are the smallest, smaller than the coronary artery. Coronary arteries are bigger. So if atherosclerosis sets in the penile artery to 50%, these patients get erectile dysfunction. But the same amount of atherosclerosis doesn't occlude the other arteries, which are larger in diameter. And hence, ED appears much before than the coronary artery disease appeared. So you are only as old as your endothelium. My teacher, Paul Vanot, beautifully said this long time back. Let me give you a deeper perspective of all this. Today's concept is that penis can become a diagnostic tool of your endothelium health by asking a simple question about erections. And we know that hypertension, diabetes, smoking, raised lipids, homocysteine, estrogen deficiency all cause increase in the endothelial cell damage and vascular smooth muscle injury, leading to endothelial dysfunction. And once endothelial dysfunction happens, you see all these complications of apoptosis, like leukocyte addition, lipid deposition, vasoconstriction, vascular smooth muscle cell growth, and thrombosis. If you have a healthy endothelium, endothelium-derived nitric oxide is anti-thrombotic and anti-atherosclerotic. Endothelium dysfunction leads to lots of abnormal. And the pathogenesis of erectile dysfunction in metabolic syndrome is visceral obesity, genetic predisposition, increased food take, decreased activity, produces visceral obesity, also produces insulin resistance. Visceral obesity is proven to reduce the androgens, and insulin resistance lead to dyslipidemia and hyperglycemia, again leading to oxidative stress and leading to endothelial dysfunction. And once you have insulin resistance and obesity, there is definitely retention of sodium and increased sympathetic activity, also leading to hypertension and endothelial dysfunction. And androgens, friends, please understand, in diabetics are all less. Testosterone is less. So androgens are important for every function of the endothelium, especially maintaining of tunica albuginea, matrix, fibroelastic properties, and also the trabecular smooth muscle structure and functions, and also the nerve conduction. Everything is dependent on the. So when we look at our patients of heart disease, till the time they get any clinical disease or right from beginning of the risk factors, all these patients had erectile dysfunction as one of the common symptoms. So there is a wealth of compelling evidence to prove that ED is a risk factor for, and today we have metformin. There are 2-3 beautiful drugs in diabetes. One is metformin, another is alpha acarbose, and the third is SGLT2 inhibitors. These 3 drugs are so beautiful to treat our patients with diabetics and erectile dysfunction that they cover up all the causes of erectile dysfunction, vasculogenic causes. We know that acarbose is also improving the endothelial health, and metformin has also been studied to improve the endothelial health, and SGLT2 reduce the weight and reduce the hyperglycemia, reduce even other things in every diabetic which are causing harmful things. So these 3 drugs can be given to every diabetic, and these patients will start getting normal erections, because these 3 are taking care of all the causes of vasculogenic erectile dysfunction, and these patients don't need any PD5 inhibitors in their whole life. So how do we manage patients of erectile dysfunction? Rule out the organic and the psychogenic cause. If you rule out the psychogenic cause, which is the main component in every patient of erectile dysfunction, you ask one simple question, that in last 8 days or 15 days, did you get up in the morning with an erection? If he says yes, he is absolutely normal. He does not have an organic ED. He is either psychogenic or situational erectile dysfunction. Please ask the couple to come together. Don't ask only the man or the woman to come together. They both should come together, because solution always lies in the couple. And we treat. There are a lot of beautiful markers. Look at the gum of your patients. Chronic periodontal disease is a marker of erectile dysfunction. Salivary tumor necrosis factor, just take a swab from the gums and see it is indication of severe erectile. Low vitamin D has been associated with raised uric acid, is again a predictor of erectile dysfunction. And that there is a relationship between platelet and lymphocyte. So just do a CBC of your patient and do total platelets and total lymphocyte. And if the ratio is more than 105, he does have mild erectile dysfunction. If it is 116, it is moderate. If it is more than 136, it's got severe erectile. So by just looking at a CBC, you can tell your patient that you are having erectile dysfunction, and you can then confront with him, and he'll call you, Sai Baba, sir, how did you know about it? Neutrophil lymphocyte ratio, which he used to do in COVID, if it is more than 3, definitely he has got a severe erectile dysfunction. So how do we treat? We have 3 modalities: oral drugs, injection of papaverine, vacuum therapy, intraurethral drugs. These are the first 2. And if these fail, we send our patient to urologist for implants and the other anastomosis. But all these things do not work unless you counsel your patient and advise them on lifestyle measures. Friends, these 2 things are the mainstay of treatment of every sexual dysfunction. 2018 revision of process of care also mentioned that lifestyle changes should be the first line of treatment. We have 4 PD5 inhibitors, various onset of actions, various doses. Amongst them, tadalafil has the highest onset of action for 45 to 120 minutes, and its duration is 36 hours. So they all have side effects of headache, dizziness, visual disturbances, and the contraindications are nitrates and any cardiovascular event in the recent past, of course, anatomical penile defects, etc. We have treated patients for last 17 years, but they don't form the cutting edge solutions for the treatment of patients. We need to give them something more, because they don't adhere to this. And PD5 inhibitors, if they are given for a long time, they are definitely beneficial as they increase the dilatation and increase the CGMP, which is responsible for relaxation of smooth muscle. They inhibit the smooth muscle contraction, etc. And beautiful studies have been shown that in diabetics, if you give 12 weeks treatment with low dose tadalafil, 5 mg or 10 mg, irrespective of whatever be the HbA1c, hypertension, prostatic hypertrophy or dyslipidemia, there is improvement in their sexual dysfunctions. My friend Dr. Jyoti, they put these patients on insulin pump, and there was a beautiful control of hyperglycemia, and he found improvement in sexual functions to the tune of 84 to 85%. Metformin, as we all know, SGLT2 inhibitors, we have already discussed. Buried penis syndrome is very common in diabetics. Give them 1 gram of metformin, apply sesame seed oil on the shaft of the penis, and L-arginine gel. Beautiful result in 6 weeks you will find. Now we have glyceryl trinitrate also can be tried and has been studied, but there is less robust evidence in our country. But yes, in the United States, they have tried, and this is very, very effective. We have newer therapies like low intensity extracorporeal shock therapy, platelet rich plasma, bariatric surgery improves the cavernosal neuronal vasorelaxation, and thus we have been treating erectile dysfunction, but none of these therapies reverse the pathophysiology of erection. So how do we look about so many newer targets have been now come and still in the pipeline? So we need to have some more tools to improve or cure erectile dysfunction, and the role of regenerative medicine is very, very useful in this. Stem cell therapy in patients who are having stubborn erectile dysfunction, not responding to any medical line of treatment, and they didn't want to go for surgery. They were tried by human umbilical cord stem cells, and most of them improved in their sex life within 3 months. And so we have new phytonutraceuticals like L-arginine and fenugreek, which is very, very useful and very beneficial. Fenugreek, the mechanism is fenugreek in a saponized form have a structure of like similar to testosterone, hence are easily bound to globulin, part of the testosterone, and so the free testosterone is released, and the patients start getting good desire back. We have new drugs called Evanafil. The onset of action is 15 minutes, less side effects, and the half-life is just 5 hours. And this is the only PD5 inhibitors which can give it to patients who are on nitrates. All you got to do is skip the nitrates on that day, give him Avanafil, he can have good enough sex. This Avanafil will be washed out in his body from after 5 hours. Next day again, he can start taking his nitrates as soon as. Beautiful study done on Avanafil, a double-blind study was done for diabetic, and they found that these patients in 360 minutes had 3 encounters. They could have sex 3 times, which is wonderful. So that's important. We have melanocortin receptor agonists. We have newer peripheral active agents like MAXK channel activator, guanylate cyclase activator, nitric oxide donor, and regenerative therapy, friends, has been shown to be a great promise in and low intensity shockwave therapy also. So let us see what is ethical perspective of the whole problem. We know that the risk factor of all risk factors is endothelial dysfunction. So we need to understand how do we restore endothelium. There are a lot of pharmacological remedies, ACE inhibitors, statins, insulin, L-arginine, tetrahydrobiotin, inhibitors of Rho kinase, and these pharmacological intervention can restore the endothelial function and improve all the things which are happening and the complications because of that. So we need to focus on these particular therapies. My teacher, Dr. R.D. Lele, long time published successful strategies for reversal of endothelial dysfunction. PPAR alpha gamma agonist, increased nitric oxide production, vitamin E, C supplement, L-arginine, tetrahydrobiodine, cypiaprin, SOD tempol, statins, so many things which we have to give to our patients. We can reverse their endothelial dysfunction and give them a normal sex life for it. So, and my teacher, Dr. Paresh Dandona, my friend from Buffalo, he gave diabetics long-term testosterone therapy, and he found remission in diabetes. He also found insulin resistance improvement, and also their sexual life increased because most of them were hypogonad. And Dean Ornish long time back proved that with intensive lifestyle changes, you can reverse the coronary artery disease. So we need to focus more on lifestyle and nutrition. Cleveland Clinic's original research said, though bypass surgery and angioplasty do exist, but nutritional intervention in their study not only halted, but even reverts the coronary artery. Huge plaque you can see has been opened up just by nutrition. So this is the most prompt, powerful, and persistent result which we can see. My new definition of erectile dysfunction, that it is diabetes type 5, which is with hypogonadism, prolonged hypoglycemia, and CV risk. Lifestyle measures have been studied to improve the pro-inflammatory milieu, insulin resistance, oxidative stress, and endothelial dysfunction. All these with healthy lifestyle can improve your well-being and wellness and also reduce the burden of sexual dysfunctions. 2 times Nobel Prize winner Dr. Linus Pauling declared that when he was receiving his second Nobel Prize, such a brilliant man, what did he say? He said nearly all disease can be traced to a nutritional deficiency. What else we want? We have brilliant people talking about nutrition, and this is possible for us to counsel our patients and improve their quality of life. So my take-home message is, take a detailed history. The secret of sexual fitness is love yourself. You are unique. And the blanket advice you can give to all your patients above 30s, try and avoid excess of salt, oil, and sugars. Give a U-turn to your metabolic imbalance. Have a regular rhythm of sex life. Keep it happening regularly and increase your romance and touch to your partners. One of the biggest challenges in India is DOL. D is diabetes, H is hypertension, O is obesity, and L is lipid, which increase in. So what do we do when the DOL is playing in a man's body? Well, the answer is simple. We do Bhangra. Now, what is Bhangra? Is behavior change, make them happy, stress-free, have an active lifestyle, do exercise, take care of your nutrition, control your hyperglycemia and all the risk reductions, and abstain from other substance of abuse. Counsel your patients on realistic expectations. Tell them at 70, 80, you can't be like 20 or 30. Increase your romance, which is, we have all PD5 inhibitors which are there, but they don't increase the desire. There are 40% patients who are not responding to it. So we give our patients testosterone, but we need to give it with caution. We can't give it to patients who are younger. They will develop azoospermia. We can't give it to older patients with morbid conditions. So what do we have? The Raja of all is L-arginine, fenugreek, lifestyle modification, and regenerative. This is the take-home message. For every diabetic, if you give them this advice, friends, they will definitely improve in their sexual life. So be fearless, passionate, and focused even in the bedroom. So erectile dysfunction due to any cause can be managed today. It's not an option for anyone. It is how gracefully we handle the process and how lucky we are as the process handles us. So today we have so many things to give to our patients that this is a symptom which we can easily manage. And the ideal prescription for diabetic with ED should be counseling, lifestyle measures to be adopted. First thing, OHA or insulin, whatever you want to give. But if you give OHA, prefer metformin, SGLT2 inhibitors, and acarbose. Statins, if he has got dyslipidemia. Antihypertensives, prefer ACE inhibitors and ARBs. If at all you want to give beta blockers, give them nebivolol. If at all you want to give diuretic, give indapamide. Low dose PD5 inhibitors if there are no contraindications. Low dose short course of testosterone if no contraindication. But monitor PSA, L-arginine supplement with fenugreek and zinc, nutritional intervention, and definitely mental health checkup. What a physician misses is he doesn't have time. He doesn't take a detailed history. He doesn't have the art of counseling. Educating the patient on realistic expectation is must, and you need to give an emphatic ear to your patients. Friends, this is triple ED. Erectile dysfunction is endothelial dysfunction and emotional dysfunction. Early diagnosis can prevent early death. Feminism, you need to love your partner. Your partner has given you a lot in your life. So you need to trust, adore, admire, and respect her. Unless we love each of us alone and each one of us, you need to love each other unconditionally, because love is a flow. It's creative. It's not sex what you want. It is why it flows, because and that gives you contentment. This contentment is much more deeper and valuable than contentment after sex. One who knows that contentment will never look for any substitute. Children who should be taught to love from infancy. The myth that teaching of love will lead the child to the world of sex is bullshit. This fear is groundless. The more love grows in a person, the more sex energy is transformed into sex. The less love-filled a person, there are lots of problems. So Voltaire beautifully said, be monogamous. Being monogamous is like a garden. Being polygamous is like a jungle. Both are beautiful. Now you have to decide what you want to be, a gardener or a jungli. But if you want to make your life beautiful and being monogamous and make your garden beautiful, you need to devote time. You need to cut the right type of trees, grass, put water, fertilizers, etc. So Voltaire beautifully said, try and cultivate your own garden. If you have patients of erectile dysfunction, don't send them to quacks. Send them to a good sexologist. So now you treat yourself, you can do it, and see that he gets a good erection and this thing. This is my book, Sex Has No Expiry Date. My last slide. Friends, diabetes, the sexual health tsunami of our century, is very, very common and earliest marker of coronary artery disease. Low dose PD5 inhibitor statins can be ideal choice for diabetics. L-arginine supplement and fenugreek is a boon. Diabetes remission is a fact and not a myth anymore. Testosterone therapy with caution can improve erectile dysfunction and even insulin resistance. Erectile dysfunction, hence, is a correctile dysfunction. Detailed history, counseling, empathy, education are the key. So don't let your diabetics die in bits every day. If you do so, sex really has no expiry date. Thank you all for your love. I'll be happy to answer any questions you all have, and I'll be there a part in the panel discussion.
Oh, thank you very much, Dr. Jumani. As usual, you have hypnotized the entire audience looking and listening to your talk. It's a type 5 diabetes from Dhol to Bhangra. ED is 3D and erectile dysfunction is correctile dysfunction as well. So it has no expiry date. So anybody who is a centenarian also, he must take your advice and must live a very juvenile, enthusiastic, and energetic life under the advice of our great sexologist. All your slides also sexual from Dr. Deepak Jumani. Thank you very much. Anytime we invite from your NUCD, never say no to it. Please join us, encourage us.
It's always an honor and pleasure to come to NUCD anytime, anytime.
Over to
I am in a conference and we are
Devarshan,
missing
anything you
Dr.
want to
Das
say,
also.
you can say. Otherwise, over to Professor Das.
Yeah, I think we had a wonderful session, and it is something which is absolutely amazing session. Now we have a very short interactive program. So first, I will just have the questions for Dr. Kanwar. First, any question anybody want to ask Dr. Kanwar? We can have 1 or 2 questions.
Sir, let us ask.
If you allow me, I have a question to Professor Kanwar. Huh?
Yeah.
Sir, let us ask JB, how do you see the risk of common complication of diabetes like hypoglycemia? He has already highlighted, and it goes without saying that it has very dreaded implications. But let him summarize how common complications can have multi-organ involvement and can be fatal. Dr. JB.
Yeah, as I presented in my talk, that hypoglycemia can be very fatal, and this is a primary reason that the blood sugar. Many of the times we find the blood sugars were not able to achieve the target HbA1c, because sometimes the physician thinks there is a risk of hypoglycemia, and sometimes the patient thinks there is a risk of hypoglycemia, and they tend to take a low doses of insulin or low doses of oral anti-diabetic agent. So, and obviously, as I presented in my talk, it immediately affects the psychosocial effects, and I presented, as well as I also discussed about the cardiovascular mortality and long-term neurological aspects. So it can affect both neurological and cardiovascular outcome.
I think what you said, Kanwar, is very correct. When we join as a resident in any of the institutes where we go for training abroad, they give us a test of hypoglycemia. It is important that every resident should get a test of hypoglycemia, because it's the number one malady. I must tell you, sir, is the number one thing which has to be known. They must experience what happens in front of the eyes. They'll give a glass which is a little bit of clouded. These people see like this, like that. They will give all sorts of things. That underscores the importance that hypoglycemia is a very important symptom. And from the HAT study, the HAT study, hypoglycemia. So it has been shown that hypoglycemia, everybody has to know everything about hypoglycemia, because one can make a distinct change and change the destiny of the patient. My question to were 2. Number 1 is that there's a feeling that type 2 diabetics who are on oral drugs do not have hypoglycemia, but there are plenty of instances of hypoglycemia even in the oral drugs. And when we're going to treat to target and going to establish rigid control, there is evidences that the hypoglycemia is little more. So I just wanted to ask you, what is your take on the type 2 diabetics who are on orals alone about hypoglycemia in them?
Yeah, this is a very pertinent and practical question. we always think that insulin would lead to hypoglycemia. I would try to explain to the patient what are the symptoms of hypoglycemia, how to treat hypoglycemia. But we all know that insulin secretagogues like sulfonylureas is very commonly used, as I was listening yesterday also, very commonly prescribed anti-diabetic agents and meglitinides. They all increases the risk of hypoglycemia. And many of the times also we see that like DP4 inhibitor, SGLT2 inhibitor, they have the very less risk of hypoglycemia, and many of the times we do tend to use these medications along with sulfonylureas or with meglitinides. So there is risk of hypoglycemia. So it's not that not only with the insulin, but with the sulfonylureas, meglitinides, there is a much increased risk of hypoglycemia is there.
Yeah. I think also, JV, one thing has to be emphasized to every patient. It is not the drugs alone. They're only 40%. 60% is the timing of the food and missing a meal. That people do not understand. So that has to be emphasized, that about the timing of the food and not missing a meal is very important to avoid hypoglycemia in type 2 diabetics. Thank you very much. Now I have a question.
Dr. Kanwar, sir, I have a question.
Sure.
See, patients do have hypoglycemia and there is a recurrent hypoglycemia. To that situation, they get suitable to that. As a result, on a recurrent hypoglycemia, at a point it comes to be hypoglycemia unawareness. But they somehow or other carry out their activities. But how clinically you will suspect, oh, here is a gentleman who is developing hypoglycemia unawareness?
Correct. Many of the times, as I mentioned, is because of recurrent hypoglycemia and long-standing type 2 diabetes. If you discuss about type 2 diabetes, because of long-standing diabetes, beta cell failure is there. So they are more likely to develop hypoglycemia-associated autonomic failure. So they won't have many of these symptoms, as I mentioned, the adrenergic and cholinergic symptoms, and they directly go into the neuroglycopenic confusion state, or maybe sometimes into the coma. So if someone is a long-standing diabetic and frequently have history of hypoglycemic, we should be very careful about that. And you keep on monitoring the blood sugar. There comes the importance of the self-monitoring glycemic control. That would give an idea of if the sugars are going down, and that would give an idea that many of the times patient comes with the blood sugar level of 50 and 60. If you ask, did you have any problem? They say, I didn't have any problem, but I just checked it and it is found to be something like 60, 62 or 58. So, and we should be very careful in those patients and also educate them that because of this recurrent hypoglycemia, you cannot have these awareness symptoms even if the blood sugars are low. And the only way to do it to avoid this recurrent hypoglycemia and keep on monitoring the blood sugar level in a long-standing diabetes.
But what should the cutoff level of blood sugar above which we should maintain it? Is it above 70?
Yeah, absolutely. It should be above 70.
Is there any nasal spray of glucagon?
Recently, in 2019, FDA approved nasal spray. It is similarly effective to the injectable one, but injectable one is available with 1 milligram dose, and the FDA approved nasal glucagon that is available as 3 milligram doses, and it is found to be equally effective.
Thank you. We'll go to the next speaker, Ghanshyam. It was a wonderful talk. Ghanshyam, are you here with us? Ghanshyam is here. If Ghanshyam is not here, we'll come back to him a little later. Now let us, but I liked one sentence he said. I would like to emphasize it again. He said that agonizing when the neuropathy is painful. Very, very true. But pain is the gift of God to us. And so a painful neuropathy has no bearing on the life expectancy. It's a nuisance. It is a painful situation with nuisance, but no bearing on the further complications, nor on the longevity of the diabetic. Whereas he said that it is devastating when it is painless. That is important. To diagnose a diabetic foot which is painless is of paramount importance, and that's what he said, which is very important. Very important. I think he will join back in time. Now let us ask question to Dr. Mani, which which is very important. And the first question, most of our diabetics have sexual dysfunction. Do you think in Indian setting, can we detect it in time? Can we correct it in time?
Absolutely, yes. Why we cannot? Because see, the whole thing is we as physicians should come out of our clinical inertia and the embarrassment to talk about these things to our patients. We should believe that we are all born out of it. You know, we talk about cancer, we talk about piles, we talk about fissures, etc. So if you are, say, a GP, take a GP who's seeing family from, generations. So he knows that this patient's father had diabetes, hypertension, also had heart disease. So his children, if they come at the age of 30, he should start asking these patients that, do you have problems in making love? And you can make out, from the way they talk to you or way they behave, you can really get a suspicion that he surely must be having some issues in the bedroom. And once you start asking them, which is the main thing, and when he tells you, yes, he has some problem, so legitimize it by telling them this is very normal and there are definitely more very good treatments available for it, and you can become all right. If you don't treat it, can become worse. So he feels that he doesn't feel alone. So we need to break the ice, and we as physicians should come out of this inertia and learn the art of talking about this to our patients. We ourselves, there are so many doctors who don't even want to ask because they feel embarrassed to talk about it.
I think Deepak, I'll more other example, one example. On my first day at King's, I had a black female patient, and she had about 4 or 5 abortions. The questionnaire said you have to ask them many questions. I just got the history of multiple abortion. I went to Peter Watkins. He said, "Did you ask him? Were they all from the same partner?" I said, "Didn't." He said, "That is the problem all of you have. You should be very frank in your questioning." When I went back, I asked her, she said, "Of course not. Of course not. Different partners." You know, open my eyes. So there are 3 things in life which are important: food, wealth, and sex. I'll repeat again. 3 things are very important for us: food, wealth, and sex. If you do not ask, you would lose a lot of patients' symptoms you can help. I just wanted to ask you 3 important questions which will be very beneficial for the audience. There are many of my friends, my students, have put up this shockwave therapy. And, I have no, but it works well. So my patients have said it works. What's your opinion on that shockwave therapy? And which patient do you recommend?
It is one of the therapies which is definitely recommended. But what we have found in our country, that it's same as lithotripsy, what used to be used for crushing the stones. So here the trabeculae of the penile corpora cavernosa, architecture is little bit. But this therapy works only in patients who have got mild to moderate erectile. It doesn't work in severe ED. And many of the patients, when they are mild, moderate, they don't come to us only. So they come at the advanced stage. And when we send these patients for this low intensity extracorporeal shockwave therapy, they don't respond. And there are a lot of centers in Kerala who have got these machines, and they've selected the right kind of cases, but they have seen no improvement in these patients. So if you have mild to moderate erectile dysfunction, we can easily treat with pharmacotherapy. Why do we send our patients for expensive treatments with this thing? The treatment is around 75,000 rupees. So, and where you get PD5 inhibitors, and you can advise them how to take it and counsel them on nutrition, etc. And you can make them better in much better way. So it is a proven therapy, definitely. In Australia, US, everywhere, there are studies which show that there is definitely improvement in this. The erections hardness is much better. The penile blood flow is improving. Everything is there. But in our country, we are not having good results. I don't know why. Maybe there is something wrong with the penile arteries or the Asian arteries are different. So something
I also had the same note with Mithun, from Guwahati, and he was also having similar results, which was helpful in some, not helpful in others. The last but one question, Deepak, is very important. Have you encountered, the questioner wants to know, have you encountered any accidents, may not be fatal, maybe not fatal, by wrong use of the PD5 inhibitor. Like if by chance they've given you a person who already had a cardiac ischemia, have you found? And I mean, you have used so many lakhs of patients. The Deepak also runs the course of a diploma in sexual health in Grant Medical College. So you or your students have any history or any case to recount?
Well, no deaths have been reported up till now for patients who are. But whenever we give PD5 inhibitors, we make sure that he's not on any nitrates.
Yeah, that's true. That's true.
That is what we take sure, because only fear is, the lethal fear is that he shouldn't get severe hypotension. Okay. PD5 inhibitors, they are vasodilators per se. When they were studied for angina and hypertension. Okay. These patients did not improve in their they did not improve in their hypertension, but they started getting good erections, and they came for the trials continuously in spite of the fact that their blood pressure did not reduce. So Dr. Louis Ignarro, who was doing this study, felt that why are they coming when they're not getting any improvement in their blood pressure? So these patients told them that we are getting good erections and we are very happy with it. We want to continue the trial. And so some 20 years later, these drugs have now been used only for erectile dysfunction. So this is the only thing. These are all dilators. They are in fact like nitrates, for the penis. So they cannot cause any gangrene or any thrombosis or embolism or infarct or anything like that. So they are very useful.
Last question was a question. We'll end with that. The questioner.
Sir, I'll ask.
Yeah, after that you want me to call?
Goenka, sir.
Yeah. Goenka, Ramesh would like to ask question now. I'll just finish in 1 second. Now, there is, you have raised your hand, so it is yours actually. You ask first. Please. Ask first.
Sir, there was one statement that sex has no expiry date, no?
Yes, it is.
When we are...
There's a voluminous book.
That on that I just wanted to comment that if we are breaking our head with glycemic control, in spite of all our efforts, we are unable to achieve glycemia. We are increasing the complications of vascular disease as well as the nerve damage. Then how can we improve all category of patient, any extent of damage caused by glycemia?
See, you are a very brilliant physician.
Very brief answer.
You are a very brilliant physician with all your clinical acumen, all your wisdom on various drugs which are available as oral hypoglycemic drugs, or oral, drugs, insulin, or whatever you can give to your patients. I am sure that out of the 100 diabetics you are seeing, at least 90 patients you will be able to control their blood sugars. And I have yet to come across a family in whose family there is no patient of hypertension. And we all can manage metabolic syndrome. The onus is with us. We need to understand the patient's problem. We need to understand what right drug to give him, what type of insulin to give him, and we can bring down these metabolic syndrome. Reversal is not a myth, it's a reality. It has been proven beyond doubt. So if we are controlling the metabolic syndrome, okay, then what are the other causes of, if he doesn't have any neurological causes, if he does not have any hormonal issues, everything we can manage it and we can give them a good quality of life. And it is written, it has been studied that you can have sex from 9 years to 90 years. What else you want? So
no, sir. Just I would like to interrupt. A patient comes to you who was never controlled, and he was having a HbA1c of 13 since last, say, couple of years. And then the extent of damage you can imagine. In such patient, how do you think that you can improve his sexual health?
So his doctor is responsible for his HbA1c going to 13.
Yes.
But his doctor is also responsible. He has not given him so much guidance. So the onus lies with we physicians, not with him.
I think we'll stop here because wait for the other session. Ramesh, kindly excuse me because people are waiting. But your point is well taken. I just want to say the last sentence that Comet of India started.
Sir, Ramesh is a panelist. Ramesh is a panelist. He deserves a question.
Yeah. So the I wanted to mention is that it is said like this, that Government of India was only doing WHI, Women Health Initiative. But now we have started one male health initiative.
Yes.
That's centered around erectile dysfunction and the ankle brachial ratio. If somebody has a lower limb artery calcified, I do not know whether Deepak is doing now or not the penile.
We do it, sir. We do it.
In the institute.
API, we do it.
Yeah, penile blood flow. That is an excellent sign for the male health initiative. It is associated with coronary disease. So we have taken that. So I think Deepak, I'll invite you to one of the next meeting where you should speak about that how this.
Sure. Yes, my pleasure and my honor, sir. I will definitely.
Now, Ramesh, I'm very sorry. Ramesh, please ask your question. Make it brief.
I was just telling that a patient who is already devastated, he comes to you and expects that you will do miracles for his sexual health. After such an extent of damage, how can you help that patient? Because we discuss a ton, but treatment is in grams.
No, we need to give him some time to improve. We need to give him all the right kind of advices, and we should motivate him to follow the advices. And if he does so, see, we have patients at 92 also having sex. It's not that it's not possible. It is possible. Why it should not be possible? If you have if you do not have if you have control over your metabolic syndrome, if your blood flow is okay, we can help you with PD5 inhibitors to increase more blood flow and also give you all the things which you need. So it's not that it is not possible. The onus is with the physician. We need to be proactive. We need to be more committed to our patients. We need to see that their life is our lives, so we should be empathic and try and treat them in the best possible way.
Yes, sir. With the limited resources, we are facing this challenge every day. That patient
I think we should go to Dr. Goenka for the last question of the panel. And my question for Dr. Goenka is, what are the situations you have hypoglycemia in a non-diabetes setting? Because we had recently few cases and we lost a case also. So in the discussion of hypoglycemia, it's important that we must tell people in a non-diabetic setting what are the situations we can have hypoglycemia and how we'll proceed in them.
One, then that insulin secreting tumors.
Yeah, that is number one.
That's the first thing. Yeah. And others are categorized as pseudo hypoglycemia. I don't think there are.
There is pseudo also reactive. So there are hypoglycemia which are not pseudo means dropping from say 200.
Yes.
Pseudo.
I think what Jadbhai is meaning hypoglycemia.
Yes, JB.
Because of time shortage, I didn't attend that part of hypoglycemia in a non-diabetic. It's a big presentation itself, other than those having acidoplastosis or insulin or other typical non-diabetic hypoglycemia. But what we should worry about in a diabetic, we should always, in particular in elderly and female patients, also can have hypoglycemia. With mild diabetes or non-diabetic patient who is having adrenal insufficiency, maybe secondary adrenal insufficiency or cortisol deficiency.
That is the number one cause that we encounter.
So practically many of the times we see even a good control of diabetics suddenly having hypoglycemia, then it's a clinical clue to look at the adrenal insufficiency. So that's always you should keep in mind while even treating with the patient on diabetes.
So dear friends, I think we should close it now. We are well behind it. When we started, we had 40 minutes, now 1 hour. Now it is 1 hour, 5 minutes. Without taking, and also people are waiting. Ramesh, Jyoti is waiting. Of course, Sambit is our own here. Sambit is here. Sambit is waiting. So without wasting time, may I invite the chairpersons of the next session, please. Next person, chairperson. Yes, we have Sandeep Devashish Mishra. We have Mahesh. Both are very young and very energetic, very dynamic people. Over to them. I will request both of you. We are not going for lunch. So we have got half an hour. Plus half an hour you have to save from this session. So now we have got 3 very important talks. This is called technology in diabetes. And we have 3 people talking on the 3 important aspects. I will not repeat them. We have Dr. Shambit, we have Dr. Jyoti, and we have Dr. Bansi Sabu. So may I hand over the session to both of you to invite Dr. Sambit for the first talk on the automated insulin delivery devices.
Thank you, sir.
Babu, I thank Dr. Jena for your kind. Sir, I closed it unceremoniously, but you are closest to my heart because just to save time, sir. But you conducted this very well. Very big hand for Shishir Babu and Dr. Jena, please.
Thank you, sir. Thank you very much.
Yeah. Good afternoon, everyone. At the outset, I would like to thank team NUCD, especially Dr. Alukanungo sir, Professor Dr. Ashok Das, and Professor Dr. Jan Panda for inviting me and giving me the opportunity to chair a scientific session of this 9th edition of NUCD. So this session is going to be the interesting one. Since the discovery of diabetes, which literally means madhumeha, that is sugar in urine, science and technology has advanced a lot. And urine sugar is now a blessing rather than a curse to manage the diabetes mellitus with SGLT2 inhibitors. Then the diagnosis and management is based on blood sugar rather than the urine sugar. And nowadays, technology blessed us with CGMS and AGP, which further eased the management of diabetes mellitus for persons with diabetes and the diabetologists. So now we'll discuss about the technology in diabetes, for which we have 3 eminent speakers having national as well as the international repute. And the first session is going to be on the automating insulin delivery for better patient outcomes. And I would like to ask Dr. Mahesh Rath to invite my younger brother, Sambit Das.
Thank you, sir. At the outset, I would like to thank Kanungo sir, Jayant sir, and Ashok Das sir for giving me this opportunity to be a chairperson in this prestigious conference. Now, I would like to invite my guru, my mentor, Professor Dr. Sambit Das. Sir is a MD DM endocrinology. Currently, sir is a senior endocrinologist at Apollo Sugar Clinic, KIMS Super Speciality, KIMS Cancer Hospital, and Professor Endocrinology at KIMS Medical College, Bhubaneswar. Sir has got more than 70 publications. He is author in the API textbook of medicine, RSSGI textbook of medicine, diabetes, ESI textbook of endocrinology, and Sadicot textbook of diabetes also. Sir has been the PI in several research and clinical trials. He is also the National EC member of Endocrine Society of India, Secretary Aero Research Chapter, Joint Secretary RSSGI Research Chapter, and has been office bearers of ESI in the past. So without taking much time, I would like to request Professor Dr. Sambit Das to carry on with his presentation.
Sambit has started his slide sharing. Sambit.
My slides are visible and I'm audible, I hope.
Yes, visible. Wonderful. Yeah. Red and black. Fantastic.
Thank you, sir. Thank you, Dr. Mahesh. Thank you, Ashok sir, Kanungo sir, Jayan sir, for giving this opportunity. So I'll be talking on a subject that's very important and new to this generation. So that is automating insulin therapy for better patient outcomes. And in fact, I'm very eagerly waiting for comments and discussion where Dr. Jyotidev is there, because while going through the review of the literature, almost all the data from India were actually coming from his center on automating insulin therapy. So I'll be discussing on automating insulin therapy for better patient outcomes. So I must acknowledge Dr. Devashish Das from Mumbai, the medical team of Metronics, and Dr. Nagesh, my friend, for providing me some of the slides and the PPT which I have quoted in this. So we have come a long way. So if we see 100 years back, then when insulin was discovered by Banding and Best, and 100 years down to 2022 and 2023, we have come a long way. So initially, type 1 diabetes, the longevity was only 1.4 years after the diagnosis, and now you can see how good their quality of life is, and throughout their life they can have a good and proper normal life for type 1 diabetes. And intensive insulin therapy, we have known from DCST and other trials that it reduces the microvascular complication and also the macrovascular complications. So insulin has definitely changed the game of type 1 diabetes and to some extent to type 2 diabetes. But it has come with some risk factors also. So it's not entirely a very safe thing from the very beginning. So insulin could save life and lower the risk of glucose toxic diabetes complication, but then there was risk of hypoglycemia. And initially there were problems with the batches of the insulin where some batches were producing more hypoglycemia, the other batches were having lower, and then the porcine bovine came, and now we are at the human insulin, and more advanced or designer insulins currently are available. So we have come a long way, but the type 1 diabetes management has not reached the proper target. If we see the Swedish registry, and Swedish management of type 1 diabetes is supposed to be one of the best management. So they've also an average A1C of 8%. The type 1 diabetes exchange from US, the DPB, the UK data, the Belgium data have all shown that the HbA1c average is definitely higher than the targeted HbA1c for type 1 diabetes, even with the best of the care. So the Holy Grail has the finding for Holy Grail, or the search for Holy Grail, has always been there for a good glycemic control, and a quest has been there for two important points. One is for quest for an ideal insulin, which I am not discussing in this current slide, because insulin also we are searching for more and more advanced insulin. But for what we are discussing today is an ideal insulin delivery. And that too, I am not discussing about the ideal pen devices, which my subsequent speakers will tell. I'll be speaking on how we are doing a more automation of the insulin delivery devices. So the insulin pump, one of the things which gives an automation of the insulin therapy, have also come a long way. So we have the initial manual insulin pumps, and then the sensor augmented pumps, we call it as the VO pump. And the first, there was a threshold suspend. So it was a CGM assisted pump where the blood glucose, once it is down, it will suspend that insulin or the insulin delivery. Then there are predictive suspend. So whenever the blood sugar is going down, that downturn itself will automatically switch off the pump, and then it will again restart. The first hybrid closed loop was 670G, and the advanced hybrid closed loop, which the newer advanced hybrid loop is the 670G. So that gives an automated correction bolus, and the target is 100, 110, and 120, and the active insulin time is 2 to 8 hours. So it's a more advanced hybrid closed loop system. And then probably the recent future will find a completely automatic pump that is known as the closed loop device. So the sensor will give the data, and then there would be an automatic insulin delivery. So that's how the insulin pump will progress, and we are in a very advanced stage of advanced hybrid closed loop. So this is one of the earliest insulin pump where the sensor was not attached. Only the doctor has to calculate the basal doses and the bolus doses, and the patient has to just continue with that infusion pump. Then the CGM was added. We call it as the VO pump minimate paradigm with insulin pump with CGM, and the CGM gives the data, and whenever the hypoglycemia happens, the insulin infusion is stopped. So that is one step advanced. And then there was a pump that thinks. So the next generation pump where when there is a trend toward lowering of the blood glucose, the insulin delivery automatically suspends, and then it again restarts. But what has happened with the newer advanced hybrid system is that it has got important three components. One is the advanced sensor enabled insulin pump, and there is a CGM sensor that sends information about the glucose to a controller. The controller can be an algorithm or AI and calculates how to automatically adjust the insulin, and the insulin pump executes the command of controller to change how much insulin is being delivered. So this is the new 780G insulin pump, and you can see that this is the pump where it is connected to a Guardian connect link 3 transmitter, that is a CGM that gives values or that sends sensor messages of the sensor glucose to the pump, and you can calibrate with the AccuCheck guide link glucometer, which you need to monitor and calibrate the pump. And then there is a Minimed mobile app in the smartphones. So in the smartphone itself, you can see that how the insulin is being delivered and how the blood glucose is, whether the basal and bolus, how much it is being continued, and it gives all the data over the smartphone. And there is a computer, and finally all the data is transferred to a CareLink server. So there is a server which actually sees time to time how the sugar is there, and by its algorithm you can actually manage the insulin delivery. 780G pump has been recently launched. I have only 2 patients who are on 780G, and it's actually it's almost like a closed loop system. So automation of insulin delivery is an important concept, because once we started with an open loop where we it's more of a user's intervention. So patient has to check the blood glucose, calculate the dose, and give the bolus or titrate the basal dose. So that is more of a user intervention, but gradually it has gone up to a automation of the insulin delivery. So the AID system, where it is more of a mechanized thing, or a system workload is more compared to the user's intervention. So basically the patient's job or the doctor's job is relatively less compared to the machine job. The 780G or the advanced hybrid pump adjusts and corrects the glucose level every 5 minutes as needed, help prevents highs or lows with less effort. Lower default target of 100 milligram per deciliter, we can keep it, and with options to select higher target like 110 and 120. So this is the, you can see on the right side the pump, and if there is a shield mark which comes, that means the patient is in automation mode. So the algorithm is giving the proper insulin delivery continuously. Offers connectivity and upgradability. Patients can check their glucose level and receive notification on smartphone, share data with care partners. So the doctor can also get the report if needed, or the patient's attendant. Suppose the child is wearing this 780G, the mother or the father can, in their office, can see how the blood glucose is fluctuating in their smartphone. So that does the software upgrades, and upgrades are also available. So Minimed 780G adjusts and corrects glucose level automatically 24/7. Smart Gut technology helps prevent high and lows. And this is how the insulin is getting delivered. So there is a selection between the basal target of 100 milligram to, you can set it as 120 milligram per deciliter also. So whenever the blood glucose goes above a particular level, the basal insulin secretion also goes to that level to control the blood glucose. But at a certain point, if the blood glucose is still higher, the basal insulin adjusts every 5 minutes based on the sensor glucose value. But if it is still higher, then autocorrection delivers in the algorithm determines the need for as frequent as every 5 minutes. A bolus can also be, autocorrection bolus can also be delivered. So the basal is from in the green line, and the blue is like the auto bolus corrections. And finally, it tries to maintain the blood glucose in a very narrow range. It runs in a smart gut technology. So advanced hybrid closed loop system, or the 780G system, has got an auto basal by the sensor glucose, and also it auto corrections by the sensor glucose. It runs with an algorithm known as a PID algorithm. So what is a PID algorithm? So it's a proportional, integral, and derivative algorithm. So proportional means how far the sensor glucose is from the target, we call it as proportional. How long the sensor glucose has been away from the target, that is the integral. And how rapidly the sensor glucose has been changing, that is known as the derivative. And the total active insulin, both basal and bolus. So this is the PID algorithm by which it runs. So there will be continuous basal changes every 5 minutes, and also if the sugar is high, it will give a auto-corrected bolus dose also. The indications and limitations, currently there are some indications and there are contraindications. So the Minimed currently 780G has been currently approved for type 1 diabetic patients only who are requiring insulin, and the age at which the type 1 diabetes can take the approval dose is 7 to 80 years. The smart guard feature cannot be used for people who require less than 8 units or more than 250 units of total daily insulin per dose. The newer pump has got this much of limitations and indications, and the system has not been studied in pregnant women, persons with type 2 diabetes, or in person using other anti-hyperglycemic therapies that do not include insulin therapy. Use of clinical judgment is always recommended in cases where patients cannot read instruction on the pump screen, refuse to routinely check glucose, or are unwilling to announce meals before the eating. So there are some drawbacks. So the physician has to be alert that these are the conditions where the patient may not be correctly taking the pump. So what are the clinical evidences? The real world data, it's from the in silico to pivotal study to real world data, and there are good number of patients on this type of pump, and in all these trials it has been shown that the time in range has been to the tune of 75 to 77%, and the time below range has been always very low. So that means the hypoglycemia chances are low and the time in range were quite high. These are results as per the country. I think India also, they have gathered a good number of population and in 780G, and they are going to publish that. And the time in range across different countries is to the tune of 75 to 80%. And we know that's quite good, 75 to 80%, and the time below range has been minimized. So these are some of the randomized control trial where transition of people with type 1 diabetes on SMBG and multiple dose insulin, when they were converted to Minimed 780G system and continued for an extended period of 9 months, they found that the time in range has improved by 21.5% in 3 months, and the significant time below range reduction has been there to the tune of 4.4%. So time in range has increased, time below range has been reduced if you are changing from the conventional MDI to the 780G system. There is another study known as the ADAPT study. They have taken type 1 diabetes on MDI for more than 2 years using CGM, and they've changed over to the newer insulin delivery system or the automation of the insulin with the newer hybrid closed loop system of 780G. And what they found was that in the 6 months and continuation period of 6 months, where they've compared the 780G versus the multiple dose insulin with CGM, there was a significant reduction in the HbA1c to the tune of 1.4%, and the hypoglycemia incidences have also come down. So with this much of data, the global recommendation of automation of insulin delivery has been there, and youth and adults with type 1 diabetes to improve glycemic control should use this type of devices. Strongly recommended for people with type 1 diabetes, as their use has been shown to increase improvement in TIR and reduction in the hypoglycemia. This method of insulin delivery is preferred over other modalities. These are some of the not the data, like the use of this newer devices in India, and probably the first one is by Dr. Mohan and also by Dr. Jyotidev et al. In their center. They've used this as first time in India, and there are some other newer automation of insulin devices like the LibrePro associated with MyLife Ipso pump. And there is also a Omnipod patch, Dexcom, and controller devices, which are not there in India, but it has got some unique features also and can be used in type 2 diabetes and also in kids. There are some active players, and many players are actually planning for closing the loop. And there are different organizations who are coming with the more closing the loop or more automation of the insulin devices. So
the popular insulin pumps. And my answer to this question is, it is never ever going to be a complete replacement. But of course, the connected insulin pens are superior to the conventional syringes and insulin pens. That we need to agree. And how do you classify the connected insulin pens? The insulin connected pens can be classified into number 1, TIP. And these are the tracking insulin pens. And number 2, the SIP or smart insulin pens. And then you have the smart insulin caps. I will very, very briefly in the next 10 or 12 minutes go through the history. and also the details. And what is the history? When did we first have the insulin pens in the global market? And this was way back in 1985 when Novo pen was launched and many followed. And in 2007, the pen with the memory function was marketed. So just showing the memory of the insulin which is delivered. In 2014, there is another version of the same pen, and there is enhanced insulin pen cap. And the caps are still developed by many others. And this is the third component of the connected insulin pen. And then you have in 2017, another remarkable innovation. The US FDA approved the reusable smart insulin pen. So the smart insulin pen is quite different from the conventional connected insulin pen. So what are these smart insulin pens? So they have the connectivity. And the connectivity is via the Bluetooth. And usually it is a Bluetooth low energy so that it can save the battery life. Or it can be in addition to via the NFC, that is near field communication. The picture you can see a Novo Pen 6 getting manually connected to your mobile phone, which is NFC enabled. The pen is also NFC enabled. And the data is transferred via this application to the mobile phone application, and it can be digitally stored. It can be stored in the cloud, for example, in the glucose. And similar to what we have listened to Dr. Sambita, similar to the stages of evolution of an automated insulin delivery system with an insulin pump, we do have a similar staging with connected insulin pens. And stage 0, unfortunately, we are still at stage 0 in India. And these are the usual pens. And in stage 1, we have the tracking insulin pen. Retrospectively, the dose is documented in the pen. And in stage 2 of a tracking insulin pen, it is a real time. In addition, you have the insulin on board data. The data is stored in the cloud. In stage 3, and that is the final stage with tracking insulin pen, it is integrated with diabetes management systems. You can retrieve the information. You have the insulin doses, the carb, and then you have the CGM data against this. And in stage 4 and 5, remember, these are the smart insulin pens. And this comes with the dose calculator. It can even detect the priming of the dose so that it is abstracted from the insulin on board. Or it can prevent the insulin stacking, it can efficiently prevent hypoglycemia. And then you can have different settings such as ICR, the insulin sensitivity factor. And these are all very similar to what is happening with an insulin pen for more than 50 years. And in the final stage where we are now, it comes with an additional setting for the weight of the person. And then it can even provide you with customized coaching and education, it can deliver the modules. And this is probably one of those examples of an advanced decision support system. So the smart insulin pens are also rapidly advancing. So this is from Novo. There are 2 insulin pens. These are not available in the Indian market. One for adults, that is Novo Pen 6, and the other one, the colored one, is the next version of Echo, that is a Novo Pen Echo Plus, meant for children, the pediatric population, which has got the ability for 0.5 dosing, that is half unit dosing. But in addition, you can see that over the pen cap, you have the memory of the last delivered bolus, or even the basal. You can use the same for even Tresiba or for long-acting insulins. And then the duration from the last injection, it stores 800 injection memory. And the battery, it has got a life of 5 years, and it is also NFC enabled. So another one which is approved by the US FDA, cleared by the US FDA, is Bigfoot Unity. So we have been listening to Bigfoot for more than 20 years now. And this is an integrated diabetes management system, which can be used along with either a basal or a bolus. So what is special about Bigfoot Unity? This is again an example of how an insulin cap can be integrated with other pens. And the cap can be used as a reader or an NFC enabled phone. You can scan the Libre reader with this, and the data is captured by the insulin pen over there, and it will automatically suggest you. It is there on the display over the insulin pen cap itself, the dose which need to be delivered. So that is quite amazing. The cap in the pen itself is suggesting you the dose of the insulin to be delivered. So what are the clinical features or the merits of a connected insulin pen? If you are a believer of precision diabetology, this is again an example of how precision can be ensured when you are using a delivery system for insulin. And another one, delivering the right dose at the right time. There is no question of missing a bolus. It will remind you if a bolus is missed or if it is mismatched. And it is also having the provision to integrate with other diabetes-related data and also capable of informing you with therapy decisions. And for the doctor as well as for the physician and for the patient, it helps you overcome the major challenge. I would say that the major challenge in diabetes is overcoming the therapeutic inertia. And some of these connected pens are also enabled for sensing the temperature of insulin. It will give an alert if it is exceeding the temperature. It can also provide you with an alert if the insulin is expired or the cartridge need to be replaced. And if you are unsure whether you have bolus or not, then you can check in the mobile phone application and the data will be there. And this is how it is transforming from Diasen to Gluco. Not available in India, but popular all over the world, a data management system where you can download the information from a insulin pump or from a glucometer or a CGM device, and including from the smart insulin pens. And this is also helping patients for a long time, and also the hospitals to probably increase the time in range. So now diabetes management all about percentage time in range and the TR metrics. So let us now have a glance on how the connected insulin pens are improving the TAR. And this is a study among 94 patients. This is with Novo Echo Plus and with Novo Pen 6. Type 1 diabetes subjects using a CGM and a basal bolus insulin regimen. And with connected insulin pens, the TAR increased by around 1.9 hours per day. And the level 2 hypoglycemia, that is below 54 milligrams per deciliter, again reduced by 0.3 hours per day. And that is significant, very, very significant, both statistically and clinically. And there is a significant reduction even for the time spent in hypoglycemia. And what is it? MPD, very important in a basal bolus regimen in type 1 as well as in type 2 diabetes, missed bolus doses. And that is very, very common. And with the use of connected insulin pens with remainder functions, the missed bolus doses were reduced by 43%. So with the use of advanced user-friendly technologies such as with the smart insulin pens, there is significantly more time spent in range, and there is a significant reduction in the missed meal boluses. And this is how it has evolved. For those of you interested in going through the history of evolution, and this is the history for the last 100 years, ever since the discovery of insulin, the insulin delivery devices are also advancing. And this review from India, this has been referred to by the ADA, by the AS in their clinical practice guidelines as well. And moving on to a detailed discussion, smart insulin pen. And this is in pen. Originally, it was actually a property of another company. This is now acquired by Medtronic. And this is a reusable pen, automatically capturing the meal dosing. So you need not manually put anything. And the data is automatically logged in. It prevents insulin stacking. But what is special? You can see that it is giving a reminder function. Did you miss your breakfast dose? And this can appear on your Apple Watch or on a smartwatch so that you will never miss a dose. And this is connecting via Bluetooth. And you can see that there is CGM at the bottom and the insulin kinetics at the top. It helps take some of the mental math out of the diabetes management. So it can itself automatically suggest the dosages of insulin to be delivered and considers insulin on board. But you have to manually, but that is important for InPen. With InPen users, you have to manually log in the data pertaining to the long-acting insulin. And it currently works with all the rapid-acting insulins. So the SIPs, so again, this is what which is shown on the picture is InPen, originally from Companion, and now with Medtronic connects to Guardian sensors as well. The SIP dose calculator offers support for those on similar but less precise fixed mealtime dosing regimens, and counting the carbohydrates, using the insulin carb ratio, and it is precise to even a decimal point. Over 4 time periods, we can change your insulin carb ratio, the insulin sensitivity factor, the variations related to the eating habits, menstruation, physical activity, and so on. So many of these are similar to the settings in an advanced smart insulin pump. And this has to go through the ISO standard. So what is the ISO standard for the connected insulin pen? So 15187 is the standard for the glucose meters. And here it is ISO 116081. And this is considering the accuracy for extremes of temperature, for extremes of humidity, for extremes of vibration, exposure to dust, and even to the moisture. It needs to be stable. So when will you recommend connected insulin pens? You can recommend connected insulin pens for those with recurrent episodes of hypo, repeated hospital admissions for uncontrolled diabetes, a glycemic variability which is sufficient enough to result in mood swings, psychological distress or depression, very common. Those who are repeatedly forgetting the bolus before a meal, those are having difficulty in mathematics, carb counting, because the pen is helping you, the app is helping you a little bit with the mathematics, and elderly who are living alone, and of course, children with type 1 diabetes, a large population who cannot afford or who are not comfortable with the use of insulin pump therapies, and women who are pregnant with diabetes. And these are also useful for those who are caregivers for people with diabetes, because it is much more convenient, and also for in-hospital use. And look at the global market. The global market for smart insulin pens, it is steadily growing. And if you look at the segment, it is in 2021, it has got a market size of US dollars 97.6 million against $306 million in 2030. And in 2021, the home care settings, that is a home care settings segment, has actually contributed to 25% of the market share. So it is steadily growing globally. And the US FDA has also started approving some of the smart pen caps in addition to the smart insulin pens. And this is the Malia medical device, a smart sensor which can be attached to either an insulin pen delivering a long-acting insulin or a rapid-acting insulin. But very recently, this is also getting approved for use with GLP-1 based pens. So that is amazing. So in conclusion, my dear friends, the future of diabetes will be heavily dependent on the use of technologies. And this is because of the reason that most of the patients are finding it very useful with better outcomes, much better outcomes. And number two, the clinicians like us cannot shy away, because the use of technologies is going to be very, very useful. And this probably will be the one which is benefiting those below the age of 40 years, because below the age of 40 years, most of the patients consider the use of technologies and a mobile health application, a user-friendly M-health application as a loving, caring companion. So thank you very much, sir. So I can see Das sir over there. So thank you for the opportunity.
And that talk, Jyoti, and it's a fabulous talk. You know, from the very beginning, from the word go, when you started thanking Sandeep and started this talk, I'm there, and I must tell you that we'll have some questions after Bansi's presentation.
Sure. I'll wait. Yeah.
Can we invite Bansi now to present? But I think it's fabulous. Yes.
Yeah. Thank you, Jyotidev sir. So it was a very nice presentation. Now I invite Dr. Bansi Sabu for his topic on CGMS, and to introduce him, he needs no introduction. He was the
I think Bansi is everything. So he's a polymath. Polymath in diabetes.
Yeah. And during his tenure of president in RSSD has seen a lot of change in technologies. So hats off to Bansi Sabu sir. And I invite Dr. Bansi Sabu sir to start the session on CGMS. Over to Bansi Sabu sir.
Thank you, Dr. Kanogo and Dr. A.K. Das for giving me an opportunity to talk on a continuous glucose monitoring. It's very, very important topic, and in next 15 minutes, I'll be finishing my talk to understand where we have to use the CGM. I have no financial disclosure for making this talk. This is very important statement. Somebody had talked that continuous glucose monitoring have a future because intermittent monitoring is not up to the task. Neither it can avoid the hypoglycemia, nor it can get a target range by using insulin. And at the same time, by doing a multiple times monitoring, you are not able to control the glucose variability too. So CGM is a future, and this has been talked in 2013. And after 10 years, we are feeling that, yes, it is really a future, and probably in another 10 years, we all will be using continuous glucose monitoring. Let me give an example. If I do a SMB, actually it is not normal person hypoglycemia too. So you can understand how CGM is more useful to know where person is getting hypo and hyperglycemia. It's like a difference between a photography and videography. You know that with a photograph, you can know the random blood glucose level, but when you do the videography, you will know that how the person is actually moving, where the glucose is going up and down. The similar way, the difference between Holter monitoring or just getting a ECG for a routine physician, just to tell them that how they are different, they're getting continuous glucose monitoring or a random blood glucose monitoring. We know that HbA1c, which we are doing since last 30 years for our patients to know the average glucose, but you may have two different type of patients, one with the same A1C, but you will find if you will do the continuous glucose monitoring on left side, you can find that their sugar variability is not very high, while other side, you will find there is a lot of glucose variability. There is a hypo and hyperglycemia, but still person is achieving HbA1c of 7.8. So whether we have to just see 7.8 A1C and further titration of the patient is to be done on 7.8. On right side, a patient will develop more hypoglycemia, but on the left side with 7.8 with less glycemic variability, probably he is doing well. So there is a rationale for using continuous glucose monitoring in the persons who are not meeting with A1C, have frequent low blood glucose level, they are unaware of low blood sugar level, or those who want to reduce their A1C target without increasing the hypoglycemic events, they are the one who need continuous glucose monitoring. The limitations for currently what available monitoring method is A1C, which is the give you average sugar and does not count for hypoglycemia and hyperglycemia in between, and it does not give you any information as far as glucose variability is concerned. If I talk about the SMBG, it gives you the information of that point of time, and when hypoglycemia there, or the overnight data is impractical. Logbooks are really difficult to interpret too. The continuous glucose monitoring, again in India, we have both available professional CGM and real-time CGM. Professional CGM is with iPro, with more commonly we are using with Libre Pro, but there is a iPro also of a Medtronic, but real-time we have with Libre, we have with Medtronic, and we have with Dexcom too. The classification can be done with a real-time, which is, as I told you, like Dexcom, intermittently scanned CGM, which is a Libre, which is the person has to do the multiple time flashing, that we also call flash glucose monitoring, then blinded one or a professional CGM, which is like Libre Pro or iPro, and there is an integrated CGM, which is also available in our country when it is integrated along with the insulin pump. So person can see his sugar report in the pump itself only, while the CGM sensor is separately placed, but the sugar monitoring can be done in the pump itself. So there are different type of CGM. Luckily in India, we have all varieties of continuous glucose monitoring which are available. If you see over the time of evolution of continuous glucose monitoring, it started almost in 1970, but in India, we started using more after 2000, but primarily in last 5-6 years, particularly when Libre had come in India with professional one, the uses of continuous glucose monitoring in our country also increased. But all over the world, the Dexcom, Medtronic, and Libre, we are very, very popular. And probably in coming near future, we will be having a continuous glucose monitoring, not for 10 days, 14 days, but it will be months together, or maybe with an eye lens with one company is working, probably it will become become, once you put it, maybe lifelong, you can see your sugar report continuously on your mobile, like you are seeing the temperature of your city or the pulse rate, which you can measure through the app or by different way. There are challenges which we used to use the electronic one, which was having a real challenges because 7 days in a 7 different colors, the continuous glucose monitoring reports used to come. So interpretation of that was real difficult. And then this a software had come, that is ambulatory glucose profile. We just put all the 7 days report in such a way that you can see the median of it. You can see that how much time the person is having, another 50% of the time moving in hypo and hyperglycemia, what is the level, and the last 10%, even the this 10% also in a slowly noted form also, which you can see that if it is not causing severe hypoglycemia for 10%, even you can omit that. If occasionally it is going in that way, you can omit it also. So this is what ambulatory glucose profile is, compressing all the data of those 7 days, 10 days, 14 days in a format in such a way that you can see that in a median glucose level and how it is moving up or down. So I mean, it becomes much easier for a clinician to interpret the data. Now the question comes, what's the utility of continuous glucose monitoring? Is it really going to give you the information? In 1983, it was showing that when we have done a DCCT trial with a self-monitoring of blood glucose level, the persons could achieve the A1C from 9 to 7.2, which was the average A1C from 9 to 7.2. But severe hypoglycemia rate was 62 per 100 patient year. This is in DCCT trial in 1983. After 25 years, these patients were put on a continuous glucose monitoring, and this was a JDR of CGM data. After 25 years, what we could see, it is decreased significantly the hypo risk by 20% instead of 62. Yes, the newer insulin analogs also we started using, but still the risk of hypoglycemia is significantly reduced by putting the patients on a continuous glucose monitoring, and that's a scientific evidence which we have. But if you put them on CGM along with pump, probably you are almost omitting the hypoglycemia. And this is a data of a pivotal trial in 2016, with the median A1C they could get from 7.7 to 6.9 without a single episode of a hypoglycemia. So this is the utility of CGM, or you can say the scientific evidence behind the using CGM, that it not only significantly reduce the A1C, but at the same time significantly reduce the risk of hypoglycemia too. Now, do we have other study for that? There is a gold study which is compared with CGM versus SMBG. Is the lower risk of hypoglycemia and better quality of life? There is a one silver study which is talking of beneficial long-term HbA1c control in a patient who have treatment satisfaction with CGM versus SMBG. Again, it had shown a significant improvement in A1C as well as risk of hypoglycemia significantly decreased. And then there is a diamond study which is talking of better glycemic efficacy and safety of CGM versus usual care. These were the type 1 diabetic patients, 158 randomly assigned for self-monitoring for 24 weeks. It had shown in its conclusion that significant reduction in A1C with lesser duration of hypoglycemia, the patients who are on CGM. So real-time CGM is superior to flash glucose monitoring for glucose control in type 1 diabetes. Coridia randomized control trial. This trial had talked about the evidence of grade 1 evidence, which is published in type 1 diabetes, that yes, it is having a grade 1 evidence, particularly in type 1 diabetic patients who are using real-time continuous glucose monitoring. In India, we have published one paper with Unni and Shashank and Jyotidev on consensus statement of using continuous glucose monitoring in type 2 diabetes. And these were the patients who are on oral anti-diabetic agent, which we had also talked that how it can be useful for the patients who are on oral anti-diabetic agents and they are type 2. So we have a lot of data from type 1 from the Western world, but we try to do some data from India also. This is a paper which is published in Journal of Diabetology with Dr. V. Mohan, again with Jyoti, Sunil, Manoj, myself, Rajiv, many more persons for talking of retrospective continuous glucose monitoring, which is Libre Pro, for optimizing the management of type 2 diabetes in India. This one more paper which I published, time in range is a target in type 2 diabetes. This is an urgent need. We need for our type 2 diabetic patients also a time in range. That has been a concept primarily been designed for type 1 diabetes when they are using CGM. But if our type 2 diabetic patients also do CGM, probably time in range will give us more idea about what is the target. CGM is an additional asset in current pandemic because the patients who are not able to come to the clinic or face-to-face meeting, even distantly, they can also contact with their doctors too. And even in the hospitals, even in hospital, we don't have the data more from the ICU, but we have the data, those who are getting hospitalized and in the room, the real-time continuous glucose monitoring can be done. And even their data can be also transferred to the diabetologist if diabetologist is not coming to see them face-to-face too. So they can be used, even the patients who are distantly, they can be treated and they don't need a face-to-face consultation too. Do we have any guideline which is talking of it? Yes, international consensus is talking use of continuous glucose monitoring. Luckily, I was part of this expert group. It has been endorsed by American Association of Clinical Endocrinology. It has been endorsed as a clinical endocrine as by showing that even in 2020, that immediately after the guideline, which was consensus was released in 2020, they are saying that using CGM whenever it is indicated in assisting patient in reaching glycemic goal. And this is for type 2 diabetes. So they were the first one in 2020 that use of continuous glucose monitoring in type 2 diabetes too. A said, talking very clearly that CGM is being recommended for type 2 diabetes patients in the algorithm in executive summary. This is one more paper which we had published in JAPI, using ambulatory glucose profile for improving monitoring and management for type 2 diabetes, and also one more paper as a consensus guideline for glycemic monitoring in type 1 and type 2 diabetes from India too. And one more paper which has recently been published, how frequently they should do the continuous glucose monitoring, but that's a very important question most of the time asked by the physician, that how frequently they should do the CGM too. And this was endorsed by multiple society across the world, including Diabetes India from India, that using CGM is not only for type 1, but also for type 2 diabetes who are on insulin or who are on multiple daily insulin injection. The frequency should be those patients who are very well controlled, even once in a year is fine. But those who are not very good control, once in a month, relatively controlled once in a 3 months, and relatively well controlled even once in 6 months, a professional CGM or a blinded CGM can be done with this. At this point of time, I can't say that we can replace A1C or SMBG. I will say all three are complementary and essential to each other. A person who is doing CGM also should have A1C as well as the random blood glucose monitoring. Let me give you one example of a patient to whom we have started after seeing the CGM, the GLP-1. This is the patient who was already with 9.5 9 HbA1c and was already on a triple drug with a gliptin, with metformin, and with sulfonylurea. He was very uncontrolled. He had gone with 2 doctors. I just put the patient on CGM and we asked them, instead of gliptin, let us put you on GLP-1. And every alternate day patient sugar was getting down. And we stopped her glimepiride from 4 milligram to 1 milligram, and then it was 0 GLP-1, metformin and SGLT2 combination, and you can see here it is very well controlled. So you can see how continuous glucose monitoring have given us the guideline or guided us to achieve a tight glycemic control without getting hypoglycemia and without using even the insulin, and patient is losing weight, recovering, and you can say almost like a getting reversal with HbA1c of 5.8. The patient is maintaining less than 6. So to summarize my talk, continuous glucose monitoring is assisting us for discovering unknown hyper and hypoglycemia. It also gives us the idea about the glycemic variability, assessing the percentage of time in range and out of range. It gives you the severity also of hypo and hyperglycemia. It gives you actionable information which we get from CGM. It gives impact of behavioral variances. It analyzes glycemic effect of new intervention effectively and efficiently, and it also gives care of diabetes which is getting digitalized. So CGM enhances patient self-management, adherence, and confidence of diabetes. With this, I once again, thank you very much for all the listeners, and thank you very much, Dr. Kanungo sir, for giving me this opportunity. Thank you. Thank you.
Thank you, Vansi, very much. At this point, I will invite Dr. Kanwar, JB Kanwar, who will be moderating question answer session. Is Abhay has come. Abhay has joined. I'll request Dr. Kanwar to start.
This session has been excellent with 3 excellent talk on automated insulin delivery and smart pen and CGM. The gist, the 3 excellent talks, and the take-home message from these 3 talks would be, we are probably reaching to the target HbA1c without hypoglycemia using these 3 talks. So all did fabulous job. And we should use more neurotechnology for achieving the glycemic control and without hypoglycemia. So my first question would be to Dr. Sambit Das. Sambit presented about automated insulin delivery, starting from the discovery of insulin to still the 870Z of insulin pump. So my question to be Sambit is, this is normally being used in type 1 diabetes. How do you place the use of this automated insulin delivery system in type 2 diabetes? And there have been studies with 670Z or 770Z with a few number of patients with type 2 diabetes, and they have been doing well. So how do you place this automated insulin delivery system in type 2 diabetes? And which subpopulation of type 2 diabetes would be more helpful of using this automated insulin delivery system?
Yeah, I think that's a very important question. The newer hybrid closed loop system, that is the 780G, the indication is only for type 1 diabetes actually. So whenever you are using type 2 diabetes, so probably that would be an off label. But nevertheless, many times type 2 diabetic patients have also been put on insulin pumps. So those who are having high fluctuation, mostly brittle diabetes with frequent hypoglycemia, hypoglycemic unawareness, requiring large doses of basal bolus therapy. So probably in those patients with type 2 diabetes, we can use, but again, it is not indicated as per the data by the new hybrid system.
Why do you think the insulin pumps are named as 670Z, 770Z, 870Z? What is the idea behind that?
I think these are the different generation of insulin pump. Dr. Jyotidev sir should make a comment on that.
Yeah. You are right. You are right. This is to indicate the generation of the pump and generation of the sensor.
Yeah.
So we started with 715, 722. So those were the partly closed loop systems, and now we have hybrid, and then advanced hybrid closed loop system is 780G. And the 780G, the algorithm, so Dr. J.B. Kanbar was asking the question on type 2. So this is widely used in type 2 as well. So there are three algorithms, that is proportional integral derivative, model predictive control, and fuzzy logic. And some hybrid closed loop systems are using PID, some others are using MPSC. But they have seen that the algorithms are so difficult in type 1 diabetes. So they are having all those clinical trials in type 1 diabetes. So type 2 diabetes is so easy to use these pumps. So it works, probably the TAR is much better when you are using in type 2 diabetes. So it is recommended, and there were earlier insulin pump therapy tested in type 2 diabetes, and those were the standalone pumps. And Medtronic themselves initiated I think 3-4 countries were involved in the clinical trial with type 2 diabetes. And they have established that this therapy is useful in anybody who requires a basal bonus therapy. That's it.
Jyoti, I wanted to ask, Converse have asked you any special patient population, and Sambit referred to brittle diabetes. Do you think it has a brittle type 2 diabetes? But do you think that it has a use in diabetic kidney disease? Morning we discussed that. Manisha mentioned about diabetic kidney disease advanced, where it can give a lot of benefit. GDM, where in India, GDM, we have got, rental available, this type of monitoring devices on rental available, and maybe difficult type 2 diabetes in the adolescent, which are now we term it malignant type 2 diabetes. JB, I wanted to ask this question to Jyoti and Sambit, because I think these are also the areas where type 2, this will be of great benefit.
Absolutely.
What do you think, Jyoti? Yeah. I think in the situations where the pain of a neuropathy is intractable.
Yeah, that is your first paper where you showed a lot of benefit of the pump in the neuropathy. Yes, I remember that.
Yeah. So still we are using it in neuropathic pain. It usually disappears very fast. And in and the same case with erectile dysfunction. It improves erectile dysfunction in CKD. Not only in early CKD, even in late CKD, when the requirement is changing, when somebody is undergoing dialysis, and then the patient can be on two different profile, because there are different patterns which can be programmed in the pump. So the patterns can be different. So Dr. Sambit Das discussed about the AAD. So the AAD, the pattern will be automated. So the basal is automated, the bolus is automated, and this is once in every 5 minutes it keeps on changing. So it's so different from all the other insulin pumps which have been used till now in India. And there are patients, Dr. Sambit, in India who are using Omnipod 5. Not only Omnipod Dash. So these are the insulin pumps which doesn't have any strings or tubes attached. Anybody who is using an insulin pump, the biggest challenge, especially in children, is because of the tubes. And the Dexcom and the attached to Omnipod, that comes with the unit. Dexcom, the generation 6 of Dexcom, and along with the pump, the algorithm when compared to Medtronic 780G is inferior. It's very important. So the time in range will be 3 to 4% less when you're using the Dexcom devices. But for those who are using, the convenience is much more. But we probably will not have Dexcom in Indian market very soon. And hence we'll be happy. But the number of people using DIY are increasing in India. You mentioned about DIY. It is very much increasing. There are more than 50 people currently using DIY in India.
How is your opinion? How is your experience with DIY, sir?
I think DIY is excellent because we have shown the 715 and the 722. So these are the older generation of the standalone insulin pumps from Medtronic, which can connect with the sensor, because now they have actually closed everything. So the API is closed and it cannot connect with the other sensors. So the old insulin pumps, which can be re-engineered, and people are using it along with even Libre Pro. So Libre Pro, it is not a real time. Even Libre is not a real time. So they are using a Night Rider or a Mio attached over the sensor, and it will function as a transmitter, and it will transmit once in every minute or once in every 5 minutes. And then there are open source algorithms available in the internet. So you can download the algorithm and you can use an intermediate device called a Riley link. And the Riley link will be connecting wirelessly the insulin pump with the sensor. So there are many people, but the recommendation is DIY shouldn't be used in small children, because we have to have so many changes, modifications. So it is preferred that it can be, and we cannot recommend anybody to use a DIY. The ADA says that if your patient is using a do-it-yourself artificial pancreas and coming to you with a question, you should be ready with the answers. You should be capable of assisting them. But since it is not regulated, you cannot recommend. But the TIR with the DIY is almost 95 to 100%. But with all commercial devices, it is only up to 75%.
So what would you advise if you put someone on an automated insulin? My question to Dr. Sambit and Dr. Jyotidev, if you are putting someone on automated insulin delivery system, what are the things they should be careful about?
I think Dr. Sambit.
Yeah, I think it is almost like a algorithm-based thing. So definitely for first 2 days, it is mostly manual, and after that a shield-like thing appears in the screen, so that it has gone into algorithm mode. So that will give a auto basal, auto this thing. So you need to just to find out the active insulin, or you have to write the active insulin time and nothing more, and the bolus what you were giving, or the bolus time or the food timing. So these are the two important things that has to be observed, and the tubing has to be changed properly. So that is as per the norm, and I think that's it. So it's actually a very good system, and I could find that one of my patient who was on earlier insulin pump, the VO, then transferred to this 780G, the TIR has actually increased up to 90%. So I was so happy to see that actually.
Yeah, more number of people would achieve the glycemic control.
Yeah.
My question is to Dr. Jyotidev. If you are using Smart Pain, it's actually a smart pen which would adjust everything: weight of the patient, what is the temperature, what is the dose left in the insulin in the pump, in the insulin pen. But can that replace the carbohydrate count? The smart insulin pen, can that replace the carbohydrate count? You don't need to count the carbohydrate amount you are taking.
Dr. Kanwar, that is a very good question. Because you are going through the stages of insulin pump, and that was demonstrated by Dr. Sambit. And I discussed about the stages in the development of a smart insulin pen, which was previously a TIP, a tracking insulin pen, and now it is an SIP. And if you look at the stage of automation of insulin pumps, now we are entering the stage 4 of automation. That is advanced hybrid closed loop, and previously it was hybrid closed loop. And even though the completely closed loop systems are existing in the clinical trials, the only difference is it doesn't require a carb counting. So that is the biggest hurdle. So even now, when you're using a hybrid closed loop system or an advanced hybrid closed loop system, because I have this WhatsApp group of patients where you can see that the patients are in the WhatsApp group.
Yeah, correct.
And this is an Omnipod. This is one of my patients using an Omnipod. And here it is almost 95% diamond range. And almost same as this, but everybody has to enter the carb manual. And the elimination of carb counting and with the use of a camera in the mobile phone automatically capturing not only carb counting, fat counting, and protein counting will be the stage 5, final stage of automation. Our dream.
Can these smart pens be connected to the real-time CGM?
Yeah, sure. Because the smart insulin pen, the Novo pen can connect with the Libre. Libre is not a real-time CGM. Libre is an intermittently scanned CGM. The only real-time CGM available in India is Guardian Connect. And the Guardian Connect connects to InPen. InPen is now marketed by Medtronic. InPen used to be with somebody else. So it actually connects with real time, and then in real time, it suggests the dose of insulin.
Jyoti, I mean, you said smart pen is ordinary insulin pen, which has got the app. Am I correct?
Sir, a smart pen is not an ordinary insulin pen. It's a very expensive insulin pen.
Novo 6, Eco Novo, the two pens.
Yeah, 2 pens. Novo Pen 6 and the Novo Pen Eco Plus. And these are very expensive. So these are very expensive because it has got near field communication enabled. The cap is Bluetooth enabled. And the cap connects with a sensor such as Libre or Guardian Connect or even with Dexcom. And then collects the data. And that data is transferred to the mobile phone application. And manually you can transfer the entire data to a cloud-based application. So it is simplified. It can be used along with the long-acting, along with the rapid-acting. And since it is prohibitively expensive, Novo Nordisk has decided not to actually launch it in India. But Guardian will launch along with InPen. Medtronic is planning to launch InPen in India. And InPen can be used along with other cartridges. It can be used with Humalog, with the Novo Rapid, with Fias. All the cartridges can be used along with InPen.
All sorts.
Okay. I think it is
my next question would be to Dr. Bansi Sabu. What is the role of CGM in hospitalized patient? We do CGM in outpatient basis, but is there a role of CGM in hospitalized patient?
I think Jyoti will answer, JB, because Bansi has just left.
Yeah, during the COVID pandemic, the Freestyle Libre, Abbott, Medtronic, they were all providing free CGM in the United States to hospitalized patients. We are all aware. And in hospital also, it has got a very pivotal role. But we should be aware of the fact that some of these CGMs, it differs from CGM to CGM, it will be interfered. The results, there are interfering substances such as high doses of vitamin C. For example, if it is more than 500 milligrams per day, or if the paracetamol dose is more than 2 grams per day. So in patients who are having fever, if they are using flu medication, some antibiotics can interfere with the accuracy of the results. And in the presence of hypothermia, in the presence of septicemia. Otherwise, in general, in hospitalized patients, it will have a very, very important role. And in some countries, there is a hospital version for the CGM. And that version is not marketed in India. Even Freestyle is having a hospital version in countries such as Japan and China. So since CGM is not that very popular in the hospitals in India, they are waiting. So the answer is, in the ICU settings, in the hospital, it will have a role. But we need to train the doctors and nurses. Am I audible, sir?
Yeah. But JB, why you had doubt about hospitalized patients? Because there is not much change in the daily activities. That's why you asked why it can or cannot be used in hospitalized patients. What was the idea behind the question, JB? Because contrary to the people who are in outpatient, inpatient has a monotonous or same type of lifestyle, so one doesn't need that. What was the reason behind this question, JB?
You are muted. You are muted. Yeah, please unmute.
So, we know that the glycemic parameter, diabetic patient with good glycemic control, they have lesser in hospitalization days, the lesser admission to the ICUs. So just I wanted to do a study. If you can control the blood sugar, these patients with CGM, do they have less hospital stay, less hospitalization to the ICU, less admission to the ICU? So that's the reason I wanted to ask this question.
Good question. Now about the connected meters. It was not the part of the discussion today, but Jyoti, Sambit, what's your take on that? As a not a replacement, it can't replace, but as rising to the occasion to certain extent.
Sir, Jyoti sir.
Sambit, yes,
yeah. So, the connected meters, which are Bluetooth enabled and connected to a smartphone or to the computer, are definitely going to be helpful because they will give a data like that of the CGM. At least they're not that expensive, but they will give a data like CGM, and many memories are there. So we can capture the data at different type. So maybe it will look like a flash glucometer.
So if you have not seen this meter, I will show a meter. This is also a connected meter. And I don't know whether you have seen this meter. It's a e-touches with 2 sensors in the front and 2 sensors at the back. And this is an upcoming non-invasive glucose meter. So it doesn't have any needle or any pricks. And this is the first version, a prototype. So you will probably in the near future, we'll have non-invasive glucose meters and also totally non-invasive continuous glucose monitor. So no needles at all.
Correct.
How they do it? From the sweat or from the band, or how they do it, Jyoti?
You remember that there were a lot of clinical trials with the sweat, with other body fluids, with the tears, and all of them miserably failed.
Which one?
Google and Novartis was behind this for more than 10 years. Apple also failed. And these are with some new technologies called bioimpedometry, then tonicity, measuring the level of fluid and electrolytes inside the RBC. So when the glucose is increasing and reducing, the fluid shift will happen within the RBC from inside and outside. So they are measuring it from the surface of the skin, but not from the fluids. So it is actually measuring not from the fluids, it will be measuring non-invasively from the blood itself. So some young people are involved in this. So many young people. And most of these are in the form of a watch or in the form of a wristband.
A glucose watch like.
Yeah. And I am also involved in one of these studies along with some boys in Bangalore and Chennai.
I was told Indian Institute of Science, they are trying to develop one such thing. They had asked me, and you remember, are you there in that meeting where we were giving money to startups?
Yeah. I know about yes, remember, sir.
Yeah, very much. I would take JB and the audience which here, Sambit is here. The boy wants to develop a pump for 1,000 rupees.
Yes.
Remember? It was great. We are so delighted, and I don't know what has happened. So, but he got the sanction to take it forward. Thank you very much. I think all good things have to end, Jyoti. We would like to have endless conversation with you and Sambit, but all good things have to end because I can see Alok getting little said that we have late for the next session. So dear friends, give big round of applause for Dr. Kanwar, who conducted the questions very well, and round of applause for Jyoti, Sambit, and Bansi. And my appreciation for Mahesh and Sandeep. Thank you very much for a wonderful session, technology. Thank you very much.
Thank you, sir. Thank you.
Thank you, sir.
Mahesh. Right. Thank you, Mahesh. So we will pass on to the next session, and that is a session on a very important topic called autoimmunity in diabetes. So I have great pleasure in inviting you to the session on the autoimmunity in diabetes. And we have very important discussion in this session. The we will be discussing autoimmunity and diabetes. I have a chairperson, Dr. Archana Sarda. Archana Sarda is a queen of type 1 diabetics. And those of you who do not know her, I know you, Sarda, but I must tell you that through her dedication, tenacity of purpose, mother-like attitude for type 1 children in and around Aurangabad, she has made a difference to the care of the type 1 diabetic patients and acclaimed not only in India, but also abroad. And any one of you can detail discuss with her how she has taken the type 1 diabetes care to the next level. And I hand over the session to her. Sarda, Archana, we have 3 speakers, as you know, and without, I request you to kindly, I must tell you that Alok had a PhD on the latent autoimmune diabetes in adults, so he's going to speak about that. Sanjeevi is an authority. He was also done extremely well, and he is from Karolinska. He will be joining. He's already joined us. And then we have Rishi, who is a great type 1 protagonist from the city of Kanpur. And he has a large patient base in the entire North India belt. Over to Sarda. Archana, please take over.
Thank you, sir. Thank you so much, sir, for that lovely introduction. And thank you for having me here as a chairperson for this very, very important session, very thrilling, and with such a beautiful array of speakers who are actually doing that work. It's always a pleasure to hear someone who has done research, innovation, and experience in that topic. Autoimmunity and diabetes is something that is more and more coming into our picture when we are seeing children all the way from neonatal diabetes, monogenic type 1, LADA, young adults, all kinds of phenotypes, and we are all almost confused. Earlier, these used to go to specialists. Now they're coming into everyday clinics, and it's time we know more about them, even as a physician who is not specializing in these fields only. So today we have wonderful 3 topics, and the first speaker for us is none other than Dr. Alok Kanugo himself. Can I have his introductory slide, please? Right. And I think he really needs no introduction. He is the person behind this wonderful program that we are seeing today. And as Dr. Das mentioned, that he has done his research in this topic itself. So I'm going to hand over directly to Alok sir to talk about LADA and autoimmunity. Over to you, sir. Sir, you're on the mute, sir.
Alok, just unmute and start.
Alok sir, you're muted. Yes.
Thank you, Archana, for your wonderful introduction. Thank you, Dr. Lisa Das, for being there as a moderator, Professor Ashok Das, and everybody. So I'll just take 1 second to present my talk.
Dr. Alok, you are visible. You can start.
Slide is not moving at all.
Hello.
Yes.
Can you see slides?
You can see, and you are also audible, Alok.
Okay. Sorry for the technical glitch. This is an important topic and very less discussed in clinical practice, and our physicians do not give much importance to this. Latent autoimmune diabetes in adult. In a recent review, we found that Chinese population has more than 1 crore of LADA patients. So the problem is really big, and more than almost 10% of our population are LADA patients. As you know, the classification is type 1, type 2, gestational, and other types of diabetes. LADA is
moving. Dr. Alok,
it is not moving.
No, slides are not moving. I think maybe unshare and then share.
Stop sharing.
Next, sir. Next.
Share
right click and next. Do right click and next.
Now? No.
So you have to share the slides first.
Saurabh. If you don't mind, can you go back to Sanjeevi and then I will present?
Sure. Dr. Sanjeevi, is that all right with you?
It is.
That is all right with me. I've already recorded my talk, and that talk is already there with RX events. They can play it.
Okay.
Yes, we have. I'm here joining just to ensure that the question answer session is clearly something where I can join and answer. So my talk is there. It can go on online. No problem.
Thank you. Thank you so much. Can we have Dr. Sanjeevi's introduction, please? Yes. So I think it's very important that we introduce Dr. Sanjeevi. We are actually privileged to have him here. Professor C.P. Sanjeevi is a professor and senior scientist at the Department of Medicine at the Karolinska Institute at Stockholm. He is also the senior advisor in the Innovation Office in the Institute. He heads the Diabetes Immunology Research Group at the center in Stockholm itself. And the reason we really want to know all this is because we are speaking to a scientist, an innovator, a researcher, and a clinician. And when it comes directly from you, it is definitely valuable and a learning point and a privilege for us. One award among so many of the ones that Sir has won is something I would like to share, that the recent one was the Pravasi Bharatiya Samman Award, which is something is truly a Samman for all of us, for him to have received in 2017, which he received from the President of India, Shri Pranab Mukherjee. It is the highest award given by the Government of India to NRIs for his excellence in the field of medicine. It is indeed a privilege to have you, sir, here. And could I ask the organizers to please play his talk on autoimmunity? Thank you.
The topic that has been given to me today is autoimmunity and diabetes. I've been very kind. I'm extremely thankful to Dr. Alok Kanungo for giving me this opportunity to talk, and it has been my privilege to talk at the NUCD right from the time the first NUCD started to happen nearly 9 years ago. Why did I choose autoimmunity and diabetes and not type 1 diabetes? Diabetes, as you know, can occur in any age group. And autoimmunity in diabetes can also occur in any age group. If people think that it occurs only in the younger individual, they are wrong. Autoimmunity predominantly occurs in younger individual, but more and more research tells us that autoimmunity can occur in older individuals also in larger frequencies. There are quite a lot of advances that have taken place in the last 1 year that tries to tell us how the disease disease starts and how the disease progresses. Some of the top class studies that are going on in the field of autoimmunity and diabetes have been coming out with some extraordinary findings. One of them is TrialNet, that is exceedingly good. Another is Type 1 Diabetes Genetics Consortium, which is financing a study that involves following children from birth until they develop diabetes. You might hear from Alok Kanungo, the diabetes that occurs in older individuals with autoimmunity called as LADA. So there are different stages of type 1 diabetes, since LADA is going to be covered by Alok. And these are the stages that are depicted in this particular cartoon. So everybody should have a genetic risk for developing type 1 diabetes. So genetic risk is the important starting point. And there are a variety of risk factors that you will see, whether you are in a family with somebody having type 1 diabetes or you have no relatives with type 1 diabetes. So there is an immune activation, and this immune activation usually triggered by environmental agents or viruses or some other stressful events in the life of the child. So this immune activation starts by destroying the beta cells slowly. And over a period of time, lots of beta cells die. When many beta cells die, what happens is that you develop autoimmunity. With the result, autoantibodies, which are the markers of the disease, start appearing in the serum, leading to identification of these autoimmune markers and diagnosis of autoimmune diabetes. So there are several stages in which these autoimmune diabetes can be picked up. In stage, you have normal glucose tolerance, but you have 2 or more autoantibody positivity. In the next stage, if there is a continuous destruction of the beta cells, you have 2 or more autoantibody positivity, but in addition, you have abnormal glucose tolerance test. This could be identified by intravenous glucose tolerance test or with more loss of beta cells, oral glucose tolerance test. So when there is some kind of an event that happens that could even be an infectious disease or a stressful event, the clinical diagnosis of diabetes can be made when the patients appear to the clinic or the hospital with symptoms. This is when it all happens in terms of what you can do to these patients. When you have these patients coming to you with clinical symptoms, you can assume that 90% of the beta cells are gone. What one can do in terms of arresting the beta cell damage is to try and prevent further damage and retain this 10% of beta cells so that you do not develop ketoacidosis or ketonuria. This is a very important complication that can kill the patient. So what are these stages that a clinician should know so that he can pick up these stages much earlier before the clinical onset? Because the TrialNet is one important aspect that will help identify, including the Type 1 Diabetes Genetics Consortium, that tells us how to pick them up. If you pick them up early, there are a variety of things that you can do to help them delay the onset. So when you look at the stages in Type 1 diabetes, there are multiple antibodies in stage 1, normal blood glucose, pre-symptomatic, no symptoms. Then in the stage 2, as you saw in the previous cartoon, multiple islet antibodies, raised blood glucose, pre-symptomatic. This signifies there is considerable loss of beta cells. Then in stage 3, you have islet autoimmunity, you have raised blood glucose, and the patient becomes symptomatic. The stage 4 is those patients who have long-standing diabetes. And the question will come whether there is anything you can do to reverse the long-standing type 1 diabetes, which is possible with some of the advances that are being made, but we still haven't got any approval for some of these things that can reverse the type 1 diabetes. Either it could be due to vaccine strategy or it could be beta cell replacement therapy. So in stage 1, individual tests positive for 1 or 2 or more autoantibodies. The immune system has started attacking the insulin-producing beta cells. When we say immune system, the predominant cell in the immune system that attacks the beta cell is T cells. And the blood glucose levels remain normal and no symptoms are present. Whereas in stage 2, the autoantibodies develop due to an autoimmune reaction after the T cells attacking the beta cells, releasing the contents of the beta cells. The GAD is actually intracellular, it's not extracellular. So the contents of the beta cells will have to be released for your immune system to react to the GAD or to the insulin, so that there are antibodies that are developing to these things. But these antibodies are only markers for the disease, which is very important for us to measure them in order to identify who are likely to develop type 1 diabetes. Stage 3 is important. Type 1 diabetes symptoms are present, and it is due to the significant loss of beta cells. Almost 90% of the beta cells are lost at this stage. The common symptoms include increased thirst, urination, unexplained weight loss, blurred vision, and fatigue. These are a little bit non-specific. What will happen is that in a poor or middle class or lower middle class families, they may not be able to identify these symptoms as specific for diabetes, seek medical advice. Sometimes they will ignore. And when that happens, these patients lose all the beta cells and then develop ketonuria or ketoacidosis and present to the hospitals with these symptoms that are a little bit more acute than you would normally when these symptoms show up. So there are 3 stages, stage 1, stage 2, and stage 3, which are the stages that progresses the type 1 diabetes from genetic risk to the exposure to the virus and to the development of clinical symptoms. And these are the clinical symptoms that I enumerated in my previous slide as well. And these clinical symptoms is the time when the doctor sees these patients in the hospital. But it would be very important for us to know whether it's possible to identify these patients a little early. The most important aspect here is the genetic risk. Without genetic risk, development of type 1 diabetes is very, very, very low. It can happen, but it's very low. So the genetic risk is determined predominantly by the HLA molecules, which are called as HLA class 2 molecules. And in the class 2 variety, DR3DQ2 and DR4DQ8 are the predominant high-risk HLA that confer susceptibility to diabetes. Many patients have both DR3DQ2 and DR4DQ8 that increases the risk substantially. But in Indian context, it's more important to know that DR3DQ2 is much more important for risk for development of autoimmune diabetes compared to DR4DQ8. So type 1 diabetes starts with the genetic risk, genes that put you at high risk for the disease. The risk for people in general population with nobody in the family having type 1 diabetes is about 1 in 300. But for those who have a family member with type 1 diabetes, the risk substantially increases at least 15 times, where the risk is there in 1 in 20 individuals. So it's important to know that for the physicians, the relatives of people with type 1 diabetes are 15 times more likely to develop type 1 diabetes, the disease, than the general population. So if there is a family that comes and tells you that they have a child with type 1 diabetes, it's important for you to ask them whether there are any other children, especially children younger to the patient who have developed type 1 diabetes, so that you can start screening them and trying to see whether there are any markers that develop. And some of the tools that you will see might be very interesting to implement at this particular stage. There have been a lot of debate whether the beta cells actually express the HLA class 2 molecule. Many of the people felt that the beta cells do not express. But now in December 2022 in Diabetologia, a paper from Matthias von Heret's group have clearly shown that there is an upregulation of HLA class 2 molecule in the pancreatic beta cells from organ donors with type 1 diabetes. This is a very important finding where a direct infection of the beta cells can cause upregulation of the HLA class 2 molecule that are high risk for susceptibility. And this could actually trigger the T cell immune response, leading to the destruction of the beta cells over a period of time. If the risk is higher, if it is DR3DQ2 and DR4DQ8, the chances of losing all the beta cells is much faster compared to one of them, either DR3DQ2 or DR4DQ8. It's also important to know, in the recent paper again, published in the last 1 year, it is clear that a particular DR called DR15DQ6 remains dominantly protective against type 1 diabetes. what does this paper clearly show is those people who carry DR15, DQ6, previously we knew that it can protect only children up to the age of 10. But now this evidence shows that it protects individuals from developing type 1 diabetes until the age of 50 or 5 decades. So this is a considerably important finding, and this finding is possible only because the sample size is really large and you are screening patients right from birth. It is the T cells that cause the disease, and you can see in the recent paper published in Nature, a subset of T cells branded as the seeds for type 1 diabetes. And this paper was the first author of the paper for GRT. And it's a very, very interesting paper, how the T cells drive autoimmunity, leading to the development of type 1 diabetes. And in this cartoon, you can see in a normal situation with a chronic viral infection, it is the viral antigen that gets expressed on the HLA. And this is what leads to the cells exhibiting the HLA to die by the effect of T cells. Whereas in a type 1 diabetic scenario, if the pancreatic antigens bind to the molecule, the HLA molecule, then it leads to the destruction of the pancreatic beta cell. And this becomes important in the light of the finding that the HLA molecule gets expressed in the beta cells directly, which is a very important step for us to know that the destruction starts with the T cells. So autoantibodies are the markers of the disease. They are the result of the disease. They are not cause of the disease. And these are the important autoantibody markers that needs to be measured in order to identify the risk. Some will have only GAD antibodies. Some will have islet antigen 2. Islet cell antibody is measurement of antibody using immunostaining, where anybody who is positive for ICA could be positive for GAD. You also have another assay, insulin autoantibody, which has got a new assay, microinsulin autoantibody assay, which is what was formerly called as IAA, and a zinc transporter. So these are the antibodies that are measured, and presence of 2 or more antibodies signifies clearly the existing autoimmunity and the loss of beta cells that is happening in these individuals. So where are we with type 1 diabetes in terms of prediction and in terms of prevention? There has been much progress in this field. One of them is the pancreas transplantation or biological replacement of islet cell functions achieved by pancreas transplantation with islet transplantation. So the islet transplantation is a very interesting area. Either you can harvest islets from cadaver donors from their pancreases, or we can have stem cells developing into insulin-producing beta cells. These stem cells could come from human embryonic stem cells, or it could come from cells that have been stimulated, the pluripotent stem cells that can offer through a technique called inducible form of pluripotent stem cells. So another potential strategy is to introduce robust beta cell replication so that regeneration of islets can be achieved. Maybe there is a drug candidate that will allow this to happen. And there are some interesting publications to tell us how this can happen, the regeneration of islets. The interesting part is the immune interventions are being studied with the hope of arresting the type 1 diabetes. And most of the immune intervention strategies have approached only one immune intervention. Either it could be GAD vaccine, or it could be a vaccine for one of the viruses. But now it is possible to have a combination of these in order to increase the protection that could be given to the beta cells from these immune cells attacking them. The interesting part, simultaneously, what is happening is the mechanical replacement of islet function is happening with the use of glucose sensor controlled insulin infusion systems. So what your pancreas does, you can have a machine do it and have the machine outside the body connected to the body with some kind of micro tubing that will allow continuous estimation of blood glucose and infusion of insulin. So all these avenues are pursued. Headlines often overstate the case. So when somebody comes up with one particular approach being successful, there's a whole lot of newspaper articles that claim, oh, we have found a cure, we have found a cure. But it is not actually the case because we are still making a lot of progress. And some of the cures does not apply to everybody. So this is the paper published by Jay Schuyler in diabetes care, where he is showing variety of approaches, and he is emphasizing that a combination therapy using these agents with complementary effects will have a great value in terms of delaying the destruction of the beta cells or even prevention of beta cell destruction taking place. It's all the question of the timing. When do you time this? And this will ensure how much of beta cells you can save. So with these approaches that are being done, what had happened in the last 1 year is there has been an exciting development with a monoclonal antibody called teplizumab. Teplizumab has been tested, which is an anti-CD3 antibody in the first degree relatives of patients with type 1 diabetes. So these are at-risk patients. And this paper was published in New England Journal of Medicine. And teplizumab delayed the progression of clinical type 1 diabetes in high-risk participants in TrialNet cohort. TrialNet is a cohort where they have a lot of patients with type 1 diabetes markers who are relatives of patients with type 1 diabetes who are being followed up regularly. And these are the candidates who are being taken for these clinical trials. So teplizumab is delaying the onset at least by 2 years in this follow-up study. And what had happened was that US FDA has already approved teplizumab for patients with antibody markers who haven't developed type 1 diabetes, who can receive teplizumab. And American Diabetes Association has given a very nice note on this, that teplizumab So there are some more clinical trials that are going on, which if could be complemented with teplizumab, it could probably delay the onset of type 1 diabetes even further. Some of the interesting things that we may have to know outside the area of medicine, outside the area of drugs, is can diet cure or can diet be the cause of type 1 diabetes? So there has been a study where it was published in one of the prestigious journals called Cell. A low-calorie, low-protein, low-carbohydrate by high-fat fasting mimicking diet was given to mouse. And this fasting has resulted in regeneration of pancreatic beta cells. So this regeneration in the diabetic mouse has resulted in the reversal of diabetes. So fasting has been one of the important things that we had been practicing over the centuries in India. And it's important that we continue to do this fasting. And it's a clear evidence now that fasting helps in beta cell regeneration and reversals of diabetes in individuals who may have diabetes. So fasting in a diabetic individual needs to be done, of course, with dietary supervision by the nutritionist as well as by the doctor. It cannot be taken by the patients by themselves as a way to reverse. But this is something that is very interesting. And it's important that we follow this carefully. And those people who are at risk for diabetes, they might find it beneficial to prolong their disease-free state for a considerable amount of time. You know, celiac disease and diabetes are relatives. Patients with celiac disease, 1/3 of them develop type 1 diabetes, and nearly 10% of the type 1 diabetic patients develop celiac disease. Both have a similar etiology. Both have HLA-DR3, DQ2 as the high-risk HLA. When you look at these features of celiac disease and type 1 diabetes, sharing with this, gluten is a diet-induced celiac disease. So if you prevent intake of gluten, you can reverse celiac disease. This is known fact. But what has now come out with animal studies, which is now being followed up in the humans also, is a gluten-free diet reduces autoimmune diabetes in mice across multiple generations. And right now, in the type 1 diabetes cohort in Sweden, they have tested gluten-free diet in high-risk individuals, meaning that those individuals who have high-risk HLA plus autoantibody markers. And the early results show that gluten-free diet is extremely beneficial in individuals who have high-risk HLA as well as high-risk autoantibody markers in delaying that diabetes. We do not know how much delay it had happened. We can expect a publication in this very soon in the next couple of months So the conclusion is gluten-free diet reduces autoimmune inflammation in salivary glands and pancreas in odd mice in a microbiota-dependent and independent manner, respectively, and has preventive effect in type 1 diabetes. So this is a very important change that the clinicians might find it very interesting. Hopefully, we will have this results available in the human beings that should throw a light on how a gluten-free diet, which is anyway being practiced by patients who have celiac disease, could also be used in either patients with type 1 diabetes or patients or individuals who have high-risk diabetes, high-risk markers for diabetes. So these are some of the very interesting developments. Teplizumab is one, gluten-free diet is another, and fasting, of course, is very important. And all these things help us understand that the diabetes is something that we can really take control of. So tissue transglutaminase is the antigen, and in the celiac disease, and antibodies to tissue transglutaminase clearly identify celiac disease. So we need to document celiac disease in a type 1 diabetic patients by doing this test. Or if there is a celiac disease patients who are tissue transglutaminase antibody positive, then you need to have GAR antibody and IA2 antibody tested to establish diabetes. If somebody has both, then of course, gluten-free diet is going to be extremely beneficial in decreasing the manifestation of both these diseases. So this is a very important finding that I would like you to have it as a take-home message. So with this, I thank you very much for your attention. And if there are any questions, I'll be happy to answer these during the panel discussion. Thank you very much and bye.
Thank you so much for that, sir. And over to you, Kongo, sir. Are you ready?
Alok, it's coming now?
Yes, perfect.
Yeah.
Sir, please unmute yourself. Sir, Alok, sir. We can see your screen, sir.
Alok, we can't hear you, Alok.
Hardik, is Alok speaking and voice not coming, or something wrong in the projection? Hardik? Nilam? What is the actual problem? Why Alok is not audible? I'll just call him.
We can hear
Okay,
you.
1 second. I'll share. Video.
Yeah. Your slides has to come and change. That's all. Yeah.
Soksa should go for lunch.
Who is going for lunch? No.
You should go for lunch.
No.
Look, you unmuted again. You'll have to unmute again. You're muted.
I think it's happening the moment he puts on his
It's
slides.
automatically.
Yes.
Need to make sure. Now you're unmuted. Go ahead and talk, Alok.
Yes. Can you see my slides?
Yes. Perfect.
Yes. Very much visible.
Sorry for all the technical defects. So, dear friends, after listening to Sanjeevi with such high-reach, high-tech scientific data, my talk becomes much easier now, and I will be talking on latent autoimmune diabetes in adult and what are the newer concepts. Classification need not be discussed. LADA this year ADA includes it in type 1 diabetes, but it is not type 1 diabetes. It is a part of that. Latent autoimmune diabetes in adult is a form of autoimmune diabetes which is diagnosed in individuals who are older than the usual age of onset of type 1 diabetes. Alternative names like late onset autoimmune diabetes of adulthood, slow onset type 1 diabetes, and type 1.5. Often patients with LADA are mistakenly thought to have type 2 diabetes. So Immunology Society of the Diabetes, they classify that it should be 30 years of age, positive for at least one of the 4 antibodies, as Sanjeevi has told, commonly found in type 1 diabetes, not treated with insulin within the first 6 months after diagnosis. This is very, very important. And some patients do not require insulin even up to 6th year. ADA recognizes LADA as a variation of type 1 diabetes, but there are a lot of changes into that. So as UKPDS first found out in 2008 that 10 to 12% of our type 2 population are in fact LADA. So they showed that in any given community across the world, there is a 2 to 10% or 2 to 12% population are having LADA in fact. And the features are patiently usually aged 30 plus, clinical presence or presentation masquerading as non-obese type 2 diabetes, initial control achieved with diet alone or diet and oral hypoglycemic agents. Insulin dependency occurs within months but can take even 10 years or more. Other features are low fasting and post-glucagon stimulated C-peptide, HLA susceptibility alleles, ICA2, GAD, and other antibodies present in type 1 diabetes. And about 80% of adults apparently with recently diagnosed type 2 diabetes but with GAD autoantibodies progress to insulin requirement within 6 years. The potential value of identifying this group at high risk of progression to insulin dependence that includes that early introduction of insulin therapy. We can see the visualization of the overlap in type 1 in children, type 1 in adults, LADA, and type 2 diabetes on the parameters of immunity, age, genesis, genes, BMI, insulin therapy. And as we all know, immunity is very strong in type 1, less in type 1 in adult, still present in LADA, but very weak in type 2 diabetes. And so also HLA, HLA plus, and Sanjeevi has already told about the genetic things. And insulin therapy is immediate in type 1 diabetes. In adults, it is also immediate. And in LADA, it is variable. and in type 2 it is infrequent. So if you look at these next things, that type 1 diabetes and LADA and type 2, LADA comes in between these two, and even if we say it is type 1, but it has a definite difference from type 1 per se, or the original type 1s. In the obesity, HLA DQ beta 1, autoantibodies, T cells, insulin treatment, age, metabolic syndrome, TCF7L2, and systemic inflammation and C-peptide presence. So if you look at that, insulin secretion in type 1 is low, LADA it varies, type 2 it varies, and they have also compared with MODY. Islet inflammation is present in both type 1 LADA and type 2. And TCF7L2 link, there is no in type 1, greater than type 1 in LADA, and almost 5% in type 2 diabetes. If you look in a prospective study, the presence of at least 2 of these distinguished clinical features or LADA clinical risk score 2 had a 90% sensitivity and 71% specificity for identifying LADA, and a negative predictive value for LADA clinical risk score is less than 1 for 99%. The epidemiology is varied, as we saw in the UKPDA study. It depends on geography, genetic susceptibility, environmental factors, gender, age, or diagnosis. In India, even our population, our LADA data, Sanjeevi's or the Chennai data, Professor Das data, and S. Bhatia's data, and Bansi Sabu's data are varying, though 2 to 10% are like that. In studies in white population, the prevalence has been reported to be almost 10%. A lower prevalence of LADA has been described in studies from Southern Europe. In other racial groups such as African Americans and Hispanics, the prevalence of LADA is lower than in white population. Genetic studies have been done by Professor Sanjeevi and our group and some other population across the globe at Karolinska, and we studied SUMO4 gene, and type 1 diabetes is associated with Asians only, and LADA no association with Asian Indians. HLA and LADA in Asian Indians is associated more with DR3-DQ2 than with DR4-DQ8. Negative association with DQ6 is not observed. The most important genetic risk factor for LADA in Swedish patients and Ecopedias is heterozygosity for DR3-DQ2 and DR4-DQ8. DR15-DQ6 is negatively associated in LADA patients. HLA class 1 alleles are not associated with LADA, so which is very much present in type 1. In India, as I told you, we have 2 to 12% of population having data. There is a surprisingly high prevalence of IA2 antibodies in patients with type 2 diabetes has been reported from Eastern India, our center, and with Karolinska collaboration, and type 2 diabetes patients from Cuttack with GAD65 antibodies were present in 7%, whereas IA2 was 31 to 36% of patients. So this has been published. IA2 antibodies, autoantibodies are predominant in latent autoimmune diabetes in adult patients from Eastern India. And we found there are 2 peaks. One is at 20 to 30 years of age, and the other is in 51 to 60 years of age in type 2 diabetes. So genetics of latent autoimmune diabetes was studied by Sanjeevi and our group, and we found that IDDM is positively associated with HLA DR4 DQ8 and or DR3-DQ2. In GAD65 antibody positive NIDDM patients from Cuttack in eastern India, DR3-DQ2 was significantly increased compared to that of GAD antibody negative patients. So one of the most important, which has been referred in many recent papers, that Mike gene and LADA. In a study on IDDM, NIDDM and healthy controls from the eastern India city of Cuttack, Mike allele 5 was significantly increased in IDD patients compared to controls, and allele 5.1 was increased in antibody positive NIDDM patients compared to controls and antibody negative NIDDM patients. We also studied KIR gene. KIR genes confer susceptibility and protects S1 and 2DS3 with protection. So KIRs are important in conferring susceptibility or protection to adult patients with LADA in study population. So if you look at the comparison, type 1 is purely KIR 2DL2, 2DS4 and 2DS5, whereas LADA is clearly 3DL1, 2DS1 and 2DS3, whereas there is a common sharing of 2DL5 and HLSC1 in type 1 diabetes and LADA. So when we come to LADA susceptibility and genetics of LADA, genetic features like HLA, MICA, INS, BNTR, PTPN22, CTL4 and TCF7L2 play an important role in specific triggers that causes insulitis with the presence of GAD and leads to insulin deficiency and LADA onset. So also visceral adiposity with a genetic background leads to low-grade inflammation, insulitis in the presence of IA2, and impaired insulin secretion is caused and causes LADA. So these are very important findings. So what is the algorithmic approach for diagnosis of latent autoimmune diabetes in adult? There are risk assessments, clinical risk assessment in a newly diagnosed diabetes, age less than 50, BMI less than 25, acute symptoms of hyperglycemia at onset, history of autoimmune disease, and familiarity of autoimmune disease. If it is there, high risk of LADA if there are two of these points are positive. Mild risk is only one clinical feature is positive, and there is no risk or low risk if there is none of these above points are positive. If it is high risk, measure GAD. If it is negative, it is type 2. If it is positive, it is LADA. I want to add here, it can measure IA2 also. If it is the mild, sorry, in the mild risk group, measure C-peptide. Normal value, consider type 2. If it is low value, measure GAD, and if it is negative, it can be type 2 diabetes, and if it is positive, it can be LADA. So what is the diagnostic pathway based on autoantibody screening and C-peptide levels at diagnosis? GAD screening, negative, type 2 diabetes. Positive, measure C-peptide. If it is less than 3 or if it is less than 3 nanomole or more than 3 to 7 nanomoles or more than 7 nanomoles, depending on that C-peptide value, LADA algorithm is applied if it is below 0.7, and if it is more than 0.7, type 2 diabetes ADA ESD guideline will be followed. You can, in type 2 diabetes, you can suspect LADA if there is any of the factors and screen for IA2, and you know that the person will require insulin in 6 months time, and you can always repeat C-peptide value at 6 months intervals. So the diagnosis or the treatment is based on C-peptide value. Less than 3, you can go for insulin. More than 3, you can use metformin, no sulfonylurea, and apply ADA and ESD guidelines And if there is a high risk, established atherosclerotic cardiovascular disease or heart failure or CKD, if it is ASCVD predominates, then GLP-1 receptor agonist can be tried. SGLT2 with proven CVD benefits. If eGFR adequate and BMI is more than 27, we can try that. And if HbA1c is above target, insulin basal bolus can be added to that. And if it's heart failure or CKD predominates, SGLT2 with proven CVD benefits. If eGFR, as Dr. Prasant was mentioning today, and if it is HbA1c remains still high, we can keep the guidelines, and without sulfonylurea, other drugs can be used. And the medications in LADA are C-peptide level more than 0.3, less than 7, 0.7 without established CVD. We can try for DPP4, GLP-1 receptor agonist, SGLT2-1, and thiazolidinediones. And ultimately, insulin will be required. There are differences between LADA and classical type 1 diabetes and type 2 diabetes in genetic background, autoimmune response, rate of islet function decline, and clinical metabolic characteristics. And the prevention and treatment, as Sanjeevi was telling, previous studies reported that adaptive immunity and innate immunity play a critical role in the etiology of LADA. Recent studies have shown that the intestinal microbiota, which impacts host immunity hugely, participates in the pathogenesis of LADA. Therapies including antidiabetic drugs with immune regulation effects and immunomodulators could contribute to promising interventions of LADA. We also, the group, they have also seen that potential interventions targeting the gut microbiota and gut associated immunity, which may be envisaged to halt or delay the process of autoimmunity in LADA, is also going on. And we are collaborating with Professor Paulo Kaich of NICER and started some work on this gut-associated immunity, innate immunity, and adaptive immunity. And immunomodulator therapies have been developed in this. Here, probiotics and prebiotics play an important role in preventing the inflammation and changing the course of patients getting inflammations and pancreatic beta cell damage. So therapies targeting adaptive immunity, tripterygium, polyglycoside, and we are also teplizumab was in type 1. Rosiglitazone has been extensively studied in LADA and it is helping, but unfortunately that has been taken out from the diabetic scenario, and we can study the pioglitazone in this case, preventing immune destruction of beta cells. Linagliptin, sitagliptin, and saxagliptin have shown promising roles in treatment and prevention of inflammation in pancreatic beta cells in LADA patients. In phase 2 clinical trial, 2 subcutaneous injections of recombinant human GAD65 formulated with aluminum hydroxide or GAD alum at 4 weeks interval were safe in patients with LADA, and that has been tried. In the future, antigen-specific treatment strategies should be individualized and more in line with precision medicine. Vitamin D is a very important factor, and in a Swedish-based case control study found that taking vitamin D rich fatty fish more than 1 time per week may reduce risk of LADA. The general goal of LADA treatment is metabolic control and preservation of residual insulin secretion function, and the development of new treatment method is urgently needed. Previously, we thought that type 1 diabetes or LADA do not have insulin resistance. Now, increasingly studies have come with finding that insulin resistance is also there in these two groups. My last slide, dulaglutide treatment results in effective glycemic control in latent autoimmune diabetes in adults. A post hoc analysis of the AWARD 2 4, and 5 trials. This is a new hope and a reason for widely differing prevalence of IA2 antibodies in different regions of India remains to be determined. Early insulin therapy should be initiated rather than waiting till conventional OADs fail in type 2 diabetes patients who are previously thought as secondary sulfonylurea failure, but they are in fact LADA patients. Role of newer therapies like SGLT2 inhibitor and all other molecules that I suggested are needed to be tried in these LADA patients. Thank you, dear, and thank you, everybody.
Thank you, sir. Thank you, Alok, sir. That was definitely worth the wait, and you have given us the entire practical aspects of LADA in our consulting practices itself. We will be having a lot of questions in the panel discussion, and I invite Dr. Rishi Shukla for the next talk, which is the clinical difficulties when it comes to working with type 1 diabetes. May I have his introduction, please? Yes, and I think everyone here knows Rishi Shukla, sir, as one of the pioneers working in the country from Kanpur in type 1 diabetes. With all his awards and publications, I just want to mention that we have seen him live working with his SPAD group, creating mentors, creating teachers, encouraging people, other doctors to come up and do that work. And I am also very grateful to have him as my mentor as well. So over to you, sir, for a topic very close to your heart, the clinical difficulties in type 1 diabetes.
Lights are visible?
Yeah. Yes, Rishi, visible.
Moving, it is moving also?
You have not moved. Move once. Let's see. Go to next slide.
Moving?
No, not yet. It's not moving.
Not moving.
No,
So it has to be made full screen.
Make full screen and also click on this slide, Rishi. Click on the slide, not on the. If not moving with the computer.
No, it is moving in my screen, not moving with you. So I'm just resharing once again.
Please reshare.
I'll do that.
Try moving now.
Visible, sir.
Just a minute. It is moving?
No, yeah, moving now.
Perfect.
Moving?
Perfect.
Moving?
Yes.
Perfect.
Yes, sir.
Yeah. Thank you, Dr. Archana, for good words. Thank you, Dr. Ashok Das, sir, and a big thanks to Dr. Alok Kanungo for this opportunity. And it was a dual benefit for me. I learned whatever I'm telling you people, and I have learned from these two wonderful speakers, and I'll be further learning from the panel discussion. So my topic is a very basic topic, which is, I think, required in a day-to-day practice. So clinical issues in management of type 1 diabetes. And what am I going to talk is basic insulin monitoring technologies and social issues. Technology, I was looking, there is a full session, so I'll briefly touch and move. The hard facts of type 1 DM is, it was 2017 data that life expectancy is less than 12 years than of general population, and the risk of cardiovascular event is 10 times than of general population. So a very humble request to those who are treating type 1 diabetes, adult type 1 should be protected by statins. India is the second largest country to have type 1 diabetes, first being US. And a word of basic advancements. We have analog and rapid acting insulin. So I'll request everyone to use, if possible and affordable. We have designers insulin also available, from Glargine to U300 to Dictmer to Degludec. So you have full choice. Fine insulins are available. Much better quality pens, disposable pens. Some of my type 1 patients have started using disposable, and then they stopped using regular pens. Much better glucometers, advanced glucose monitoring system. We have been discussing artificial pancreas. So there is another, there was a talk on pump and everything, a session prior to us. I think what is the important thing about type 1 is, and that what we have learned in last 30 years. It was 1993, 94 when I started endocrinology. People used to ask what is new, and that point of time the understanding was once complications come, they are progressive. And Professor Das and all my senior Dr. Alok would agree, even Archana would agree that that point the understanding was once it comes, they will progress not in type 1 but in type 2 also. So that was the first study that showed that good control not only arrests the complication but also reverses. So now we have more than 30 years of follow-up diabetes control and complication trial. The follow-up of diabetes study is known as EDIC summary, epidemiology of diabetes intervention and complication. It showed categorically that microvascular complications are reversible, long-term benefits in macrovascular events. Initial control is the success, and it is a key. So whenever a diabetes comes younger, first time detected, go for best control, no change in cognitive function. What was observed that in intensive arm of DCCT, that because of very nice control, 7.6 we were discussing, the more chances of hypoglycemia. Was there any cognitive dysfunction? No, there was
like
no.
the slides are not moving.
All right, all right. Is it not seen moving? Okay. I'll just reshare. Is this moving? Full screen is visible?
This
Slides
is
are
visible.
moving?
Yes, now it's moving. Yes.
It is moving. All right. Sorry. So this is plan of the talk. I've discussed about hard fact,
Yes, till
advancement.
here it was visible. Next, right.
So DCCT, I think this is a trial that showed us the way. Not only type 1, because UK PDS trial came, I think, 5 years later. So this was the trial that showed a way to type 2 diabetes as well. And what was observed that in intensive arm, we had a suspicion that in long-term follow-up, because of more frequent hypoglycemia, the cognitive function could be disturbed in active arm. But long-term follow-up, there is no cognitive change in adults with type 1 diabetes. So the barrier was tough to keep low A1C with lesser frequency of hypoglycemia, which I shared. And the golden rule is take advantage of metabolic memory. Whenever best control in beginning plays the best role and gives you a long-term best results. Yes. Now I'll be talking of very basic thing, understanding to use insulins. What insulin should we use? Anyone? Because a lot is happening. Many of type 1 patients are mixtures, and some of them are doing well. And I'll say very minority of my patients are there on mixtures. And in spite of telling them they are not shifting, but if you look CGM and do frequent monitoring, there are gaps. So it is better say no to mixtures. 1. MDI multi-dose insulin is a preferred choice. 1 long-acting and 3 short-acting, or 4 short-acting in children. Then MDI plus CGM or flash CGM is always encourage using monitoring, because if these two things are used together, the results are best. Talk about pump. First patient should be on MDI plus sensor. Then if patients agree, pump, and pump with sensor. So this is the order which we are using. The different types of pumps which we have been discussed. Now we have latest 680G pump. Again, it has been discussed. And the problem is pump should be talked about with type 1. And I was listening to the discussion. This is the latest Medtronic pump 680G, and it is recommended with patients with type 1 diabetes, not with type 2. Some of my type 2 patients are also on this pump, but it is recommended with type 1. There is a hybrid loop system in the pump. The basal system is automated. Bolus is to be given based on meals and carb counting. Ultra rapid insulin yields better results. So technologies, those who are listening to this, the SPAT guidelines are insulin pump, especially since augmented pump is a useful therapy, and barriers in pump therapy are unnatural attachment, stress.
I think Rishi, it has not moved beyond the things you said just now. For the SPAT guideline is not coming. It is with the EDIC summary slide.
Rishi sir, could you try right click and doing next?
Click or just click over the slide on your system.
Okay. Is it moving? I'm clicking.
Not yet.
Oh, no.
Right click and then press the next on top of that.
Right click and then?
His next comes on top of that.
Actually, it is moving in my screen. Just a minute. It is moving now?
Your slide seems to be very choosy for you only, Rishi.
Right, right. Jargar sir, not it will work. I'm just quickly stop share and I'll just. Hello, I'm following you. Is it coming full screen? The screen is there?
Yes, is there. No.
Is it moving? Just a minute, I'm moving. It is moving now?
Yes, yes. Just like that, on top of that, press that next.
It is moving?
Yes, yes, it's moving.
Okay, okay, sir. Thank you. Thank you for the help. So where was I? This is mixture. Everybody seeing understanding to use insulin? This top heading, is that all right? What heading is, what is the?
Understanding to use insulin.
Right, correct. So I'll move faster. So I have discussed this. I think only message is avoid using mixtures. 3 dose, 4 dose insulin, 1 long acting and 3 short acting is the answer. Pump therapy is a very useful therapy. I think it should be encouraged, and the sole reason is it makes patients almost like non-diabetic, but there are barriers. And I was reading the SPAT guidelines. The barriers in insulin pump therapy are unnatural attachment, lipohypertrophy, decay, financial. I think more than financial constraint is the mental barrier. Many of my well-off patients, they are not using. I mean, money is not the issue, understanding is not the issue, but the mental barrier of something putting in body is the biggest issue. And now we talk in terms of glycemic variability in time in range. CGM and flash glucose monitoring are truly useful and safe. Metformin in type 1 diabetes, this slide is visible, sir?
Yeah, bilkul.
All right. So a word about metformin in type 1 diabetes. It is helpful in weight reduction, insulin dose reduction, but as the number of trials, we have not found much change in HbA1c. Type 1 diabetes in dapagliflozin, there had been a trial, and compared to placebo, significant reduction in HbA1c was seen, weight loss, change in insulin doses, 8.8%, no change in hypoglycemia, no difference in diabetic ketoacidosis. But latest recommendations are that this is not recommended. So my understanding is the adult diabetics who are controlled, who understand they are a bit overweight, why not they should be provided cardiovascular and renal protection, because this salt, the SGLT2 inhibitors are protective even to non-diabetic. So that is my point. Then considering educating individuals with type 1 on matching prandial insulin doses to carb. So what is most important is a carb counting. I'll talk. And the psychological counseling is a very, very important. I think we have had 2-3 sessions with a clinical psychologist with some of our patients. I thought the moral boost up, the understanding, many of the questions we are not able to answer, they answered. That is very, very important. Those who are dealing with type 1, even with type 2, it is required, but type 1, it is very, very much required. The psychological counseling, and if individual counseling somehow because of ROSAS is not possible, go for group counseling. Maybe one counseling very recently we had, I think, around 40 children above 18 years, and a clinical psychologist spoke for them, and it was out of the world top. The carb counting, protein, fat counting, this is by and large in clinical practice is not encouraged. So make our children understand that carb counting is very important. And lastly, a systemic review recommends that 30% increment in bolus insulin doses for the meals containing high fat and protein, because proteins and carb and fat we seldom include. So now this is also included. But basic thing is every children with type 1 diabetes or even type 2 who are dominantly on insulin, they should know the carb counting. Monitoring is very important. Self-monitoring of blood sugar to be measured 6 to 8 times a day for aggressive management. Real-time CGM data is very, very important, but they should be made acquainted. They should understand and they should use it. Intermittent self-monitoring, again, those who are not using these technological things, they can use basic monitoring. Diabetes center personnel should advocate to, this is again very important, that if we can provide regular strips, and sometimes even we are providing, patients are not doing. So CGM, this is all about CGM. This is Guardian Connect. Once I put to myself, I think it gives a very nice thing. I mean, look at the data, and this is a very full. The AGP metabolic glucose profile is approved up to the age of above 4 years. Hypoglycemia should also be discussed. Very important. And most important thing is hypoglycemia awareness for long-standing type 1 diabetes patients. And another important thing is whenever hypoglycemia occurs, whenever it occurs, people go for sweets or chocolates or something sweet. But what is most important thing is at that point of time, give pure carbohydrate in form of glucose or sucrose. So the answer is either glucose or fruit juice or cold drink, because these are the things that contain pure carbohydrate. Because if you're giving sweets, the chocolates or the gulab jamun, they contain fat and complex carbohydrate too. This is, I think, very important. Diabetes to be managed with brain. This is a science. And type 1 diabetes to be managed with brain and heart. Archana is sitting, Professor Das is sitting, Alok is sitting, they can understand. And clinicians truly dealing with type 1 diabetes need to handle them with love and compassion. I think I wrote long back on this India Today, unknown face of type 1 diabetes. So discuss these issues. A very brief about social issues. I'll be finishing in this 2-3 minutes. There is a school and education, food choices, whether to reveal diabetes or not. That is another big issue. I mean, I was discussing with Dr. Leja Das if we can discuss 1 or 2 questions on social issues. Social gathering, whether they should tell diabetes or not. What is happening in employment and job? What is the legal status? And relationships and marriages. School and diabetes. Teachers and support staff behavior is variable. Many schools are not aware of hypoglycemia and snacks before games. Meal in class is not allowed sometimes. So that is the status. I think very recently we published a paper in Pediatric Endocrinology, Journal of Pediatric Endocrinology. It was the multi-center study and I was part of it. Type 1 diabetes self-care in urban schools, and what it tells: refuse permission to check blood sugar, prohibited child from sports, excursion, did not allow pre-sport snacks. Private schools had a better infrastructure but equal frequency of non-supportive behavior. So healthcare professionals may need to focus on lesser educated parents and children in government schools to improve diabetes care. College and diabetes, whether reveal or not, healthy, unhealthy, moving with flow of life, same time managing diabetes is a challenging. But if at the back diabetes is in the mind, they can do. Marriage and diabetes is, I think, is still a big issue. People with type 1 diabetes are as normal as anybody. We talk, we say, but in reality it is not. And they have full right and can handle the responsibility of marriage. What is happening? People hide their diabetes, males more, females also, but creating problem. They undergo a number of refusals, even if they declare that they have diabetes. If asked for opinion, many times, I mean, this is again request family doctors that if type 1 diabetes is controlled, A1C is normal, no complication, he or she is as normal. So they should not so say no to the marriage. So that is another part. I think Professor Jargas is there. He witnessed one of our meeting 14 years back. And the solution to this is encourage them to be independent, smarter, and carry themselves nicely. Team management involving patients, parents, social workers, and doctors. Team and society equilibrium. That is again, the society should know what these type 1 diabetics are there. Convince family doctors and society that they are normal as anybody else. And finally, I'm giving you today's thought. Why most of affordable pump type 1 are not on pumps. So this is my thought I just wanted to share with you. And to conclude, DCCT addict trial showed the path that good control from beginning is very useful in terms of long-term outcome. It is more than 30 years of follow-up. Monitoring evolved as key component of complication-free life, because until unless we know, we can't do it. Awareness of individual, family, and society continues to be important. Lots of social issues need to address, especially relationships and marriage. And this is one of our big, I think for the first time in country, we did a fashion show with type 1 diabetes. So I lived with type 1 diabetes for last, I think, 28, 29 years. Thank you so much for your kind attention, and apologies for interruption.
Great, Rishi, great talk. Yes, Shraddha, you can conclude, then I will invite Dr. Lija Das. Shraddha, you can contribute. You were the pioneer in the social aspects as Rishi showed. 1 or 2 words, then we'll pass on to the panel discussion. Shraddha, 1 or 2 words.
Right, sir. Thank you so much. And I think this marrying the two topics, the social aspect, the clinical care, and the science and advances, all have to come hand in hand, and the technology and the latest science has to reach the last mile. And that is why it takes all of us. If they say it takes a village to raise a child, here it's taking the entire world to bring our children a better life, and also adults, as Dr. Sanjeevi mentioned. So thank you so much for having this panel and having me here. Over to you, Das, to introduce.
Thank you. All of you are in the panel. Sanjeevi, Alok, Rishi, of course, Archana, everybody is in the panel. This is my great honor and now to please invite Dr. Lija Das for the moderation. Can I have the okay. We have Dr. Lija Das, who is MD Medicine and DM Endocrinology. She is the one fortunate lady to be associate fellow of the Academic Medical Science. This we introduced this year. This was SIP's brain idea, and people with DM at a very young age to become the fellow of the Academic Medical Science. We call him associate, but they're almost equal to full fellowship. Thank you, Lija, for joining us. Consultant, Department of Telemedicine and Endocrinology in PG Mod, Chandigarh. Without taking much time, I'll pass on the panel discussion to you. Lija, please take over and conduct it.
Well, thank you very much, sir, for those kind words. And at the outset, I'd like to thank you and Dr. Alok for organizing this wonderful conference and for having me here. It is a matter of not only pleasure, but also privilege for me. So good afternoon, one and all, and good afternoon to all the respected panelists, Dr. Alok, Dr. Sanjeevi, Dr. Rishi, Professor Das, of course, and Dr. Archana ma'am. So after these excellent talks, I would just like to carry on the momentum. So I think I'll address the first question to Dr. Alok. And I would like to start by asking, what is the role of autoimmunity in diabetes? And just to improve our understanding better, are the autoantibodies really pathogenic, or are they merely an epiphenomenon of the disease?
Alok, is it just a bystander or the disease initiator, perpetrator? Alok, are you there?
Maybe I can take this question, Dr. Das.
Yes, Sanjeev.
See, the autoantibodies are markers for the disease. They do not cause the disease. They are the result of the disease. So the damage to beta cells is not done by the autoantibodies. The damage to beta cells are done by the T cells. There is an abundant evidence to that. So it is antibodies are basically markers. They do not cause the disease. That's the answer.
Right. Well, thank you, sir, for setting the ball rolling. And
we have time. Can I supplement a question to Sanjeevi, who is the father of autoimmune diabetes? Sanjeevi, I just like to know. I think you beautifully said that it is not it's not pathogenic, but you said something. They do not damage beta cells. Something you said, Sanjeevi, I couldn't follow that. You said
they do not cause the disease. That means they do not cause the damage to the beta cells. They are the result of the disease because GAD is intracellular. Okay, GAD has to come out, and the GAD has to be taken by the macrophages. And this happens in the local lymph nodes. And these macrophages present the GAD to the T cells. And this happens again in the local lymph nodes. So for these things to happen, the antibodies develop. For the antibodies to develop, GAD, they cannot develop if the GAD is still inside the beta cell. So something causes the destruction of the beta cell that releases the contents of the beta cell, and the autoimmunity is developing to the contents of the beta cell. So the basic trigger is the T cells or the viruses that result in the destruction and the damage by being done by the T cells. So T cells is the culprit. They cause the disease. So this is how the facts are. And we just use the antibodies to measure the disease intensity, disease severity, as well as for making diagnosis and prediction. And they are excellent tools for these aspects.
Thank you. I think as you rightly said, even said in multiple writings, same thing. There are excellent tools for the prediction and also the disease prediction.
Diagnosis.
Yeah. But Alok, but Sanjeevi, when you give the tuber, GAD antibody potatoes, you were trying that, I know, for inducing tolerance. Does it present to the B cells, or how does it help?
No. See, basically, the amount of GAD that is available to induce tolerance has to be substantial. And when you give GAD in terms of putting it into tomatoes or potatoes or whatever, the bioavailability becomes very small. So that approach has really not worked at all. Because amount of GAD, whatever you consume in this form, GAD is a protein. It gets digested by your stomach acids, and nothing is available beyond the passage of the stomach. So this approach was tried, but you have to eat kilos of potatoes that is got GAD in it in order to get the effect. So this is an experimental study, but not meant for use for people yet.
Thank you. I think Dr. Lija, please take over.
Yes, sir. Thank you. So just continuing with the momentum. So now that we are discussing about antibodies, and so Dr. Rishi, if I may pose this question to you, what are the types of antibodies that one should commonly look for? But more importantly, are these assays qualitative, or do they really have a bearing in terms of their titers or their quantitativeness?
I think the antibodies that we usually measure, the most common one is the GAD1 and insulin antibodies. These are the very common antibodies. Then ICA, islet cell antibodies, then zinc, T8 antibodies, and finally macrosomal. 5 antibodies are there that are responsible. Of the two, GAD and IA2 are very important. And GAD, as Alok was saying, not frequently seen in the eastern population, but I think in this northern part, it is seen in more than 60% of population. So more frequently we see. So at least these two antibodies are very important. So this is one. Quantitative value is there. If the titer is more, they are more harmful, most likely. This is the way I perceive. I think Dr. Sanjeevi is there. Can you answer this?
See, the titer actually reflects the amount of antigen that is available. One of the conditions where you have autoimmune diabetes, in addition to a neurological condition called stiff man syndrome or stiff person syndrome, as it is called, where there is a serious cerebellar damage. Okay. And GAD is also expressed in cerebellum. So this is the result of GAD antibodies being formed in patients with stiff person syndrome. Okay. In this situation, nearly 40-50% of patients who are diagnosed with stiff person syndrome have type 1 diabetes also. This is the only condition where the GAD titers is through the roof. If you have a titer, say 10% in type 1 diabetic patients, it's 1000% in Swift-Man syndrome. So the titer is not something that you will use, but you will use the interpretation of GAD index in terms of the severity or the positivity that you will find. So GAD is very important tool for making diagnosis. 80 to 85% of patients newly diagnosed with type 1 diabetes are GAD positive. That doesn't mean the rest of the 15% do not have autoimmune diabetes. If you look at the combination of antibodies, whether it is either GAD or IA2 or zinc transporter antibodies, then you will arrive at 96% of patients have either of these antibodies or more than one of these antibodies. That still leaves you with 4% of patients who are not antibody positive to these known antigens, but there is something else that could probably be the reason for them to develop autoimmunity. So these antibodies are very important. The titers are very important. Titers denote what kind of subset of diabetes that you might have. So there are several conditions, as I just discussed about the Stiff-Person syndrome, where the type 1 diabetes is seen in association with some other disease. And celiac disease is another example where type 1 diabetes is seen in association with some other disease. So in these situations, the titer becomes important for you to identify. Could it be something else? Is it just pure type 1 diabetes? Is there something else also there that you're not detecting? If you are looking for newly diagnosed type 1 diabetes, many of them are positive for thyroiditis, and they will have development of thyroid immunity also. People don't check all that. So GAD is also a part of type 1 diabetes, also a part of polyendocrine autoimmunity. In those situations, we ignore the possibility that other endocrine organs are involved in terms of autoimmune process. So one needs to be a little careful in terms of identifying, is it one antibodies to other antigens, say for instance in celiac disease or for instance in thyroid autoimmunity, to just distinguish, is it pure type 1 or is it pure, it's a mixture.
Thank you. I think the second part, Dr. Lija, you can ask.
Yes. Like Sir Dr. Sanjeevi, you told about the prevalence of nearly 80 to 85% of these antibodies, especially GAD, in an autoimmune diabetes population. On the other hand, can GAD antibodies be positive in a non-diabetic individual or in a person who is clinically type 2 and continues to be type 2?
See, GAD antibody in the general population, 2% of the general population have GAD antibodies. Okay. GAD is 585 amino acids long. And there is something called GAD1 and GAD2. So there is something called GAD65 and GAD67. If you would look between GAD65 and GAD67, the sequence homology between them is more than 80%. Okay. So when you're developing an assay or when you're using an assay that measures GAD antibodies, the assay is targeting certain part of GAD protein that is common to GAD65 as well as GAD67. You have a tendency to identify GAD67 positivity and interpret it as GAD65. So these are all things that might come out in relation to the assay methods and what kind of antigenic fragments that assay go and determine. So the quick answer to your question is that 2% of the general population have GAD antibodies. It's possible to have GAD antibodies and not develop type 1 diabetes because GAD antibodies is the first antibody that occurs in pre-diabetic individuals. When we are following children from birth, we are following 44,000 newborn babies all the way from birth until they develop type 1 diabetes. Nearly 300 or 400 of these children have developed diabetes, and we have all the samples. So GAD antibody positive type 1 diabetes is different from IA2 positive antibody type 1 diabetes. So these are two different diabetes basically, where the etiology is different, the destruction of pancreatic beta cell is different. So we tend to generalize the use of the word type 1 diabetes and assume that everything is common under that title. It is not the case. So you have patients who have zinc transporter antibodies developing type 1 diabetes who are GAD negative and IA2 negative. And zinc transporter antibodies develop first and they also stop first. They are present as long as the honeymoon phase is present. So we are now mixing a lot of things and calling it under the name of type 1 diabetes and assume that that terminology encompasses everybody, which is not the case. And our screening of newborns and following them up is giving us a lot of clues. So GAD type 1 diabetes is different, IA to type 1 diabetes. So if you want to treat GAD type 1 diabetes in terms of intervention, the same approach will not work for IA2. But in certain severe cases, if you are DR3, DR4 positive, then you might have both types of autoimmunity occurring, GAD antibody being positive, IA2 antibody being positive. So these are two type 1 diabetes etiologically different under the clinical umbrella of one type 1 diabetes. So we need to have these distinctions so that our data does not get a confused picture. So this is my answer to your question.
Lisa, Dr. Lisa,
Yes.
during our study in GAD antibody in normal controls from Cuttack, 20 of National Sports Academy students were included, and 4 of them had GAD antibody positive. National players of football. I have been studying them for last 25 years, and none of them have developed any diabetes. So GAD can stay, whereas IA2 and other antibodies will disappear, as zinc transporter Sanjeevi was telling. They disappear quickly. GAD remains even in normal population. So that is one thing we all should know. Just by getting a GAD report, we should not.
With your own experience, Alok, very
Follow up this question. I have a query, sir. Also, sir.
Yes, sir. Yes, sir.
If someone is non-diabetic and siblings, all of his siblings are type 2 diabetic and parents are also diabetic, and the patient is very conscious about his future, and he did antibody and GAD65 is positive, but he's not diabetic. Siblings and parents are diabetic. My question to Dr. Sanjeevi, that in this scenario, how do you interpret in this, how do you approach this person who is not diabetic and all the siblings are diabetic and the parents are diabetic and he is GAD65 positive? And what's the role of teplizumab in this particular scenario?
See, when you say diabetic, I assume you are referring to autoimmune diabetes in the relatives, or are you talking about type 2 diabetes? So you are talking about type 2 diabetes in the family. And one of the members have developed GAD antibody positivity. And GAD antibody positivity can become positive, and over a period of time, maybe even 1 or 2 months later, can become negative. Okay, these are the low titer GAD antibodies. And these low titer GAD antibodies, which was very clearly shown by Paolo Pazzilli and his wife Raffaella Buzzetti, show that these are not to be taken into consideration as they are unstable in their positivity over a period of time. So in this case, if the GAD index as it is measured in terms of JDRF units, clearly shows certain percentage of positivity or certain cutoff value is something that's going to be very relevant. In terms of teplizumab, for somebody to use teplizumab, you need to have at least 2 or more autoantibody positivity, and there should be a family with type 1 diabetes in the family. Okay, so there is a clear indication that the sibling of the type 1 diabetic patient who is autoantibody positive would greatly benefit from teplizumab in terms of delaying the onset. So the teplizumab follow-up has happened something like 2.5 years only. So we cannot say it will be protective for 5 years. With the data available for teplizumab, we can confidently say there is a delay by 2.5 years. Maybe 1 year later, if you are going to ask the question, now the people with teplizumab still don't develop type 1 diabetes, we can clearly say 3.5 year follow-up is going to. So until the follow-up data is clearly available, we cannot predict the length of the protection teplizumab is given. Right now, it is delaying the onset in first-degree relatives of patients with type 1 diabetes. But in terms of type 2 diabetic patients, where one of the relative happens to have GAD antibodies, we need to measure the titer of the GAD antibodies, and the risk for them developing type 1 diabetes is really, really low. You need to follow these patients periodically. That's also very important. Yes.
Hi, Dr.
Devjit,
Sanjeevi. This is Devjit. Hi. Just a comment on the GAD antibody titers. So when I was in Sweden, worked with the Leif Group and Tina Mayatumi, we published a paper in which actually, and she has published several, and she has shown, and actually we also noticed that even in non-diabetic subjects, the GAD antibody titer correlated with the disease severity. In non-diabetic, like if you have a higher, very high titers, they have lower insulin secretion and more insulin sensitive also. They're in general in between type 2 and type 1. And those are high titers, their insulin secretion was slightly lower than those are low titers. So just a comment.
Yeah, I agree with you, Devjit. It's really a fantastic observation that Leaf Group had made when you were there, where he also indicated that it is possible for somebody to be both type 1 and type 2 diabetic patients, because the etiology, the genes associated are so different. What prevents you from having both the disease in the same individual? And that is realistic. And in that situation, you will tend to think is it type 1 or is it type 2? Because it could possibly be both. We are not taking that part of the argument into consideration, but it was Leaf Group who pointed out that quite a number of patients can be both positive.
Actually, I think it was he who coined the term ladder. I think he was the first one, right?
No, the Australian groups did it for the first time. Okay. But he did some pioneering studies to show that TCLF-LA, the marker for type 2 diabetes, is significantly increased in LADA patients in his cohort, which is the Botnia cohort. So that is clearly an indication where type 2 diabetes genes are present, type 1 diabetes genes are present. And he argued that it is a separate disease, not type 1 diabetes or type 2 diabetes. That was his argument in his diabetes. But very interesting observation, very interesting findings.
Thank you.
No, you have to go a little far because I can see Devjit has come. Dr. Jargar also has arrived. But we should go through questions quickly. Very important.
Sir. So I'm doing exactly that. So just a quick follow-up on that question, sir. Dr. Sanjeevi, is there a cutoff that we can use to say high and low titer? And the second question, immediate follow-up to, I think I can address it to Professor Das. So, sir, we know that the incidence of type 1 diabetes is increasing, and despite the fact that the autoimmunity levels really haven't changed. So how would you address this discrepancy?
I'll answer the easy question first, difficult one for Sanjeevi, with whom I worked for 1 year. I must tell you that the type 1 diabetes is increasing by 3% per year. I mean, that's what you're referring to. And that's why type 1 diabetes is increasing. And also your question is that is the autoantibody appearance increasing or not? Is that the question? Type 1 diabetes.
So from whatever has been the titer, she is talking about the titer. And the titer, see, how do you arrive at the positivity? You arrive at the positivity by measuring antibodies in healthy individuals of certain number and then correct the mean value. And that mean value has to have mean plus 2 or 3 standard deviation, depending on whether you're looking at 95th percentile or 99th percentile. So if you take, say, 1,000 healthy individuals in India and measure antibodies, your GAD index is going to look different. If you take 1,000 Europeans and measure healthy people and measure, the GAD index is so, you cannot use a control of one country to compare the positivity for the control of another country. When you're using GAD kits, the GAD kits are all created with control population. Say, for instance, in Europe, if you buy this European kits and use it in India, your cutoff for positivity cannot be what the Europeans are using for cutoff for positivity. You need to develop your own cutoff on your own healthy control. So the cutoff for positivity will differ with the different population, and that needs to be measured with healthy individuals tested in the local population.
We have not
established. We don't do.
I think Sanjeev is absolutely correct that we don't have yet the standard testing in our country. We don't have the standard. What is the exact prevalence of the GAD antibody positivity? We can pass to next question, Lija, or the whichever question.
Yes. So the next question, I'd like to invite Dr. Alok. So, sir, is LADA, would you consider it as a single disease entity, or would you consider it to be really a cluster of phenotypes? And are there any therapeutic implications if we identify a phenotype of LADA?
It's very important.
Alok, yeah.
This is very important. We need not say it is a cluster of phenotypes, but progressive changes in different stages of LADA. And initially you find the same person with certain presentation, and gradually it changes over time. And as per the antibody markers, genetic markers, and other aspects, so many aspects are playing important role in LADA. So LADA is not one single disease or one single type, phenotype. It is a progressive disorder.
Fine. Lija, you can take up question number 6. That is very interesting.
Yes, yes, sir. And that's exactly what I wanted to ask you about. So if we discuss about micro and macroangiopathy in LADA versus type 1 vis-a-vis type 2 diabetes, so is there a difference in the degree, in the types of involvement of complications? Professor Das, sir?
Yeah, I think the complications in type 1 and type 2 diabetes have been studied, and to my mind, the complications of the microvascular disease and the microvascular disease are different between type 1 and type 2, because there are two different kettle of fish, and there are a lot of factors which affect the type 2 microvascular disease, the risk factors, which possibly are not so in type 1 diabetes. That's my feeling. And
that's absolutely right, sir. Sorry to interrupt there. I just wanted to know about LADA complications in LADA versus type 2 and type 1.
LADA is basically type 1. LADA is basically type 1, little elderly age group. But if you take question number 6, it says that recently there is also association of LADA, which occurs around 30 years of age, obesity, smoking, and sedentary lifestyle, and therefore I think they are also predisposed to environmental factors, risk factors as any type 2. So one has to study them. I don't have the data here to describe, but there it may be different. But type 1 diabetes and this differs. I just want to ask one question to Sanjeev and Alok. Sanjeev, we discussed about the autoimmunity LADA, but we have to also discuss a little bit about autoimmunity in the other diabetic complications. Sanjeev, you remember?
Yeah, one of the landmark papers is talking about is type 1 diabetes induced by diet.
Yeah.
We are all thinking about variety of factors that induce type 1 diabetes, the trigger for type 1 diabetes. We commonly presume viruses as one of the causes. If you follow some of the recent results, and we don't have the published the T1DGC follow-up results on children followed from birth in Sweden, gluten is a clear-cut dietary marker or dietary component that causes celiac disease. And gluten also is probably responsible in some way for type 1 diabetes. Since gluten has been studied and it has been clearly established as an important dietary component, it is a clear-cut case, but we still do not know what other dietary components are relevant for etiology or development of type 1 diabetes. The current studies, again coming from the Malmo group, where Devjit had spent some time, Okel and Mark is following all these Swedish children from birth, clearly show that depriving gluten in children who have developed type 1 diabetes, depriving gluten in children who are autoantibody positive, high-risk HLA positive, not yet developed diabetes, there's a great contribution by keeping gluten away from their diet. So this is something one needs to ponder in terms of how diet plays an important role in development of type 1 diabetes and also in its reversal. So I would like to leave this thought in the minds of the physician, and somebody in India need to study this in a follow-up basis.
Exactly.
And come out with it.
Yeah, coming to the point of the bovine serum albumin. India sometime back, ICMR took up a project to look into whether, I think Lija would remember, camel's milk. You remember? Dr. P.R. Agrawal's project we gave him about the camel's milk. I mean, Sanjeev might not have seen that paper, which was negative. But do you feel that apart from gluten, you beautifully pointed gluten. I think that was the title you had given earlier. So I looked up literature. It was great. Thank you very much for that new fact you put before us. What is the status of milk? Do you have any idea about the camel's milk?
Well, I do not have the idea because even with regards to the milk story and the etiology of type 1 diabetes, the data is predominantly coming from Finland. Then you start talking about type A cow and type B cow. Okay, now I do not know where does the camel fit into this picture. Are they similar to type A cow or type B cow, or is it a separate camel type A, camel type B? We do not know. So we need to really figure out where does this come into the picture if we want to describe. Maybe there is something that's totally different etiology in terms of what camel milk does to the gut microbiota and how it influences the diabetes development or diabetes control. So we need to study more. If the Finns have studied a great detail about cow's milk, we need to study a great detail about camel milk and decide what is there in the camel milk that causes the remission or whatever.
I think Lija will stop here in interest of time because we have 2 more sessions left. That is 6 plus 1, 7 lectures left. So if you want to take 1 or 2 questions more, Lija, most welcome. Maybe 2 quick questions you can take. We will not have time for all the questions. You can take your choice. 2 more questions.
Okay, right. I got it, sir. Thank you. So I was just moving on to the immunomodulation in type 1 diabetes.
Yes.
Would we really say it is more of a bench issue now, or has it moved to the bedside, especially in the wake of the approval of teplizumab? So I think it is addressed to all the panelists. So, please.
I think it still remains in the bench.
No,
but not the bedside. As Sanjeevi has clearly mentioned, who are the probable candidates for teplizumab use, 2 antibody markers, siblings, many other things. So it is still in the research stage. It will take maybe 10 years or any number of years to come to the.
I happened to go to two pediatric endocrinologists from England, and they said they had got good results, but maybe they have to use again after 2 years to prolong the what should I say, the dormant phase. They may have to use. So things are not yet clear. But Sanjeev, I want to ask you one more thing, which is very important for our purposes. Sanjeev, don't you believe that the BCG, we wrote about BCG, does it not produce some degree of immune modulation?
Yes, it does. Actually, it is in phase 3 clinical trial right now.
Really good.
Dennis Fossman from Harvard University is doing that. And we need to wait for these phase 3 results, and we need to get the FDA approval for it. The first approval from FDA has come only for teplizumab, the first ever intervention.
Thank you.
So if BCG comes with a very good results in the phase 3 trial, maybe that is something we may have to consider. There again, we will have to be very careful on what we mean by BCG. It is actually the Danish strain of BCG that is relevant, not the Russian strain or a Tokyo strain. That's the most immunogenic form, and that is what is being tried in the clinical trial right now in US. And the same trial net cohort is what is being used for that study.
Thank you, Sanjeev, for giving the concept. It was in the New York Academy of Annals of Academy of Medical Science that you probably published that. And thank you very much for. I mean, it's a great thing. And I also had 1 or 2 inquiries after that paper you wrote. Thank you very much, Sanjeev. I think.
Thank you very much. Thank you.
Lija, one more question. I cannot say no to young ladies. So, Lija, one more question, please. That's all.
Right, sir. So if we can just briefly talk about the importance of time in range in the clinical management of type 1 diabetes, its association with the complications, its association with overall control.
A question for Rishi. Rishi is here.
Yeah, time in range is very, very important. And only thing that we can address to our Indian audience is we should start using more and more CGM. Even if CGM is not being used, I simply say use more frequent blood sugar monitoring. One question that Lisa raised is, what are the barriers of poor control? I think the basic thing is monitoring. Once our type 1 patients need to understand the monitoring, I think more than half the task is done, because then they act upon that. And basic monitoring, then CGM monitoring, then time in range. And time in range, I think we have shown, Bansi has shown that the hypoglycemia has gone down drastically. The A1C has gone down drastically without hypoglycemia. So these are the advantages. And I think in one of my slides, I've shown that
you showed that
every patient we should encourage pump, and to every patient we should encourage CGM. So this is what my take is, because we are lagging behind somewhere. not because of financial reason, but because of maybe we are not able to make our type 1 population understand. So
Dr. Lija, thank you very much. Kindly conclude the session.
Yeah, dear friends, I must tell you that Lija, you were wonderful. Your questions were fantastic and superb. Thank you, Alok. Sanjeevi, I have no words to express my thanks to you. Sanjeevi, thank you very much for being here. And Devjit for your very brief comment. Rishi, I always hold you in very high esteem because of your work as Sarda, who both of you have made a great contribution. Because lack of time in silence get us respect. I'll keep silent to my great regards to Alok, Sanjeevi, to you, Arishi, of course to Sharda and to Lija. Thank you very much. But dear friends, wonderful session.
Bye. Thanks.
Thank you, sir, and thank you to all the panelists.
Thank you.
Thank you, Lisa. Thank you, Lisa.
Thank you.
Thank you, Alok.
Sanjeevi, thank you.
I leave. Thank you. I leave the meeting. Thank you.
Yeah, thank you, Sanjeevi. I'll catch up with you sometime on email.
Yeah, definitely.
So now, dear friends, it's time to start the next session. Heavyweight session. Heavy because Devjit is there, but my friend, you can see him photographed now, is Dr. Jargar is here. And Dr. Jargar is from the Kashmir and, head of the Sere-Kashmir Institute. I don't believe in calling ex-wife, former head of the department, former secretary to the government. I mean, you are for me the director of Sere-Kashmir for this year to that year, and also in the institute boards of all India institutes, AIMS, SGPGI, and all that, and selection committee member. A lot of original work he has done. One such work will present today.
Yes, sir.
Finally, Nikhil, are you there? Nikhil will join us subsequently. Nikhil Tandon.
Sir, I'm there, but I'm actually, there was a little conflict, so I'm here, but I've recorded my lecture, so I'll be keeping quiet while the lecture is played whenever the time comes on, sir.
Okay, Nikhil, sorry. Thank you very much.
Not at all, sir, but I'm very much there, sir.
Thank you. Did you enjoy the previous session, Nikhil?
Sorry, sir.
Yes. Nikhil also is the top in the young group. Did you enjoy the previous deliberations on type?
Yes. Yeah, very much so, sir. Very much so.
Okay, I'm very happy that you are there. Now, dear friends, at this stage, it's my great pleasure. I don't have anything to in the context setting. Is Kalpana here? Kalpana Dash.
Sir, good afternoon, sir. Very good afternoon, sir. Yeah.
Good afternoon. Kalpana is a top endocrinologist of the country. In Raipur, I'll make it very short to save time. And Kalpana Dash. We invite Devjit. Devjit is very close to us. And Kalpana, please invite emerging role of dual GLP-GIP agonist in management of diabetes obesity is going to come to our country next year. So, tirzepatide. So, Kalpana, please take forward quickly.
Sir, thank you very much, organizer, for having me here. It's actually...
Yes, Kalpana. You can read the one or two words from the...
I'm sharing my chair with you, sir. Hello?
Yes,
Thank you very much, sir. Yeah. Thank you very much, sir. I'm very much proud to share the chair with you, sir. You had been my mentor in the past and also my examiner.
So
we have with us because you have already introduced them. So we'll be talking on 3 topics. First is the emerging role of dual GLP and GIP agonist in the management of diabetes and obesity. And that will be delivered by good friend Dr. Devjit Tripathi, who is from US. And the second talk will be on PCOS. That will be spoken by Dr. Professor H. Jargar, and third will be by GDM, the long-term outcome, by Professor Nikhil Tandon. So we are already using the GLP-1 RAS in the form of injectable once daily and once weekly, and also oral also we have. But now we are having the use of this GLP-1 and the GIP-1 dual agonist with us. And we are having this injectable form once weekly. We use it, and we'll be discussing regarding this. And Devjit will deliver the talk. What is the efficacy and what are the head-to-head analysis with semaglutide and all the things. And so I call upon Dr. Devjit Tripathi to please deliver the lecture.
Okay, so thank you, Kalpana, and thank you, Dr. Kanungo, for the opportunity here. It's indeed a great feeling to be here amongst our former teachers and colleagues, Dr. Professor Das, Kanungo, Dr. Sanjeevi, Nikhil Tandon. So today, okay, let me share my slides. Okay, just a minute. Okay, can you see my slides?
Yeah, we can see. Yeah,
okay.
Yes, we can.
Okay. Okay, so let me see if it is a full screen. Okay, so there's a slight change in the title of my talk. Initially, it was GLP-GIP dual agonist, but I will briefly mention about the triple agonist. So I think the appropriate title will be unimolecular polyagonist in management of diabetes and obesity. So I start with a case. Can you see the slide changing?
Yeah.
Yeah, there.
Okay. So I started the case which I see in my clinic, and he's a middle-aged male, which is obese male, has a long-standing history of type 2 diabetes, is on high dose of insulin, and is also on SGLT2 inhibitor, and has an extensive history of cardiovascular disease, and has multiple stents. And his A1C, current A1C is 8.2%, as he has chronic kidney disease, and he wants to achieve better glycemic control, but he's very concerned about weight gain. So what will be the appropriate choice in therapeutic option in this case? So we can increase the dose of insulin, but it will lead to weight gain. And DPP-4 inhibitors, these class of drugs have very modest improvement on glycemic control and have no effect on weight. And pioglitazone can lead to weight gain. So obviously the choice will be a GLP-1 agonist. And he was in fact started on a GLP-1 agonist. I'll tell you which one. And 8 months later, when I see him in the clinic, his current A1C is 5.9%. That is in the pre-diabetes range. And he no longer is on insulin. And he's lost 50 pounds of weight, which is more than 20 kilos, about 20 kilos. And his eGFR is stable. So, and this kind of efficacy with the anti-diabetic agent, we have not seen before. And he was in fact started on a drug called tirzepatide, which is GLP and GIP agonist. And this class of drugs, is comparable. The efficacy is kind of comparable to that you see following a bariatric surgery. So, as for guidelines, patients with pre-existing heart disease, I think other previous speakers have mentioned that pre-existing heart disease, you start with the GLP-1 agonist, particularly those of atherosclerotic heart disease, or those of heart failure, you start with a SGLT2 inhibitor. So we currently have several GLP-1 agonists available in the market, including the oral GLP-1 agonist, Dr. Das mentioned. But the limiting factor of GLP-1 agonists is that the adverse events, they're very potent. They're lower A1C by 1 to 1.5%, and semaglutide on higher dose can lead to weight loss about 15%. But the limiting factor again is the GI side, mainly the GI side effects. So
slides are not moving, I think.
Okay, slides not moving. Okay. It's moving now. Is it moving?
No.
Okay, it's moving on my end. Okay, let me just restart it.
Reshare will be better.
Okay, can you see it now?
No, now it has come.
Okay. Yes. It's moving?
Yeah, moving. Yes.
Yeah, it's moving.
Okay.
It's moving very well, Debjit.
Okay. So that's the limiting side effect of the limiting factor in GLP-1 agonist treatment is the GI side effects. So one strategy is that if you could add.
Can you make it full screen? Full screen.
Okay, is it done now?
No.
No?
No.
And why is that? Okay. Okay. Is it okay now?
Now it's done. Yeah.
Okay. So yeah, the one strategy is to combine with another agent, which will with the GLP-1 as a foundation, and then target other pathways like lipid metabolism or insulin sensitivity. Because GLP-1 agonists do not have a direct effect on insulin sensitivity or do not affect the lipids much. So, and how about the GIP? No, GIP is a glucose-dependent insulinotropic polypeptide, and it's another incretin. And in fact, the endogenous GIP accounts for majority of the endogenous incretin effect. It's more important than GLP, the endogenous GIP. However, the GIP secretion is found to be normal in patients with type 2 diabetes. And early studies shown that if you infuse GIP to patient type 2 diabetes, you do not see any effect on insulin secretion or improvement of glycemia. And animal studies, earlier animal studies are controversial, like if you knock out GIP receptor, there were some studies that shown actual weight gain, some studies show weight loss. So therefore, the GIP agonists are not pursued for management of type 2 diabetes. All the studies were mostly on GLP-1 agonists because GLP-1 agonists are very potent in weight loss and improving glycemic control. However, recently, it has been shown that in animal models, if you overexpress GIP, it leads to weight loss and improved glycemic control. And if you infuse combined GLP and GIP to patient type 2 diabetes, it's shown to be an additive effect in terms of insulin secretion, and but not on weight loss, just insulin secretion. However, it's not practical. You cannot combine and give two separate infusions or injections of GLP and GIP. So there's the possibility of a single molecule, which is both GIP and GLP, was being explored. And here it shows the compare and the contrast the effects of GLP and GIP. And on the left is the GLP. And here they both increase satiety or decrease food intake. That's how they cause weight loss. The difference is that GLP-1 actually increases nausea, whereas GIP actually decreases nausea. So if you combine GLP and GIP, then you expect that this will attenuate the adverse events of GLP-1. The other major difference is that GLP-1 reduces glucagon, whereas GIP increases glucagon, particularly in hypoglycemia and euglycemic settings. And another major difference, the effect on adipose tissue, because there's no GLP-1 receptors in the adipose tissue. So GIP has the effect, it's kind of mimics that of a thiazolidinedione. It improves adipose tissue insulin sensitivity, storage capacity, and the inflammation in the adipose tissue. That's why it can improve both adipose tissue and skeletal muscle in insulin sensitivity. So therefore, if you combine, so the newer strategy is to combine two molecules, because instead of giving two different injections, if you combine one molecule which can act on both receptors, that will be much beneficial. And it's called unimolecular multi-agonist. So single molecule act on different receptors, or it's called a hybrid molecules. So the hybrid molecule that is being now developed, or some of them are already in clinical trials. For diabetes, there's one combined with GLP and GIP. There's another one, glucagon. Glucagon and GLP-1, they're combined because they're both derived from the same pre-pro-glucagon, and they're homologous amino acid between GIP, GLP, and glucagon. That's why it's easier to develop a molecule which acts on all three receptors. And the benefit of hybrid molecules is that they confer the beneficial effect to each, like GLP and GIP, and they can counteract or the offset the negative effects of GLP. So, for example, in GLP causes increased nausea, GIP causes less nausea. So that's why you can increase the therapeutic windows for the GLP-1. So you can give higher dose without any side effect. And the other benefit is the single pharmacokinetic profile, because this is just a single molecule. And this is particularly important in patients who have chronic kidney disease, and those who have liver and hepatic disease also. And they have single molecules which acts on multiple effects on the single target organ. For example, in the pancreatic beta cells, both GLP and GIP increase insulin secretion from glucose-dependent insulin secretion from the beta cells. That's why they can increase insulin secretion, have a complementary effect or additive effect on insulin secretion. So these are the schematics showing the polyagonist that being now pursued for treatment in type 2 diabetes and obesity, GLP and glucagon. And I will not talk much about it because there's one drug developed by AstraZeneca. It's called cotatutide. And they went to phase 2 trials, then somehow, for some reason, they decided not to pursue. So there's no, currently right now, there's no drug being developed, but there's some drugs by Novo. They're pursuing it for treatment of NASH. And I will show details about the tirzepatide, which is the GLP-GIP, the only approved GLP-GIP co-agonist. And I'll show some data of the triple agonist, GLP-GIP and glucagon triple agonist. So these are the structures native for GLP-1, and this is GIP. GLP-1 has about 30 amino acids, GIP has 42, and this is tirzepatide, which is 39 amino acids. And tirzepatide is a peptide which is basically has the backbone of GIP. It's mainly acts like a native GIP. And in vitro studies have shown that this is more similar to native GIP in terms of efficacy in animal models and binding affinity and cyclic AMP generation, and is less than native GLP-1. And the half-life is 5 days, so you can eat, that's why you can have a once a week dosing. The structure of tirzepatide, the top one is GLP-1, then the GIP, then this is exenatide, the first GLP-1 agonist approved for the use in humans. And this is tirzepatide. So you can see those in light blue. These are the amino acids shared from GLP and GIP. So tirzepatide contains 9 amino acids derived from similar to that in GIP, about 4 amino acids derived, which is common to GLP-1, and about 10, which are common to both GLP-1 and GIP. So it has a lot of amino acids which is similar to GLP and GIP, and there's some from similar to exendin. And is bind to fatty acid, which binds to albumin, that's a prolongs its half-life. So this structure has a lot of similarity between GLP and GIP, but mainly more close to GIP than GLP-1. And in vitro studies have shown that it's equivalent to native GIP in terms of cyclic AMP generation, because both GLP, GIP, and glucagon, this class of drugs, they act on the G protein, this called G protein coupled receptors, which generate cyclic AMP. And you measure the amount of cyclic AMP to measure the activity of these compounds. So it is equivalent to native GIP, but much less than native GLP-1, 24 lower cyclic AMP than native GLP-1, and 5 for lower binding affinity than native GLP-1. Again, but these were animal studies and in vitro study. In human, what happens, we do not know. So they're the first in human studies. It was published as early as 2018, and showing that type 2 patients treated for 6 months with this compound. That time it was known as LY32981. And showing that the red one is dulaglutide as compared to GLP-1. And over a period of 6 months, while dulaglutide causes lowering of A1C by 1.1%, the high dose of tirzepatide led to hemoglobin A1C lowering of 2.4%. And the weight loss was similar over a period of 6 months, 11 kilogram weight loss with the higher dose compared to 2.7 kilograms with dulaglutide. So as of all available anti-diabetic agents, as of now, this appears to be the most potent agent in terms of lowering hemoglobin A1C and body weight. So I'm not going to go through individual studies. There are like 5 SURPASS trials, SURPASS 1, 2, 3, 4, and 5. And most of them have kind of similar design, just the comparator is different. Also a summary slide, which shows, so this is the phase 2 studies compared with, and then this is the SURPASS 1 with placebo. And then SURPASS 2 compared with semaglutide, SURPASS 3 compared with insulin degludec, SURPASS 4 compared with glargine and patient with high-risk cardiovascular disease, and SURPASS 5 again compared with insulin glargine. So as you can see, compared to placebo, this is the baseline A1C is slightly low. There's reduction of 1.5 to 2%, but all other studies consistently shown that there's A1C lowering in high dose ranges from 2 to 2.4%. And it is greater than semaglutide. This is semaglutide, but this is not the high dose semaglutide. This is semaglutide 1 milligram, which leads to hemoglobin A1C lowering about 1.7%. And this tirzepatide showed a greater A1C improvement compared to semaglutide. Not only that, in about 40% of patients with high dose tirzepatide, it leads to A1C lowering in the non-diabetic range, that is between 5.7 to 6.5. As we discussed a little bit earlier about metabolic memory, so if you can induce euglycemia in a patient with type 2 diabetes, that will have a long-term effect in terms of reducing complications, although those data are not available yet. And it is more beneficial, more effective than patients on insulin. This is insulin degludec, and this is insulin glargine. Again, both are insulin glargine. So consistently shown A1C lowering 2 to 2.4%. The bottom panel shows the effect on body weight, and again showing the 8 to 10 kilogram of weight loss, which is about 10 to 15% weight loss. Again, no other drug leads to that weight loss except semaglutide high dose 2.4 milligram can lead to 15% weight loss. And again, consistently shown about 10 kilogram of weight loss, which is about 10% of 10 to 15% weight loss. So overall, this study tirzepatide causes about 2% lowering of A1C and 10 to 15% weight loss in patients with type 2 diabetes. And how about adverse events? The basic premise was that if you combine GIP, you will should not see much side effects. However, that was not seen. But as with any GLP-1 agonist, the adverse event is seen initially in the first 4 to 8 weeks of treatment. And here this is compared with this is the semaglutide, this is tirzepatide 5, 10, and 15 milligram. You can see that first the higher dose, so there's a dose-dependent increase in adverse events, particularly nausea and vomiting. And however, it's seen earlier in the first 4 to 8 weeks. So the plan is, or the recommendation is to start low and go slow. So you start with 2.5 milligram and go by every 4 weeks, you increase by 2.5 milligram. If you go slow, the risk of side effect is slightly lower. But what was disappointing was that this was not really different than semaglutide. So although we show that this drug causes greater weight loss and A1C lowering, but you still see the similar kind of nausea and vomiting as you see with semaglutide. And here the bottom panel showing the vomiting, you see the similar data. So summary, the tirzepatide this is SURPASS-2, but it's similar to all of the studies, leads to about 10 kilogram weight loss and improved A1C, and also improves the triglycerides, lowering about 25 to 30%. It does not affect much of the LDL, and the HDL goes up by about 7 points. And the adverse events are comparable, not less or not higher, but it's comparable to other GLP-1 agonists. Now, this is a study on patients with non-diabetic obese patients. This drug is not yet approved for obesity, but a lot of people are using this as off-label use for obesity. And so in non-diabetic obesity, it shows a greater weight loss, 20%. This is consistent across all studies. You see greater weight loss in non-diabetic subjects than diabetics. One theory is that for each 1% lowering for A1C, you gain about 2.2 kilogram because you reduce the glucosuria. And that's a theory by Eki Arvinen. And but with the onset of with concomitant treatment with SGLT2, we don't know how true that is. But that is one theory that you always see a greater weight loss in non-diabetic compared to diabetics, any drug. And about 90% individual lost more than 5% of body weight, which is the requirement for approval of any anti-obesity drug by the FDA if you lose more than 5%. And based on this data, almost 80 to 90% lost more than 5% body weight. So cardiovascular events, this study was not powered to look at the cardiovascular benefits, or just about for the FDA requirement, you have to show that it does not increase cardiovascular risk. So from this, you can conclude that it does not increase cardiovascular risk. Only in the higher dose, 15 milligram, there's a trend, but again, the event rate was very low. So you cannot conclude whether it's cardiovascular benefit or not. One can conclude that there is not increased cardiovascular risk, both in SURPASS-4 as well as other SURPASS trials. So how does this drug work? How is it so potent compared to other GLP-1? There's several theories. Nothing has been tested in humans yet. The mechanism of action of this drug. The animal models does not always translate to that in humans. And one theory is that possibly GIP agonism acts to GIP, so there's an additive effect of GIP. Another theory is GIP enhances the effective of GLP-1, or GLP. If you start with the treatment of GLP-1, you achieve euglycemia. Several studies have shown in many humans that once you achieve euglycemia, the GIP can be effective. So possibly that initially you see the GLP-1 effect, then subsequently the GIP effect is observed. And there's who believe that this drug is nothing but just a very potent GLP-1 receptor agonist. So, but the human studies are not done yet. We are proposing to do one so that you can blocking one receptor, see if you can still see the effects. Another theory is that GIP enhances the lipid buffering capacity, that is a thiazolidine-like effect, which is not seen in GLP-1 agonist. And possibly there's an increased weight loss in tirzepatide. Again, it's in most weight loss not because of energy expenditure, but because of decreased caloric intake. And that is one theory, that there's increased effect of both GIP and GLP and the both receptors on hypothalamus. You'll see increased effect on satiety on the combined GLP and GIP versus single, only GLP-1. And again, there's a weight loss independent insulin sensitizing effect of this drug, likely to the adipose tissue. So there's one study looked at the mechanism of action, but again, this was in obese mice. And it showed that there's a weight-independent insulin sensitization by tirzepatide. Again, we discussed it could be like a thiazolidine-like effect of GIP. And this is the only study which looked at the mechanism of action in humans. What they did was in Germany, they performed euglycemic clamps followed by hypoglycemic clamps in patients randomized to placebo. Then one group randomized to semaglutide, one is tirzepatide. This is the effect on the clamp-induced disposition index, which is a marker of beta cell function, showing that patient on the green column, showing that they are higher, greater improvement in beta cell function, those who are on tirzepatide for 6 months. And it shows the clamp insulin data at baseline. They're similar. This is a hyperglycemic clamp. Here is the first phase insulin response. This is the insulin response following arginine. In a hyperglycemic clamp, this is the second phase insulin response. And showing that the red is the one with semaglutide, the green one was tirzepatide. At baseline, there was no difference in insulin response. However, after 6 months of treatment with semaglutide or tirzepatide, you see a greater effect on first phase insulin response, second phase insulin response with tirzepatide. And there is a greater, here again, confirming that the first phase insulin response was higher with semaglutide. The second phase tended to be slightly higher. Again, the insulin sensitivity was higher with tirzepatide. But again, there was a greater weight loss with tirzepatide than semaglutide, so the weight loss could be contributing to the improved insulin sensitivity. So to summarize, that tirzepatide is superior to semaglutide in terms of improving insulin sensitivity, but they have looked at the change in insulin sensitivity in the weight loss. So with the similar weight loss, semaglutide, tirzepatide has led to a greater improvement in insulin sensitivity than that of semaglutide. It improved better improvement in beta cell function, and also, even though there's a GIP component here, there's a greater suppression plasma glucagon with tirzepatide than with semaglutide. That could also be contributing to improved glycemic control. And the side effects are comparable to GLP-1 agonists. So overall, tirzepatide is very effective in terms of lowering glycemic body weight and improving glycemic control. The mechanism it does by improving both insulin sensitivity and beta cell function. And the synergistic effect of GLP and GIP, that it increases insulin sensitivity, insulin secretion, improves triglyceride clearance, and that's why plasma triglyceride is markedly reduced and possibly decreasing lipolysis, and increased fatty oxide and decreasing lipolysis. And here, possibly by decreasing postprandial glucagon and decreasing hepatic glucose production. Again, not all of them has been yet proven in humans. This is a hypothesis. So now, changing gear to glucagon. So we all know that glucagon is a drug which is the primary effect of increasing hepatic glucose production. So we use it for treatment of hypoglycemia. So it's counterintuitive to see that how glucagon can be used for treatment of type 2 diabetes. Now, glucagon has also effect on beta cell. If you give a glucagon, we do that called glucagon stimulation test to see insulin secretion. If you give acutely, glucagon increases insulin secretion. It has effect on the hypothalamus, decreasing appetite, increases energy expenditure, which is different than that of other GLP-1 agonists. They increase satiety and have no effect on energy expenditure. They increase fatty acid oxidation. That's why it's effective. That being pursued for treatment of non-alcoholic steatohepatitis or NAFLD. And they also decrease gastric motility, and they increase postprandial amino acid uptake. So the rationale for combining glucagon is because of these effects. So if you can increase energy expenditure, increase insulin secretion, and by combining a slightly glucagon-like activity in turn with GLP and GIP, you may see an additive effect. So, and of note, both glucagon antagonists and agonists are being developed for treatment of type 2 diabetes. In fact, we did a study on glucagon antagonists, but that drug is now being no longer being developed because it has some hepatic side effects. But the other glucagon antagonists are being tried also. So again, I just showed you GIP has effect on adipose tissue, improving insulin sensitivity and regulation lipid metabolism. Its effect on appetite. It has no effect on energy expenditure, increase insulin secretion, and increase glucagon. And GLP-1 mainly acts on the CNS, decrease appetite, insulin secretion, and delayed gastric emptying. And glucagon has energy expenditure, delayed, decreases appetite, increases appetite. So, and also cause increased fatty acid oxidation. So these are the two triple agonists that is being pursued in clinical trials. They both were published in Cell Metabolism in 2022. This is a compound developed by Sanofi, and this is a compound by Lilly. And this drug, both these drugs in animal models showed that it improved weight loss and improved insulin sensitivity and insulin secretion. However, for the Sanofi compound was once a day compound, whereas Lilly compound is at once a week. So for some reason, this compound they stopped for the development. We don't know why. But the Lilly compound, they've been pursuing phase 2 and phase 3 data. I'll just show you some phase 1b data. This is the data on triple agonist GLP-1, GIP, and glucagon, and it was published last year in Lancet. And this is a study, a small study, phase 1b study, and patient and dose escalating compared to placebo. There are 5 different doses of this triple agonist compared to dulaglutide. Patient with type 2 diabetes and 10 years duration of diabetes were randomized to receive 5 different doses. And as you can see, the bottom line, the dulaglutide is on the blue, and the others are different doses of the triple agonist. And this was only a 12-week study, that is for 3 months. And over 3 months, you can see that there's a decline in A1C by 1.5% with the highest dose of this triple agonist, but other doses shown between 1 to 1.5%. And this suggests that this is not a plateau. If you increase further, maybe for 6 months, you can see a further lowering of A1C. So they are currently doing the 6-month studies. And this is the weight adjusted body weight loss, again showing that 9 to 10 kilogram weight loss only in 3 months. But the most remarkable effect was seen in lipids. And here it shows that HDL on the left panel, the HDL actually went down, which is not good, but it slightly went down, whereas tirzepatide and other GLP-1 agonists increased the HDL slightly. And the LDL, there was a 30% decrease in LDL, highest dose. There's a 40% decrease in VLDL and triglycerides. So that's why these drugs are being pursued now by the compound by Novo for treatment of NASH. And the other beneficial effect just seen in a short study, this is like small number in short studies, so we don't know whether this will be replicated in bigger trials. They showed it 12 to 15 milligram, 12 millimeter of mercury decrease in systolic blood pressure. Usually all of the drugs like GLP-1 and SGLT2 inhibitor, you see a single digit drop in blood pressure, maybe 4 to 5 millimeter of mercury, whereas this drug, it's a significant lowering of systolic blood pressure. So overall, this compound over 12 weeks shown a similar safety profile as incretin agonist, improvement in glycemic control and body weight, and showed improved lipid profile. So, and the rationale for development of this drug, that even with a highly potent drug like tirzepatide, about 12% patients in all the SURPASS trials did not achieve control. So there is room for development of the drugs. Not all the drugs will not be good for everyone. So that's a rationale for developing other drugs, because 10 to 12% not respond to even the potent drug like tirzepatide. Although tirzepatide, they showed us effective regardless of the duration of diabetes, the baseline A1C, or the baseline C-peptide level. But still, there are patients who will not respond to tirzepatide. Maybe in those patients, one may try this triple agonist. So to summarize, GLP-1 agonists improve glycemic control, reduce body weight with hypoglycemia, and again, tirzepatide does not cause hypoglycemia per se, and so promising results in both glycemic control, weight loss, and has potential for use in NAFLD and NASH. And actually, we saw the type 1 diabetes studies earlier. They're actually doing some study in type 1 diabetes too. We do not know the results. And they're superior to other GLP-1 agonists. And the adverse effects of tirzepatide or the dual agonist comparable to GLP-1 agonist. And long-term data for tirzepatide, particularly in the cardiovascular outcome data, is still pending. It will be published in the called SURPASS CVOT trial. That will be published in 2024 October, when that trial ends. And the triple agonists, GLP, glucagon, and GIP, they are show a very promising role in terms of improving glycemic control for weight loss. may be approved for treatment of diabetes and obesity in future. I think that was the last slide. And as I showed that there are several trials undergoing now but there's no the GLP and GIP in pipeline now, but GLP and glucagon being pursued for treatment of type 2 diabetes and NASH, and GLP, GIP and glucagon again pursued for treatment of type NASH as well as type 2 diabetes. I think that was the last slide, and thank you. I think we'll wait for the panel discussion for the questions.
Yeah, Devjit, it was an excellent exposition of the dual agonist, and also you alluded to the triple agonist. It was very clear, and we'll get back to the other two lectures, and after that we'll have panel discussion. I welcome Professor Rakesh Shah, Professor Head of Endocrinology at the Osmania Medical College, who has joined us now. He will be moderating this session. Rakesh, welcome. And I at this moment hand over to Kalpana again to invite Professor Jargar for his talk. Devjit, it was wonderful, and you educated us on the new molecules on which you had very, very initial ideas. Thank you, Devjit. Over to Kalpana to invite Professor Jargar.
Thank you, sir. I request Professor H. Jargar to give his deliberation on PCOD. And sir has already given his introduction. He needs actually no introduction. He's the Don in the Srinagar and Jammu and Kashmir. And he's the boss in endocrinology in Jammu and Kashmir. Sir, over to you, sir, please.
Are my slides visible?
Yeah, visible and moving also.
Visible, sir.
Wonderful.
Yes.
Thank you, Kalpana, and thank you, Alok and Ashok. And particularly thank you, Ashok, for upgrading me to the stats of heavyweights today. But I think you ditched a lightweight in the middle of two heavyweights. Nikhil on the one side and Dr. Tripathi on the other side. It's a pleasure, a real pleasure, talking to friends, colleagues on a problem that I have seen evolving in front of me in the last 4 decades. You know, when I was doing my endocrinology, hardly any data was coming on so-called polycystic ovarian disease, and we did not even have a definition for it. We do not have even a proper understanding for it. So it's a real pleasure, as Dr. Tripathi was just now talking about, looking at molecules not only from the point of view of taking care of the metabolic components of diabetes, but also simultaneously addressing the weight, which, you know, some of the worst obesity we have seen is in the area where Dr. Tripathi is living, San Antonio and Texas. There was a, you know, just look at it. In 1980, when, you know, when I was a postgraduate, and 2011, when I left SKIMS, this write-up in Reuters in New York published. Hardly anything was known in the 80s about this particular disease process, and hardly anything was talked about. And then, you know, steadily, the problem became to a status where today, the commonest endocrinopathy in women is polycystic ovarian syndrome. And this whole gamut started with the same expansion of those metabolic diseases, non-communicable disease, the root cause in most being that obesity that we have been alluding to for quite a few years, that has been eluding us for quite a few decades now. Not that all patients with polycystic ovarian syndrome have necessarily obesity, but quite few have, and most have. This is a paper that we published more than 2 decades back, where we showed, yes, a significant number of people are becoming obese in Kashmir. But what surprised us that women were 3 times more obese than men. And that really surprised us, because we thought, you know, women in the Indian subcontinent are not being taken care of. The magnitude of nutrition is not that good. And so we were surprised that against 7.1% Kashmir adult being obese, males, 23% of the females were obese. And much later, a group known as Non-Communicable Diseases Collaboration Group, which we have been a part of for more than a decade, published how obesity has been globally behaving in the last half a century. This paper that this group published in Lancet in May issue 2016. We have been a part of this collaboration group for more than a decade, and this is being monitored from Harvard Medical School and Imperial College London. And it showed some fascinating things. We are interested predominantly for India. If you just look at this slide, on your left side, look at the magnitude of obesity in men. In the whole trajectory of different nations on this globe, India was at position number 19, which literally would mean that if you look in terms of absolute obese individuals, in 1975, even Germany had more obese people than us. Ukraine had more obese people than us. And now Indian men are at position number 5. Means the nation, we are getting obeser. It's not that rest of the world is not getting obeser, but we seem to be getting our bit now with vengeance in the last half a century. And if this was the situation in females, males, what happened to females? Look at it today. If you look at 1975, Indian women also were at position number 19, meaning that if you look at different nations in terms of absolute number of obese women, we had the 19th position in that trajectory. But today, after China and the United States, we have the highest number of obese women. And that's why today every gynecologist, every physician is looking all those ultrasounds with polycystic ovarian syndromes, getting referred to people right, left, and center. This is a paper that we published a decade after the last one, where we looked at relatively youngish people. Again, we saw that this obesity is taking off early, and there's a difference in this obesity between boys and girls. And later we published a paper where we studied children from 5 to 15 years. This trend was not as marked in them, in boys and girls, but the trend was there on the higher side in the females. Then in that global data that I alluded to, we looked at obesity globally in children, adolescents, and young adults. Situation globally exactly same. Much worse, obesity getting worse and much worse in females. When we look at how we make a diagnosis of a polycystic ovarian syndrome, it has eluded for a long time clarity, and I believe still continues to elude. NIH made an attempt in 1990 and very grossly underlined some clinical features, investigative features. And then a group of guys met in Rotterdam in 2003 in Holland. And today, predominantly one definition that we hold today, Androgen Access Society 2007 and guidelines. But what does it in real terms mean? You have a suggestion of hyperandrogenemia and hyperandrogenism and anovulation, a very broad thing and not a very precise thing. Oligo or anovulation and clinical or biochemical suggestion of hyperandrogenism may or may not have an polycystic ovaries, invariably would have on an imaging tool. But also it says that we have to exclude other conditions that are likely to give a scenario like that. Cushing's syndrome, hyperprolactinemia, hypothyroidism, non-classical congenital adrenal hyperplasia, androgen secreting lesions. But if you look at those exclusions and look at the level at which we diagnose polycystic ovarian syndrome today, these numbers for these disorders would be extremely minuscule. So many times, now today, the first thing that attracts this attention is this thatch of hair on the face. And the criteria that have been given by the Androgen Access Society, which again emphasized you need to have a clinical or biochemical suggestion of hyperandrogenism, ovarian dysfunction in the form of anovulation or oligoovulation, and a polycystic ovarian morphology, and exclude those clinical or pathological disorders that are likely to lead to a similar situation. Epidemiologically, depending on what subset of population you are studying and which criteria you are using, you will get different figures. Understandably, when you look at amenorrhea, when you look at oligomenorrhea, different percentages would come. But by and large, if you look at Rotterdam criteria or androgen excess society criteria, 10 to 12% of the people were said to have a possible diagnosis of polycystic ovarian syndrome. And I do believe, ever since this paper was published in Human Reproduction, probably the numbers have increased, the percentage has increased because the obesity has worsened. A very complex disorder, not obesity alone. Yes, a lot of data shows that this particular pathological process is associated with insulin resistance, which will come down to very soon. Is it a generalized insulin resistance? Some people have been believing that it's a more sectoral insulin resistance in the ovarian tissue. Is this fundamentally an ovarian defect, which ends up in creating more sex steroids, androgens, and estrogens that start the vicious circle, or a peripheral cortisol metabolism? But there's a significant thought and very relevant thought that it fundamentally is a neuroendocrine defect. When you look at GnRH from hypothalamus and the response of the gonadotropins to this GnRH, and the response of the ovary to this LH and FSH in the ovaries is aberrant. Now, today, there appear to be very differently two classes of people. Why? Insulin resistance is predominant. Because of obesity, it is emerging a much bigger class. And there's a class where neuroendocrine defects may be predominant. It's a relatively smaller class. But again, there is no clear-cut demarcation between these two. Just look at it. Almost 100 years back, Gist published in American Journal of Obstetrics and Gynecology, bilateral polycystic ovarian syndrome is most probably a result of some hormonal stimulation and very likely relates to the anterior lobe of the pituitary gland. And much later, about 40 years later, studies showed, yes, in a big chunk of these people who had this polycystic disease of the ovaries, there was an excess LH activity in the plasma. Again, if you just recapitulate this is what I said. You have a GnRH, it acts on the pituitary. Either the pituitary is hyper-responsive to the GnRH and causes more LH, or there is a defect in the feedback from the sex hormones, androgens and estrogens, into the hypothalamus that responds aberrantly to the GnRH secretion. But this may still be debatable, the precise mechanism, even though a lot is known today, than was known 4 decades later, 3 decades later, 2 decades later. But what is unquestioned, that this is a clinical stage which is characterized by hyperandrogenemia, but also hyperestrogenemia, because that's the main source of estrogens is androgens. And that's why, you get endometrial proliferation and possibility of an endometrial malignancies and excessive bleeding, all that. Whatever the reasons for insulin resistance, whether they are genetic, autoimmune, some defects, hyperinsulinemia through different routes has been shown to cause a decrease in sex hormone binding proteins. So free testosterone is on the higher side, gives a hyperandrogen state. This also decreases in IGF binding proteins. So IGF is on the higher side, can cause ovarian stimulation. And this differentiation of a ratio between LH and FSH drives it more towards an excessive production of androgens. A lot of data right from 80s has shown that almost half to 2/3 of women with polycystic ovarian syndrome demonstrate clinically measurable insulin resistance above and beyond as determined by their body weight. So there's something more than the body weight alone that does cause hyperinsulinemia. A lot of data has come up for the last half a decade, for the last half a century now. Firstly, those crude urinary emissions of LH. Now, ever since this radioimmunoassay came to the fore, particularly from 80s, PCOD, yes, is characterized by hyperinsulinemia, at least in most of the individuals. But presence of insulin resistance necessarily is not diagnostic, because it's so common otherwise also. Now, central to polycystic ovarian disease, as I said, is hyperandrogenism. From diagnostic point of view, not hyperinsulinemia. And this barrage of androgens have been studied: dihydroepiandrosterone, dihydroepiandrosterone sulfate, androstenedione, testosterone, blah, blah, blah. But probably one of the best to look at would be a free testosterone. This data suggests, are there any racial differences? This data published about half a decade back in American Journal of Obstetrics and Gynecology between different races. Yes, it was shown that in the United States, Hispanic women with polycystic ovarian syndrome have the more severe phenotype. Maybe Tripathi would be seeing, Professor Tripathi, more of it. A lot of Hispanic, almost a Hispanic population in San Antonio, both in terms of hyperandrogenemia and metabolic criteria. Non-Hispanic Black women have an overall milder polycystic ovarian syndrome than Hispanics, and in some respects, than non-Hispanic whites. From clinical presentation, probably one of the first things that drives our attention is this patch of hair on the face. And this is a data that we published long back in Fertility and Sterility. Second commonest cause of hirsutism in that young age was polycystic ovarian syndrome. And quite few had would be characterized for idiopathic hirsutism, but PCOD was one treatable disease there. And then when a person comes out of that juvenile concern for cosmetics, fertility becomes an issue. And in this study published in Fertility, we found out that this was the most anovulation, because that time when we published the data, only NIH criteria were available and tools for making a more refined diagnosis were not there. But we've documented anovulation, and 1/3 of total infertility was associated with infertility, which was not associated with any form of ovarian failure, but LHFSH characteristics of polycystic ovarian syndrome. And when that fertility issue is settled, insulin resistance is there, gestation diabetes many times more in these women. So that issue needs to be handled with a different thought process. And once that issue is taken care of, overall, now diabetes is much worse in these people. As I told you, data shows that firstly, a good chunk of them are obese. So obesity-related insulin resistance, there are a lot of studies have shown creating an equipoise in body weight or body mass index. Women with polycystic ovarian syndrome have a much worse insulin resistance than women who do not have a polycystic ovarian syndrome, but have a similar body profile in terms of waist-hip ratio and body mass index. And there's almost 40% people will be developing diabetes by 40th birthday. Now, this is a data that, again, sort of concerns me in my own country, that now this epidemic, this is a paper that our group published in Nature, and a year before this COVID epidemic, we showed that now urban and semi-urban areas are saturated with obesity. Whoever has to get obese is already obese. Now the juggernaut is moving to the rural area. McDonald's is moving to rural area. KFC is moving to rural area. Biryani is moving to rural area. And now that will in future drive the obesity. And now when that happens in India, because still most of the India is rural, we will have a much worse problem at our hand than we have been seeing for the last couple of decades. And not only that, now it's not the only consequence that we look at it from annihilation, we look at from diabetes, fertility, gestation diabetes, permanent diabetes, the associated epidemic of coronary arteries in the country, which has doubled up in the last 2 decades. Consequence of the same metabolic disorder, dyslipidemia, hypertension, and diabetes. So, in conclusion, if you look at this polycystic ovarian syndrome, it is an insulin-resistant syndrome that is characterized by hyperandrogenemia, but simultaneously also has significant components of metabolic dysfunction. It might incidentally be associated with reproductive dysfunction, but also has dyslipidemia when their body mass starts increasing. In those youngsters, you certainly find out a TG of 250 at 15, 16 years and 18, 350, at 21, 400. And we have seen it, and I'm sure many of you have observed it in the hypertension very early. Now, gone are the days when you say essential hypertension beyond 30, almost starts occurring a decade or a half decade earlier. Central adiposity has become so common. It was already in the Western world assuming huge proportions, but is now assuming big proportions in our country also. So in totality, if you look at the total lifespan of a patient with the polycystic ovarian syndrome or tendency, right from the beginning, youngsters, in that 6th, 7th class menstrual irregularities, and then that thatch of hair on the face, predominantly, looking at dermatological, that cosmetic, and then those menstrual irregularities and going from gynecologist to gynecologist, getting different hormones, and then someday getting to an endocrinologist, and then certainly, some form of dyslipidemia or dysglycemia. And then the consequences as the age goes by, decade by decade. Huge problem. In conclusion, I must tell you, emerging problem. But unfortunately, when we have the time to reverse or control or treat many of these components, most of us lose these components because we spend a decade on that hair growth and electrolysis. We spend another decade only on that annihilation and proper menstrual cycles, but never give a consolidated concept either to ourselves or to our colleagues, and more importantly, to our patients. Thank you so much.
It has been excellent, Dr. Jargar. I know you have developed this story beautifully. And your storytelling style is always unique and given a wealth of data and also given a lot of original data. Now, in interest of time, we'll just stop here and we'll have the panel discussion. Professor Rakesh is getting some clinical questions for you. He told me just now. And at this moment, on my own behalf, on behalf of Dr. Kalpana Das, it's my great pleasure and honor to invite Professor Dr. Nikhil Tandon, the Professor and Head of Endocrinology, Metabolism, Diabetes at the AIIMS Delhi, to deliberate on a very important issue. GDM, the long-term outcome. Dear friends, Nikhil does not need any introduction. I'll just say that he's one of the person I adore. His tenacity of purpose, academics, research, patient care, OPD care, patient care is something great. And he has been involved in the NCDs for a very long time in his own department, in the clinics, in the outreach programs, also in the ministry and the PHFI and ICMR. He has more than 500 publications and has been cited more than 40,000 times. I'm telling this, Nikhil, just to inspire a lot of young audiences there. The H index is about 65. And I will not go further. He has been decorated as with Padam Shri and many other honors, and he has been the fellow of the Academy of Medical Science, FAMS. He has been the fellow of the Indian Academy of Science, which is great, and National Academy of Science, and the BC Roy Award winner and the Padam Shri decorated. Dear friends, I present you Dr. Nikhil Tandon to speak to us regarding the GDM, its long-term outcome. Nikhil, all is yours. Can we have the presentation?
Greetings from a freezing Delhi, and let me first start by thanking the organizers, especially my very old friend, Dr. Alok Kanungo, for having invited me for this year's meeting and to make a presentation on gestational diabetes, post-delivery outcomes.
Please mute yourself, except the speaker. Others, please be.
The plan of my presentation today will be talking briefly about postpartum hyperglycemia, conversion to diabetes, depending on how the GDM was diagnosed, whether we use Carpenter-Couston criteria or the IAD-PSG criteria, and then taking you directly to results from our study called Living, in which we looked at a sort of a real-life implementation of a lifestyle intervention to see if we can retard or prevent this progression to type 2 diabetes. Now, the audience would be very familiar with the fact that the overall risk for type 2 diabetes is about 10 times higher in women with previous gestational diabetes as compared to healthy controls. And this is a systematic review which was published a couple of years ago. These are data from a multi-ethnic study done in Canada, and you can see that the conversion of GDM to postpartum diabetes was compared between South Asians, Chinese, and whites. And not only was the prevalence of GDM higher in South Asians, the likelihood of progressing to type 2 diabetes was also the highest among South Asians when compared to the other ethnic groups. What about data from India? Now, these are data in which the Carpenter-Couston criteria was used. The first couple of studies, one from Dr. Kale and colleagues in Pune, showed that over a mean postpartum follow-up of about 4.5 years, 50% of the women who had GDM had moved on to develop diabetes. And a smaller study from Mysore, again showing that a 5-year period, about 1 in 3 of these women moved on to diabetes. We went on to do a similar study in which we evaluated the conversion of GDM to future A1C and the predictive value of HbA1c in an Indian cohort. This was published in 2016, and we'd use the Carpenter-Couston criteria to diagnose GDM. And the data from this study is the largest study done in India from this on just more than 350 people. At a median follow-up of 1.6 years, 1 in 3 had already progressed to diabetes. And in the group which had been followed up between 2 and 4 years, 50% had already gone on to develop diabetes. So again, showing that this is an extremely high risk group for disease progression. This is, again, to give you a sense that if you looked at these 366 women, at the end of the follow-up period, 32% had diabetes and another 40% had pre-diabetes. So actually only 1 in 4 women stayed in normal glucose tolerance if they had GDM when it was diagnosed using the Carpenter-Couston criteria. I've already mentioned to you that about 50% had diabetes after 2 to 4 years. And compared to an age-matched general population, these were data taken from the INDIAP study. If you had a woman between 20 and 29 years of age, there was an 18-fold excess risk. And when it was between 30 and 39 years, there was nearly a 10-fold excess risk. So clearly, this is a category of individuals who nearly need to be looked after. So a summary of this part, these were the highest reports ever reported in literature. Postpartum screening rates, unfortunately, were about 35%, suggesting that not all the women turn up for postpartum evaluation. Overweight and obesity became a significant part. If you compare the pre-pregnancy BMIs to the postpartum BMIs, there was a change of 4 kilograms per square meter at this point in time. And therefore, given the early conversion, any efforts to reduce development diabetes should become early. Subsequent to this study, the criteria all over the world started changing to IAD-PSG. In our cohort, when we use the Carpenter and Couston criteria, 70% of women were on insulin, whereas in the IAD-PSG diagnosed women, especially when you remove overt diabetes, only 20 or 30% women require insulin. So there were a handful of studies again done from India using the IAD-PSG criteria, and again showed one thing, that now, because you possibly ended up having a milder cohort of individuals, the diabetes conversion rates at a short term were lower, though dysglycemia rates were again between 20 and 30%. And except for one study from Chennai, which went up to 1 year, the rest of them were really very short duration studies. So this was another piece of work which we did, and it was long term, which is more than 1 year postpartum glucose tolerance status amongst women who'd been diagnosed with GDM using the IID-PSG criteria. And you can see the difference out here. As opposed to about 28% women who were normal glycemic, this number increased to about 42%. Diabetes, which is about 32%, came down to 10%, but pre-diabetes was 47%. So overall dysglycemia was about 60%, despite identifying a cohort of women which perhaps had less severe disease than those identified by the Carpenter-Couston criteria, because with IID-PSG, anybody with a fasting more than 126 and a post-load of more than 200 would be called overt diabetes and not called gestational diabetes. And again, the not surprising predictors of dysglycemia were insulin or oral agent use during pregnancy, first-degree relative having diabetes. The older the person, the longer the duration since the index delivery, the heavier the individual, and features of insulin resistance. Now, the important thing to understand is compared to the HARPO study, which led to the creation of the IID-PSG criteria, our women were younger, and the median follow-up was much, much less, despite which the diabetes rates were very similar, suggesting that if we had longer follow-ups, I mean, this was 11 years from the HARPO study compared to under 2 years in our study, the conversion rate would be even higher. So we went on to evaluate the way we could try and prevent this progression by looking at a lifestyle intervention. I will not go into the details of the pilot study which we did, which was looking at the feasibility of this lifestyle intervention, which encouraged us to proceed. This is a protocol from the study, which was published in Diabetic Medicine, and the study was funded by the Global Alliance for Chronic Disease, a combination in our instance of the ICMR and the NHMRC Australia. So this is really the design of the study. It was an open label, parallel group, pragmatic, individually randomized controlled trial with a blinded endpoint adjudication. It was a very low intensity lifestyle modification program because we wanted to see whether such a low touch intervention, which could be easily adaptable to routine care, especially in low resource settings, would make a difference. We calculated that about 1,400 women would be required. We looked at 19 hospitals across 3 South Asian countries. And the primary outcome was a proportion of women with a change of glycemic category. That is, from normal glucose tolerance to either prediabetes or diabetes, and normal and prediabetes to diabetes. Secondary outcomes were changes in body weight, waist circumference, blood pressure, fasting glucose, physical activity level, and diet. And the inclusion criteria were very straightforward. Anybody who did not have diabetes between 3 and 18 months in their postpartum GTT after having been diagnosed as GDM during pregnancy using the IID-PSG criteria were invited to participate. Anybody who had diabetes was clearly out. Anybody who lived far from the hospital, did not have a mobile telephone, and was likely to move residence in the next 3 years because we wanted a follow-up, were not included in the study. Now, this is the flow. Women were identified between 24 and 34 weeks of gestation, nearly 3,500 women, which is a large study. Eventually, only half of them, a little bit more than half of them, ended up coming for the postpartum GTT, which was 3 to 18 months later, again suggesting that there is a significant drop-off despite the fact that we had contacted these women during pregnancy and they had agreed that they will come back to us during the postpartum period. This then led to certain conditions which caused us to exclude them, and then they were randomized to intervention and control arm, 6 monthly follow-ups using a 75-gram GTT at the end of the study to categorize individual. We'd planned on 1,400 people, eventually ended up doing 1,600, which is the largest ever study done anywhere in the world. 70% of our patients came from public hospital, and the follow-up ranged from 1 to 3 years. So this was the intervention, very simple, very marginal, and very light touch. Group sessions, the 4 group sessions, initially at 3 weekly intervals, so first, second, and third were done by 6 weeks. This was then supplemented by 2 SMSs, either text or voice, depending on the preference of the participant, every week to reinforce the intervention, and a monthly phone call from the care coordinators, and a 4th session at 26 weeks. At the end of 6 months, we would then take a decision based on weight change, whether or not the trajectory we expected was being followed. And if it was not being followed, that is, if there had been no weight loss or there was weight gain, Those individuals were then converted into intensification category, in which 2 more individual sessions were done, while for the remainder you continued with the 2 SMSs or voice messages and the monthly phone call. So this entire intervention lasted for 1 year, and the follow-up continued thereafter. So these are the baseline characteristics, and I just wanted to point out here that they were very well matched in terms of gravida, time since delivery, the prior history of GDM, insulin use, family history of diabetes, their BMIs, the waist circumferences, the hemoglobin A1C, the fasting glucose, and their glycemic status. As I mentioned, by the time they underwent the postpartum OGTT, and 9% of women already had diabetes, again suggesting this is a very rapid conversion happening, and therefore all interventions should really happen soon. 37% were pre-diabetes and 62% had normal glucose tolerance. The other thing which is important to understand is, despite this being from South Asia and 70% of the population coming from public hospitals, 40% of women were overweight and 23% were obese. So 2 out of every 3 women was either overweight or obese. That's a very important finding. The results, unfortunately, were not encouraging. 1,308 participants, 81% had an end of study visit. And if you included women in whom we had an A1C on follow-up, that became 90%. Remember, this study was done right during the COVID epidemic, which led to problems. A lot of the sessions which were supposed to be face-to-face could not be done face-to-face, and we had to convert that into video sessions. And also the ability of the participants to participate in lifestyle modification, including physical activity, was significantly impacted, as was our ability to actually, monitor things as much as we'd done. So worsening of glycemic status happened in about 25% in the lifestyle intervention group and 27% in the usual care group. There was a trend towards benefit in the intervention arm, but this clearly did not meet statistical significance. So if you see the error, the confidence intervals, you'll see that they were clearly shifted towards a trend towards benefit. Pre-diabetes at baseline led to a 20% of them developing type 2 diabetes during the short follow-up period, suggesting that if in the postpartum GTT you have pre-diabetes, this would be an even more important subgroup to follow. This is again showing the same thing on a Kaplan-Meier plot, and you can see that there is no significant difference. And there was a significant follow-up, which is available till about 18 months after the study was initiated. So this and the secondary outcomes, whether it was development of diabetes, change in fasting glucose, change in body weight, waist circumference, blood pressure, etc., were again not different. So overall, there were trends towards benefit, but there was no clear benefit. So a summary of this: 1,600 women randomized to either usual care or lifestyle intervention. There was no significant difference in the proportion of study participants with change in glycemic category, though we are encouraged to see the direction in which this response was happening. And we look forward to be able to strengthen this, but we feel that there may be a reason or requirement to add oral agents in this form. So let me just wind up and say that the strength was this is the largest study ever conducted globally, very broad inclusion and limited exclusion criteria, which mirrors real life. So it was replicable in the real life, extremely difficult study design and recruitment. And then unfortunately, like many things which happened in the last 2 years, the COVID-19 impacted. So let me conclude by saying, number one, that the risk of type 2 diabetes in women with prior GDM is nearly 10 times higher compared to healthy controls, even in our population. Very high conversion rates in Indian women, and that's happening even extremely soon after delivery. So any intervention, if you plan, must start very soon after delivery. There are multiple cardiometabolic abnormalities which are coexisting in this population, which I did not talk about. We need an intervention strategy to prevent or delay this. A light touch intervention alone may not be adequate. We may need to think of involving the family as a unit, so that it's not just the woman who's participating in the intervention, but the entire family, and or use preventive drug therapies to facilitate that. let me thank you. But before I do that, I'd like to put on record that this work was done in collaboration with several people. For the interest of time, I've not been able to name all my collaborators, both within the department, within AIIMS, but outside the department, and a whole bunch of principal investigators across 19 trial sites across 3 countries and members of the steering committee. Thank you so much, and I'll stop here.
I think, Nikhil, it was fabulous, excellent. So much of original data and so beautifully presented. I think it's the only study which has such a large number of GDM mothers being followed up, and I have no time to put my words properly, but I must tell you that it has given a wealth of data to the country. Nikhil, I agree with you. GDM is a pre-diabetic condition, and GDM, Government of India has approved a DCGI. Both of us are there in the member. We have approved use of metformin that we'll discuss in the detailed panel discussion. But Nikhil, on behalf of all of us, I congratulate you for an wonderful study and giving us a wealth of data on a topic which we do not have any data. Thank you very much. Over to Professor Rakesh Nayak to carry forward the panel discussion. We have about 20 minutes time.
Yeah, thank you, sir. Thank you, sir. I think you have put it very rightly that we had a very excellent session by 3 illustrious speakers. I think all of them did an excellent job. And I would like to take up a few questions to each of them. Very clinically relevant questions I would like to ask them. So I think the first talk by Dr. Devji, actually, he showed us that tirzepatide is actually becoming a blockbuster molecule in the US. From what I hear from many of my friends and others there, is that it's likely to become a blockbuster molecule. And he has also highlighted the fact that in the coming years, I think the molecules are going to be the polyagonists are going to be the molecules of future. So I think, but I would like to ask him couple of quick questions. One is that, you spoke about tirzepatide itself. I would like to know about, when you look at GLP-1 agonists, we are a little worried about using it in people with pancreatitis and previous history of pancreatitis, and although it has not been shown to be directly causing this, but what is the status with these polyagonists? Particularly tirzepatide and the other agonists that we're going to see in the future?
So, answering the question, so that is a relative contraindication patient with prior history of pancreatitis, because GLP and GIP receptor are present in the pancreatic duct. So there is a dose-dependent increase in amylase lipase. If you see, because part of the research trial, we see that there is rise in lipase and pancreatic amylase. But I have not seen any. So far, the data has not shown that this drug causes increase the risk of pancreatitis, but it's safer not to prescribe these drugs in patients with prior history of pancreatitis.
Yeah, another clinical paradox that we commonly see is you spoke about the glucagon agonists being used along with the GLP agonism to sort of get greater benefits. But glucagon, if you look at it, we are using it for management of hypoglycemia. So, how do you explain this paradox? Because the current use of glucagon is mainly for management of hypoglycemia.
Yeah, so actually I showed in my slide. So there's both glucagon agonists and antagonists are being developed for treatment of diabetes. As I told you, we did a trial in glucagon antagonists that improved glycemic control, but had a hepatotoxicity. That's why it is withdrawn. But the glucagon activity of this agonist that I showed, triple agonist, there's primarily actually, if you do in vitro study, that is 9 times more potent than the native GIP. So it's more like GIP. Is 3-4 less potent than glucagon and GLP-1. So although it has a glucagon-like activity, it's very mild activity. And that is the hyperglycemic effect of glucagon is counteracted by the GLP and GIP. So you see the beneficial effect of glucagon, that is the weight loss, energy expenditure, and effect on fat oxidation, and increase appetite satiety, or decrease appetite, increase satiety. So those are, and if you combine the glucagon are also receptors on the hypothalamus. So that's the rationale for combining glucagon with, you cannot give glucagon alone. Like if you give the glucagon dose that we use for treatment hypoglycemia much higher. If you give glucagon alone, of course, you'll see hypoglycemia. But if low dose glucagon combined with GLP and GIP, it may potentially, because glucagon is also insulin secretagogue. That's why glucagon is not used for treatment hypoglycemia and type 2 diabetes, because it can increase insulin secretion too. So that's the rationale for insulin secretion and effect on weight loss and energy expenditure. That's why I combined with glucagon with GLP and GIP.
Rakesh, can I have one question?
Yeah.
Rakesh,
Yes,
I ask you, Devjit, wonderful presentation, and you made clear many doubts. This drug is supposed to come to India. It will take 2 years, I'm told. Now, we have only 2 drugs. We have Rybelsus oral semaglutide 3714, and we don't have even 1 milligram for diabetes treatment. We will be getting 2.4 sema next year, sometime March, April, we are supposed to get it. So any comparison has been done. I saw the comparison 15 milligram of this dual agonist with 1 milligram injectable that we have. We're having in USA that. So any comparison to oral sema or to 2.4 injectable sema weekly?
Right now, there's no data available on comparison to 2.4 milligram sema or with oral semaglutide. But with 1 milligram, this drug appears superior. But with 2.4 milligram, based on the data that is available, it can lead to weight loss of 15% for 2.4 milligram. And the highest dose of tirzepatide will also lead to weight loss of about 15 to 20%, 15% in diabetes. So I would say it's comparable, but I think the glycemic effect on A1C, the tirzepatide appears to be more potent. And there's no data yet compared between oral semaglutide versus tirzepatide. And
Yeah, your one quick question about your thoughts about the effects of FGF21 and amylin agonists. Are they also going to be added to these?
Yeah, actually, Novo actually has a compound. We'll be doing a trial on that. They added as amylin derivative, lauric acid, and something combined with semaglutide. Novo has a drug which is amylin combined with sema. So that's being studied now. And FGF21 is used mainly, having looked at mainly for liver NASH and not for diabetes. So I don't think there's any trials going on for FGF21 diabetes, but mainly for NASH.
Thank you, sir. Shall we move to Professor Jargar and ask him a few quick questions?
Yes. Yeah, to Dr. Jargar.
Yes. Sir, Dr. Jargar again, gave a very good story about how he has seen the evolution of PCOS over the last 4 decades and how things have been changing. And so I wanted to ask you, sir, about the metabolic effects, particularly when you've spoken about PCOS having very high risk of diabetes. Would you say that how do you think this diabetes in women who have had PCOS differs from? How do they differ from the women who have diabetes but did not have PCOS?
Very important question. I'll tell you, when a person develops diabetes at any age, there's a signal the fellow is not well. He needs some treatment. And as Nikhil was saying in his talk, that when from GDM you want to follow them up, that lightweight lifestyle education does not seem to work. It needs to be aggressive. It needs to be very relevant. It needs to be focused. It needs to be repetitive. Why does that need to happen? Because this gestation diabetes gives us an inkling, yes, there is something grossly wrong with the metabolic machinery of this individual, right? Because if left unattended, in another couple of years, you will have 1/4 of people who will have permanent diabetes, and at a very young age. See the consequences of that problem at the age of 30 for another 50 years. Now imagine a person at the age of 15, 16. You make a diagnosis, comes for a thatch of hair on the face, but you make a diagnosis of polycystic ovarian syndrome. And you see a triglyceride of 180, 210 at that 16 years old girl. In a similar fashion, it gives you a window of opportunity to look at this girl's health for the last 60 years, for the next 60 years. Like that GDM tells you how she's going to behave in another 50 years, 30 years, 40 years. So yes, we know that, as I was showing you the data right from 80s, insulin resistance definitely is there. But if you compare the insulin resistance between young girls with PCOD and who are otherwise normal, the insulin resistance is over and above that. not only does it prognosticate what is going to happen to their metabolic stats in terms of diabetes, but as I told you, these are the girls who in those second decade only will have a hypertriglyceridemia. Wait for another half a decade, their HDL will go down. Wait for another decade, their LDL will be going up. So their cardiovascular health has already started getting perverted. At the age of 25 to 35, they have been harboring a metabolic problem, which is liable to give them an accelerated vasculopathy, vascular disease, endothelial dysfunction. So this is an opportunity for the clinician, not just regulating a menstrual cycle, which is important at that age, not to be obsessed with that thatch of hair on the face, which is again important in those young girls to get a good image of their own self and body, but also give them a proper perspective. It is not all about just a thatch of hair on the face and menstrual irregularity. That should be focused on, but the education for a total lifestyle and possible protection of a metabolic dysfunction, if not totally averted, but at least a diabetes occurring at the age of 25 is far different than a diabetes occurring at 55. You see, I'll tell you, there's published data available today which shows that in 1980s, average diabetes in India used to occur at 48 years. And at that time, life expectancy was 55, 56 years. People used to be retired at the age of 54. Today, the same diabetes is occurring at 30 and 32. And people refuse to retire at 70. And a big chunk of people live at 85 and 90. Now, it's a great thing. But imagine living with a metabolic burden for 60 years. I'm not saying it's not worthwhile living. The amount of time spent on health, the amount of money spent on investigation, the amount of time spent with the doctors, the amount of anxiety that you see in correlation to all that. So if it can be truncated in a significant number of people, it's important. If it can be delayed, it is important and relevant. And that's what, preventive healthcare is all about. And here it gives an idea that, yes, this girl's metabolic health is not on the road. It is derailed. We need to put it on the rails. I'll tell you, Rakesh, I'm sure you'll be seeing a lot of this in Hyderabad also. Many times I tell somebody, a girl of 16 comes with a pouch, abdomen and all that, 70 kilos girl, and I tell mother, she looks a bit thickish. Nahin, doctor sahab, thoda haldi si thi, to they refuse to accept that this is a pathological process. I said, her father should be 72. She is 74. And I saw a girl the other day studying in the 11th class, 124 kilos. One afternoon in my clinic, I was stunned. I saw 8 girls, more than 90 kilos. I'm still like, what sort of a life one is living, moving from doctor to doctor. So that's why it's a window of opportunity.
Yes, sir.
Yes, Rakesh, Rakesh, what you said, it is very important. Somebody made a comment. We had a small webinar on these PCOS, Professor Jargar, and I had with me Dr. Usha Shiram and Sheila Sheikh. You remember, you know these two young.
Yeah, I know them.
So what happened? The comment were expressed, as you rightly said, the education about PCOS is very, very low. That's why you won't believe the comment was made by some other endocrinologists. You also know them. They said, sir, they all go to salons. They don't come to us at all. The awareness of PCOS in the country is very low. I think I will request you, with Rakesh's permission, to tell to the audience, thousands have logged in at this time, Dr. Jargar, to you, to listen to you, Debjit and Nikhil, just in 2 minutes about the treatment. I mean, a little bit about lifestyle. Lifestyle everybody knows, and a little bit about the metformin and the spironolactone, a little bit about the ovulation induction, and whatever you want to say. Very, very briefly about the management. They have asked it on the net. So some few lines about the management. Very simply, in a very short time.
You see, understandably, if we look at Hirschism alone, you need an anti-androgen. And we have been using it liberally. Spironolactone has been used for a long time. And many times, before we push the patient to the cosmetologist, as you very rightly said, or to the electrolysis guy or a dermatologist more often, we invariably use suboptimal dose of spironolactone. The 25 milligrams, and then calling it a day. The dose is beyond 100 milligrams if you want to give a real extensive to that 85 kilo girl androgen blockade. Metformin, a lot of controversy is there, but nobody has controversy on metformin and polycystic ovarian syndrome. But not a minuscule dose of, we get stuck up with a minuscule dose of those 500 milligram tablets. Feel liberty after 18th birthday, give a full dose of metformin. And there's something that's going to have a long-lasting effect. You might start with a good metabolic memory right from that 18th birthday. But unfortunately, many of us create timelines, particularly the parents. How long does he need? She has been taking it for such a long, for 6 months taking a tablet as if it's an antitubercular drug. Mm-hmm. So those timelines should not be given. It's a safe drug, can be given for a long time. And many times, does help anovulation, and a lot of fertility could be helped. Dysglycemia could be helped. Clomiphene citrate, if it doesn't work, that we have been routinely using for decades and decades and decades. And then, a shot of HCG to help the ovulation, somewhere in the middle of the cycle, timing it well when it's needed. And then and now, people, two things have happened to Dr. Das in the recent times. Marriages are delayed quite a bit. A person wants to do a PhD, DM, and, wants to get a good job with Nikhil Tandon, and by the time suddenly realizes he's 38. Now, nothing is happening for the next 20 years. We are panicking. Now, the way the reserve is getting lesser. So then, you then short circuiting. And straight away say, no, just find out if she still has some ova left behind before the panic sets in. She is almost in that preparatory for a perimenopausal state. And IVF have done wonderful things, and people now get pregnant at any stage in life. We see regularly. I saw the other day a lady who had got pregnant at the age of 46 and delivered a baby. Not that she was desperate for it. She had already 2 girls. She wanted a boy, and low below she got another one. And then, that progressive depending on what sort of desperation you have. Somebody make a diagnosis at 25, you don't have had pregnancy till 26, comfortably metformin, over a year or two, add on to clomiphene, and then slowly. Don't rush it through at that age. But, panic sets in beyond 35th birthday and desperation after 40th birthday.
Thank you.
Thank you, sir. Sir, I'll quickly move on to Dr. Nikhil Tandon.
Dr. Tripathi wants to make a comment.
Yeah.
Yes, so just a comment, because, it's also for Dr. Tandon. So, for both PCOS and gestational diabetes, insulin resistance plays a key role in pathogenesis, particularly PCOS. So, and the only drug that is available which targets insulin resistance is the pioglitazone. I know there's a lot of hesitancy on using. We use to liberally in the US pioglitazone, although it's not recommended by any ethical society. So I don't understand why it should not be used, particularly if the patient not expecting for a child. Like low dose pioglitazone is very safe and targets insulin resistance and will improve triglyceride, SDL, and it will not lead to much weight gain if you use 15 milligram or maximum 30 milligram. So I don't know why it's not being used. And for Dr. Rendon also, for drug intervention, I know metformin was mentioned, but I think there was a study at Tom Buchanan and UCLA. He had done studies in the gestational diabetes, triglyceridine, and then pioglitazone. So are you planning an intervention with thiazolidine?
Thank you.
Dr. Tripathi, before Nikhil responds, I did a program with DeFranco last month.
Okay.
And we knew that he has been a fan of.
Yeah, I have a bias to pioglitazone too.
Pioglitazone, he comes from an institution. And I too, I must tell you, when this pioglitazone was banned in India, I was the first person who brought it to the notice of government of India. That is a good drug. It's a poor man's drug. It should be brought back. And it was brought back in less than a month. And yes, I think, we have been using it quite a bit, right from its inception. But it became a victim of a quote unquote sponsored propaganda that it causes very aggressive bladder cancers and other things. So there was some form of a media campaign some years back. So the industry certainly went scant with the formulations that they had been promoting for a decade or decade and a half. But I think many of us have no stop. We are using it liberally, smallish doses. And yes, you are right, with some hesitancy. But it's a good molecule. It's an amazing insulin sensitizer, and I used it in many people, ladies with, one doctor's daughter, and one day we'll give her, Paglisone and metformin, and she achieved ovulation within 3 months and was pregnant in 6. So yes, we selectively use it, and when you properly inform the people that you need to be a little bit careful, but giving a drug that has a tendency to put on weight in a person who already is obese, and at that age, when you're so concerned about the figure you have, particularly if you are a Kashmiri girl who's infatuated with their looks, because a bit difficult.
I think 15 milligram will be good. It won't cause much. Because there's a trial in
We'll go to Nikhil. Nikhil.
Yeah.
So let me just respond to Devjit's comment. If you actually go back to the diabetes prevention program, there was a troglodyrazone arm.
Right.
If you actually go back and tease out the women with a prior history of gestational diabetes who were recruited as part of DPP, there were about 250 odd women. Interestingly, the number of years post the index pregnancy was about 10 or 11 years, which is, again, very, very different from what we are seeing out here. The rapidity of conversion from GDM to overt diabetes is tremendous. And this, again, became very stark when you compared women who are identified with Carpenter and Couston, where you did not segregate the so-called significant hyperglycemia. So, but even with IDPSG, when anything more than 126 fasting, anything more than 200 is no longer called GDM, it's called overt diabetes. Even in that, we're seeing very, very rapid conversion rate. So it's a slightly different and more aggressive progression, at least in South Asians. That's point number one. The second thing, which is of interest, and while I totally agree with you about the critical role of insulin resistance, is that if you compare, and I'm moving away from GDM for a very brief moment, if you look at our own cohort data in terms of incident diabetes, and you compare our data with, let's say, the PIMA data from the Gila River community, you will see that the contribution of beta cell failure is significantly more in a South Asian population compared to what was reported there. So at equivalent levels of BMI, the contribution of beta cell failure was much, much more. So it's a very interesting sort of basic observation that is not, the insulin resistance story, which has been driven predominantly through the North American data, especially through the PIMA, may be only giving a part of the story in a South Asian context. I'm not saying insulin resistance is not important. Clearly, it is important. But I think the rate at which we seem to decline in beta cell function seems to be very, very different. So coming back to your question and sort of giving you a general response first, the way the study was conducted, Rakesh has been, a partner in crime, so to say. He was a very critical site for us during living, and he'll tell you all the difficulties we faced. But the important point was that this was supposed to be an implementation science study. So we had to do an intervention which could be then taken up by a health system and not do a DPP style intervention in which, you threw the kitchen sink at everybody. And that was the reason why we looked at a light touch. And unfortunately, it didn't work. We are planning on a pharmacological intervention. We're looking at that option. Metformin will remain one because metformin was part of DPP. But we're also concurrently looking at other agents, not necessarily insulin sensitizers. And I won't say more to that at this point in time because that's, still very active discussions going on there. The point is that, unfortunately, unlike 40-year-old pre-diabetics who are obese, 28-year-old previous GDMs are not terribly enthusiastic about taking any medication.
It's true.
Because telling somebody who has no overt problem, and in a parallel to what Dr. Zargar said, people are more concerned of what is afflicting them today and are not really interested in thinking about what may happen 5 or 10 years down the line. They're concerned about what's happening today. So it's going to be a challenge. We're looking at all of those things, but that is in response to what you said. And very quickly, I think all of us use pioglitazone. The only thing what has happened is possibly gone down. Instead of maybe a third line after, when we were a resident with us, thiazolidinase was possibly third line. SUs and metformin were first or second and first, and then pio. I think pio, with the appearance of DPP4 and SGLT2, has possibly slipped to fifth line for many of our practice, and that's the reality. There's with the buzz around, and I think most of us have also capped it at 15. I don't think many of us go up to 30 anymore because of concerns of weight. Slightly different from a North American population where, we're not so big to start with. So even a small amount of fluid retention actually translates into a more significant percentage body weight increase than it would in 100 kilograms, big North American person. So there's my sort of general personal perspective on this.
Thank you.
With you, Rakesh and Dr. Das.
Yeah, thank you, sir. Thank you, sir, for the excellent and well-planned study which spanned across 3 nations. And I would like to ask you from this, what are your takes on, what could be the factors? What are the factors? You rightly highlighted the weight as the important factor. And because in the study also you looked at those who lost weight versus those who did not lose weight. Could you tell us a few more factors which are important in saying that these are the women who are going to develop diabetes?
Yeah, so I think the first thing is just to put slightly a bit more perspective, the study included any woman who had GDM, and when they were studied after delivery had either normal glucose tolerance or pre-diabetes. Very clearly, those who had pre-diabetes had a significantly higher incidence. And so if I was saying when there are limited resources and you have to focus on somebody, number one, I would ensure that more and more women go into a post-delivery GTT. In real life, it's possibly happening to 10 or 15% or 20%. We're missing that out altogether. Then I would focus on women who have either impaired fasting glucose or impaired glucose tolerance, and devote my energies there. The NGT women also progress, but you can wait for them a little bit. But the pre-diabetes conversion rate is tremendous. It's a 20% over 16 or 18 months, which is an extremely high incident rate for diabetes. And as Dr. Zargar mentioned, listen, the average age of the women who were participating in this study was 28 or 29, right? And if you compare prevalence of diabetes in this population compared to, let's say, INDIAB data, it's about 9-fold higher. That is just a lot. The second thing is, of course, it depended on age. So the older the woman, the duration since their delivery. So, if you recruited somebody later after the delivery, they were much more likely to have progress, which is easy to understand. And obviously, the more severe the hyperglycemia was, anybody who required pharmacological therapy, whether oral or insulin, were much, much more likely to have progressed towards diabetes later. And of course, family history of diabetes comes into play. So I think it's sort of very logical and easy to understand risk factors which are explaining the progression out here.
Great, and a great answer. I just want one question to ask Nikhil. I don't know, we had proposed that to this follow-up of the pregnant mothers to do immediately. Maybe there are some studies that do immediately after second day of delivery, and that matches to 6 weeks later. We had also suggested to twin it with their children, with their born children vaccination. Is that happening? We had suggested in the ministry.
So I'll tell you what really happens is, the way I look at it, the first 6 months after delivery are really the toughest time, right? So even if, and I'm sorry, this is a personal view and it's a pragmatic view, even if you get the information that they have abnormal glucose status, it is very difficult for the woman to start doing anything that you want them to do, right? At least in North India, there will be 500 older generation women in the family who'll say, ye nahi karo, laddu khilao, ye karo, wo karo. They will not be able to step out of the house for 40 days. Exercise, forget about it. They're not even getting sleep. So the way I look at it from a practical point of view, what you said, sir, is scientifically very appropriate. From a practical point of view, I would say, even if you manage to delay the GTT for 3, 4, 6 months, it's all right. Because before that, even if you have an abnormal test, the likelihood of them following your advice is remote. The vaccination part, sir, is again, I think we also thought exactly the same way that it should be done. The problem there is that very often women may go to a hospital for their delivery, but may go to a local pediatrician who's in the neighborhood for the vaccination. So it's not always possible for that person to arrange for the GTT. But if the health system takes over the responsibility, which means unfortunately only 30% or 25% of the population goes to a government health system, you may be able to devise a post-pregnancy sort of service. But at the moment, it really hasn't taken up. Sir.
But on behalf of all of us, we congratulate you. Whatever you have done is revealing. I had seen the original Nobel Frankel's paper when he said the ideal ground for the experimentation of that. No, the numbers you have is really, you have 3,400, you have got 1,800 out of them. Great. I think, Rakesh, any other question you have? Otherwise, we'll close the session.
I think we'll close the session, sir, in interest of time. Thank you.
Pleasure. It is one of the, why I said heavyweight. It's not weight is heavy, but the intellectual discourse that we had today, this session, to my mind, was one of the greatest sessions. I have no time, but I must tell you that, Devjit, thank you very much. Thank you very, very much.
Thank you, President. Pleasure. Okay.
Abdul, you are my friend. I don't know what to tell you. But, your presentation style, the storytelling, and the original data was great, as usual.
Thank you. Thank you so much.
For you, I'll keep silent because I have no words put on record. My deepest appreciation, not only here, we meet very often. What all you were doing. The other day he presented density control, generation. So I'll remain quiet here because I think the other session. But Nikhil, my sincere appreciation. My words fail to express my feelings and the gratitude. Dear friends, thank you very much. Big hand.
Thank you. Thank you.
Your friends.
I just want to thank Devjit for accepting our invitation, Abdul Bhai for doing the job so nicely, and Nikhil, my friend, for taking all the trouble and presenting. And this and Rakesh for wonderful conduction. But one thing is coming to my mind. NUCD should have 2, 3, 4 sessions like this, and every session should be 4 hours, 3 hours like that. And what a wonderful exchange of knowledge.
We've got the recording, subject to their or whatever the edit, we can, I would like
panel discussions are really the best part of the session. So thank you everybody, Ashok Bhai, to you for untiring effort. Thank you.
Thank you.
Thank you so much.
We have the last session of the day. And happy Bihu to Arundhati. Arundhati, can I see you? The Queen of Assam. Arundhati, you were there. I saw you.
Yes, sir. I'm there, sir.
Yeah. Happy Bihu and happy welcome. Dr. Mandal sir, very sincere regards and greetings and happy Bihu. And Abhay has arrived. Abhay came a little late from Bombay. Greetings to Abhay. And I have great pleasure. It is independent lectures on very important aspects, preventing the severe complications in type 2 diabetes, role of DPP4 plus SGLT2 inhibitor, translating science into practice, the clinical perspective of Gen 2.0 basal analogs, and third one is the best optimization, moving towards a patient-centric approach. I hand over the session to Professor P.C. Das and Dr. Philip Rautrai. I'm sorry for the late, but sir, it was beyond our control. Purno, my sincere apologies, but it was a great session. Over to you, Dr. P.C. Das and Philip. Dr. P.C. Das to take over, please.
Thank you, sir. Thank you for your kind words. And yeah, as you have already told, this is the last session. I am having sore throat, sir. Sorry. So, we are already 1.5 hours late. So, without delay, let us start with this session. And to all of you, hello. Am I audible, sir?
Yes.
Hello.
Yes. Yes.
Hello. Now, as we have already discussed you will know this is a very complex disease leading to different complications, and there are different modes of drugs which act in different action, and there are different combinations, lot of permutation and combination we have tried and we are practicing in our practice. And these two novel drugs like DPP4 inhibitor and SGLT2 inhibitor, these have recently developed for last decades, and they have wonderful molecules and having a lot of benefits. But combining these two, how far it is beneficial for preventing the CV complications? Let's listen from our speaker, Dr. P.S. Mandal. Over to Dr. P.S. Mandal.
Thank you, Dr. Das, for your kind introduction. And at first, I want to express my thanks to Dr. Kanungo for inviting me and giving me this opportunity to talk in this prestigious program. And now, all of you, can you see my slides? Yes, my slides are visible.
Yeah, it is visible. Yes.
Yeah. Okay. Now, all of you.
On this introduction slide, Purno.
Sir?
The introduction slide.
Slides is not visible. It's only the presenting slides are visible.
Okay, ठीक है. Please continue, Dr. Professor.
Okay. Yeah. So we understand the global burden of type 2 diabetes. At this point of time, nearly 8 crore type 2 diabetic persons are living in India. The important thing is that type 2 diabetes is associated with cardiovascular event. There is increased risk for cardiovascular event, increased risk for cardiovascular death and all-cause mortality. Not only that, this heart failure is a very serious complication of type 2 diabetes. And large number of our type 2 diabetic patients, nearly 50% of our type 2 diabetics, they also suffer from kidney disease. And when any type 2 diabetic patient suffers from kidney disease, they are at increased risk for cardiovascular event, all-cause mortality, and also heart failure. So we want to prevent this cardiovascular event and cardiovascular death. So when you talk about the diabetes care, we want to prevent the complication made with the microvascular complications. No, there is a clear good relation of these microvascular complications with good glycemic control. But if you want to reduce the cardiovascular event, then we need to address cardiovascular risk factors as well. So diabetes care means the prevention of complication and also to optimize the quality of life and also we want to improve the lifespan by reducing diabetes-related complications. Now, this is the joint position statement by ESD and the American Diabetic Association. All of you have seen this thing. When you talk about the diabetes management, that means that we need to be more aggressive about this glycemic control. If we can achieve good glycemic control from the very early part of the disease, and if we can maintain this good glycemic control throughout the disease process, then definitely we can prevent diabetes-related complications, mainly microvascular complications and also to some extent macrovascular complications. So if you look at this new guideline that emphasizes more on this aggressive management of this glycemic, we need to use more efficacious glucose lowering drugs, GLP-1 receptors, agonists, metformin, and combination of glucose lowering drugs, insulin, and a combination of GLP-1 with insulin. And few minutes ago, you have heard about this dual receptor agonist, the GLP-1 and GIP. So we need to use those agents more and more so that we can achieve good glycemic control. So there is a role of combination therapy like this DPP4 and SGLT2. That will be helpful to achieve good glycemic control faster, and we can achieve better control. That would be durable. And we also need to reduce the cardio-renal burden. We need to protect our patient from cardiac and also renal events. And we need to pay more importance to weight reduction when someone can reduce the body weight. And we have heard lots of things from our previous session. And that's what is the importance of reducing body weight. If someone can reduce the body weight, that will be helpful in achieving good glycemic control, and that will also reduce the cardiovascular risk factor. Diabetes is often associated with cardiovascular risk factors like hypertension, dyslipidemia, and smoking, and there are other cardiovascular risk factors like albuminuria and chronic kidney disease. Now, we need to address these cardiovascular risk factors too if we want to prevent cardiovascular events. Now, regarding these cardiovascular risk factors, there are huge evidence that if you can address these cardiovascular risk factors, then we can reduce the burden of cardiovascular events, and we can reduce this cardiovascular burden if we simultaneously address these cardiovascular risk factors, and that will be a great achievement for our type 2 diabetic patients. Again, I'm telling you that when any type 2 diabetic patients suffer from kidney disease, there is increased risk for heart failure and cardiovascular disease. So yeah, I have seen this slide several times, that the dominance of it. And the multiple pathophysiological factors are responsible for type 2 diabetes. So if we use more than one agent, that will address more than one pathophysiological factors, and we can reach the target HbA1c goal sooner, and that would be better. So in the market, in India market, there are the many combination of glucose lowering, the fixed dose combination. Definitely those are very much helpful in terms of compliance and adherence, and also in terms of cost. But I'm going to talk on this DPP-4 inhibitor and SGLT2 inhibitor combination. The interesting thing is that there is no metformin in this combination. So I would prefer always that the use of this combination, DPP-4 inhibitor and SGLT2 inhibitors along with metformin, unless there is contraindication of using metformin, or unless the patient is intolerant to metformin. Now, what are the benefits? Definitely, if you use these two molecules at the same time, then there will be the better improvement of the glycemic control. Let's see, all of you know the SGLT2 inhibitors, they induce the glycosuria, there will be the loss of body weight and loss of systolic blood pressure, and with the reduction of the body weight, that will be improvement of the insulin resistance, and also we know that when there is a loss of body weight, that actually improves the sensitivity of the beta cells. But important thing is that with the use of the SGLT2 inhibitor, what we found that there is an increased secretion of glucagon. And if you use the DPP-4 inhibitor itself is not the very potent glucose lowering agent, but DPP-4 inhibitor increases this endogenous GLP-1 level that actually stimulates the beta cell to secrete insulin and suppresses the glucagon. This is the important thing. If you use these two, then this effect, the increased glucagon by SGLT2, will be mitigated by this lowering of the glucagon by DPP-4. And SGLT2 inhibitor reduces the body weight, whereas the DPP-4 is very much weight neutral. And DPP-4 inhibitors, when we talk about the DPP-4 inhibitors, the tolerability is very, very good. They are very much well tolerated. That's the very good thing at the DPP-4 inhibitor. Now, as I mentioned, that type 2 diabetes is associated with increased risk for cardiovascular disease. There is increased risk for atherosclerotic cardiovascular disease. There is the coronary heart disease, the cerebrovascular disease, and peripheral artery disease. The atherosclerotic process in diabetes is very much virulent, accelerated, and very much diffuse. And all of us know that almost 2/3 of type 2 diabetic patients, they die from the cardiovascular event. So we need to reduce this cardiovascular event in our type 2 diabetic patients. The important thing is that type 1 and type 2 diabetes both are the risk factor for heart failure. We learned this fact nearly 50 years ago after the Framingham study, Framingham heart study, which showed that there's a very strong relation with between this diabetes to the heart failure. There's increased risk of heart failure by 2 to 5 folds in men and women respectively. Now, this is the one study from Denmark, and which included that of nearly 150,000 newly diagnosed type 2 diabetic patients. And they looked at the effect of this development of the heart failure on the mortality compared to other cardiovascular disease like ischemic heart disease, peripheral artery disease, and stroke, and also the chronic kidney disease. But they found that with the development of heart failure, there was the increased risk for death, maybe relative or absolute risk of death increased, and that decrease the lifespan. And I want to tell you that diabetes itself is the worst prognostic factor for heart failure, and this large number of these heart failure patients, they die suddenly, and all of you know that type 2 diabetes is associated, or the heart in a subject who suffers from diabetes and heart failure, there is increased risk for readmission in hospital for heart failure. Heart failure, yes, we know that type 2 diabetes is associated with heart failure that may be again heart failure with preserved ejection fraction or the reduced ejection fraction. And nearly 50% of type 2 diabetic patients with heart failure, they suffer from heart failure with preserved ejection fraction. And many of these heart failure with preserved ejection fraction may have underlying hypertension. But here I want to mention both of these heart failure with preserved ejection fraction and reduced ejection fraction may be associated with underlying atherosclerotic cardiovascular disease. But definitely, myocardial infarction is the risk factor for heart failure with reduced ejection fraction. And many times we find that without this hypertension or underlying coronary artery disease, patients may have a heart failure. And this is mainly due to the microvascular disease and what we call diabetes cardiomyopathy. There are many factors which are responsible for this development of heart failure in these patients, and these are the increased oxidative stress, chronic inflammation, and the impairment of insulin signaling pathway, and also the formation of advanced glycation end product, and also impairment of the mitochondrial function, glucotoxicity, lipotoxicity, impairment of these cardioprotective and cardio-reparative process. So these are responsible for the heart failure in type 2 diabetic patients. And when you talk about this heart failure, you can see here this when the subject suffers from the heart failure, this glycemic control is also deteriorates due to several factors, due to the increased sympathetic activity and secretion of more cytokines, sedentary lifestyle, and due to few drugs like diuretics. And we can see here that type 2 diabetes and 40% of type 2 diabetes and diabetic patients, they suffer from some degree of kidney disease. From India, we have data that 50% nearly suffer from chronic diabetic kidney disease, maybe in the form of albuminuria or reduced eGFR or both. Now, why I'm talking about this kidney disease? Because there's a very common coexistence of heart failure and CKD, both in diabetic and the non-diabetic patients. And there is a very very much interaction of this heart failure with the CKD, and that is the multifactorial. And when any patient suffers from the CKD, then that actually causes the deterioration of the heart failure. Any patient who suffers from the heart failure, that causes the deterioration of chronic kidney chronic kidney disease. That means the insult of one organ may be in the renal cortex or the myocardium that actually influence the function of other organs and causes the aggravation of the disease process. When both of these heart failure and CKD exist in the same patient, there is increased risk for mortality. And if you see here that 63% of heart failure patients have renal impairment and 3 times more risk of heart failure in patients of CKD as compared to the non-CKD individuals. So with the progression of heart failure, there is the progression of the kidney disease and vice versa. When there is the progression of the kidney disease, there is the increase, there is the progression of the heart failure, the deterioration of heart failure, I must say, and that can cause death. And there is a clear-cut evidence that any molecule which improves the heart failure will also improve the renal outcome. Any molecule which improves the renal disease progression, that will also will have beneficial effect on the heart failure. Now, there is a recent publication, this recent meta-analysis, which showed the SGLT2 inhibitors reduce the heart failure hospitalization, all-cause mortality, and all-cause and the CV mortality in patients with or without atherosclerotic cardiovascular disease. So this is the joint position statement for management of hyperglycemia. So here's the clear-cut mention about this risk reduction for the cardiorenal disease. And if someone has the underlying atherosclerotic cardiovascular disease or risk factor for the cardiovascular disease, then we need to prescribe SGLT2 inhibitors or GLP-1 receptor agonists. And anyone who suffers from heart failure or documented, that has the documented heart failure with preserved ejection fraction or reduced ejection fraction, then SGLT2 inhibitors with proven benefit is the treatment of choice as the glucose lowering agent. And any patient whose eGFR is below 60 and who has the proteinuria should receive this SGLT2 inhibitor. If the SGLT2 inhibitor is the contraindicated or the patient cannot tolerate, the GLP-1 receptor agonist should be the choice, which is proved in the outcome trial to reduce the cardiovascular events. And there is also, as I mentioned, we need to be a bit more aggressive in reducing this glycemic, improving the glycemic control. And here you can see there's a strong advice regarding the weight reduction, and we need to prescribe those agents which can reduce the body weight, like the GLP-1 receptor agonists, particularly these semaglutide, or as a few minutes ago you have heard about this dual GLP-1 and GIP receptor agonists. Now, what is the role of the sodium glucose co-transporter inhibitor and the DPP4 inhibitor? So these are the outcome trials of these SGLT2 inhibitors, the empiric canvas, and you can see the declared TIMI and the credence, and this is the DAPA CKD, is the Bharti CV, and there are also here the heart failure outcome trials, the SGLT2 inhibitors. The basic thing is that all the CVOT trials with SGLT2 inhibitors clearly showed the benefit of hospitalization heart failure, and if we look at here, then we'll find this all these SGLT2 inhibitors also improve the renal outcome. And similarly, the renal outcome, this slide didn't include EMPA kidney outcome trial, but if you look at this credence and also the DAPA CKD, you will realize that all these, with the improvement of this renal outcome, there is also improvement in the cardiovascular outcome. And These SGLT2 inhibitors, empagliflozin and dapagliflozin, clearly showed their beneficial effect in both in diabetic and non-diabetic patients with preserved ejection fraction and also in the reduced ejection fraction. And when there was the, if you look at this, if you look at this this worsening nephropathy, will appreciate that with the improvement of the heart failure outcome, there is also improvement of the renal outcome. So any molecule, as I'm telling you, that any molecule which improves the heart failure outcome also have the impact on the renal outcome, and any molecule which improves the renal outcome also have the beneficial effect on the cardiovascular outcome. And SGLT2 inhibitors is one of them that improves this heart failure outcome. And when we use in the CKD patient, that also improves the progression of the renal disease and also improves the cardiovascular outcome. DELIVER and preserve, these two outcome trials included the patients with the preserved ejection fraction, and again there's a benefit in the primary outcome, which was the composite of cardiovascular death with the hospitalization for heart failure. And both of this molecule, the dapagliflozin and empagliflozin, was very much effective. And this table shows that CVOT trials, so the DPP4 inhibitors. The important thing is that DPP4 inhibitors is very much neutral with regard to the cardiovascular risk reduction. But one important thing is that in this outcome trial, the saxagliptin actually increased the risk for hospitalization of heart failure. Just a minute. Here you can see there's the increased heart failure, and also the examined trial, allogliptin also increased the risk for heart failure, but that was not statistically significant. But linagliptin, sitagliptin in their CVOT didn't show any increased risk for hospitalization for heart failure. They were very much neutral. Now, when we talk about this SGLT2 and DPP4 inhibitors combination, we also need to know about the efficacy and also the safety. This review actually included trials which compared the SGLT2 DPP4 with DPP4, SGLT DPP4 with the SGLT2 inhibitor, and also the both, and that included this 8 trials which we compared this SGLT2 inhibitor DPP4 with DPP4 inhibitor, SGLT2, and 3 trials, there's 5 trials with SGLT2 inhibitor and DPP4 inhibitors with SGLT2 inhibitors, and 3 trials compared the both. And the interesting finding was that SGLT2 inhibitor with DPP4 inhibitor, this combination reduced the HbA1c compared to DPP4 or SGLT2 inhibitor. But interesting thing is that when a SGLT2 inhibitor was added to DPP4 inhibitor, there's a more HbA1c reduction, but that didn't happen when DPP4 inhibitor was added to SGLT2 inhibitor. And this was also true for the weight reduction. And there is not much concern about these safety issues. And there is some evidence that when this DPP4 inhibitors is used with the SGLT2 inhibitors, that can reduce the risk for these urinary tract infection, GTI, genitourinary tract infection. Now, in the Indian market, we have a few these combinations: the empagliflozin, linagliptin, dapagliflozin, saxagliptin, and remogliflozin, vildagliptin, dapa-vilda, and the dapa-sita. The interesting thing is that we don't have any outcome trial with the vildagliptin, but we have huge huge evidence from real study that vildagliptin is very much safe. It doesn't increase the cardiovascular risk for the cardiovascular event, or it is not associated with increased risk for heart failure. What we gather from the real world study, and if you look at here, this dapagliflozin and saxagliptin, I will not prefer to use this combination in a patient who has history of heart failure, because the sabotimi, the trial clearly showed that increased risk for hospitalization and heart failure with this saxagliptin. Probably I will prefer to use other combination, empalina or the dapagliflozin with sitagliptin maybe, and we can use, of course, the dapagliflozin and the vildagliptin, as I have mentioned, though we don't have any designated CVOT trial with the vildagliptin or any heart failure with the vildagliptin, but we can use that. Now, definitely, one important thing is that decision making where to use this SGLT2 inhibitor and DPP4. Of course, when the patient is not tolerant, when the patient is intolerant to metformin, or when the metformin is contraindicated, then the SGLT2 inhibitor DPP4, or we can use this combination when the patient cannot reach to the target HbA1c goal with metformin, and to reduce the severe risk, including the heart failure, if the patient has underlying atherosclerotic cardiovascular disease, or if there is a risk factors for cardiovascular disease, then we should use these SGLT2 inhibitors along. We can use GLP-1 receptor agonist, and there's a very good choice if you use the SGLT2 inhibitors, so the GLP-1 receptor agonist. But DPP4 inhibitors, when we talk about this DPP4 inhibitors combined with the SGLT2 inhibitors, we need to look at that which are the safe molecules. DPP4 is inhibitors with proven CV and heart failure safety, such as the linagliptin and sitagliptin, have shown a favorable CV safety profile, including the non-increased risk for hospitalization due to heart failure in their CVOT trials. I've already mentioned that. And regarding the CKD, this is the slide, older slide. Here we can use this SGLT2 inhibitors in patients with eGFR 20 milliliter per minute, and once it is started, it should not be stopped unless the patient goes into for renal transplantation or dialysis. Regarding the DPP4 inhibitors, with the progression of this renal disease, we need to reduce the dose of DPP4 inhibitors except linagliptin. So we need to remember that, and we should use the DPP4 with a proven renal safety like linagliptin, or you can also use the sitagliptin. I think all these DPP4 inhibitors are very much safe in a type 2 diabetic patients. They don't increase the risk for cardiovascular event or increase the risk for heart failure. Except the saxagliptin. Only thing we need to remember, they need to reduce the dose adjustment with the progression of this renal disease. A very important thing is that when we use this combination, there is a very minimum chance of hypoglycemia, and we know clearly that hypoglycemia is the independent risk factor for cardiovascular event. So the combination of these SGLT2 inhibitors and DPP4 inhibitors will definitely reduce the risk for hypoglycemia compared to sulfonylurea with metformin. And another important thing is I want to mention this: the SGLT2 inhibitors, mainly SGLT2 inhibitors reduces the fasting and postprandial blood glucose, whereas the DPP4 inhibitors mainly reduces the postprandial glycemic postprandial blood glucose level. But both of these molecules, they reduce the glycemic variability, which is again the important risk factor for cardiovascular event. So whenever we are using these two molecules, there is a very less chance of glycemic variability, and there is a patients time in range will improve. And there are evidences that DPP-4 inhibitors, when used with the sulfonylurea and the insulin, with the insulin, there is lower risk of hypoglycemia, and that is mediated through GIP. Thank you. I'll stop it here. And
thank you, Dr. Mandal, from the City of Joy, and with a great experience, and you have given us this new combination and shown the cardiovascular being the #1 complications, how this combination DPP-4 with SGLT2 does a great job. We'll come back to discussion. I will hand over to the chairpersons, Dr. P.C. Das and Dr. Philip Rautray. Before that, I have a very pleasant job to perform. May I kindly invite Dr. A.K. Birmani. A.K. Birmani sir is the physician from the city of Jamshedpur. Anil will be the moderator for the discussion. Anil, are you there? Anil, he'll be here. And dear friends, I hand over the session to the chairpersons to call the second speaker. Philip, you can call the second speaker.
Yes, sir. Thank you, sir. Thank you, Dr. Mandal. Thank you very much for your nice elaboration on the topic. So as we move to the last session of this wonderful meeting, so first of all, I must thank Dr. Alok Kanungo sir for organizing such a, academic 2 days academic fiesta extravaganza. And also I must thank the organizing committee, Dr. Ashok Kumar Das sir and Dr. Jayant Panda sir, for this beautifully organized meeting. So as we know, we all know the role of insulin as a cornerstone in the management of diabetes, be it type 1 diabetes or type 2 diabetes. We all know its importance, and also the importance of basal insulin. Now we have the second generation basal insulin, and how it is better in terms of both its efficacy, in terms of lower incidence of hypoglycemia or increasing in the time in range. And most importantly, how we can translate these advantages in our clinical practice. May I now call upon respected Dr. Arundhati Dasgupta ma'am, who is a senior consultant endocrinologist, director of Rudraksha Super Specialty Care, Siliguri. He is a recipient of many awards like A.B. Gandhi Award, Diabetes Initiative Awards. He has several national and international publications to her credit, and author also of several chapters in many books. Welcome, Dr. Arundhati Dasgupta ma'am. Thank you so much.
And Arundhati carries in herself a great warmth and one of the most sought after speaker. I mean, not because I must tell you that her talks are absolutely exemplary, and she's a great friend of ours and established. She belongs to second batch of Guwahati DM. Am I correct? On the second batch of Guwahati, very young, and has contributed immensely. And her diction, delivery, and the content are fabulous. Over to Arundhati.
Thank you so much, sir. So for that very, very warm welcome. I do not know whether I deserve all of that or not. But since we're running short of time, I'll try to kind of keep this brief. We'll basically be discussing about translating science to...
Arundhati, take your time. You must have prepared. We have Dr. Abhay Shah after you. That's all. With that, we'll finish. Okay, thank you. And thousands have logged in to listen.
Okay. So basically, what I have been given is translating science to practice, and what are the clinical perspectives of generation 2 basal insulin. When you're talking about translating science to practice, that's a very, these are just 4 words, but these are very important words because there is so much that we have evolved in terms of the science of the treatment of diabetes. But whether that has translated from the books or the knowledge or the web to our clinical practice, our day-to-day practice, is something that we know that it has not really happened the way that it should have. The lacunae between science and practice still exists to a large extent, and that is the gap that we will try to kind of cover up and narrow down. The basic purpose of all these meetings is basically to narrow down the gap between science and practice, and today I'll be talking about generation 2 basal insulin. Now, these are aspects of insulin therapy that we are all aware of, but at the same time, I feel, and I guess all my seniors would agree, and juniors also will agree, that these are points that need to be reiterated in our mind again and again and again. because the impact of delayed insulin initiation is immense in the total outcome of the diabetes treatment. And we are talking day in, day about the timely initiation of basal insulin, but it's not happening. And today what we'll try to take a look at is basically these two aspects, along with when you're talking about generation to basal insulin, is there any particular benefit that we are offering to our patients? If so, is it, is the cost benefit ratio good enough? Is it worthwhile to think of initiating generation 2 basal insulin instead of 1? And what are the practical considerations for the use of generation 2 basal insulin? Talking about the impact of delayed insulin initiation. Now, we are aware that there has been a trial which is known as a landmark trial, and a lot of doctors from across the country, 382 sites actually, have been a part of this study, which was it was a large scale, it was a longitudinal prospective real world study. And the basic intention of the study was to investigate the management of the complications in type 2 diabetes across India over a period of 3 years. Now, as you can see there, what were the basic...
Your slides are not moving.
My slides are not moving? Can you not see?
No, yes, no.
Now it is come.
Oh, okay. Can you see this now, the landmark?
Yes, yes.
And the next?
No.
Oh.
Maybe, ma'am, in full screen mode, it's not moving.
Okay, so what I'll do is, I'll keep it this way. So that'll be easier. I hope they are visible now. So this is the landmark, and these are the highlights that came out from this study. Very disappointing statistics, actually, that 4 out of 5 people in India who have type 2 diabetes have uncontrolled diabetes, right? Secondly, less than 1 in 4 Indians with established type 2 diabetes take insulin. And I think every one of us know how that, I would in fact assume that the numbers would be higher, because it is so very difficult to convince people to take insulin. And the third point is basically a point which has an onus on us, doctors, the treating physicians, that the average HbA1c at which insulin is initiated is 9.2%. So we cannot put all the blame on the patients, because here is where our action starts. Unless the HbA1c goes really high, or a lot of molecules have been used up and still we're not reaching results, many of the doctors will not even think of initiating insulin. Delayed insulin, we have known about this, but again, I would want to reiterate, generally, there is a significant delay from where insulin is needed to where insulin is used. So you can see, the time from the start of regimen to intensification also. So from 1 OAD to 2 OADs and 3 OADs. So not only are we initiating insulin in a delayed manner, we are also intensifying insulin much slowly or much less aggressively than we need to do. And as a result, the implications are on a bad metabolic memory. Right? A bad metabolic memory leads to all of it. We know the oxidative stress, the advanced glycosylation end products, all the collagen linking, all of it leading ultimately to the chronic diabetes complications. And that is why, in spite of all our knowledge that we have about insulin today, in spite of all our knowledge that we have about diabetes control, HbA1c tightening, we're still at very poor figures when it comes to chronic diabetes complications. And that is where we really need to take a hold on things and start off insulin from the point that we think that insulin is needed, and not allow it like another 6 months or another 6 months and so on. So these are the drawbacks of the delayed insulin initiation in terms of microvascular complications, in terms of macrovascular complications. The drawbacks are immense, and they are kind of moving forward in a categoric manner. Now, when we're talking about initiation of insulin, basal insulin is what is recommended in most of the guidelines. It would depend which kind of insulin you are initiating, but a lot of times initiation with basal insulin with maybe an up titration of the OAD or an adjustment of the OAD often does the trick, because we have had the concept of fixing the fasting first and then going on to the basal, depending, of course, again on the fasting and the PP levels of at that point. This is about the early initiation of insulin, which significantly has an effect on the metabolic control. And we've known it all along. From the Wikipedia's study onwards, we've known that the concept of metabolic memory and how insulin significantly changes that. And this is one slide that is shown at least 10 times in every, I think, conference, which is telling us about the importance of the aggressive intervention and how, we should start off with the aggressive treatment from the very word go. Now, when we're talking about an early basal insulin initiation, this is the B-SMART technique. We're talking about the basal early strategies to maximum HbA1c reduction with both oral therapy. So that's BOT, the basal and oral therapy combined together. It is a convenient insulin regimen. It's a convenient, it's an effective regimen, of course. You could choose your doses depending on the fasting level, depending on the body weight, depending on your clinical discretion. But generally, this is what is said, that you could start off with 0.1 or 0.2 units per kg per day, depending on the degree of hyperglycemia, or flatly at 10 units. But that is something that we generally do not do. We kind of, decide the dose based on the sugar level that the patient has and the body weight of the patient. You could decide to inject the basal insulin either at night, which is the usual protocol that is followed, but you could also give it in the morning, because now that we have so many options available with more flexible insulin, with insulin that are more broad-based, that act over a much flatter insulin. So we can decide on our dosing timings according to the convenience of the patient. Flexibility of timing is one thing that has really, really helped us convince patients, convinced ourselves, and adjust the dose, and made it much more simple for use, less intrusive. The very concept of that insulin is cumbersome. I have to take it 20 minutes prior or after, whatever we had, the problems that we had earlier on, or there were certain timings that you needed to confirm to, that those have kind of gone out. And when we're telling our patients that it's okay, you can take it at any time, it's all right. Even if you forget it at that particular time, you can take it an hour later or 2 hours later or earlier. And that really helps them in kind of accepting insulin better, and helps us in putting insulin in place at earlier. Now, if you have decided to initiate basal insulin, what do you do with the other OADs? Metformin obviously can be continued if there are no specific contraindications. The newer therapies, the SGLT2 inhibitors, the incretin-based therapies can very well be continued. If the patient is on thiazolidine-DANs, there would be a concern about increased body weight. So probably the concomitant use of thiazolidine-DANs and insulin is not really a combination that we kind of encourage a lot. It can be given at times. It's not that it cannot be given, but preferably because of the body weight and other factors, the PD demand, the others that are there, that should be reduced or discontinued in favor of other molecules. What a lot of people say is that if you're initiating an insulin, you stop the sulfonylureas, but a lot of times you cannot really do that, because sulfonylureas are potent agents by themselves. Now, if you take away the sulfonylureas and you're putting only a basal and you're taking away the sulfonylurea in the morning, that might kind of actually lead to poorer glycemic control. So maybe what you should do is decide based on that individual patient's condition, but you could reduce the use of the dosage of the sulfonylurea if there is a concern about hypoglycemia. What are the benefits of early basal supported oral therapy? Not when all 3 groups, 4 groups have been used and there is nothing else to give, and then you're telling the patient that, okay, I have kind of exhausted all my treatment, this is what I can give you. Not then. When you have used maybe 1 or 2 drugs and you think there is a scope of using a 3rd drug, but you choose to prefer a basal therapy there, that is where you are basically providing the patient with the chance of restoring some of the residual beta cell function over a short period of time. You could decide to use that for a short period or for a longer period. And of course, about the attenuation of the microvascular complications and, with a lower risk of hypoglycemia and weight gain, which have been major concerns with the use of insulin. With the advent of basal therapy, that has gone down a lot. And today, when we are talking about the next generation, the way forward with basal insulin, the generation 2 basal insulin, there we are talking of added benefits. Now, what are the generation 2 basal insulins? There are 2. There is Glargine 300 and there's the Degludec. The basic concept is that these are, basal insulins that have come a lot after the initial basal insulins were introduced. Remember, NPH came in 1946, and it took so many years till 1992 for a basal insulin to come in. And then you had Glargine and then you had Detamil. By 2010, we had Degludec, which was a new concept. We are talking about less variability, more prolonged action, a flatter curve. And then we had glargine 300 in 2011. So these two molecules, the deglutic and the glargine 300, are actually a way forward that have been developed to overcome the limitations of the generation 1 basal insulin. So if you're talking about glargine 100 and glargine 300, basically what is the difference? The same molecule, which has been kind of condensed. The molecular structure is the same. It just forms precipitates, and the metabolism is such that because it is forming a precipitate, it is released slowly, and thereby it acts for a longer duration of action, and there are no major peaks. It is much flatter as compared to the glargine 100. So the absorption kinetics is what is basically different, with a more gradual release with glargine 300 as compared to glargine 100. So what does that result in? When you're looking at the PK/PD profile of these patients and you're comparing glargine 100 with glargine 300, there is basically a stable and prolonged action which offers you an injection timing flexibility of ±3 hours. So earlier on we were saying 9 p.m. or 10 p.m. So now what are we saying? We are saying you can give it at 7 p.m. You could give it at 10 p.m. You can go ahead and give it at 12 p.m. So that greatly enhances the flexibility of the of the insulin for the patient and makes it much easier for them to take your offered insulin in their day-to-day life. So, and when it comes to what are the benefits that we are talking about, why, apart from that flatter profile, what is it? Are we seeing benefits in terms of weight gain? Because flatter profile basically will translate into lower hypoglycemia. That is what is expected. So are we seeing that in our studies? Are we seeing that in the real world evidence? So what have we seen? Yes, sustainable HbA1c reduction, much lower hypoglycemia, and weight gain was also seen to be much less. Now, there have been a number of studies that have been done across with the different generation 2 with the generation 1, which, there have been the benign trials and there have been the addition trials where glargine 300 and deglutic have been compared to glargine 100 with much lesser incidence of hypoglycemia, as you can see. I'll just briefly touch upon the special population areas here, because these are also areas that you would want to know that, am I offering any benefit if I'm giving a generation 2 in place of a generation 1? So first of all, the CVD, population which is at a higher risk of CVD or has CVD. Now, what was said that because glargine 100 has established the CV safety, there is no reason, the regulatory body said that there is no reason to carry out another CV safety trial with glargine 300. But having said that, there has been a look at or a relook at some of the data that is there, where we have compared glargine 100 and glargine 300, and it has been seen that the second generation analogs are safe and effective, and lesser hypoglycemia in general and nocturnal would translate into a CV safety benefit. Obesity, we must remember that both the addition and the begin pivotal trials had obesity, because the average BMI was 34.8 in the addition and 30.1 in the begin trials, and there were no concerns with the use of the second generation basal insulins in these populations with type 2 diabetes and obesity. In hospital patients, would you prefer a generation 1 or a generation 2? Now, there have been a few published studies which have compared, the insulin initiation with the second generation versus the first generation. And though the general hypoglycemia did not really differ in these in-hospital patients, the frequency of nocturnal hypoglycemia was significantly lower in the 300 group as compared to the 100 group. Now, there have been concerns about hypoglycemia and the use of deglutic, though a real-world study did find that, somewhat higher incidence of hypoglycemia with deglutic versus glargine 300, and they hypothesized that, it was the serum albumin level which was responsible for this, because they found a negative correlation between a 24-hour hypoglycemia and the serum albumin level. And thereby it has been said that if a patient has a low serum albumin level, and that has been corroborated by another study by Kawaguchi, that the mean percentage of time with hypoglycemia would be expected to be lower in those with glargine 300 as compared to ITEC. But then again, we must remember, these are small studies, but these have been hypotheses that have been put forward. Another area which we might not think to be very important, but is very important for the patient, of course, is the pain that is associated with the injection. Because these are one step ahead. The pens are also better. The pens are such that they are easier to use, and patients have reported lesser force to inject, or lesser pain, ease of use. These are the points taken from the patient's perspective. He's not understanding this flatter curve and all these things. He's understanding my flexibility of use. He's understanding lesser pain. He's understanding, okay, lesser hypoglycemia. He's understanding lesser weight gain when you're telling him. So these are points from the patient's point of view. And all in all, thereby, where we stand today with the availability of the generation 2 basal insulin, definitely a lot of advantages being put forward by the studies, initial studies, the pivotal studies, and then subsequent studies, and now the real world data. Longer duration of action, greater flexibility, glycemic variability. We've recently had the in-range study, which has shown us the reduced glycemic variability with the use of basal generation 2 insulin, easily titratable, lesser hypoglycemia, leading to more patient satisfaction and lesser concerns about weight gain. Some practical considerations. What is the initiation dose? Again, I'll say this is very, very individualized, but it has been put forward as 0.2 units per kg. Preferred timing of injection, any time of the day, but at around the same time, not like today you've taken in the morning and the next day you've taken at night. All OADs can be continued, can be safely titrated maybe once in 3 days or with weekly titration schedules, as we've done with the generation 1. And up to what dose would you go up with glargine 300? Up to 0.5 units per kg per day has been put forward. And what are the advantages over the first generation? Obviously, the ones that we've discussed, variability, flexibility, hypoglycemia, weight gain, and safer titration. This is one a slide that I got from one of the company people, because this seems important, because when they told me that this is associated with lesser pain, I had to understand why is it associated with lesser pain. And so this is what they gave me, that okay, this is a 5-second hold time, which is less injection force, easy to use. Apparently we are also getting patient data telling us that yes, this is indeed an easier insulin to use when it comes to their compliance and their and these are dedicated cartridges and other things, the total capacity being 450. So summarizing what we have discussed is that early insulin initiation again and again is important to understand, is crucial to achieve effective glycemic control, and delay may increase the risk of complications. So today we have the options about generation 1 and generation 2 basal insulins to start off as basal therapy. Generation 2 basal insulins that have come across have demonstrated good glycemic reduction, are convenient with a lot of advantages that we have discussed, and therefore today remain a good choice when you're starting off insulin for your patients. And we are maybe going to see even better insulins come across to us today. But from where we have started off with the NPH insulin across the journey through the 100 glargine and the detamir to the 300 glargine and degludec, whatever we have in our hands today, that has indeed been a great way forward. And today, when we give basal insulins to our patients, we are a lot relaxed. We are not that concerned, and that is probably why we need to increase the use of insulin in our day-to-day practice. On that note, I'll stop sharing the slide and I'll hand it back to the organizers.
Thank you very much. I think you have very simply given the message. I have no time to summarize it, but I'll tell you 3 sentences that you have said very beautifully. Insulin inertia, we start late and escalate still later, which has to be addressed. Amongst many things available, the basal insulin is the safest. All of us know, if you start basal insulin, don't have to worry about hypoglycemia. It is absolutely safe. And amongst the molecules available in their armamentarium, Gen 2.0, Gen basal 2.0 stands out as per its benefits of flexibility, plus minus 3 hours, for its efficacy, lesser volume, less pain, and various studies you gave, in-range study, conclude study, so many other studies shown absolutely safe in comparison to other basal insulin, less hypoglycemia and much more acceptable. I think there are many points. I like the way you said about the basal supported oral therapy. That's one of the greatest things. Yesterday I was discussing with Arvind regarding an article on the BIDS therapy, the bedtime insulin, daytime sulfonylurea. So that's what you said, that one of the greatest way of treating type 2 diabetes in our country, if you cannot give 2 injections, you can give a basal supported oral therapy. The chairpersons will give their comments, but your talk was fabulous. Thank you very, very much for this great talk. You have to stay back for the discussion. Over to Philip, and then you have to invite the third speaker.
Thank you. Thank you, ma'am, Arundhati ma'am, for your wonderful talk and how lucidly you have, explained how to, the idea about how to translate into the clinical practice. And now, can we have the introductory slide for Dr. Abhay? Although Dr. Abhay doesn't need any, words of introduction, he is very well known, and from such a young age, he has achieved so many things. He is DM endocrinology, currently working as a professor of endocrinology in a department in IMS Some Hospital, Bhubaneswar. He has made several contributions. He has conducted several diabetes detection camps, and he has international and national publication. To his repute, he has invited faculty for so many, and most importantly, he is the organizing secretary for the ACCON 2018, co-organizing secretary for 14th Annual Conference of All India Association for Obesity. So over to you, Dr. Abhay.
And Philip Abhay had been the member of the scientific committee.
Yes.
And he one of the part and parcel, not today, for the last 9 years. And in the making the program, he is absolutely involved and taken upon himself to be the last speaker. Abhay, all is yours.
Yeah. Thank you, Ashok sir. Thank you, Alok sir. And thank you, Philip, for your kind introduction. So actually, Arundhati has made my job a bit easy with her presentation. And I am going to this basal insulin optimization, moving towards a more patient-centric approach in India. Yeah. So I will discuss the topic in the how this basal insulin initiation occurs in diabetic management. Then second, we'll discuss why and how this basal insulin titration among the management. What are the titration inertia there? What are the unmet needs for particular specifically in the hypoglycemia risk with basal insulin? What are the unmet needs specifically in relationship to the titration algorithms? And we'll discuss about the insulin intensification strategies and what is the concept of basal bolus in the practical guideline point of view. So first thing is we'll discuss how, let us understand how of this basal insulin initiation in the management of diabetes. We know already Arundhati has also partly discussed that part. One dose does not fit to all because we know that insulin requirement is dependent on the body weight, also dependent on how much insulin resistance in the body, but we don't know from our side that we cannot calculate insulin resistance as individually in every patient, and clinically also practically not required. So for all practical purpose, if adjuvance is less than 8%, in 60 kg person, classically we give 0.2 unit per kg, which comes around 12 units. And if a person is 80 kg, then it will come 16 units. If it's come 100 unit kg, then it will come 20 units. If adjuvance is less than 8. But if initial adjuvance is high, 9, 9.5, 10, probably a bit higher dose is beneficial. In that case, we can directly start with 0.2, 0.3 units per kg, which in 60 kg it will be 18 units, in 80 kg 24 units, and in the 100 kg it will be 30 units. So starting dose depends on the blood glucose level and also body weight. Both plays a critical role for knowing about the fast starting dose of the insulin. There are different recommendations from the basal insulin initiation. Indian expert opinions are there. If you will see the B-Smart expert opinion, usually they have actually advised that the basal insulin regimen starts with either 10 units per day or 0.1 to 0.0 units per kg per day, depends on degree of hyperglycemia. And open doctor-patient communication should be there, how rapidly or actively the patient, doctor and patient is participating, and how rapidly you are achieving the glycemic control with reduced hypoglycemia is what most factor when we are titrating this basal regimen. Then Delphi expert opinion shows start with 8 to 12 units of the basal insulin is the ideal initial dose. Start at 4 to 6 units if hypoglycemia is a concern. Then ask the patient to follow up every 1 to 2 weeks after initiating insulin for assessing the need for titration of the doses. Then let us understand why and how of this basal insulin titration in the diabetes management. We know that there are suboptimal glycemic control occurs despite of insulin use in the type 2 diabetic patients. We know almost 86 for type 2 diabetic patients using insulin plus OHS or Ashok now telling either BITS therapy, basal insulin, or bedtime insulin, daytime sulfonylurea, or along with any sort of sulfonylurea, we can start giving specifically this basal insulins. And 80% of these patients using only insulin are not on the target. That means despite of use of insulin, still they are not achieving the target. Because we know that diabetes itself is a progressive disease, that is associated with increased comorbidities, and it necessitates insulin therapy in majority of the individuals of the type 2 diabetic patients. And we know that despite of insulin therapy, the glycemic control is not as achieved. The reason is probably we are not actually doing proper optimization of insulin therapies. And if we are not doing proper optimization, probably we cannot achieve the target and we are not reaching the goal. So the needs for titration, that is systemic dose of titration helps the patient achieve the target. That means once we are starting an initial dose, gradually we have to increase the dose by every third day, every 7th day, according to the patient's need, according to how the doctor-patient is communicating with each other. If patient is in the hospital, in hospital, we do almost daily titration. If someone is in the at home, then that needs the doctor and patient relationship and communication that leads to a early increase in the dose or the titration of the doses, and ultimately that comes to helps in the reduction of the blood glucose level. So early titration is what most important. And this is the HbA1c glycemic glargine doses and fasting trends observed in the patients HbA1c less than 7 with glargine doses and more than 8.5 minutes throughout the study. Then discussing the titration of the patients. This is online survey to determine the healthcare professionals and patients among close to 400 healthcare professionals and 318 patients attitude towards the basal insulin initiation, titration, and that from the US, France, both US and some of the European countries, France and Germany participated in that. The key information regarding this basal insulin titration should be reinforced with regular intervals. What SCB has given that more than 75% reported discussing titration at the initial visit is utmost important. Whereas in the patient's point of view, only 60 to 30% patient remembered such discussion, initial discussion. Many were unaware of the need of this titration of the basal insulin. Only close to 40% recalls mention of the time needed to reach the glycemic control. That means that when we first time discuss with the patient, a lot of the time patient also take it lightly, and sometimes also they forget that they thought that if doctor has written the dose, probably that is the final dose. They never, for subsequently few days, neither they test the blood glucose nor they want to titrate, and that leads to actually a persistent elevation of the blood glucose. So titration is utmost important. And most of the SCPs and patients agree that a more effective support tools to assist this basal insulin initiation and titration is needed. And patient indicated that the provision of such tools should increase the confidence in the self-titration. The lack of insulin initiation is a prominent cause of poor glycemic control. What are the evidence for global and national studies? This is the NANI studies, which has clearly shown that achievement of the glycemic goal less than 7% was suboptimal among the adult diabetic patients. Almost half of the study population did not reach the glycemic control. If you see the from NANI's 1988 to 1994 to 2007 to 2010, there is definitely a increase in the people who have achieved target HbA1c less than 7%. In actual 1988 to 94, it was 40%. Now it has increased to almost 57%. But still, despite of this improvement, still close to 40% people are still there who are having HbA1c more than 7%. So the lack of insulin titration is a prominent cause of poor glycemic control, and evidence from the global and national studies. These are the studies which has, this is the IDMPS Web 7 India subgroup analysis. This shows the lack of titration of insulin and fear of hypoglycemia are two important factors are the key barriers. You will see what are the reasons for different key barriers or reasons of actually either discontinuation or failure of titration of the doses. There are discontinuation of insulin, fear of hypoglycemia, occurrence of one episode of hypoglycemia, day-to-day blood glucose instability or variability, weight gain, lack of insulin, knowledge of insulin off titration, lack of support, lack of experience of self-management of insulin dosing, lack of diabetic education, the cost of medication and other things. What they found among those two important things, the fear of hypoglycemia, and also another important thing is occurrence of episodes of hypoglycemia and lack of insulin off titration has found to be three important factors, and they play a critical role specifically for titration of the insulin doses. Then lack of titration of insulin titration is considered one of the prominent cause of poor glycemic control as evidence from the global and national studies. These are the top 5 physician perceived patient barriers. What are the barriers? Patients' reluctance and unwillingness to consider basal insulin treatment, patients' non-adherence to existing medical therapies, patients' inability to self-monitor their blood glucose with sufficient frequency, patients' concern about out-of-the-pocket cost, and patients' lifestyle that includes diet and exercise. Majority time, what they found that the physician survey reported, patients' inability to self-titrate the dose of insulin is one of the major barrier for insulin titration. So every patient should have some knowledge of how they would titrate their blood glucose if they are testing their or doing CGMS, or if they are doing blood glucose monitoring with point of test care machine, then they should actually know how they are actually going to increase the dose of the insulin. So if they will know that they can titrate the dose at home, they can in actual frequent intervals within 15 days, every 20 days, they can contact their physician and inform them about the blood glucose level. But every 3rd to 4th days, they can do blood glucose at home, and also they can titrate the doses. So titration inertia is a real reality. So this titration inertia is a key barrier to achieve the desired glycemic control with insulin therapies. There is progression of type 2 diabetes and increased association with comorbidities. Eventually, it necessitates insulin therapy in majority of the individuals of type 2 diabetic patients. The second inertia is, despite of use of insulin therapies, large prospective studies has clearly shown that in the clinical practice, the desired glycemic control is not routinely achieved. There is insufficient dose adjustment of insulin is termed as titration inertia. And this suboptimal insulin dose titration was one of the key barriers to achieve the optimal insulin therapies and also insulin optimal glycemic control. So what are the factors which actually contributes to this titration inertia? There is reluctance by the HCPs and the patients or both. There is reluctance from both the sides. Weight gain is one of the important factor, because a lot of the time we know that once we have started, a lot of people comes to us and discuss that we have gained a lot of weight. And is it due to insulin? Of course, we know that this is insulin is one of the factor. And a lot of the people actually have, that is one of the barrier. Then fear of hypoglycemia. If someone develops a nocturnal hypoglycemia or severe hypoglycemia, that actually leads to a lot of the time they either miss few doses of insulin, or they take underdosing of insulin by themselves. And another factor is defensive snacking. And all those factors actually plays a critical role for particularly uncontrolled blood glucose. Then the effect of insulin therapies on the quality of life. There is lack of flexibility to different types of other insulin regimens. There is complex titration algorithms. There is lack of constant self-glucose monitoring, and also lack of education. So among these, this fear of hypoglycemia and a complex titration regimen are the two most important perceived things, or biggest inertia, which actually prevents the patients for titration of the insulin doses. So addressing the unmet needs of hypoglycemia risk with basal insulin, we know that if you see the hypoglycemia is concerned, impedes the aggressive treatment by either physicians or patients' confidence. And 2 out of 5 patients with type 2 diabetes reduces their insulin dosage. I have already previously discussed. Once they develop even if a mild episode of hypoglycemia, they automatically take underdosing. They do the underdosing of the insulin, and again they also start taking defensive snacking in between. And these are 2 important factors which not only increase the blood glucose, not only increase the HbA1c level, but also causes significant weight gain. So if you see the hypoglycemia is a concern for people, the primary care physicians and diabetologists all have actually close to 75 to 80% actually physicians and diabetologists tell that they have actually concern about hypoglycemia. If their patient develops one the episode of hypoglycemia, subsequently they did not become aggressive. They did not go actually become very much serious or very much proactive to reduce the blood glucose rapidly, or they don't titrate very rapidly to reduce the blood glucose or to achieve the target. So what the consequences of fear of hypoglycemia in type 2 diabetic patients with basal insulin? The first is decrease for tight glycemic control. There is poor adherence to the therapies. There is reduced willingness to intensify therapy. Also, there is compromised complements of for taking the therapy. So for the hypoglycemic episodes, if there is a fear for hypoglycemia, that also leads to resistance to titration, again poor glycemic control, and patient can also resort to defensive snacking, which also leads to weight gain, as I have already discussed that part. Then again, if we compare basal insulin versus premixed insulin regarding the hypoglycemia, if you see the overall hypoglycemia, you see it is 2.85 actually proportions, but as 13.3 in particularly in premixed insulin. And if you see the overall mean number of confirmed hypoglycemic units per patient year, you will see overall whether it is symptomatic hypoglycemia, whether it is nocturnal hypoglycemia, everywhere actually the basal insulin has significant less number of events in comparison to the premixed related. Almost 50% reduction in symptomatic and nocturnal hypoglycemia with basal insulin in comparison to the premixed insulins. Then basal insulin versus co-formulation with hypoglycemia. This is glargine versus idagasp. That again shows that there is 86% higher rate of overall confirmed hypoglycemia with idagasp in comparison to glargine U300, and that is also glargine in comparison to glargine U100. And also, if we take particularly confirmed patient having hypoglycemia, and without this hypoglycemia with HbA1c less than 7%, without confirmed hypoglycemia, again in that group also glargine is far superior than idagasp in this present study. Then addressing the unmet needs of titration algorithm, complexities of the basal insulin. A strict and stringent up titration algorithm should be there, and this is the basic reason behind hypoglycemia with the basal insulins, because Insight, LANMET and TTT all has clearly shown that evaluated that glargine U100 is very much strict and stringent algorithm, involves a stringent fasting and SMBG values, which is not classically observed in the routine clinical practice. And if you are going very stringent, that actually leads to increased risk of hypoglycemia. And they attain the glycemic goals, but hypoglycemia is seen more frequently. That means if you are very much strict, you are trying for a stringent algorithm, if you want a very tight fasting and postprandial control, if you are doing multiple SMBGs and trying to titrate the dose early, frequently, probably the risk of hypoglycemia will be more. So that shows a more aggressive insulin dosing adjustment or titration leads to higher rate of hypoglycemia. So these all three trials has clearly shown that. Again, from the stringent to simpler algorithm. So now the motto is actually it should be a patient-friendly algorithm, so that the patient, it will be easy for the patient to titrate, it will be easy for the patient to follow, and it will be easy for the patient to know how they can up-titrate the dose, and if required, they can take the help of their physician, but everything is from the patient side, so it should be as simple as possible. So this is the Atlantis and Goal HOKNC. They focuses on up-titrating the insulin dose of glargine U100 for optimal glycemic control, but gradual and slowly, without pushing the patient so much as to cause hypoglycemia. So you should very slowly increase by 2 units or decrease by 2 units or 1 units. Slowly you go, so that every third day, fourth day, you just up titrate or down titrate according to the goal, according to the blood glucose level, and don't be hasty and don't go for very high doses. As a doctor, we know and we can do that, but when the patient is doing, patient should be advised to go very slowly, and that will help to prevent hypoglycemia in those group patients. So use of glargine 100 with a simple algorithm with active titration leads to a significant improvement in the glycemic control in the people of type 2 diabetic patients. So a patient-centric basal insulin up titration strategies, as I have discussed, if any baseline HbA1c is less than 80, you reduce by 2 units. Our target is between 80 to 130, so keep that if within the target. If it is 130 to 160, increase by 2 units. 160 to 180 increased by 4 units, and more than 180 increased by 6 units. So an active titration period lasts up to 12 weeks. So every third to fourth day or twice weekly, you can titrate the dose, and you can actually gradually increase the dose. So this titration period usually classically takes around 8 to 12 weeks, and period of maximum glycemic burden reduction. This titration insulin dose based on the average 3 most recent fasting glucose, and increase the dose once or twice a week if fasting is above the target age. Already I have discussed. So the barrier to patient-centric approach in India, what are the barriers? Because despite of all sort of discussions, still there are a lot of barriers. Even if we are going for the patient-centric approach, we face a lot of barriers. The biggest barriers or the biggest problem is there is a low level of awareness among our patients and physicians. And in our PGOPD, where actually a physician hardly giving few minutes to a patient, in that case, actually discussing diabetic education with the patient, actually it's a bit difficult. Again, if you see the diabetic educator point of view, probably in our country, we don't have that much of number of diabetic educators we can provide or we can give adequate education to our patients. Again, there is low level of adherence to the therapies. There is constraint in the patient's time and resources. There is insufficient glucose monitoring by SMPG devices, and there is undue medical and financial burden of the therapies a lot of the time, because we know in our country, all medical facilities, everything is our own pocket-driven things. It's not majority part, it's not insurance-driven, and that is one of the biggest challenge and biggest issue for our population. So developing an educational self-management program and using simple titration algorithms is essential for optimizing clinical outcomes in people of type 2 diabetic patients. So the implementing a patient-centric approach in India is definitely a possible solution. Everybody should know what is the significance of SMPG. The highlights, it should be highlighted to everybody, it should be highlighted to each and every patient, and also the highlights in every national and international guideline which has highlighted that it should be actually discussed with the patient, and that will motivate the patient for SMPG. There is a lack of structured patient education program or patient support program is there in our country, and that is one of the biggest challenge. And that if we have that patient structured patient education program or patient support program, probably that will help for optimizing not only dose of insulin, also optimizing the dose of OHA also, and that will make quite a big number of people achieving the target HbA1c less than 7%. And third must is to encourage the better adherence to insulin therapies, patient support from the providers, diabetic support educations, and another biggest thing is there should be some support from the family, because family members are the members who is actually in contact with daily basis. So if the family members are well educated and your family members are supportive, that gives a biggest boost to the patient from the insulin continuation point of view, from the titration point of view, and also further intensification point of view. So several trials have shown patient can titrate their insulin regimen as effectively as physicians if they will given a simple titration algorithm. Hence, developing a simple titration algorithm will help in optimizing the basal insulin therapies. Then insulin intensification strategies, a stepwise progress towards glycemic control. So when to stop titration basal and add prandial insulin? What is the current opinion? First, titrate the basal and add prandial insulin if the patient is unable to achieve HbA1c target with 0.5 unit per kg per day of basal insulin. That means you are already giving 0.5 units per kg per day of basal insulin. Still, the patient is not achieving HbA1c, or HbA1c goal is not achieved despite of normal fasting plasma glucose. Your fasting is very much close to normal, but still HbA1c is high. Probably that is a prandial rise, and we have to target that prandial rise. So a targeted PPG level persistently above goal with basal insulin. That means even if you are doing a fasting PP, every time the PP is high, but your fasting is in the normal range, then probably you cannot further titrate the dose of basal. You have to start a prandial insulin, and you have to either go for basal plus therapies or subsequently basal bolus therapies for achieving the target HbA1c level. So what is the concept of basal plus and practical? As I have discussed, that once you are thinking about basal plus, then you have to choose what is the largest meal for the patient. So if you are targeting that largest meal, and if you are giving the prandial insulin at that will actually, basal is taking care of the whole throughout 24 hours. And the largest meal, if you are giving the prandial insulin with the largest meal, then probably you can, even if achieve, the majority of the blood glucose will come down to normal. So as I have shown, one of the major meal, breakfast will give highest peak and contributes to most of the PPG. So if you are thinking breakfast, then you give here. If you are thinking the lunch is the biggest one, you give at lunch. If you think dinner is the biggest one, you give that dinner. So that will take care the rest of the part. So at the time of injection, if you are giving, then not only subsequent blood glucose is coming down, so that will help to achieve, or that will reduce the HbA1c level, and that will also help to reduce the postprandial blood glucose level. So the proof of concept studies comparing basal plus therapy with insulin glargine alone. So it is a type 2 diabetic patients, HbA1c between 7.5 to 9.5 with BMI up to 33.1, and mean diabetic duration is close to 12 years. Insulin glargine is given initially to 135%, then divided to group and given 3 months of glargine alone. Another group, glargine plus once daily glulysin was given in the another 50 patients. So that shows that adding glulysin to glargine further improves the glycemic control. So if you will see that at the at randomization at the end point, you see glargine glulysin is definitely has significant lower HbA1c in comparison to the glargine group. Again, those people see that the percentage of people who are achieving HbA1c less than 7%, again, glargine and glulysin group, it is 22% versus only 9% in the glargine group. So addition of glulysin not only reduces the postprandial blood glucose, also helps in significant reduction in the HbA1c level, and a large major percentage of people achieving the target HbA1c of less than 7%. Again, basal plus approach with glargine and glulysin, the point of clinical practice. A mealtime insulin may begin with one of the methods describing below, depending on the patient's characteristics. A fixed dose of single bolus dose of 4 to 6 units is administered with the largest meal of the day, where actually there is a significant rise in the postprandial blood glucose is happening. A dose defined based on the level of PPG level and glucose values divided by 2, or in the majority divided by 18 into 2. That means if you are actually having a PPG, if divided by the glucose level by 2, and if it is more than 18, probably they require the prandial insulin. A dose based on the previous basal dose. So that means if you are knowing the previous, suppose someone is on the previously premixed insulin, now we are shifting to basal plus. So 50% should be given, 50 to 60% should be given as a basal, and rest 30 to 40% should be given as a single dose. A dose based the patient's weight, it is 0.05 unit per kg should be given. So key message is titration inertia due to fear of hypoglycemia and weight gain leads to inadequate insulin off titration and poor glycemic control. If you are going with systematic yet patient-friendly dose of titration strategies with the basal insulin, that helps a good glycemic control. Simplicity and convenience of once daily regimen with basal insulin allows the patient empowerment for effective insulin dosing management in the Indian setting. Due to progressive nature of diabetes, that results in the subsequent incentivization is utmost important, because even if you are starting basal, either you on due course of time, you have to go for basal plus or basal bolus therapies. Rapid acting and long acting insulin analogs mimic endogenous prandial and basal insulin secretion. A stepwise intensification of basal insulin glargine with a single injection of glulysin also can be considered or is helpful, or a lot of the patients could achieve target HbA1c with this much of insulin. Thank you.
Thank you, Aware, for a very comprehensive presentation. And now I'll request Dr. Peshidas, Professor Peshidas, to kindly invite Dr. Anil Kumar Birmani, who is here with us, to take up the panel discussion. We'll have a very short panel discussion for about 10 to 12 minutes.
Thanks. Thank you. Thank you, sir. Hello.
Yes, sir. Anil, are you there?
Sir,
Anil?
all the speakers have spoken very nicely and vividly, and have given a clear picture about the basal insulin and the combination of the DPP4 and SGLT2 inhibitors and the how to titrate the dose of basal insulin in the patient-centric approach. A lot of factors, patient factors, play a role in controlling of diabetes. So all the speakers are presented very nicely. Now I invite Dr. A.K. Birmani, who is the moderator for the panel discussion, to take over the mic.
Thank you. You can take up speaker by speaker, sir. Start with the because there are topics.
Good evening to everybody, and thank you, Alok and Professor Ashok Das, for inviting me here. I will start with the first speaker, Dr. Mandal. I hope he is there. Dr. Mandal, are you there?
Yes, I'm.
Dr. Mandal, you very nicely talked about the role of SGLT2 inhibitors and combination therapy in reducing cardiorenal risk as well as optimal glycemic control. Now, we have sufficient evidence today that optimal glycemic control reduces microvascular complications but has minimal effect on macrovascular complications. And to reduce macrovascular complications, we need to control the conventional risk factors. So what are the current targets for two of the risk factors like blood pressure and lipids in patients of diabetes with high cardiovascular risk?
Yes, it's a very good question. Yes, we need to address the cardiovascular risk factors if we need to reduce the cardiovascular event in our type 2 diabetic patients. The more important thing is that we need to address all the cardiovascular risk factors simultaneously so that we can achieve the bigger benefit or greater benefit. Now, the patients with hypertension, we need to bring down this blood pressure at least from the 140/80. And if the patient has underlying kidney disease or the diabetic kidney disease, then we need to bring down, this target is to keep the blood pressure below 130/80. And regarding lipid profile, that's this target should be lowering of the LDL cholesterol. And if the patient doesn't, you mentioned that the patient has a high risk for atherosclerotic cardiovascular disease. In that case, the blood LDL cholesterol should be below 100. And if the patient has previous cardiovascular event like MI or angioplasty or the CABG, then we need to at least bring down that below 70. And if we look at this lipid association in the guideline, then we need to bring it down below 50. And usually I follow that we need to keep it below 50. And triglycerides should not be the primary target when you consider the lipid lowering. But of course, if it is more than 500, then we need to bring down this.
So the current 2023 ADA standards have now brought down the blood pressure to 130/80, that we should be less than 130/80 blood pressure. And lipids, of course, we should be following the Lipid Association of India guidelines. The LDL should be less than 70 in all diabetics, and maybe as the risk increases to less than 50 or even less than 30. Now, suppose you have reached, the patient has reached the LDL goal. What do you understand by the term residual risk, and what do you do?
Yes, the residual risk means that in spite of reaching to the target LDL goal, you will find that you cannot prevent this cardiovascular event. And in that case, we know that if you bring down this LDL cholesterol further, there will be the further reduction of cardiovascular event. And we need to give the maximum tolerated dose of LDL lowering agent, the statin. And we know there is a clear relation with this lowering of the LDL cholesterol with the cardiovascular events. For example, if someone's LDL cholesterol is 100, and if you bring down to the 70, there is a 30% reduction of the LDL level. So there will be the 30% reduction of the cardiovascular event. So if we reduce this further, then there will be more reduction of the cardiovascular event. And if after reaching to the tolerated dose, if we cannot reach to the target LDL goal, then we need to add another agents. For example, we can add ezetimibe with LDL cholesterol, the statin.
So basically, as you said rightly, residual risk is something, once you have reached the LDL goals, there are still patients who get a cardiovascular event. So we must look at the non-HDL. and try to target that, because it is the atherogenic proteins, other proteins that may be responsible for the residual risk. And there we need to intensify statin therapy or add ezetimibe or even add PCSK. Anyway, now you have talked about SGLT2 inhibitors, GLP-1 are also the drugs that are guideline directed drugs for reduction of cardiovascular risk. Where would you place pioglitazone today in cardiovascular risk reduction?
Yes, definitely. In our previous session, we discussed it about this pioglitazone. There's a very good insulin sensitizer, and the only problem with the pioglitazone is that it can increase the risk for heart failure. It can cause the pre-retention. So definitely, the patient who has history of heart failure, the patients with a current heart failure, we cannot use the pioglitazone. But from the proactive study, what we learned that if the patient, it reduces the risk for stroke at least. So then post-stroke patient, ischemic stroke, we can use this pioglitazone particularly to reduce the risk for further stroke. But if someone doesn't have any evidence of heart failure, then in particular in the young patient, we can use this pioglitazone. I personally prescribe the pioglitazone with metformin in significant number of patients, and the durability of the pioglitazone is a very important what we have observed from several studies and from our practice. The durability of the pioglitazone
study all have shown, and the current recommendations of again ADA, there's a strong recommendation to use pioglitazone, especially in patients with past history of TIA or stroke or MI. So it is a wonderful drug, but judicious use is very important, and you must know where to use.
And you know, Forest Dandona of our origin, you know, they have given pioglitazone in the first treatment, combination therapy, and have used. They said we don't have complications. They give a combination of 4 drugs sometimes, and pioglitazone is an integral part of it. In fact, people joined Anil. There was Debjit Tripathi and from USA, and he was talking about why not we give given
in PCOS.
You were there. So I think it's correct. I have just one question for Dr. Mandal. I think the combination you told of DPP4 and SGLT2 inhibitor is a very intelligent combination. I must tell you, because I work for the DCGI, the SGLT2 inhibitor, that is sitagliptin alone, introduced by 27 companies, is not moving well. It is the combinations are moving well, and if you combine with gliptin, you have 5 + 1, 6 of the ominous octet we're addressing. So that's why I think this combination is very good. I think we'll go to now Arundhati, Dr. Sir. Arundhati.
Yes, sir, Ashok sir, your thought process, DPP sita plus metformin, DPP sita plus pioglitazone.
It is definitely there. Indian government has not allowed yet 4-drug combination FDC. You know, we
not four, sir. 3. DPP SGLT plus metformin, DPP SGLT plus pio.
Yeah, I think pio has come only by Dr. Landmark, and the metformin has come by many companies. And you know, there is no head-to-head trial between them, but I think definitely they'll be much better than double drug combination.
So pio actually, sir, they have come with teneligliptin, that is actually
I call it Jita Met Pio.
Yeah, so bit otherwise.
But I think it is the offering that maybe a combination of metformin and SGLT2 and pio, that is in the offing, very much in the offing.
I think that is to come, and they have actually a new study has compared this combination which Abhay is telling, gliptin plus SGLT2 plus metformin with plus pioglitazone in place of pio. The other study they have taken sulfonylurea, and you know, the hypoglycemia was as expected more. But I think this combination, but the bottom line is that we have shown the way to the world. India gives the concept of FDC for convenience, for increased compliance, and for decreasing the cost. And that has come to stay. But I liked your presentation, Dr. Mandal. Thank you very much. Let's go to Dr. Arundhati now, sir.
Yeah. Okay, Dr. Arundhati, that was an excellent talk. And I agree with you, millions and millions of dollars are spent on clinical research, on randomized controlled trials, but then translating into clinical practice is very poor. And it is something very important. You have very nicely talked about the benefits about the latest generation 2 basal insulins. At the moment, we have 5 basal insulins in our armamentarium. We have NPH, we have Detamir, we have the Glargine, and then we have the elder brother Glargine, Taugio, and then we have the Degludec. Now, agreed that the second generation are better as far as the hypoglycemia is concerned and the flexibility is concerned. But if you look at the glycemic efficacy remains the same of all the 5 insulins. There is no difference as far as the glycemic efficacy is concerned. So where would you particularly use each? Because everyone has got its place today in our country. So where will you, in one word, each you give the indication for NPH, indication for Detamir, indication for all the 5?
So in the area where I practice, I actually cater to a very diverse segment. One segment is a segment who cannot even think of buying the basal insulin. No matter how the price has come down, they cannot even buy it, even if I tell them to. So that is where I would generally place the N today. I also use some amount of N during pregnancy when I'm using Detamir, and N is what I use in pregnancy and in people where economy is a big factor. Where these are not major concern. All these years, we have been using a lot of Glargine, sir, Glargine 100. Now, with the advent of Glargine 300, there is a general tendency to generally, use Glargine 300 because there is not much of a difference when it comes to the cost, a little bit of difference. But I think today, I use Glargine 300 more often because of the data that has come forward. I feel more secure. I feel more safe and lesser worries about hypoglycemia. Also, it becomes easier to convince the patients. When you tell them that about the flexibility, that is one word that really works well with them. That, 2 hours here and there, then they're a lot, easier and not major concerns about hypoglycemia. In all these years of using Glargine, sir, and also Degludec to its credit, I don't think hypoglycemia has been a major issue with any of us, maybe 1 or 2 offbeat cases. So where there are concerns of generally, if I decide on a basal insulin today, I would choose a generation 2 basal insulin, unless I have particular reasons not to choose generation 2. Pregnancy is where I'll use Detamir and human insulin N.
In fact, we had a study, Professor Anil Virmani, the insulin is given not always by the medical personnels. Somebody's daughter-in-law will come back from her work and give. Somebody's daughter will come back and give. Husband never gives. I know somebody come will give. So what happens? This flexibility in timing is a great boon. Am I correct, Anil? So therefore, 3 plus 3, 6 hours of flexibility gives a window of opportunity to give, and they don't omit the drop. Second thing, I fully agree. Arundhati's friends are all good friends. She has not seen any hypoglycemia that much. I will give an example of a CEO. I spent some time in Calcutta. I was called the director of Indian Institute of Diabetes. I had a CEO. He drinks like fish, but doesn't drink water. So he's very severely diabetic. So what happened? He went to the bathroom, and he's the CEO of the office. So he went to the bathroom and took an injection. He took an ordinary NPH insulin. And, in an inebriated state, he forgot to take food or did not take food. So he reached home. I got a phone call from his wife. Sir, my husband is behaving very badly, sweating. I knew what it was. So, I think the flexibility and hypoglycemia freedom are there in cases. So from that day, I said that, you are CEO, why are you not taking your analog insulin? And he started taking it. So we sometimes underestimate that the patient cannot take. Number 2, the study which Arundhati presented at the beginning, the insulin use alone, Anil, is only 0.5%, 0.7%. But insulin plus oral is 24%. So that is the latest statistics. So therefore, I think I also promote quite a bit of insulin plus oral, which has been one of the mainstay. And there's an article, the books that we have written. S.R. Arvind written the article. He has written how he was influenced by Dr. Sheshaya and Dr. He was trained at Mohan Center, and by Dr. Vishwanathan, Mohan's father, how he was influenced to give this combination therapy, and he has given that. I'll pass on that book to you. So therefore, I think it has a great time. But if it cannot be done, I worked in Jipmar for entire life. There is a government hospital. We have only approached to NP at that time. But once I became MS, Dean and Director, I can influence to buy things. But I think there is a benefit. And as you rightly said, these had to be customized, individualized, depending upon the affordability, appropriateness.
Right. Another last question to you, Arundhati. There is a controversy regarding initiating insulin. In the Indian scenario, where we have a very high carbohydrate intake, should we not initiate insulin, premix insulin, rather than a basal insulin? I know all the international guidelines do recommend initiating basal insulin, but RSSG is the first guideline that has come out that yes, you can even start initiate with premix. So what is your opinion regarding that?
So premix is a very good insulin. There is no doubt about that. And all of us are using premix. They're not taking away anything from premix. But having said that, I mean, the one thing that definitely is a negative point for premix is its fixed ratio, 30-70 or 50-50. The carbohydrate intake does not necessarily occur in that order. So that is why I would think that if we need to give a coverage for that particular carbohydrate intake at night or in the morning, whatever it is, I would personally prefer a basal plus regimen. Or maybe we put in something like say an acarbose or a voglibose, if it does the trick for that carbohydrate intake, and add on a basal insulin or a basal plus for me, sir. A fixed ratio is difficult. But having said that, then people do not agree. They'll not agree to take 2 insulins at night. And that is when you would choose the premix. There are also periods of time when the patient is presenting with very high fasting, very high PP. Only controlling the fasting will not do at that point in time. Maybe there's an urgent requirement to bring the blood sugar levels down. That is when we will choose a premix if the patient doesn't agree for a basal bolus, which most people will not.
Arundhati, a base therapy would be ideal.
Birmani was one thing to add. What Arundhati is telling is absolutely right. But if in this gathering, whoever we are sitting, if we'll see the number of insulin, what we are writing in our clinical practice, probably premix will be much more higher than other things. We have shifted from premix to basal or basal plus or basal bolus or even if these co-formulations. But still, if we'll see in last 1 month, how many prescriptions I have written in insulin, if we'll compare, definitely the premix will come from everybody's pen. Premix will come high. Because our people want that. They can't change that. You can't change their pattern. You can't change their diet pattern. They'll look at that. And another important thing is now this Lantus insulin actually is off patent. Now, even if in this NUCD, everything is actually, we are getting glargine insulin. So glargine is now affordable. So from the cost point of view, again, that is one of the important factor that one might not afford Pujio, might not afford Ryzodec, but then this glargine also is one of the best insulin which significantly reduces our headache regarding the hypoglycemia point of view.
Right. It is easier for the patient to take premix insulins because he doesn't need to titrate. It is we who titrate for him. That is another part. Just moving around, moving off from you, Arundhati, I just want to beg to differ with you on one point. You talked about early insulin initiation. Do you really believe in early insulin initiation or timely insulin initiation?
Certainly time, but a lot of times early is timely.
There is a difference between the two.
People start really in a practice, people start early insulin initiation. Every month you lose 300, 400 patients.
Yeah. So it should be timely insulin initiation, not early insulin.
It is, yeah.
Okay, coming to you, Abhay.
Something very interesting. What has been talked about today in 2022 October, published in Diabetes Care Anil, first year control matters. You must have seen that paper by Litepong. And it says 13,034 patients followed up for 13 years. He found the nephropathy and cardiopathy and eye complications were more in the people whose first year HbA1c was not 6.5 or not between 6.5%.
Yeah, I've seen that.
You saw that paper. Those people who were HbA1c above 7, he found, I think I remember the percentage, The 32 people out that had retinopathy, nephropathy about 56, and cardiac complication about 17. And he has used the term a propensity to end of life. That means they're going towards progressing towards life. I mean, especially in the some population. So what she has said that if you want to produce results, produce in the first year. Therefore, if you have in our country, if you have blood sugar of average H1C we have is 8.4, 8.6, 9, rarely 7.8, around 8 we have, 8.5 we have. So there is a thought process that let us control it first for at least a year. Then the legacy effect is much longer. The second is that you tell somebody, Anil, that you take insulin today, you will see after 10 years, even then you get the legacy effect. They may not be impressed. You tell some person with diabetes that you take this injection for 6 months, 3 months, 9 months. With the first year you control well, the whole life you are going to have legacy effect. I'm just telling you, you'll be more convinced.
I agree with you, but my only fact is that let us be very practical oriented.
I just told you.
Refuse to take insulin. Our aim is, as you very rightly said, if you can get to goal with oral drugs, then why to start insulin?
Okay,
so unless the oral drugs fail, earlier the tradition was that 3 drugs fail, then you start insulin. But today we have a lot of drugs in our hand.
So
and with semaglutide coming, you can further delay insulin therapy now. So we have to cater to what our customers want.
Yeah,
they don't want to take insulin right from first day.
Yeah.
As simple as that.
We have a tendency to
except for pregnancy. Except for pregnancy, no patient wants to take insulin.
The time period given to establish good control with combination oral in that paper is 6 weeks. If you do not achieve good control 6 weeks, you can discuss with your patients. Right. But the important point, you see, we don't want to medicalize insulinization, but we are just telling, as you rightly said, appropriate and timely insulinization. And
prepare the patient for insulin.
Yeah, sir. Actually, what Birman sir, actually Ashok sir, one of our patients actually is a doctor. His father is 22 years diabetic, and he's on glibenclamide since last 20 years. He's on glibenclamide, and his H1C is 6.5. No hypoglycemia. What to be done? And he's not at all ready to change. He is not at all ready to change. No, I am perfectly fine, and I am taking. This initially was taking Dionyl, now he's taking Sonka is taking that, and it's perfect.
The thumb rule is when something is not broken, don't try to fix it. So if it's well controlled, if he doesn't have a cardiovascular risk, let him continue.
And the important thing is not on metformin, only glibenclamide, not on metformin.
As long as it's controlled, how does it matter?
For last 22 years, actually, he's on glibenclamide.
Okay, now coming to you, Abhay. Again, an excellent talk as usual. What is over-basalization and how will you recognize it? Over-basalization.
Sir, over-basalization is actually, it's a partly, this is what I have discussed. There is inertia from the patient point of view. Also, there are some inertia from the doctor point of view. If we are not communicating with the patients properly, like what hastily increasing the dose rapidly, because in the hospital a lot of the time what we do, suppose today the blood glucose is 300, we directly increase our basal by 10 units, 15 units. So patient use a lot of time, sees that doctor has increased the dose by 15 units. Sometimes at home with a blood glucose of 200, like that they increase by 10 to 15 units, and suddenly the next day there will be sudden hypoglycemia. So always, whenever you are giving tricks to the patient, always give increase by 2 units or maximum 4 units, not more than that. And even if you are achieving a target within 6 weeks, 8 weeks, that is okay. No need to that. I don't want in a hurry. I'm not in a hurry. I don't want to achieve my target within 7 days, 10 days. Gradually, so that the patient will properly know how the patient is going to titrate, whether it is increase or decrease, and that will prevent over-basalization or under-basalization. But if sometimes what the patients, those are clever patients, what they do, that doctor has increased directly by 15 units. Today, I will directly increase by 10 to 15 units. And these people actually will be trapped, and these people actually creates problem.
So what is the beam score?
So actually the rule is only increase by just 2 to 4 units or reduce by 2 units, 1 units, and that will actually give confidence to the patients actually for particularly increasing the doses or reducing the doses.
So, but what is beam score? Beam score for diagnosing over baselization. What is the beam score? The bedtime and the AM morning sugar. The difference between the two tells you when you have over
If it's more than 50.
Yeah. So actually, if it is actually that see the what is the bedtime in blood glucose level and the morning blood glucose level divided by insulin. If it is more than 15, then actually you need a prandial blood glucose injection. And if it is less than that, that is only basal is sufficient. There is no need of giving prandial.
Okay, what is the difference between optimization and intensification of insulin therapy?
Yeah, so the optimization is, suppose I have started today, I have started with basal insulin. First, I have to optimize the basal because my target with basal is to fix the fasting first. So with basal, gradually I am increasing the doses as I have actually discussed with the patient. Gradually, patient is increasing and patient is communicating with me every 7 days or 10 days. And once I have seen that my fasting is controlled, but I am doing a 6-point testing or 7-point testing, I am seeing all prandials are increasing, or only one with the measure meal, that is one rise in prandial is increasing. Then probably once I have fasting is controlled, my basal titration is over. Then, or optimization, I have optimized the basal dose. Then I have to titrate or I have to intensify the dose. But then intensification, you have to go for either basal plus. If someone is taking one measure meal and there are 2 small snacks, then probably only with intensification with one short course of insulin, you can go for directly at that maximum meal and you can totally control the blood glucose. But like our Odisha people, West Bengal people, they have 2 large carb meals. So in that case, probably they require 2 short-acting insulins. And when you are seeing that still there is 3 peaks with breakfast, lunch, dinner, all are producing peak, probably there we have to go for a complete basal bolus therapies during the intensification phase.
But if the patient is having 2 large meals, don't you think pre-mixed insulin would be much better?
But if someone is taking lunch and dinner, how pre-mixes, you cannot do that pre-mix, it will be difficult. So there is flexibility with basal bolus or basal plus or basal 2 plus, whatever may be, that is flexibility is there. But if someone is taking only breakfast and dinner as 2 large meal, then probably the premix is the better option rather than going for basal 2 plus.
Okay. Just last question to all the three. Now you have got 3 drugs. Which 3 drugs would you prefer as the first line treatment? Metformin, SGLT2, DPP4, number 1. Metformin, SGLT2 inhibitors, pioglitazone, number 2. Metformin, SGLT2 and voglibose or acarbose, whatever it is, number 3. Which 3 among the 3?
बस आपने GLP-1 को छोड़ दिया बिल्कुल.
I am talking oral.
Okay. Oral GLP-1 बोल रहे हैं बस. Oral GLP-1 बोल रहे हैं.
नहीं.
Oral GLP-1 because nobody can afford it. And lot of technical problems.
The third option, I think there will be not many buyers.
Correct.
When the has come.
The fight is between first and second.
Arundhati away have to choose which one.
I will choose for metformin, DP4 and SGLT2.
You will choose that one. Okay, Arundhati, what one will you choose?
Depending on the BMI and the other comorbidities. I'll decide on that.
Okay, very good. Dr. Mandal sir, what would you choose?
Yes, I'll go for this metformin, DPP4 and SGLT2 inhibitor.
Okay.
Friends, thank you very much.
Sir, people are still hesitant to use pioglitazone.
To tell you why they're hesitant to use.
Despite listening to Deep Franzo, people are still hesitant to use pioglitazone.
But you see that, the pioglitazone is gaining more and more important. I know we have listened to the latest sale of the pioglitazone. I'll just give an example. The still sulfonylurea, metformin are number 1 drug. The DPP4 has shown a 10 to 20, that is 100% rise. SGLT2 has shown from 7 to 21, 300% rise, rising very fast, SGLT2. Now coming to pioglitazone, which was almost in the just invisible line, has shown itself about 150 to 200% rise. So it's slowly rising. The only other drawback is that we are not promoting 7.5. Many combinations are promoting only 15.
15.
So there is one caveat in that, because we are still holding on to total dose of pioglitazone. So there are a few issues we are going to address, and we'll see how it is. About imiglamin, Anil, please excuse me. What is your experience of the efficacy, glycemic efficacy? Same as
I have just put 10 patients on imiglamin. I need to get data after about 2 months.
Same.
But sir, my take home is, actually, if someone is going to spend 50 rupees with imiglamin and will leave SGLT2 or all those drugs,
Sorry.
it will be a disaster.
No, Abhay, imiglamin is an add-on drug. Drug.
I know, that's what I'm telling you.
Cost is only 18 rupees per day.
By paying
only 18 rupees per day, for your kind information.
How much?
18. Imiglamin of Zydus is costing 8 rupees 80 paisa.
Anil, 1 minute. Anil, what happened?
Glycemic efficacy is not that strong.
We had not that. Agree. I think Mandal sir, I agree with you. We had written to the DCGI that this 500 tablet won't do. Make 1000 milligram tablet
twice daily.
Then that is daily. Then this
is a placebo.
1 minute. They said the cost will go very high. Then in between, we had Zydus. So they reduced the price immediately to 7 rupees. And that is for the 500, I think 9 rupees. So what you say is correct. But we have to see, a new drug, we take time to adapt. We take time to adapt. I have not used it.
How will we know?
We can wait and see.
Sir, can I ask one question to Professor Das, that what do you think about this reason for this under prescription of pioglitazone, in spite of that there's a very good glucose lowering agent, durability is very good, is very good.
A wonderful drug. I use it regularly. You have to be little cautious about 3 things. Number 1, about the weight gain, heart failure, heart problem, no. And also look whether the person is getting a little bit of pedal edema. Then you can, that little bit of pedal edema less than grade 1, I don't bother. If it's grade 1, grade 2, I bother. It is a wonderful drug. I have written about pioglitazone and habit. You write HABIT, habit. You take out H, A bit remains. Take out B, it remains. So by habit, from that year, when it went into disreputation, our minds are not yet free that it does side effect. Pharmacopoeia Intelligence of India and World Pharmacopoeia Intelligence has said it is quite safe, and people are using it live, left, and center. So I think in years to come, in months to come, in days to come, you will find a significant difference and the control is superb. The glycemic efficacy, not on the first day, not the second day, third day onwards is great. Am I correct, Arundhati? It takes 3 days to control. So it is.
Pioglitazone takes almost 2 weeks.
4 weeks. 4 to 6 weeks.
4 to 6 weeks. 2 to 3 weeks. 2 to 3 weeks for optimal action.
They are referring to that. It takes time. So therefore, it is if there's no MACE trial, it's a wonderful pro-cardiac drug. That was proactive trial showed. Lot of benefits we have with that drug. But I think, it will re-establish itself in a very short time. And the time is coming, Anilji, when people will take to triple drug combination or even 4th drug combination in the initial treatment for at least for few months to reap the consequences for entire life. So I strongly believe in that. And I think the practices are changing. I'm very happy to note that DPP4 and SGLT2 200%, 300% rise. The reason is it has come very affordable. But that is not the only reason. There's a lot of education, lot of programs. People realize, doctors realize. And I don't know about tier 2, tier 3 cities. They are the commonly used drug today. So dear friends, it's great to have you here. I understand it's a little late and there's a festival day. I offer on behalf of NUCD, great thanks to all of you. And thanks is a very simple word. I must tell you that I really sincerely appreciate your participation in it. You take any specialty.
And in Odisha now the festival is continuously going on, Hockey World Cup.
Yeah. Whether it is hypertension, whether take it ophthalmology, take it skin, the diabetes is the happening place. Is the happening place. While we are discussing it now, something else, diabetes is happening somewhere in Delhi. there is something else happening. Mohan is speaking somewhere. Somebody. So I personally believe that has driven the diabetes care, diabetes academics, and diabetes therapy to a little higher level. With that note, I thank Anil, I thank Professor Pishidas and Dr. Rautre. I thank the three eminent speakers, Dr. Mandal, Dr. Arundhati, and Ave for their great lectures. I really enjoyed throughout the meeting their great lecture. Thank you very much. I request to stay for 1 minute. Alok, are you there? Alok?
Yes, sir. Alok sir is there.
Alok?
Alok sir is there.
Yes?
Sir, unmute yourself.
Alok, unmute yourself. Let us be here for 1 minute to say.
Yes, sir.
We had wonderful 9.
Yes, I have unmuted. Can you hear me?
Yeah,
Yes, yes.
Start speaking.
So, Professor Das, our dear friend, Dr. Birmani, Arundhati, Abhay, Professor Jayant Panda, Sambit Das, Devashish Das,
Dr. Mandal
Dr. Bharat Panigrahi, Dr. Mandal on the stage, and all the members of scientific committee, those who have really worked hard to make this edition possibly the best edition in NUCD history, where science took over everything. And I have never seen such interest of faculty members and delegates to stick to science and practical utility in clinical medicine. So this was a wonderful show. It was a team effort, and Professor Ashok Das has never taken his dinner before 11:30 when we conduct the scientific meetings. We start at 10 and Bhaujo gives him food, and by 11:30 we complete. So this is excellent. And I thank everybody, all delegates. And Mayank, can you please share the screen of our sponsors? Mayank, can you kindly share the screen of our sponsors? Hello? Mayank, can you hear me? Anyway, so
yes, sir.
This time, Mayank, please share the sponsor screen. So the scientific extravaganza, this scientific event could only be possible with the help of our dear friends from the pharma industry. Their unconditional academic support, even though it is a virtual meeting, they have done whatever they could, and I have never questioned any one of them, those who came voluntarily, and we have accepted everything as a gift. So my first thanks goes to US Vitamins. Mayank, can we see the screen? Hello? Mayank?
Yes, sir. Please allow me 1 minute.
Okay. So US Vitamin, Madam Farida and her team, they are a part of NUCD. They treat as if NUCD is their conference, connecting to doctors, connecting to faculties, spreading the message, and everything that we need help. Today morning, Professor Samal wanted somebody to come with a laptop, and yesterday morning, and he will give the inaugural speech. Somebody from USB came and supported Professor Niranjan Tripathi like that. So I am really grateful to USB team for their unconditional support. Same thing with Sanofi, the talk that all of you are giving now, it is sponsored by them. Novo Nordisk has been always a partner to us. Glenmark, with their increased presence in the field of oral drugs and gliptins and everything, they were also supporting us. Danone, the protein company, for the first time supported us. Along with Dr. Reddy's, they are also protein companies for us. Wakad, Biocon Biologics had a talk yesterday. Jarun Pharmaceutical, Mr. Umakant Nayak and his team, they were really very helpful. Boehringer Ingelheim, Mrutyunjay and their team, Medley, Rishi and their team, Mankind, everybody from the Mankind like Prabhas and others, Alchem, Abbott, and all of them really helped us. So my unconditional thanks to all the partners, those who made this possible. Professor Das, I kindly invite Jayant to speak few lines.
Jayant, Jayant, are you there? Jayant, Jayant, are you there? I think we should make it brief now because Jayant, if you're there, please speak for about a couple of minutes.
I think he's not there.
We have away 1 minute. Can you speak 1 minute? Away.
Sir, as usual, every year like this, Kanungo sir usually plan these things 6 months back. Every time, every monthly, we have a discussion. What will be the plan? What are the new things we'll do? What are the new ideas we will incorporate every year's NUCD? And this year, the scientific agenda was mesmerizing, and all the stalwarts from different parts, everybody participated, and everybody, the talks all are brilliant talks this year.
Thank you. I think Alok, Abhay, my dear friend, Dr. Mandal, all of you present here today. It's my great pleasure and honor to say that we started this journey 9 years back. This has been a journey of diabetes academics and has made a dent in the country's diabetes education program. Believe me, the amount of feedback we have from various parts of the country, somebody has said it is one of the best national program at the national level. Very, very encouraging program. We have resolved to bring out a small booklet, at least with the major points that has been discussed here and the presentations with the permission of the presenters. We have also resolved that we should make some sort of a email entry to email communication to all the people who have attended this meeting, and so that we can send them send them literatures and all that. We'll start it from the kids, Dr. Kanungo Institute of Diabetes, and we have taken resolution. But I will say the last word, that a good beginning was made 9 years back. All the 9 years we have well continuation. But there are only two ways along a mountain. You have to either go up, otherwise you will come down. We resolve to go up, and we resolve to make it better and better. And this program will continue for eternity. There is no end and endless progression for NUCD. Thank you very much. We'll meet next year.
And
thank you. Yes,
the last but not the least, this technical high drama could be only possible by a thoughtful preparation of the format by Saurabh Tripathi, my son, and he has done it and he's still following it, by Hardik Chandrana and his team, Mayank particularly, doing the all hard work, and Sanjay Swai for uploading the program. And for your information, whole NUCD 9th edition will be available at nucd.in in YouTube for years to come. You can also see last 2 years in the YouTube. So dear friends, thank you very much for everything that you have joined, with a special thanks to Professor Ashok Das.
I think most important are the people who have joined for this program, because we are here. So we thank you profusely, the thousands of logging in. We thank the entire people who have joined us. Thank you very much for reposing faith in us and joining us. Thanks to all faculty, all chair. We had 91 faculty. and we had for
And
everybody.
it will be incomplete.
Please speak.
It will be incomplete if you don't thank Priyadarshini.
Yeah.
Priyadarshini, my executive assistant, untiringly has worked for the conference, and she was the contact point. Thank you, Priyadarshini, for everything.
All the communications to us, to the speakers, to the chairpersons. She was the main person. Priyadarshini, thank you very much. She will join from her house virtually in all the meetings that we held, and absolutely fabulous service, Priyadarshini. Dear friends, thank you very much, and see you much before the 10th NUCD. But 10th NUCD, we'll try to make it with Alok's resolution up to and beyond your expectation. Thank you. Thank you. Thank you. Thank you.
Thank you.
Thank you.
Thank you, everybody.
Thank you, everybody. Thank you, everybody. Thank you.
In the content of academics and the rolling out the plan, and the plan good with the committee. It went very well. So I congratulate the whole team, and in future days it will be still mature and full of science, and will be adored internationally, I'm sure. So I'm proud to be a member of the team and looking forward to further escalation in the scientific and the administrative growth. I thank Dr. Kanungo, Professor Das, and the whole team, scientific team, for the program. Thank you, sir.
Thank you.
Thank you, everyone.
Thank you. Let us close.
Sir, sir.
Everybody has told. Everybody
Good
has
night,
told.
sir. Good night. Thank you.
Good night. Good night.
Sir, ଆମେ ଆଉଥରେ ଗୋଟେ analysis କରିବା ଆମର how to improve and how to go further. The analysis